all of you guys. I would like before to think um, for everyone involved in emergency medicine to think about what we do now in emergency medicine and how busy our emergency medicine departments are and whatever. I'm going to present a project called Smart Art that we develop. I mean, it's been developed mainly in the UK by a colleague of mine called Dr. Anjin Mohamed, that he runs the emergency department in Doncaster, and that's where this project is been proven and it's been tried for the last 4 years. So I would like all the audience to have an open mind. It's a very I got a lot of slides, but I know that we are restricted in time, so I'll try to make it as fast as possible. I only want to share the concept because this is something that probably we will need a conference in itself. Um, if you have any questions or you are interested more in this project, you can always contact me or Dr. Mohammed in the UK. And then if you want more info, we will be happy to share it with you. So obviously, emergency medicine now is a global problem, not only in the developed world, also in the low middle income countries, because we are increasing the demands every year. We have limited resources, and there are a lot of implications, health, financial, and political. Um, the concept of the Smart ER project is we have to understand what the downtime is in the emergency department and elsewhere, that we want a smart ER. I mean, we had the idea that the patient has to be the center of the process. Um, this smart ER works better when we have an increase of activity. That is, a bit strange when we are talking about emergency medicine because it seems like increasing activity is always worse. We think that increasing activity for us is better because the machine engineers everything better, that the patients are part of the solution, that we not only look at the in-reach care, which is where when the patient is in the emergency department, also the system looks at the outreach care. We try to bring order versus the chaos that usually is and usually happens in the emergency departments. And we believe in the major emergence of emergency medicine. Things have to change. Obviously, we need a change. We need to innovate. We need to be modern. We have to embrace technology. Obviously, if we center the process into a patient, that will lead us to have a patient-centered care. We have to rethink the relationships between the patients and us. Um, the pressure is not only because of the blockage of the emergency departments in the exit. Also, when people come to emergency department with low acuity attendances, and I think that happens in every emergency department in the world. The challenge, I mean, I think there is a format problem, with the slide, but anyway, I don't know, you can see that I will tell you that the emergency departments are the most utilized services in acute, sorry, the most utilized department in acute services. Just to give you a figure, that usually nearly half of the population, between 35 and 50% of the population of every nation, attend the emergency department in 1 year. So in a country like ours in Spain, that we have a population of approximately 40 million, 42 million people, nearly half of that people, so we're talking about 20 million, 20 million people come to the emergency department nationwide in our country. There is a variable demand, and we know that. We don't have a lot of technology to support us. I mean, it's very variable, the technology that we use in the emergency departments. We have electronic health records, we don't. So we need and require solutions that perform well under high demands. Um, no, we think that the care doesn't have to stop when the patient leaves. It's got to be a continuity of care, when the patient goes. We have to have a measurable follow-up. Um, Obviously, I think with the technology and with all the things that we have at our disposal, we need digital health solution. We provide InReach, with which we want the patient to engage while he is in the department, and the outreach, which is we need to follow up this patient where they live. So obviously we are talking about innovation, development, and improvement. We try to think ahead for all these things. Obviously, we developed this depending on where we are now and we are going to be in a few years. So we know that it's going to be an increase of demands, increased morbidity. The patients are changing. The patients are more pluripathological. The patients, like keep living longer, and obviously they got more expectations. There is a problem with the staffing. I mean, you asked me how many staff we have. It's a problem worldwide. We haven't got enough doctors, enough nurses, to attend the population at the moment. Obviously, there's a worry about the cost, the value for money, how efficient we are, and obviously social and IT changes. And that the last one is NHS strategies, because obviously this presentation and this system is working in a national health system hospital in the UK. I can. There is something in the format of this slide anyway when we pass it there, but this slide only show that there have been some strategies in the UK in the national health system, some projects to try to implement technology and digital workforce in the system. So as long as 2011, they started thinking about how they could do it. But now, I mean, that was obviously a thing for the future, but where are we now? What do we do in the emergency departments? I mean, we haven't changed the system. We haven't changed the way we work in, many years, probably 60 years, we've been doing the same, which is the patient arrives, the patient registers, the patient waits, the patient waits, the patient waits even some more. Then is seen by a healthcare professional for consultation. They discharge, transfer, or we admit him. There are a lot of social, technological, and patient expectations change over the last decades that I don't think we are ready and we are catering for it. The emergency departments fail to keep up with these developments. That's a fact. I mean, I think everybody, the audience, and everybody working in the emergency department, we got this every day. And obviously, from a clinician perspective, where are we now? Obviously, the departments are always busy, under pressure. The waiting times are longer. We haven't got sometimes a good record keeping. There are many complaints and concerns that we have to face. It's very difficult in the emergency departments to establish accurate audit and data collection. If there is these inefficiencies in the medical staff, that leads to poor performance. There are many duplication of processes. There's a lot of time that we have to spend writing clinical records. Sometimes, we fail to meet targets that even our politicians or the guys in senior management put on us. We try to manage everything as a crowd management, not as an individualized patient care. It's only a review of the time that we spend with the patients. F1s and F2s in the UK system are like residents, junior doctors, and you can see that they spend most of the time with the patients, probably because they are less experienced. But it's a lot of time that we, especially if you see this is the time that we have to spend writing history. And you can see that it's a lot of time, 71%. We all know that. Everybody that works in the emergency department know the time that we spent doing very, very valuable tasks that we could do or we can spare, if we have some technological help. And the patients, 80-90% of the time that the patient is in the department, they are simply waiting because they get triage, they wait, they are called, then they wait, to be seen by the doctor, then the doctor orders some tests. Think about it, because the journey, I think, of a patient in the emergency department is well known by everyone. The longer the patients wait, the less time the clinician has with them. So it's an inverse relationship. The longer the patients wait, the more the complaints. It's that direct relationship. Most of the complaints in the emergency departments are because they are waiting, or the patient perceives that they are waiting inappropriately. Frustration at doing nothing for several hours, waiting for something to happen. There is a feeling of inadequate consultation after the long wait. Is that it? There is a feeling that information wasn't conveyed bilaterally. During post-consultation, there are communication issues that we all know. I mean, you can see in this slide that the downtime is the time that the patient spends in the emergency department. So it's a big percentage. And then compared to the time that the patient spent interacting with us or receiving care. So what we do is trying to get downtime solutions is what can we do in that time that the patient is waiting and it seems to be wasted. So we are creating, and the concept of downtime of trying to sort the problem out. What we try is, we said is embrace technology, trying to get, a patient-centered approach solutions and solutions with current NHS concerns and future design. I mean, we have to bust the myth that the patients don't know anything, that they are part of the problem, that our perception that they are most of the time satisfied even with brief interaction and explanations, that they don't have anything to offer to contribute to the care. I mean, we disregard them really. Usually, we also say that the patient are our enemy. They are drunk, disrupted, angry. Um, Obviously, the lack of communication also we blame to how busy we are. We think there are no better ways of doing things, and basically most of the time we think that we need to build walls and to try to separate them from us. As we said before, we are offering more crowd management and not personalized care. So the downtime solution, that's why we started with this project called Smart ER. So we want to use downtime more efficiently. If the patients are waiting, can they help? I mean, they possibly have 80, 90% of the data that we need to make the diagnosis. I mean, probably if they could have more time telling us what's wrong with them, obviously probably they will give us more info, and then we probably will reach diagnosis and will reach a better care for them. Um, we can engage with the patient from the moment that they start waiting. Uh, Everybody has a smart device now at the moment, smartphone, tablet, laptops, and everybody comes to the emergency department now with their mobile phones. If not, we can provide kiosks in which the patients can interact. We can even provide with tablets or any laptops or anything that the department can provide. We can give an application that can give some ownership to most patients while waiting. We can improve the experience and we can improve performance and efficiencies. We can develop applications in other settings where the patients are waiting. So while the patient is waiting, we can do data collection. The future, we'll talk about the data analysis. We reduce the variation in one of the part of the system, so it reduces the whole system variation. The aim is to reduce variation in data collection. I mean, how many times the patient changed the history from one healthcare provider to another. I mean, from triage to be seen by the doctor, the patient sometimes, change the history, and that confuses us. And imagine if the patient is writing his history in the on device, appears in our screen. That's in our smart ER is about. Obviously, is consistent with any public health, with any healthcare organization. Obviously, we are trying to develop algorithms, obviously based on the information that we are collecting. The data analysis can be supported, and the data collection is even sometimes direct and live, happening at the same time. So this is what we do now at the moment. The patient attends the the emergency department, he registers. If he's suitable for the smart ER, he starts interacting with the smart ER, even via console, via tablet, via their own device. The history is taken from the patient because the patient is writing the history in the system, in his tablet or in the kiosk or in their tablet. Obviously, you can see all the travel and all the information that we can download. Obviously, we can start identifying all the toxic habits. We even can start even interacting the system automatically, can give advice. They can be waiting down, and then interacting with the system at the same time. And we can identify allergies. We can even interact with friends and families. We can do, I mean, we do a summary to confirm accuracy. Obviously, the portal and the system, when we see the patient, is open, and then everything is uploaded, we submit, and we can print it on a scanner or a file. So who is suitable for a smart ER? Usually are patients that can interact with the system. Obviously, they have to be alert and orientated. They are patients or carers have to be able to use applications. I mean, not to use a mobile device that a lot of people obviously do. Uh, Obviously, no contraindications to use, because this is not to stop the flow of being triaged and be identified as a critical intervention needed, and obviously depending on the ability of the application. And you will see, obviously, that most of the people that come into the emergency department on a daily basis are suitable for the smart ER, because approximately we found that 80% of the patients that attend an emergency department daily are suitable for this, because I mean that happens in every emergency department in the world. I mean 80%, really between 75 and 80% are people that come ambulance and are people that come with a minor illness. Even now, we after we started developing and putting this system in motion, we are trying to make change in order for this system to be applicable to major illnesses as well. Um, Obviously, it's more inclusive because we can put this smart ER in many languages. Obviously, the UK is a multi-ethnic country with people speaking lots of languages, and then we can put the system, and we can, I mean, and we've been using the system in, I think it's been translated already to 17 languages. This is in order how the architecture overview of the on how the smart ER works computer-wise. I mean, I will, and sorry, this slide is very, very, very thick, but mainly you can see, I mean, and as I said, I'll be happy to share this presentation and to have more information, because a waiting patient can produce a lot of information for all these 1, 2, 3, 4, 5, 6, 7. So it can give us information, obviously the history from the patient. It can help us to research. It can help us to advertising, to advice, to education, to even pediatric care for the kids, friends. So the implications of a patient waiting and downloading information to us and to the system are massive, and we are seeing that. And smart ER obviously communicate. Smart ER has been developed to address the in-reach problem. It allows a patient to enter clinical data regarding their condition, optimize questions of help, and determine by the condition of the patient. Obviously, using Smart ER, we can coordinate the in-reach and the outreach care. Post-visit digital care models and they are developed at this moment based on conditions determined in the department. We can auto-generate information more efficiently, and allows a secure, personalized patient record to be created by the patient for the patient in the health space. And obviously, the outreach beyond the emergency department is the digital health allows care models to extend beyond the emergency department, because the patient is going to be going home with the application downloaded, and we still can communicate and with the technology at our disposal. I mean, everybody now has a smart device, and we know how we interact now with the digital technology. And even we can send personal health information and outcome of the data through the patient health. Obviously, it will allow and is allowing some interaction with other care providers, GPs, nurse practitioners, social workers, etc., etc. Obviously, we are seeing that provides the insight in the models, I mean, to determine how effective, how efficient, and how satisfied the patients are. And this is again a total healthcare platform which we want to do with the smart ER, in which the patients are the components of the solution, and through the smart ER, we interact and we can create a lot of data to help the patient and to personalize their care as much as possible. Obviously, we are seeing that smart ER is providing at the moment key operational and clinical benefits to the department and the patient. Um, a smart communicate allows patients' health space to be created and populated with personalized conditional information, and the outreach digital care models can be developed for patients, which obviously put the patients at the center of the care process, allow care to be seamlessly delivered across the care spectrum. The models can be built to include all providers, and models can interoperate with the system, and the model can be measured and optimized to provide optimum combined care on personalized basis. So it's all about trying to get the patient at the center, to follow it up, and to interact with other systems of healthcare. Um, we can do a screening of patients. We can obviously know about their the toxic habits or anything that we can identify and we can help with. For example, if they are not doing enough exercise, we can provide way information about how can we do exercise promotion. Um, is all about how to send information to the patient health space. The platform can be used to connect the patient to community-based services like Aspire, or that's in the UK, or social workers or whatever. Obviously, it's an opportunity to educate, inform the risks, and try to change health behaviors. That is one of the problems that concerns us more in the public health system, that we are not being very effective overall to change habits in our population. Obviously, we can increase consistency, reduce the variation, intra-hospital, inter-hospital, inter-primary, secondary care. We have to have central control. We have a central updating. We have bespoke elements, research and updating. And obviously, this is down to the education medical information system, that we can do all this with the smart ER, because we can advise, do all the information, and improve how we can interact with the patient overall. In other settings, the waiting patients even can help us, like with all the information that they give in the smart ER, how to create new outpatients, and how to refer them to the appropriate specialist, interact with pre-hospital. We can interact with radiology. We can interact with everything, and we are seeing that. We have a proof of concept, because everybody, probably the audience is asking, and does this work? Obviously, it's been working for 4 years. And this is the first trial that we did in a minor injury unit. We did a trial for 3 months, and we did 6 weeks refine, which is in our training, and setting everything in motion. And we did a 6 weeks testing. We tested this with 70, 80 patients per day, 12 hours a day, and it was put into and the EMIS integration into Symphony. And obviously, we target the patient satisfaction, the clinical satisfaction, and productivity. Um, Sorry that we cannot see the results, but everything, because of problems with the slide. But if you see what we tested, patient satisfaction, clinical satisfaction, and productivity, everything was positive. Patient satisfaction increased. The clinician satisfaction obviously increased, because think about that. While the patient is waiting, he's interacting with the system, and you got all the information in your computer when you see the patient. And obviously, the productivity increase, because it reduced the time that we have to be writing notes and doing times, especially the healthcare practitioner. That was sorry, see if I can pass. Yeah. Obviously, one thing that we are seeing after we implemented the Smart ER is data is power. And this is in other way we are now. We have been acquiring 4 years now since the system was put in motion of data. And obviously, there are some questions about how we can comply with the data law protection, but we have all these, what we saw at the beginning, is now we have it, because we have a lot of data. Now is where artificial intelligence will have to help us to try to work out what we're going to do with this data. Sorry about this slide. This is what I wanted to show from before. That is about all the this is all the results that we are seeing after applying the Smart TR. The patient gets more personalized care. They communicate bilaterally with us. Obviously, the waiting times are decreased, and the process are improved. There is more satisfaction. There are better consultations. There is better post-consultation communication, and is less likely to return. That is one of the quality indicators of the emergency departments, and we can use it in different languages and modalities. For the healthcare practitioner, obviously, we have more accurate history. They are already written. We don't have to write it down. A better communication. We'll have more time with the patients, interacting with them. We have less time with the computers because the patient is already writing the history to us in their device and appears into our screen. We are more efficient. Obviously, the language difficulties are overcome because the patient is writing in their own language. Even disabilities difficulties overcome because we can optimize another time with them. In terms of the department, obviously it's a cost. It will reduce the cost. We increase the income. It's better flow. We increase the productivity. Less complaint. There's less negligent claims. It's better data. It's mandatory with all the quality indicators. We have central management of real-time data. Happier patients, and from the public health system, obviously, is very advantageous as well because they have better data consistency, they reduce the cost. It's applicable across other areas, even in our primary care and whatever.
Dr. Maya, can you conclude, please?
Yeah. I mean, so obviously what we do is integrate this into what we already do, which is self-registration triage, and the Smart TR will apply. And the summary concepts are we have to understand the downtime. Obviously, I think, I try to probably, make you aware of that. We have to change into a patient-centered process. The process works better with increased activity, and it provides better engineering. Patients are part of the solution. We can improve the in-reach care. The outreach care is a third solution to constraints. We have to bring order versus chaos, and it's the emergence of emergency medicine. As Einstein said, doing the same things again and again and expecting a different result is a definition of madness. The only thing that is constant in the universe is the speed of light. Everything else is relative, even time. So this is what the system is. We hope and happy to answer any questions that you have. And if you want more information, happy to provide it as well. Teşekkür ederim. I finish now. Thank you.
Thank you, Dr. Maya, for this useful presentation. Do you have any question? Okay. Okay.
So for our next presentation, I will be presenting my colleague, Nazmin Guler, who is the expert in medical hypnosis and emergency medicine in France. She will be talking about the uses of hypnosis in emergency medicine. We have a question here.
Yes. Okay, Türkçe konuşayım mı? Okay, if you want, I can speak in Turkish. It's not a problem for me. Okay. It's better for me.
No, for sure.
Antoine, it is a problem for you? Okay. Test. Beni duyuyor musunuz? Okay, süper. Çok güzel. Şansıma Türkçe sunuyorum. Daha hızlı sunabileceğim ve daha çok bilgi verebileceğim size. Çok mutluyum bu sebepten dolayı. Antoine, tu comprends tout? Yes? Okay. I understand everything. Bildiğiniz gibi acil uzmanıyım. 2005 senesinde mezun oldum. 2012'den beri acilde hipnoz uyguluyorum ve uzun yıllardır tecrübem var ve bu konuda inşallah sizi ikna edebilirim acilde hipnoz uygulamanız için. Bu konuda zaten Başar Hoca ve Mehmet Gül Hoca ile düşüncelerimiz var. Belki yakın zamanlarda size bir atölye çatısı altında bir eğitim teklif edebiliriz. Bunu hatırlarsınız. Tenten dizisindeki fakir. Deli olduğumu düşünüyor musunuz? Yok. Sizce benim gözlerime bakarak beyninizin kontrolünü alabilir miyim? Alabilir miyim Behçet Hoca? Okey. Okey. O zaman bakalım alabiliyor muyuz, alamıyor muyuz? Keşke alabilseydim. Gerçekten hastanedeki yönetimdeki insanların beynini çalardım ama benim gayet işime yarardı. Öyle bir gücüm, kuvvetim olsaydı. Bildiğiniz gibi acilin ortamı çok stres, çok büyük bir anksiyete yaratan bir ortam. Özellikle korku, ağrı, stres, öfke, özellikle öfke patlamaların çok olduğu yerler. Ve gerçekten bu ortamda çalışmak ve yaşamak çok çok zor. Çünkü bizim de kendi ayna nöronlarımız var ve ayna nöronlarımız olduğundan dolayı bizde de çok kaldıramayacağımız duygular uyandırabiliyor ve sonuç olarak öfke patlamaları çok yoğun olan bir yer. Sizce tabii ki doğru bilinen yanlışlar var ki zaten bu sebeplerden dolayı yıllardan beri acilde zaten hipnoz uygulanmıyor. Yıllardır böyle çünkü işte psikiyatride yapılabilir, işte anestezide yapılabilir ama acil kesinlikle yeri değil ve ön yargılardan birisi işte bir zaman kaybı. Çok fazla ses var, hastaların direnci çok yüksek. Hele hazırlıksız kesinlikle olmaz diye ön yargılar var. Bakalım bunları bir bir yıkabileceğiz mi? Başlangıç olarak vaktimiz var. Son sunum olduğum için biraz 5 dakika fazla sunum ekledim. Size 2 tane video gösterebilmek için ilk videoyu gösteriyorum. Belki aranızda bazıları görmüş olabilir bu videoları. Tekrar gösteriyorum görmeyenler için. Omuz çıkığı redüksiyonu. Bu hastamız diyaliz hastası. Daha önce omuzu çıktı ve acile ağlayarak geldi ve dedi ki ben ilaç istemiyorum. Lütfen bana ilaçsız müdahale edebilir misin? Ben evime bir an evvel dönmek istiyorum. Haftada 3 sefer acile gidiyorum artık hastaneye geliyorum ve ben artık hastane görmek istemiyorum. Gördüğünüz gibi röntgene gerek yok, omuz çıkık. Hepinizin bu konuda zaten tecrübesi var biliyorsunuz. İlaç, serum takmamız gerekiyor, monitoraj, midazolam, süfentanil, değişik ilaçlar kullanmak zorunda kalıyoruz. Hipnoz seansı genelde anestezi gibidir. Endüksiyon vardır, derinleştirme vardır, çalıştığımız an vardır ve ondan sonra hastayı uyarma vardır. Tabii bunların hepsini ilaçsız yapıyoruz. Serum takmadık hastamıza, dikkatinizi çekerim. Şu an endüksiyondayız. Yavaş yavaş derinleştirmeye geçeceğim. Özellikle nefes odaklı, nefesinizi takip edin şu an diye hastaya telkinliyorum. Gördüğünüz gibi aşırı gencim. Yıllar önce yaptığım ve hemen eğitimden çıkar çıkmaz yaptığım bir hipnoz tedavisi. Arkadaşlar videoları çekiyorsanız da sosyal medyaya koymayın. Çünkü gerçekten arkadaşlarıma, bu hastalara söz verdim sosyal medyaya sızmayacağını videoları. Çekebilirsiniz ama kendiniz için. Efendim? Ona ne söylüyorum? Nefesine odaklanmasını gerektiğini söylüyorum. Ondan sonra yavaş yavaş şimdi bana lazım olan ne? Rahatlaması ve omuzunu hissetmemesi. Yani ilaçların yaptığı şeyleri ben telkinliyorum. Omuzunu artık hissetmiyorsun, rahatlıyorsun, kasların gevşiyor. Direkt telkin veriyorum ve yavaş yavaş zaten hastamız rahatlıyor. 5 dakika sonra redüksiyona başlıyoruz. Hastamızı genelde güvenli bir mekana gönderiyorum ve orada omuzunu bana emanet etmesi gerektiğini, yani disosyasyon teknikleri kullanıyoruz. Burada bana omzunu emanet etti. Arkadaş çekiyor ama biliyorsunuz normalde bu prosedürler çok bazen hızlı ve güç kuvvet isteyen prosedürler. Hastamız biliyorsunuz hiç bağırmadı. Bazen 2 kişi tutuyoruz biz acilde gerektiğinde.
Pas forcément exactement ce que vous me disiez, j'arrive pas forcément à suivre ce que vous me dites, mais par contre, ça m'aide à me...
Şimdi prosedürü arkadaş kolu çekiyor, ben hipnoz uyguluyorum ama kendim hipnoz uygulayıp da kendim de çekebiliyorum. Bizim acilde özellikle omuz çıkığı, anterior omuz çıkıklarını biz acilciler tekrar yani redükte edebiliyoruz. Posterior Ortopedistler anterior biz yapıyoruz. 6 dakika arkadaşlar, biliyorsunuz acilde normalde 6 dakikada mümkün değil. O yüzden zaman kaybımı gördünüz. İlk ön yargıyı yıktık. Zaman kazandık. Çünkü normalde bu hastayı ben bizim orada critical care üniteye koyuyorum, monitoraj yapıyorum, ilaç yapıyorum, hemşire bulmam gerekiyor yoğunluğun içerisinde. Yani gerçekten yarım saat 45 dakikada ancak hazırlıyoruz hastamızı. 6 dakikada 1 saat içerisinde acilden ayrıldı. Vaktimiz olduğu için ikinci bir video gösteriyorum. Ondan sonra size ikna etmeye çalışacağım bilimsel olarak. Burada ufak bir çocuğumuz var. Bisikletten düştü. Annesi lokal anestezi yapmadan bacağını sütürasyon yapacağız. Bu benim tabii ki ilk başladığım zamanlarda ve o zamanlar biraz tedirgin hipnoz uyguluyordum ve böyle sesimi kısa kısa konuşuyordum. Çünkü biraz utanıyordum. Çünkü herkes garip garip bakıyordu. İşte bu ne yapıyor, işte deli midir nedir diye. Çok sessiz konuşuyorum. Çocuğa tabii ki bir oyun yapacağız beraber diyerek sedyeye getiriyorum. İstediği, sevdiği bir oyunu yapacağını telkinliyorum. Ve tabii ki vizüel fokalizasyon kullanıyorum. Yani karşındaki bir noktaya bakar mısın? Onların tabii ki tekniği çok derin. Hani onu büyük bir eğitim gerekiyor ama noktaya bakabilir misin diyorum. Çocuk bakıyor tabii. Ondan sonra da istediği oyunu oynaması gerektiğini telkinliyorum. Tabii telkinlerken de aynı anda bacağına tabii ki direkt telkin veriyorum. Bacağı rahatlıyor. İşte bir yavaş yavaş bacağı uyumaya başlıyor. Bir daha artık hiçbir şey hissetmeyeceğini, bacağından hafif bir rüzgar geçtiğini ve hiçbir şey artık hissetmeyeceğini direkt telkin olarak söylüyorum bunu. Genelde çocuklara hipnoz uyguladığımız zaman gözleri genel olarak açık kalıyor. Yani ön yargı biliyorsunuz, gözleri kapalı, ondan sonra kendisini teslim ediyor ama burada çocuk gördüğünüz gibi hareket ediyor ve gözleri açık. Ellerini gördünüz mü? Sizce ne yapıyor? Oyun oynuyor. PlayStation oynuyordur muhtemelen. Git bir oyun oyna diyorum. Bizim biliyorsunuz gençlerimiz artık virtüel dünyada devamlı oyun oynuyorlar. Muhtemelen orada bir oyun oynuyor. Bakın yan tarafta ben çok ses yapıyorum ve çocuk çıkmıyor transtan. Genelde bu çocukları birkaç kişi tutmak zorunda kalıyoruz. Ben bir şeyler hazırlarken çocuk genelde ne yapıyorsun diye mesela soru soruyor, anksiyete içerisinde ağlıyor. Gördüğünüz gibi kendi dünyasında. Yarasını temizliyorum ve sütürasyona başlıyorum. Gördüğünüz gibi hipnozu uyguluyorum ve kendim sütürasyon yapıyorum. Yani tabii ki iki arkadaş olduğumuz zaman ben hipnozu uygulayıp sütürasyonu da başka birisi yapabilir. Genelde şu an artık hasta acilde hemşirelere ve hasta bakıcılara da eğitim veriyoruz ki doktorlara destek olsun diye. Normalde bunu bu şekilde hipnozsuz yapmak imkansız biliyorsunuz. Yani çocuk 7-8 yaşlarında bir çocuk. Sütür bitti. Şimdi artık uyandırıyorum. Ne zaman istersen buraya geri gelebilirsin diye telkin veriyorum. Uyandı çocuk gördüğünüz gibi. Transtan çıkması çok enteresan oldu. Şimdi bakın çocuklarımıza bu şekilde yaklaşım yaptığımız zaman ilerideki posttraumatik travmalardan koruyoruz. Benim oğlum 2 yaşında sütürasyon yapıldı ona alnından. İnanın hala da 23 yaşında ve hala da onu hatırlıyor. Şimdi bu reşit insanlar tam uzun onlara bakmamıza gerek yok ama gerçekten ileriki yaşlarında onları yapılacak tedavilerden bir nevi koruyor gibi oluyoruz yani bunları uygulayarak. Çünkü travmatik hafızayı şey yapmıyoruz, yerleştirmiyoruz. Gördüğünüz gibi all terrain hipnoz istedim. Yani her yerde, 4 çeker araba gibi her yerde bunu uygulayabilirsiniz. Yani acilde, telefonda, ambulansta her yerde uygulayabilirsiniz. Tabii ki hani benim gelmek istediğim genel mesaj şu, yani gerçekten hipnozu elinize aldığınız zaman, kullandığınız zaman iletişim olarak 7/24 her zaman kullanabileceksiniz ve size gerçekten insani ilişkilerinizde çok büyük bir rahatlık verecek. Yani özellikle hastalarla olan ilişkinizde her zaman kullanabileceksiniz. Yani öfkeyi nasıl yönetebilirim, hastanın korkusunu nasıl yönetebilirim? Uzman doktorlarla biliyorsunuz sürekli ping pong oynuyoruz. Yani özellikle mesela solunum nefesi çekiyorsa hasta, kardiyologla pneumologla arasında oynuyoruz. İşte karın problemi olduğu zaman hepatogastro ile işte cerrahla arasında böyle bir ping pong oynuyoruz. Yok onun hastası, bunun hastası derken işte bu uzmanlarla bile ilişkilerimizi daha iyi yönetebiliyoruz. Self hipnoziz de çok önemli. Benim için gerçekten hipnozun en büyük katkıları iletişim ve self hipnozuz. Mesela ben gerçekten bu pandemide biliyorsunuz Fransa'nın kuzeydoğusunda çok büyük bir patlama yaşadık. Çok stresli bir dönem yaşadık ve bana gerçekten çok yardımcı oldu. Her gün self hipnozuz yaptım kendi duygularımı yönetebilmek için. Arkadaşlar gerçekten hastaların duygularını yönetmek istiyorsanız ilk önce kendi duygularımızı yönetmemizi öğrenmemiz lazım. Ben kendi duygularımı yönetemiyorsam hastanınkini yönetemem. İşte hipnoz aslında buna yardımcı oluyor. Ve tabii ki videolardaki gördüğünüz gibi formal hipnozu, o da gerektiği zaman eğer hasta gerçekten kendi duygularını yönetiyorsa yani hipnoz uygulamaya gerek yok. Yani sanmayın ki ben her hastaya hipnoz uyguluyorum. Gerektiğinde uyguluyorum o şekilde. Tabii ki sağlıklı olarak kendinizi daha iyi hissetmeniz için. Size gerçekten Inside Out dizisini, filmini bakmanızı tavsiye ederim. Çok duyguları açıklayan çok güzel bir film. Yani genelde bizim korkulu rüyalarımız kim? Mr. Anger and Mr. Fear. Acilde bu ikisi başımıza gelince zaten bunlarla uğraşmak çok zor. Ama artık ben bunlardan korkmuyorum. Bunları çok güzel yönetebiliyorum. Özellikle öfkeli hastalar hiç problem değil benim için gerçekten. Benim aslında genel vermek istediğim insani ilişkilerinde gerçekten bunu bir İsviçre bıçağı gibi düşünebilirsiniz hipnozu. Özellikle tabii ki normal ilaçların yerini tutmaz ama insani ilişkilerde yönetmekte bana göre bu İsviçre bıçağı gibi bir şey. Acilde olmazsa olmazlar, kesinlikle her acilcinin cebinde bulunması gereken, zor anları yönetebilmek için gereken bir uti, bir tools diyeyim, Türkçesini şimdi aklıma getiremedim. Size birkaç araştırma göstereceğim. Bakın bu araştırmada Elvi Halong 2000 senesinde çıkan bir araştırma. Endovasküler tedavilerde özellikle burada renal damarı kateterizasyon yapıyorlar. Yani arteritik hastalarda. 3 tane gruba ayrıldı. Kontrol grup en üstte. Ortada empati ve en altta hipnoz. Burada anxiety ve ağrıyı nasıl yönetebilir biliyorsunuz, scale'ler var şu tarafta ve gördüğünüz gibi hipnoz grupta daha iyi yönetim var. Çünkü hastanın stresini ve ağrısını daha iyi yönetirseniz eğer daha uyumlu oluyor ve bakın daha erken bitiriyoruz tedavileri. Empati iyi çünkü empatiyle bir grup yapması çok iyi oldu. Çünkü mesela ben acilde başladığımda hipnoz uygulamaya, ya Nazmiye işte sen hastalarla jantisin o yüzden etkili oluyorsun yani diye bana böyle bir ön yargı var. Ama bakın gördüğünüz gibi empati tabii ki kontrol gruptan normal travmatik iletişim diyorum ben ona. O tarz iletişimden daha iyi. Mesela ben laboratuvara gittiğim zaman hemşire güler yüzlüyse gerçekten daha iyi. Surat asıyorsa bende stres yaratıyor yani sonuç olarak. Gördüğünüz gibi ve bu gruplarda ilaçlar kullanıldı. Mesela burada midazolam ve süfentanil kullandı ve en üst grupta, kontrol grupta hem daha ilaç kullanıldı, daha çok ilaç kullanıldı hem de bakın ağrı yönetimi çok kötü. Scale'ler çok yüksekte. Hipnozda az ilaç kullanıldı. Ağrı ve stres yönetimi en düşük seviyede. Şimdi bu yeni bir meta-analiz çıktı 2021'de. Bunu muhtemelen siz isterseniz okuyabilirsiniz. Bakın burada son 20 yıl araştırmalarını bir araya getirdiler ve sonuç olarak bakın hipnoz ağrının %73'üne kadar düşürebiliyor. Yani gerçekten acaba lüksümüz var mı hipnoz eğitimi almamak için? Gerçekten çünkü hem kendinizi koruyacaksınız, hem hastayı daha iyi yönetebileceksiniz, hem kendinizi daha iyi hissedeceksiniz. Şimdi burada da başka bir araştırma görsel olarak çok önemli olduğu için size göstermek istiyorum. Üst tarafta Hastanın bilinci yerindeyken elini lazerle ağrı veriyorlar. Yani elini acıtıyorlar. Bak gördüğünüz gibi ağrı bölgeleri uyandırılıyor. Altta hipnoz uygulanıyor ve ağrı bölgelerindeki aktivasyon sönüyor. Yani hipnozla gerçekten görsel olarak bunu görebilirsin. Beyinde gerçekten büyük bir etkisi var. Yani bu şey değil, yani hayali bir etki değil. Gerçekten beyin görüntülemede bu bir MR veya PET scanner, ikisi kullanılıyor imaging olarak. Görebilirsiniz ki gerçekten hastanın ağrısını çok iyi yönetebiliyoruz ve bunun gerçekten reel bir etkisi var. Burada başka bir anestezist ameliyattan sonra hastalara nötr bir fluid enjekte ettiği halde, bakın yanan bir fluid enjekte ediyorum diye hastayı telkinliyor. Gördüğünüz gibi hepimizin ağrı hafızası olduğu için ağrı bölgeleri uyanıyor. İkinci etapta hastaya ben sana nötr bir ilaç enjekte edeceğim ve nötr bir ilaç enjekte ediyor. Bakın telkinlerin bile normal günlük hayatta ne kadar önemi var. Çünkü bizim gerçekten ağrı hafızamız var ve kullandığımız kelimelere çok dikkat etmemiz gerekiyor. Bunu zaten tomografide çok yoğun yaşıyoruz. Hatırlarsanız hastayı tomografiye getirdiğimiz zaman aman dikkat, yanacak, iod enjekte ediyoruz diyoruz. Ben mesela bizim röntgen bölümündeki arkadaşlara lütfen diyorum, ne olur artık dikkat, yanacak, iod enjekte ediyorum demeyin lütfen diyorum. Diyorum ki gerçekten şu an sakin olun. İşte size bir ilaç enjekte edeceğiz. Bir şeyler hissedeceksiniz, bir sıcaklık. Bakın yanmak başka, sıcaklık hissedeceksin ve gerçekten sizin için çok hoş olacak diye provokatif bir şekilde telkinliyoruz ve inanın hastanın o anki yaşadığı daha pozitif oluyor. Aynen böyle, biliyorsunuz beynimiz negasyonları duymuyor, keywordleri duyuyor. O yüzden hastanıza yaklaştığınız zaman stres yapma yerine sakin olun, rahatla. Yani pozitif terimler kullanacağınız bütün keywordler pozitif olsun. Yani canın yanmayacak yerine ne söyleyebiliriz arkadaşlar? Mesela bir çocuğa tedavi uyguladığınız zaman işte stres yapma, canın yanmayacak. Sakin ol, seninle iyi ilgileneceğiz, göreceksin her şey iyi geçecek gibi. İşte kendi kreativitenize bırakıyorum. Gerçekten pozitif kelimeleri kullan. Burada maksat pozitif olmak değil, yani hayata pozitif bakmak değil. İletişiminizi pozitif kelimelere, yani negatif kelimeleri pozitif kelimeye çevirmek. Yani önerim şu, tabii ki hastaya bütün prosedürleri A'dan Z'ye anlatmak zorundayız. Yani gerçekten ağrıyı anons etmeyin, prosedürü anons edin ama ağrıyı anons etmeyin. İşte sonuna geldik, sunumun vaktim var biraz herhalde. Son olarak bakın, araştırmalarda EEG'de kesinlikle herhangi bir karakteristik bir tracing yok. Sadece sakin bir uyanık hal olduğunu görebiliyoruz. Ve burada bu da çok yeni bir sistematik review 2017'de publikasyona geçti. Bakın şu an artık bütün araştırmalar aynı fikirde. Yani ben hipnoza girdiğim zaman 3 tane network uyandırıyorum. Salience Network, Executive Network ve Default Network. Yani ben bu üçünü birden aktive edebiliyorum. Normalinde ben şu an sizinle konuşurken üçünü birden aktive etmem imkansız. Ama trans halinde bu üçünü birden aktive edebiliyorum. Yani bu ne demektir ki ben kendi içimdeki gerçekten daha farklı davranışları ve daha farklı kompetanslara ulaşabiliyorum hipnoz halinde. Biliyorsunuz ben çocuğa normal halinde şu bacağını uyut demiş olsam veya bir hastaya şu kolunu rahatlat demiş olsam bu kız deli diyecek bana. Ama ben hipnoz halinde direkt telkin verdiğim zaman uyguluyor. Tabii ki hipnozu plasebo olmakla suçlandı ama plasebo değil. Hipnozun içinde plasebo var ama sadece plasebo yok. Tabii bunları anlatmak uzun sürer, vaktimiz yok. Yani sonuç olarak hipnozu her alanda, ağrı ve stresin olduğu her alanda, prosedür olsun olmasın. Mesela bir migren için, bir karın ağrısı için bile kullanabilirsiniz. Ben ayrıyeten part-time terapi uyguluyorum. İnanın çok şeyler, mesela post-traumatik, tabii bunlar terapi, bunlar daha uzun işler de. Ama acilde kriz yönetiyorsunuz. Yani terapi yapmıyorsunuz. Kriz yönetiminde gerçekten medikal hipnozu her alanda kullanabilirsiniz. Özellikle mesela anksiyete krizine girmiş insanlarda çok çok etkili. İlaç vereceğinize ben 2-3 dakikada gerçekten onları hemen sakinletebiliyorum. Sonuç olarak for every stress and pain okay. Tabii ki ön yargını hastamın direnci yüksek ama bu doğru bilinen bir yanlış. Hastam gerçekten çok büyük bir stres içinde olduğu için siz onun kurtarıcısınız. Ve genelde siz ona ne bir hasta size derse ki eğer lütfen doktor beni kurtarın bu ağrıdan beni kurtarın dediği an zaten sizin etkiniz altındadır ve hipnozu uygulamaya hazır, hipnozu kabul etmeye hazırdır. İnanın ben kronik hastalarla ilgileniyorum. En kolay uygulanan yer acildir. Acilde o kadar kolay ki ve o kadar hızlı hipnoz yapabilirsiniz ki çok basit ve çok rapid. Çok kolay, çok yani hızlı teknikler var, çok kolay. Tabii ki ilişkilerinizi düzeltiyor ve kendi ruh sağlığınıza da iyi geliyor. Yani sonuç olarak time saving and less medication. Yani bu gerçekten benim atasözüm oldu hipnozda. Gerçekten zaman kazandırıyor ve ilaç da kazandırıyor. Herhalde vaktimiz bitti ama isterseniz prehospital olarak bir video gösterebilirim. Bakmak ister misiniz? El kaldırın. Okey. Tamam. O zaman bir call center'dan da bir ses kaydı dinleyeceğim stres yönetimi için. Vaktiniz var madem. Buyurun. STEMI hastasını ben şu an anjiyoya getiriyorum.
Donc là, je vous montre simplement, on va commencer la séance, tu peux t'exprimer, simplement de suivre votre respiration, d'accord? En remarquant l'air qui entre dans votre narine droite profondément. De la même manière peut-être, ou d'une manière différente, je ne sais pas. Vous allez remarquer qu'il y a plein de bruit autour de vous, à travers vos oreilles.
Bakın ses var, monitör çalışıyor, alarmlar var, hiç problem değil. Ne kadar çok ses, o kadar hipnoza sokabiliyorsunuz hastanızı.
Des mouvements de va-et-vient dans tous les sens.
Monitörajı gördünüz değil mi? STEMI'yi görebildiniz yani. STEMI var resmen hastada. Tabii ki aspirin, tabii ki bütün ilaçları, heparin hepsi yapıldı. Evet. Şu an bana gerçekten bakın eliyle soruyorum hangi bölge vücudundaki hangi bölge acı çekiyor şu an bana kalbini gösteriyor. Şimdi şu an katalepsi teknikleri kullanıyorum. Birazdan bana neresi ağrıyor diye sorduğumda bakın bana kalbini gösteriyor. Direkt iletişime girebilirsiniz yani hipnozda hastayla. Çok konfüzyon teknikleri kullanıyoruz. Ve şu an ben ona hani vücudunun başka bir yere işte kalbine yardımcı olacağını söylüyorum. Bacağını gösteriyor. Yani burada rasyonelite aramayın. Hipnozda rasyonelite yoktur. Yani zaten konfüzyon teknikleri kullanıyoruz. Şu an şimdi bir çapa yapıyorum. Çünkü ben anjiyoda olmayacağım onunla. Yani bir renk çapası yapıyorum ve telkinliyorum. Kateterizasyon room'da olduğun zaman bu rengi hatırlayarak tekrar aynı şekilde self hipnozis yapabileceksin diye. Bakın ağrısı düştü. Altının üstünde morfin uyguluyoruz. Morfin uygulamama gerek yok. Özellikle kardiyologlar mümkün mertebe yapmayın diyorlar. Çünkü gerçekten hasta o zaman daha çok midesi bulanıyor. Daha az uyum sağlıyor anjiyoda. Ben bu hastaya özellikle hipnozdan çıkmak zorunda kalmadığını ve tedavinin sonuna kadar hipnoz altında istediği gibi girip çıkıp kalabileceğini telkinliyorum. Çünkü ona şu an lazım ama sonra da lazım. Ağrısı düşüyor, 7'den 4'e düşüyor. O yüzden sadece parasetamol koydum. Anjiyodan sonra hastaya soru soruyorum nasıl geçti sizin için diye. İnancı, tabii kısaca şey yapıyorum, inancı olmadığını ve herkese tavsiye ettiğini, ağrısını ve stresini kateterizasyon odasında çok daha iyi yönetebildiğini söyledi, paylaştı bizimle. Yani bakın insanın hayati teklizi en dorukta olduğu halde biz değil mi? Yani sonuçta bir kalp krizi orada bile stresini çok gayet normal bir şekilde yönetebildi ve ben o hipnoz uygulayabildim. Çünkü ön yargı ne? İşte bu durumda hastanın hiçbir yeteneği yok, yapamaz. Gördüğünüz ses kısa sürede ses olduğu halde hastaların direnci düşük. Bütün ön yargıları herhalde kırabildik. Son olarak bu ses kaydını dinle. Bir tane anne yani görsel olarak hastanızı görmeseniz bile telefonda hipnoz uygulayabilirsiniz. Daha da etkili olabiliyorsunuz. Ses iyi gelmiyor herhalde. Bebeği kusuyor. Yani burada sadece ses dozunu takip edin. Anlamasanız bile ses tonundan hani stres
Ils
yönetimini
savent pas trop ce que
anlayacaksınız.
c'est. Madame, elle est consciente là actuellement?
Ben, elle ferme les yeux, elle ouvre les yeux.
Vous la trouvez fatiguée, c'est ça?
Oui, oui.
D'accord. Madame, je vais
Kaygısını
vous envoyer une
hissediyorsunuz.
ambulance et elle sera surveillée en pédiatrie. D'accord?
Oui, merci.
Voilà. Prenez-la contre vous, madame. Allez.
Oui,
Vous l'avez contre vous, là?
oui,
Voilà. Vous allez suivre sa respiration, tranquillement. D'accord?
oui,
Allez, vous sentez sa respiration?
oui,
Voilà. Elle respire comme il faut?
oui.
Voilà. Donc maintenant, vous allez vous synchroniser avec elle, respirer avec elle. Vous allez voir, si vous vous calmez, elle va se calmer. D'accord?
D'accord.
Voilà. Donc vous allez garder votre calme pour lui transmettre votre calme.
Oui,
Voilà. Ça va mieux?
oui.
Madame, les secours sont partis, hein. Ils vont arriver très vite. D'accord?
D'accord.
Soyez rassurés. Ok?
Oui.
Vous l'avez toujours contre vous?
Oui.
Voilà. Ressentez bien sa respiration. Prenez une grande inspiration, madame. Voilà, c'est bien. Très, très bien. Et vous allez ressentir votre bébé contre votre peau.
Oui.
Voilà. Vous voyez bien, regardez.
Tabii bir
Elle est-
acil
elle est
uzmanı
plus
olarak
sereine,
benim
elle pleure,
görevim,
c'est
çünkü
bien.
biz triyaj yapıyoruz
Voilà, madame,
112
c'est très, très
santralde.
bien.
Çocuğun iyi olduğunu
Continuez de
tabii
bien la garder contre vous, de
anlamak.
bien la ressentir contre
Çocuk
vous.
iyi, rahatlıyoruz.
Voilà. Ça va
Anneyi
mieux?
sakinleştiriyoruz gitgide.
Voilà, très bien.
Gördüğünüz
madame. C'est
gibi
très bien
bakın
ce que vous faites.
dediğim
Prenez-la
telkinleri
contre
direkt
vous,
dinliyor. Ne kadar
ressentez
derin
bien le
nefes
contact de
alıyor.
vos bras sur elle.
Derin nefes alıyorum, dibine kadar nefes alıyor.
D'accord? Très bien. Voilà.
Burada
Et
sadece
vous prenez
solunum
une inspiration
telkinleri
profonde,
veriyorum.
de plus en plus profonde. Voilà, c'est très bien. Très très bien.
Ses
Et
tonunu
vous allez
farkını
ressentir l'air
hissedebiliyor
qui
musunuz?
entre dans votre narine droite, profondément. Voilà, c'est très bien. Et l'air qui entre dans votre narine gauche, de la même manière peut-être, ou d'une manière différente. Voilà, c'est bien. Ça va mieux, madame?
Oui.
Voilà, c'est très très bien. Donc vous continuez de la garder contre vous et vous suivez votre respiration et la sienne, tranquillement. Et les secours arrivent très très vite. D'accord?
Ils arrivent, d'accord.
Ils sont déjà
Merci.
sur la route, madame. Soyez rassurée, votre gamine, elle va bien. Regardez, elle est calme. Et vous lui avez transmis votre calme, c'est très bien.
Merci.
Voilà, madame, c'est très très bien ce que vous
Bir
faites.
de bir
Continuez
merci
comme ça.
alıyoruz sonunda gördüğünüz
Allez,
gibi.
madame, au revoir.
Oui, ça va mieux. Au revoir.
Sonuna geldik herhalde. Teşekkür ederim. Soruları olan var mı? Zeynep hocam? Behçet hocam her zaman sorusu var. Buyurun. Sor sor.
Teşekkür ediyorum. Gerçekten çok istifade ettim. Daha önce de benzer bir şey bir yerde görmüştüm. Şöyle, şimdi Nazmine hocam bahsettiği şey gerçekten insanı bir alemden başka bir aleme götürmektir. Mesela bizim bildiğimiz işte buna işte görünür veya şehadet alemi, yani cismen yaşadığımız şey. Bunun dışında işte mana alemi var, hayal alemi var. Hayalde yaşıyoruz, uyku alemi
Evet,
var.
evet, tabii.
Uykuya giriyoruz. Halbuki her şeyimiz fizyolojik olarak çalışıyor. Ama biz başka şeyleri duymuyoruz. Misal alemi var. Böyle onlarca bu şekilde alem var. Ve insan bunu buradan buraya götürebiliyor. Şöyle bir şey söyleyeyim. Ya bir sözden su olur mu? Yani bir kelime söyleyeceğim, bu su olur mu? Oluyor. Mesela nasıl? Mesela örnek olarak hani Zeynep hocam bana kırılmayacağını bildiğim için ona ben şimdi kötü bir kelime söylesem hemen su olup gözyaşı akıtır, su olur. Kelimeden öfke oluyor mu? Evet, olabiliyor. Özlem hocama bir şey söylesem, desem ki mesela eşiniz artık sizi sevmiyormuş filan. Hemen değil mi bir öfke
Aman.
olur. Öyle şey, yani nazım geçtiği için onlara söylüyorum. İstersen şey söyleyeyim. Aynen bunun gibi kelime painkiller olabilir. Yani
Kesinlikle.
İşte buna işte isim konulmuş, hipnoz denilmiş. Yani kelimeden ağrı kesici ilaç olur. Kelimeden ağrı da olur. Kelime
Telkinler
söylerseniz
işte kullandığımız
kalbime dokunduruyor diyorsunuz. Tam kalbime indirdin. Hakeza kelimeden mutluluk olur. Kelimeden su da olur, gözyaşı da olur. Teşekkür ediyorum. İstifade ettiğim için paylaşmak istedim.
Evet Behçet hocam, katılıyorum size. Normal hayatımızda farkına varmadan zaten hipnoz uyguluyoruz. Ama tekniğini öğrenirseniz daha da etkili olursunuz. Gerçekten hani tavsiye ederim. Çok teşekkür ederim. Ben Başar Hoca'ya ayrıyeten ve takımına ayrıyeten teşekkür ediyorum bu davet için. Ve ayrıyeten Emre'ye de, Emre Tetik'e de çok ayrı teşekkür ediyorum. 7/24 gerçekten bütün sorularımıza cevap verdi. Her konuda yardımcı oldu bize. Gerçekten hepinize çok teşekkür ederim.
Affedersiniz, ben bir soru sorabilir miyim? Beni göremediniz arkada da. İsmim Doktor Alten Oskay. Bir kere hipnozun acilde kullanılabileceğine inananlardanım. Elinize sağlık, tebrik ederim.
Teşekkür ederim.
Bunun dışında galiba yurt dışında kullandınız. Türkiye'de hiç denediniz mi?
Tam anlamadım. Mikroyu yaparız. Yurt dışındası gerisini duymadım.
Türkiye'de kullandınız mı? Hipnozu acil serviste.
Şimdi ben yurt dışında çalıştığım için, yani Türkiye'de çalışmadığım için uygulamadım.
Peki aydınlatılmış onam gibi bir şeye ihtiyacınız var mı?
Hasta tarafından mı diyorsun?
Evet.
Şimdi bizim Fransa'da artık hipnoz herhangi bir onay istemiyor. Yani ben bazen anons ediyorum. Çünkü hipnoz, morfin gibi hipnoz yapacağım dediğiniz zaman morfin gibi etkisi oluyor. Hasta zaten hemen sizi dinlemeye başlıyor, etkileniyor. Mesela kalp hastası için vaktim oldu haber vermeye ama çocuk için yani anlamaz diye haber vermiyorum. Ya duruma göre ama yani resmi, legal olarak herhangi bir izne ihtiyacım yok. Onu o şekilde yani zararsız bir yöntem diye Fransa'da zaten kabul etti Fransız Tıp Akademisi.
Peki acil servisin ortasında uyguladığınız zaman özel bir odaya
Thank you very much, Hannah, for this very nice invitation. It's a privilege for me to be the first speaker of this huge Congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the powerful of emergency medicine worldwide. I really am happy to address this topic, and this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with Watson worldwide try to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound have totally changed our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers input some substance into the vessels of humans. And these skeletons are still there in Naples, one man and one woman. And you see, he put these injections, but unfortunately, patients died. But luckily now, we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have very clear opportunity to see the brain, the neck, the aorta, the chest, the gastrointestinal tract, and so on. But what is important? Not to abuse the technology, but to make the right decision. First of all, now, blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are linked here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really need to want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all these cases, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than the 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients. What about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important, frequent reason of patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patients can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients come in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have 3 possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have a presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MRS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal. The occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or culling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due on cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider two classifications. AAST, liver trauma classification, but also when you put together, let's say, the injury type, the grade, and injury description, you should also put one important, very, very important evaluation, the hemodynamic instability. So I would like to emphasize this important clinical judgment of hemodynamic instability, because if hemodynamic instability is present in the case of liver trauma, you can go a very severe lesion to WHS, ESIV, and go to operating room immediately after an angiography. So there is no doubt that also in the case of liver trauma, you can have a lot of possibility. And I think that this is going to be of a great importance also in other trauma. Now, you know, our neurosurgeons are very good and with the intervention radiology to make spinal arteriography. And in the case of spinal trauma, they are able also to make embolization of very small vessels of our spinal doors and resolve the issue. So now let's move to the last but very important topic, that is acute gastrointestinal bleeding. I'm sure you are fighting every day with a lot of geriatric people coming in, taking anticoagulants, even decumarol, or new anticoagulants that have a lot of bleeding, especially if they take decumarol because they are able to control INR. So there is a very important, again, the need for the emergency physician to assess the hemodynamic instability and then immediately to perform an upper endoscopy. If the endoscopy is negative, you can go to check the colonoscopy, but if it is not possible to be prepared because you need colonoscopy, you need preparation, that you really, then you can go immediately for angiography. That is really something that emphasizes the need to have angiography area where you can do a lot of important setting decision making. Now, what about embolization? I am sure this has been, during the last 10 years, the revolution in stopping bleeding. And you can see from these data coming from registry, you can see that in trauma, the overall success of embolization is around 100%. Amazing. Amazing. You can solve the issue in many trauma, and also in the case of gastrointestinal bleeding, both from upper or lower sides of the enterical system, you can have embolization that are going to save lives. So it's not only a problem of hemorrhagic situation, but also of ischemic. Acute mesenteric ischemia is another important situation where, again, starting with the clinical suspicion, you are going to look about the possibility to have acute mesenteric ischemia and then to do CT scan and angiography. And also, in this case, you can have arterial thrombus that you can find, and then you can open the vessel. So I think it's very, very important to make important decision where to move or not from non-invasive clinical assessment to angiography. It seems to me there is a lot of room to improve and to need of angiography in acute setting. Let's talk about the contraindications, last 2 minutes of my talk. I will address this important situation. Let me tell you that there are not really many contraindications in the case of need to perform angiography. You just need to make sure the blood pressure is quite controlled. You don't want to make sure that there is a renal insufficiency, so that the iodide contrast material is not going to deteriorate the damage, the function of the kidney. But thanks to the new quality of a new product, this issue is going to be very low. So in the future, my friends, we are going to have a lot of people, especially because life expectancy is worldwide increasing. And for a reason of that, we should, and also geriatric people, they have a lot of bleeding. We should really think about to increase our angiography performance into the emergency room. And these are my conclusions. After an initial clinical non-invasive technology evaluation, I put this in red, because it's the starting point. Please don't go immediately to angiography unless you have not made clinical judgment. In any case, it represents angiography a cornerstone in various clinical situations in the emergency department. It is also important because you are going to reduce the time of saving life and in hospital length of stay, so you can also save a cost. And in the future, I think it's very important that we are going to increase working together in the skills of angiography. But what do we need? We need research, data publishing, because like this consensus statement on academic emergency medicine pointed out a couple of years ago, in order to optimizing emergency department, the diagnostic imaging has the potential to improve the quality, safety, and outcome in the emergency department. Because also don't forget the radiation are potentially dangerous for your patients. You really want to vote for the right patients, and we need the data. So my final auspice will be to produce more data in this setting. And thank you again for giving my talk. So just in the last 20 seconds, how many of you now are happy to have an angiography service next day in your emergency department? Yeah, I think it's increasing. I was expecting more, but that's okay. It's coming from 15% to 30%. Not bad, actually, without our auspicious. So in any way, if you want really to contribute to our research, please come to Edinburgh or this biomarker, but last but not least, in San Diego, where we are working in implementing the geriatric emergency medicine, where I think angiography should be a big value. Thank you very much for your attention.
Thank you, Dr. De Soma. That was fantastic. At this time, are there any questions? I have a question for you.
Good.
That was a fantastic review of all the ways that we can use angiography in the emergency department in acute setting. It's not only diagnostic, but it's therapeutic as well. Do you see angiography at some point replacing the need for surgeons or surgery?
That is really the most important question. And I think, yes, this is the way we have to go together. To produce evidence, if you saw last slides, I was making the evidence that we have to compare the value in any kind of innovations in emergency department that are two objective, patient's outcome and cost related. So if we are going, as you said, to demonstrate that we can reduce surgeon length of stay and mortality due to therapeutic angiography, we are going to get the goal. And this is possible only with emergency physician skills in this topic.
Now, how many people want angiography in their emergency department?
I want. Thank you.
Okay, I want to invite with my pleasure. He is chairman of from Stanford University, chairman of Emergency Medicine Department, and he's very popular in Turkey, if you remember from last Congress. And I think he has very excellent textbook of emergency medicine in United States. He will talk about retrograde intubation. Mr. Mahadevan, with my pleasure.
Good afternoon to everyone. How are you? Good, good. It's great to be here. Instead of retrograde intubation, I spoke with Dr. Chandler about talking about video laryngoscopy, so I'm going to focus on that today. And first, oops. Let's just do one thing. Okay, good. Let's try again now. There we go. Sorry. Okay. Just want to show you where I'm from. I'm from Stanford University, which is in the United States, in California. So yesterday, approximately yesterday, 24 hours ago, my wife and I were there at that star right here. And now we're obviously in beautiful Antalya. And I just want to say this is my 5th visit to Turkey, and love it here. I've been to Istanbul, Kayseri, Izmir, Konya, Çatalhöyük, and now this is my 2nd visit to Antalya, and I had the pleasure of attending a prior Congress, also getting to sing on stage. Hopefully I don't do that today and scare everyone away, and spend time with Bashar, which is always fantastic. In my talk today on video laryngoscopy, I'm going to define what it is. I'm going to talk about the different classes, the different kinds of video laryngoscopes, the advantages and disadvantages of this new device, and then most importantly, the current literature about video laryngoscopy and how it's maybe taking over how we approach airways. Very quickly, show of hands, how many of you are using video laryngoscopes in your department? Okay, fantastic. So quickly, with regards to the definition, video laryngoscopy is indirect laryngoscopy, which means you're not looking directly at the cords, that you're using a digital device, a digital laryngoscope, to show you the vocal cords in the glottis instead of line of sight. And generally, for what we need them for, acute intubations, we're inserting these devices intraorally. And why would we need to do this? Well, our goal is to see the glottis, and that hopefully will help us improve our success with intubation. And ultimately, we want fewer failed intubations. Obviously, we want to reduce our failure rate. So there are 3 big classes of video laryngoscopes. The first is the channeled video laryngoscope, where the endotracheal tube is part of the device or is inserted into the device, and this matches the anatomic curve of your pharynx and allows you to direct it towards the larynx. But unlike the other approaches where you are manipulating the endotracheal tube separately, this is all one device. So want to adjust where the endotracheal tube is, you have to adjust the device. And so the other issue with this, as you can see, is it's bulkier. It's larger than some of the other devices. And so if you have someone with a small mouth, it may be difficult to insert it. The next device I want to describe is something called a Macintosh-style video laryngoscope, where the technique is similar to what we're doing with direct laryngoscopy. And in fact, you could either use the video or do direct laryngoscopy. And for this reason, since everyone in the room can see what's going on and you can give advice, it's great for teaching and training institutions. And then finally, the glide scope or glide scope-like devices are acute angle blade video laryngoscopes, where they're really good at showing you the very anterior structures, but if it fails for whatever reason, you cannot convert to direct laryngoscopy where you can see the cord. So let's take a look at this. A glide scope-like device inserted into the pharynx, and then you're looking at the monitor, you're looking at the screen when you're inserting the endotracheal tube, and so you're looking at the monitor but performing the function in the patient's pharynx. So what are the advantages of this approach, video laryngoscopy? Well, first of all, we always struggle when we're doing direct laryngoscopy to line these three axes. There's the oral axis, the pharyngeal axis, and the laryngeal axis. And if you look at this diagram, what you can see is that it's impossible for us to see like this. We have that line of sight. And so what we do is we try and get the patient into the sniffing position, as you can see here, and then by using the direct laryngoscopy and just raising their soft tissues, we achieve line of sight. And sometimes it can be very difficult, as you know, to see the glottis. And especially in patients like this. This is a trauma victim where you're not allowed to get the patient into the sniffing position because you're keeping them in the neutral position. And that makes it very difficult to align these axes. And in this particular case, the patient couldn't be intubated with the video or with the direct laryngoscopy. The other advantage in trauma patients specifically is the video laryngoscope can be inserted and manipulated in a way where you don't have to move the patient's head and potentially cause injury. Here's an example of a patient with an inferior anterior C2 fracture, but if we look at their cervical alignment, it's normal. So the spinal cord at this point is doing just fine. But what happens when you try to intubate the patient and you put them in the sniffing position? As you can see, this patient has a complete disruption of the ligaments holding the vertebral column together, and now the bones have moved and impacted potentially the area where the spinal cord is. So the last thing that we want to do is move the patient's vertebral column and potentially cause injury, which could happen in theory with direct laryngoscopy. And then finally, we're looking at a very narrow, small area and trying to insert an endotracheal tube through that area. Well, what if we were able to enlarge it, make it easier to see? And also, more importantly, as a teaching physician, that not only I could see what was going on, but everybody in the room could have confidence that this was being done properly or that we could assist. So those are the advantages of video laryngoscopy. What are some disadvantages? Well, if there's secretions or blood and it gets on the end of the scope, potentially you wouldn't be able to see. Or if the device fails for some reason and that's the only way, that might be an issue. There are a lot of different kinds of devices, so you have to be familiar with all of them, and we're not sure which ones really are the best. And there's no real evidence to tell us this is the best one at this time. And the technique for insertion is different than what we're used to. And it may be more challenging, just in the same way that if I play video games with my son, he's going to beat me every time because I'm not used to playing video games. Learning how to do a new approach may be challenging because you're not doing it under direct visualization. You're holding the device and then trying to look at a screen and perform the technique. And a number of studies have shown that when you're doing it indirectly, it can be more challenging. So now let's go over 5 important studies that might change the way that you think about video laryngoscopy as part of emergency medicine. And the first one to bring a lot of sort of attention to this was this systematic review, Cochrane review, that was done in 2016. This Cochrane review wasn't specifically focused on emergency physicians or critical care physicians, but looking in general at comparing direct laryngoscopy to video laryngoscopy. So they looked at a lot of studies, 64, 7,000 plus adult patients, but again, mostly in the operating theater and not in emergency settings. They compared different kinds of video laryngoscopy to direct laryngoscopy using a Mac blade. And here are the primary findings of the study. There were fewer failed intubations with video laryngoscopy, and this was statistically significant. When dealing with difficult airways, there were fewer failed intubations with video laryngoscopy. And then when they compared the incidence of hypoxemia, it was similar between the two. So, major headlines, bottom line from this large Cochrane review: fewer failed intubations overall, fewer failed intubations when dealing with difficult airways. Next, we decided, since that was a focus on all comers and primarily the operating rooms or operating theaters, what about for those of us that practice outside of the operating room? Well, this systematic review and meta-analysis looked just at those places. So this was 32 studies with over 15,000 intubations. And you can see that there were about 6,300 video intubations and 8,700 direct laryngoscopic intubations. And these studies were outside of the operating theater, outside of the operating room. So they were in the pre-hospital setting. They were in the ICU. They were in the emergency department, places that we practice. And again, they used different kinds of video laryngoscopes as opposed to just one kind, and multiple kinds of providers. So there were beginners, there were experts, there were paramedics, there were emergency physicians, there were ICU doctors. So a whole mix of different kinds of providers. And what they were interested in is, how often do you succeed intubating the patient the first time that you try? So let's take a look and see what they found. With regards to first pass intubation, there was no overall difference in this study between video laryngoscopy and direct laryngoscopy. However, if you were in the ICU, video laryngoscopes were better, but if you were in the emergency department or pre-hospital area, they were similar. What about the glide scope, which is one kind of video laryngoscope, and direct laryngoscopy? Well, they were similar. But when the CMAC, a specific kind of video laryngoscope that allows both direct and indirect laryngoscopy, was compared to direct laryngoscopy, it was better in terms of getting that first pass intubation. If you were a novice or a trainee, video laryngoscopes were better. But if you were experienced or a paramedic, it was the same. And then with video laryngoscopy, there were fewer esophageal intubations and more arterial hypotension. So what are the big takeaways from this study of non-operating theater, of emergency situations, ICUs, emergency departments, pre-hospital? Well, if you're in an ICU, video laryngoscopy was better. CMAC was better than direct laryngoscopy overall. And that if you were a novice or a trainee, that video laryngoscopy was better, and that there were fewer esophageal intubations. One of the themes that you're seeing here is that in many cases, in different facets, it's better, but it's never worse. And that's a very important thing as we move forward. Finally, I want to look at a study that it was a systematic review and another meta-analysis, but this time they looked at difficult airways and experienced providers. So most of you are experienced providers, and all of us that practice emergency medicine have had a difficult airway. And one of the things I think we can all tell you is, though we try and figure out who might have a difficult airway, sometimes it's very difficult to predict. And in this study, published in Anesthesia in 2015, of patients going to the operating room, the anesthetist could not predict a difficult intubation 93% of the time. They could not predict a difficult patient to mass ventilate 94% of the time, which tells us all of those tools and rules that we have don't work very well, and that any intubation could be a difficult intubation or a difficult airway. So in this study, which looked at experts in difficult airways, how did video laryngoscopy do? Well, it was better for first attempt at success, and you can see on average, when using a video laryngoscope, 95% of the time you were successful the first time versus 86% with direct laryngoscopy. And you got better views of the glottis and less trauma to the airway overall. So again, the take-homes, we're talking about experienced providers, difficult airways, and video laryngoscopy perform better. So it begs the question, this was an editorial that was in the British Journal of Anesthesia, about whether we should be using video laryngoscopy as the first approach all the time. And here's the analogy that they used. They basically said, how many of you still have a huge bulky cell phone like you did in 1995? None of us, right? We're all using some kind of iPhone or new phone equivalent, and none of us are using dial-up phones either. So as technology progresses, why are we relying on old technology when new technology is potentially superior? And they went one step further. They said it should be used on every intubation, and that we should record the video and put it in the medical record so that if the patient ever came back, they could review the video and determine if there was an airway problem or not. Two more studies to review before I finish. This is a group of anesthesiologists that decided to replace all of their direct laryngoscopy with video laryngoscopy. So I'm going to show you what happened. First, they assessed all of their team about their attitudes towards video laryngoscopy. And then for 2 months, they removed all the Mac blades from their operating room and from the places where they worked, and they only had CMAX there, okay? Which CMAX, where you can do video laryngoscopy and direct laryngoscopy if you needed to. And then they did serial assessments over a course of time to see what attitudes were by the anesthesiologists towards video laryngoscopy. So here's what they found. When they started, about a third, and a third either said we fully support only video laryngoscopes, or we have some reservations, or some people said they don't support it. At the end of the trial, the 2 months of just using video laryngoscopes, there were fewer people that didn't support, but it certainly didn't have unanimous support. 6 months later, you can see a lot more of the anesthesiologists supported it. And then 18 months later, uniformly, everybody in their department supported having only video laryngoscopy. And the reason that they said was they felt it was better for patient safety, team dynamics, human factors, quality of care, and quality of training. So they changed after being forced to use them for a period of time. Their attitudes totally changed. And for many of us, it's the same. We're so used to direct laryngoscopy, we don't want to change, even though it might be good for us. And the last study I want to show you is one that's done in the pre-hospital setting, where they looked at a protocol where they used the CMAC, again, this video laryngoscope, and a bougie in all rapid sequence intubations. And so this was done in Finland, where for a period of time, they said you're going to use video laryngoscopy and a bougie, in particular it was a Frova introducer for all intubations. And then they compared that 22 months where they were doing that to the year before where you were able to do direct laryngoscopy. And here's what they found. Before using video laryngoscopy and the bougie, the first pass success rate was 85.7%. After being forced to use this protocol, using the bougie and the video laryngoscope, it increased to 98.2%. And think about it, intubating, doing RSI in a helicopter is a difficult airway situation. And here they went all the way up to 98%. And it begs the question, we always think of video laryngoscopy as a rescue device or difficult airway device, but what if we used it routinely? What if we used difficult airway devices routinely? We can see that we would have an increased success rate, which we all want, and that, again, a bougie may be easier to pass with a video laryngoscope than an endotracheal tube. So a couple of takeaways from this study. So finally, what do we know? What's the bottom line? What can we say about video laryngoscopy? It improves the view of the glottis. It may improve first attempt intubation success rate. Remember the study I reviewed from Peters et al., 95% success rate with video laryngoscopy compared to 86% for direct laryngoscopy. The Cochrane review found that it may reduce the number of failed intubations. Again, fewer failed intubations when for overall and also when dealing with difficult airways. We know that it's already become part of our difficult airway algorithm, but it may be the primary approach for all intubations in the near future. And if you're using a device like I like, and I don't have any ties or affiliations with stores or the CMAC, but a device like CMAC, which allows you both direct and video laryngoscopy, is a device that might allow you to embrace the future without abandoning the past. And so those are my big takeaways about video laryngoscopy. And I want to thank you for your attention. Thank you very much.
Thank you very much, Dr. Madhavan, for fantastic presentation. Any comment or question? Yes, please.
First of all, welcome to Turkey and thank you for your presentation. I want to ask that I work in a hospital where approximately 1,000 patients apply per day. And I think that means that we manage disaster every day. And in my country, there are so many centers. While we are examining the cold or myalgia, on the other side, we may need to intubate the patients. And I think it's more difficult about us. What do you think about the practicality of this process in crowded emergency departments? Thank you.
Thank you for your question. I believe the question is that in settings where maybe you have less experienced providers, yet are crowded, what about having a device like this in those settings? And I think, you know, it's, as the studies pointed out, those who are less experienced with intubating actually showed the greatest benefit in first pass success. And so it probably behooves us, if you're intubating all the time, you might have some expertise, but if it's an infrequent procedure, having a video laryngoscope might be of benefit, especially if you're doing it infrequently. But the other study I showed also revealed that even in experienced hands, it's hard to know when we're going to encounter a difficult airway. So rather than take a chance, my feeling is that we are progressing towards where we'll be using this exclusively, and that direct laryngoscopy will be something of the past.
Okay, thank you very much. Any another question?
Yeah, here, yeah.
Okay.
No, Basar, I have a question.
Okay.
Thank you very much for this nice presentation. And it's clear we have the evidence for using this kind of tools. My question is, do you have information about the cost? You know, if you compare CMAC to the direct, laryngoscopy, this is very important, for different countries in the world.
So the question was a very good one, which is it fiscally responsible to replace a device that may be working with something that may be more expensive? There's two ways of looking at it. If you already are adding a device like a CMAC as a rescue device, then you're already purchasing it anyway in addition to the direct laryngoscopes. And the other one is more philosophical, which is that if your complication rate goes down and you have one less patient who has anoxia as a result of a difficult airway encounter, and the hospital isn't sued or doesn't lose money as a result, or the family doesn't lose money as a result, then that could justify, that cost savings from fewer complications could easily justify the cost difference between a laryngoscope and a video laryngoscope.
Okay, thank you very much. Last question, please. Last question. Yes.
And thank you very much for your presentation. I will ask, you said that some kind of video laryngoscopy is better than direct laryngoscopy in difficult intubation. But was it expected difficult intubation or unexpected, or was it well-designed criteria?
In the study that I presented, it was anesthesiologists who predicted a difficult airway based on patient characteristics or prior knowledge. And in that case, video laryngoscopy was more effective, even though they were experienced. But there was one study that I presented also that just shows we are not good at figuring out who is going to be a difficult intubation or difficult mass ventilation. And that's the problem. If we could just look at them and say, oh, you've got a beard or you've got a short neck, you're going to be a problem. But we've all encountered somebody that we're really worried about, and then we go in and it's an easy intubation. And we've also had patients where we say, oh, they've got a long neck, it's going to be fine, and then you go to try and intubate, and it's much more challenging. And so it's just, we don't have good tools. And we should just, basically, my feeling is approach every patient like they're going to be a difficult intubation. Thank you again for your question, and thank you for your attention. Thank you. Thank you.
The next speaker, very important topic for emergency medicine, new topic. Reboa in ED, Dr. Yosuke Matsumura from Japan. Thank you.
Haikese I Gunda. Benim adim Yosuke Matsumura, Japonia'dan geldim. I'm an emergency medicine physician, and I also cover the ICU. And my another subspecialization is endovascular therapy. I cover the interventional radiology and, of course, REBOR, and I also love to perform ECMO. So I am very interested to be here. Thank you for having me. So here's my disclosure. So let me introduce some REBOR practice in Japan. So this is the procedure video. The first thing you need to do is get the access. The access at the common femoral artery. You need to puncture between inguinal ligament and bifurcation. Of course, you should use ultrasound routinely. You can see the bifurcation directly. And you advance the guide wire to the aorta. Then remove the needle and insert the arterial sheath over the guide wire. Then you can put the REBOR over the guide wire. In this setting, the balloon is going up to zone 1. And next step, you need to exchange the guide wire for a stiff wire. This stiff wire will strengthen the shaft of the catheter. Then, then you can inflate the balloon. So by the way, the term REBOR was published in Journal of Trauma in 2011. But in Japan, We start to use Reboa catheter in 1998. So we have a very long history. Oh, sorry. But unfortunately, we didn't publish a lot of research paper in this field. 2003, 2009, 2015. Sorry about such long silence. Only small case series were published from Japan until 2015. But in this year, one case series was published in Journal of Trauma. The title is Safety and Feasibility. But I need to give a question to this paper because they reported the rate of lower limb amputation at over 20%. Surprising number. Next year, another paper was published. This is a database analysis using a propensity score match analysis. And they reported higher in-hospital mortality in Reboa group. This is negative data from Japan. A similar study was published very recently in JAMA surgery from the United States. This is again propensity score matching. And they reported higher rate of AKI, amputation, and high 24-hour mortality in Reboa group. So lower limb amputation. These two studies, the research period was before 7 French Reboa device. In the United States, they used to use 12 French, and in Japan, we used to use 10 French catheter. But now, we have 7 French small profile Reboa catheter. So probably this problem can be solved with such small profile catheter. This is our publication. So we demonstrated the fewer complications in small sheaths. We didn't require any fasciotomy, amputation, or PTA. But what about higher mortality? How should we use Reboa? One possible answer is here, algorithm. This is the classical algorithm suggested by Shock Trauma Center in the United States. And this is another algorithm from the Denver. This is another algorithm presented in the Western Trauma Association. How many Reboa algorithms do we have to learn? I hate to memorize many things. I believe to learn trauma strategy is more important to learn algorithm. So this is the summary of today's my talk. The first is thoracotomy plus Reboa can be the good solution in a critically ill patient. And second is early access, undelayed but short occlusion. These are the key issues for the successful management of Reboa. And third, I'm going to mention the education and research briefly. So let me introduce our recent case. 17-year-old boy, he fell from 11th story of the building. Actually, he jumped from the building. He collapsed 5 minutes before arrival, and CPR was initiated by the EMT. So first, we performed resuscitative thoracotomy and LD cross clamp. And he was resuscitated after 8 minutes of the CPR, and chest X-ray didn't show any significant injury. And the fast exam was negative, and pelvis showed the fracture. So I identified the cause of the shock was here. So we got bilateral arterial access and the large venous access, and the massive transfusion was initiated. Then the fast turned positive at right upper quadrant. So I decided to go to laparotomy first. Can you see this picture? Before going to the operating room, we converted thoracotomy to zone 1 Reboa. And the patient was transported with partial Reboa. And in the operation room, we could defrate the Reboa within 20 minutes. And the surgeon found a liver injury. But it was not so severe, and fortunately, no other organ injury was found. Instead, retroperitoneal hematoma was expanding rapidly, and so the surgeon simply performed perihepatic packing, and abdomen was left open. And next, this is my turn. I embolized bilateral internal iliac artery approximately within 10 minutes. And now, we didn't see an apparent extravasation in this patient. Now we scanned the patient, but we found a chest wall bleeding. So we reclosed the chest wall in the ICU. So first, the thoracotomy plus rebore. So we performed thoracotomy first, then converted rebore. So this is a comparison between thoracotomy and rebore. The thoracotomy is absolutely more speedy and definite, but we need to make new chest wound, and sometimes the chest wall bleeding is significant, and thoracotomy may induce hypothermia. The rebore is less invasive and adjustable, but we need to puncture the common femoral artery. Sometimes this is troublesome, and the patient has a leg ischemia. So this, in Japanese educational course, we suggest this strategy. If the patient is impending cardiac arrest, or if the patient doesn't have arterial access, don't hesitate to do thoracotomy. But if the patient is shock but not cardiac arrest, and the patient has the arterial access, consider the rebore. This is a comparison between thoracotomy versus rebore. So one study showed the benefit in rebore, and the other did not. This is a study from the United States. They concluded rebore has a benefit in selected patient. What is a select patient? It means no CPR, but hypotension at arrival. But do we have to compare thoracotomy versus rebore? My answer is no. We can perform these two aortic occlusion methods in one patient. I know thoracotomy is not strongly recommended in pulseless blunt trauma patient. And of the 106 trauma rebore patients, we experienced 30 thoracotomy plus rebore population. And of these, 6 patients survived. And interestingly, all of them received CPR before rebore. It means thoracotomy plus rebore may give a chance even in a pulseless blunt trauma patient. Theoretically speaking, conversion prevents hypothermia, and closing the chest may prevent the chest wall bleeding. The second, the early access. So we obtained arterial access simultaneously with a thoracotomy. So we got bilateral arterial access. In the top stent textbook, this was published by the EVTM Society, the guys with the Swedish or European guys, and we suggested AABCDE concept. What is AA? Airway and access come first. Of course, there are some disadvantages in arterial access, such as the vascular injury or hematoma, but delayed access can lead to more significant catastrophe, like less palpable cardiac arrest, more hematoma. So I investigated the benefit in arterial access in rebore patient. So I analyzed 109 rebore patients, and naturally, in non-survivors, presented a higher ISS and lower SBP, pre-occlusion, lower SBP, and longer total duration of occlusion. And non-survivor showed longer arrival to access. The survivor got access earlier. So I performed a binary logistic regression analysis, and the result showed arrival access time was significantly associated with the survival outcome. The odds ratio or the ratio of 0.989 seems small number, but this is every minute. So if the access delay is 10 minutes, the patient's survival rate decreased 10%. This is a big number. And then I defined the cutoff value about 20 minutes. In early access group, they showed significantly better survival curve. So I believe there is a benefit of early access in Riboa patient. And next, the undelayed but short occlusion. We could deflate the balloon within 20 minutes. So how long can we occlude? This question is very good but difficult to answer. So I couldn't answer this in a good answer, but the survivor shows the pre-occlusion pressure of 70, and survivor shows total duration of occlusion of 30 minutes. So this is not the cutoff value, but undelayed but shorter occlusion can be will lead the successful management. So there is a different trauma system in the world. So let's compare Japan, Turkey, and the United States. So I found a lot of similarity between Japan and Turkey. For example, I'm an emergency medicine, and we are responsible for the resuscitation of the patient. But in the United States, the statement recommend acute care surgeon or vascular surgeon should perform the rebore. But in Japan, we, emergency medicine, perform rebore. So in my mind, resuscitation must not be delayed, so first responder should perform rebore. So in this country, this is you should perform rebore. Because emergency medicine, we have the good friend, ultrasound. We can see the bifurcation of the conifemoral artery, and we can see the guide wire in the aorta. This can lead to a safe procedure. And next, the patient population and the mechanism of injury. We have a lot of geriatric population. So we often have the coagulopathy, and we often have such tortuous aorta. So you may encounter such difficult patient. So that is why education is very important. So regarding the education, the endovascular workshop is the key education, key occasion. And there are several endovascular workshops in the world. We start the DIRECT Society. DIRECT means Diagnostic and Interventional Radiology in Emergency and Critical Care and Trauma. We start a workshop in 2011, and we create a program including such a simulation or a 3D vessel model. Sometimes we use live animals, sometimes we use cadaver. This is zone 1 occlusion, this is a zone 3 occlusion. And in the United States, from 2013, the BEST course, the Basic Endovascular Skills for Trauma, started in the US. The shock trauma is the center for the BEST course, and I've been working as a visiting researcher here. So I supported the course. And from 2014, in Sweden, the EVTM, the Endovascular Resuscitation and Trauma Management workshop, started. I met the Turkish colleague here, Dr. Acil, Dr. Uzleb here. And in the UK, from 2016, and they are teaching to the emergency medicine and the paramedics. This is a very unique system. And last year, South Korea started the similar course. Then finally, I will mention the research briefly. Rebora seems very useful tool, but don't forget, we have negative data from Japan and from the United States. I found some limitation in this study. The higher AKI, higher amputation, higher 24-hour mortality. So I wrote the letter to the editor, to the editorial office. Looking at the table in detail, the reward group shows the SBP of 109 and GCS was 14. The patients are too stable. And this is the comparison between survivor versus non-survivor. The survivor patient showed SBP 140 and GCS 15 and head AIS 0. So probably, the survivor received only 1 unit of transfusion of red blood cell, plasma, and platelet. So the patients were too stable to require reward. Probably in the United States, they are overusing reward. So this suggests unnecessary reward placement in a stable population, and it induced the unnecessary complication. And then they didn't consider the physiological derangement, so resuscitation time bias might decrease, may happen. So ideally, time-dependent propensity score matching should be performed. So we are going to start the international prospective observational study in the very, very future. So in conclusion, first, the thoracotomy plus reward that may give a chance in blunt cardiac arrest. And early access and delayed but shorter occlusion, these are the key issues for the successful management. And education and research, it means endovascular workshop and international multi-center study, these are required. So let's proceed education and research together. İlgini için teşekkür ederim.
Any questions from the audience? Yes. 1 second, the microphone's coming.
Congratulations, that's been a great talk. I have a couple of questions just on the base of your results. And first of all, I agree 100% what you said about the need of more data, multinational study, and also this allow me to emphasize the importance of angiography into the emergency room. One question would be, in your experience, you are using a less dimension French catheter. That is going to be less occlusive, and then is ameliorating acute kidney damage and limb acute ischemia. But on the other side, I assume that is going also to not reduce too much the hemorrhages. So this is the reason why you are taking 10 minutes. Assuming that I'm not going to take a TC scan that is actually mandatory in polytrauma patients, I will use echo. I think there is other solution that I know that is the cardiosurgery used today. They put a hole in the way that is the catheter make occlusion, but another part of a catheter is going to give blood. So I think the technology, we should together to think about the different catheter they use in cardiosurgery. Because I don't like the idea to use too much my question is, how much is the bleeding in your less French dimension catheter compared to occlusive one?
Bleeding from where? Bleeding from the organ or bleeding from the...
I mean, using a less French dimension, you have more bleedings, right? Because you are not making occlusion.
No. Oh, even in the small profile catheter, the balloon can occlude the aorta completely.
So which is the value?
Yes. So, but as I mentioned before, the small shaft, sometimes the balloon can migrate downstream, but the balloon can occlude the aortic flow completely. The balloon sizes are same.
Okay, understand. And then what about the opening another hole downstairs?
Yeah, that can be a good idea. We often use in
We are using that.
Yeah, but this is technically difficult. So we need to the skilled surgeon and ultrasound, hopefully in the fluoroscopy.
I agree. Thank you very much. Any another question or comment? Okay, I want to announce after last topic, we have very fantastic opening ceremony. It was to join all to this fantastic. I think never seen like this opening ceremony till this time. So, and after the opening ceremony, we give book for everybody. Okay. Thank you very much. You can continue. Yes. Yes.
Next, I'd like to introduce Mujahid Acil.
Bu alttaki yazıları görebilir miyim? Okay. Hello, everyone. It's a great pleasure to be here with you today. We have seen excellent presentation about the future of the emergency medicine. The last presentation is about Reboa and EVTM. In Turkey, EVTM concept started in 2018. I hope it will be lead to use angiography in emergency medicine. Dear Dr. Talhörer, he is not here today, and our friend Dr. Yasuka Motsumuro helped us so much for EVTM concept. Also, I would like to thank Dr. Jander for supporting us in the learning of this concept. Here is some problem, I think. I can't control this. Evet. Geçiş yapamıyorum.
Beyler bir sonraki slayta geçebilir misiniz mi? Tamam, bir deneyin hocam.
Sona attı. Home. En başa gelmeniz lazım.
Kaç? Hemen bir en başına. Tamam hocam.
Evet.
Tamam, buyurun hocam.
Bununla mı?
Onunla da yapabilirsiniz, öbür videoda.
Tamam.
Tamam, nasıl harcayın?
Okay. Sorry about it. ECMO can be used in many different situations in the emergency room, especially in case of cardiac arrest. Its use has become widely accepted and widespread in the world. In addition, ERDC and cardiogenic shock due to intoxication and pre-arrest conditions such as pulmonary embolism are other indications in the emergency department. Resuscitation is one of the priorities of emergency medicine. In spite of all efforts, it's not possible to achieve satisfactory results in conventional CPR. Survival of both in-hospital cardiac arrest and out-of-hospital cardiac arrest treated with conventional cardiopulmonary resuscitation is very low, estimated at 20 and 10% respectively. Use of eCPR can restore perfusion more rapidly and can prevent mediator storm. Recent meta-analysis of 6 trials containing 2,200 patients concluded that eCPR improved both survival and long-term neurologic outcome. Here are the results. Here are some observational studies about eCPR. First one is from ELSO registry. 270 patients were included in the study. Percutaneous cannulation rate was 70%. One-third of the patients underwent coronary intervention. Median duration of ECMO was 47 hours. Overall survival rate was 27%. The second study is from Canadian ECLS organization registry, and nearly 3,000 adult patients, cardiac arrest over than 15 minutes duration and not responding to conventional treatment was included in the study. Okay. The third study was systematic review of adults with refractory out-of-hospital cardiac arrest. Survival rate was 22. Refractory circulatory shock and severe ERDC, which occur in poisoned patients, is still a challenge to treat. Hypoxemia from ERDC results in multiple organ failure, which is incompatible with life. ERDC is still a severe lung disease with a high associated mortality rate. In the most severe forms of the disease, mortality rate may exceed 60%. First successful clinical application of ECMO for ERDC was described in 1972. Until 2008, only 100 patients per year in which ECMO was used for ERDC. Following the influenza A pandemic in 2009, there has been a significant increase in VVA ECMO utilization. In the last 5 years, more than 400 cases per year of VVA ECMO for adult respiratory failure have been reported in the ILSO registry. Now let's look at the VVA ECMO studies. First one is EOLIA. Randomly assigned 249 ERDC patients included the study. They compared conventional therapy to VVA ECMO therapy. There was 11% lower mortality rate in ECMO group, but not statistically significant. The study was terminated because the analysis could not reach the expected mortality decrease rate of 20%. The second trial is CESAR trial. ECMO significantly increased survival without disability at 6 months compared to conventional management. This is a very good study for ECMO, but there is some limitations. There is a lot of patient crossover the ECMO group. Okay, case from Turkey. This is a patient who had ECMO therapy in my clinic. He was found unconscious in bathroom. He was diagnosed with major depression and has a history of psychiatric medication use. He was suspected of having a large amount of medication from his own drugs. The benzodiazepines was positive in the urine drug tests. So we administered flumazenil, but he did not respond. After that, lipid emulsion therapy was started due to worsening condition. Patient did not respond to lipid therapy either, and therefore the patient was intubated. On the second day, hypoxia occurred, and despite the low volume protocol, hypoxemia worsened. On the third day of his admission, the patient was diagnosed with ERDC due to severe hypoxemia and radiologic findings. Then patient connected to ECMO. ERDC may be occurred due to the drugs, or it may be developed due to our lipid therapy. I need help again.
Evet. Tamam. Buyurun. Çekiyorum.
This is a short video from the cannulation process of this patient. In case of intoxication, VA ECMO is usually required due to cardiogenic shock. Our patient was a ERDC case, but we use VA ECMO, not VV ECMO, because we worried about hemodynamic of patient will deteriorate in following days.
Bu klempler verir mi? Klemp yerini görmüyorum.
Anlayamıyor şu an.
Nasıl sağlık yok?
Okay. Pulmonary embolism is an important cause of death in the emergency department, as you know. There are very few centers in Turkey that are able to make thrombectomy, and they are not available 24/7. Thrombolytics are the only treatment option in the cardiogenic shock and arrest due to pulmonary embolism. ECMO can provide support to patient until the clot dissolves or until the thrombectomy is performed. Yusuf and colleagues published a review of the reported case of the pulmonary emboli managed with VA ECMO. A total of 78 patients were reported. Half of them had a cardiac arrest. Overall survival rate was 70%. For patients who presented with cardiac arrest has a survival rate of nearly 50% compared with historical rate as high as 75%. Now, I want to talk a little bit about the ECMO process because the emergency staff is new in this area and there are important points to consider. ECMO is a risky and expensive procedure. Criteria for the initiation of ECMO include acute severe cardiac or pulmonary failure that is potentially reversible and unresponsive to conventional management. Peripheral cannulation is performed either percutaneously or by vascular cut-down. Ultrasound guidance is mandatory. Advantages of percutaneous cannulation include decreased bleeding and infection risk. Percutaneous cannulation is more suitable for emergency physicians, but emergency physicians should also know about the cut-down method in order to apply them when things process go wrong. Many physicians prefer the right femoral area, both artery and vein cannulation for VA ECMO. And for VV ECMO, right or left femoral vein and right jugular vein preferred. Sometimes an extra second venous drainage may be required to increase the amount of the blood in severely hypoxemic patients. Maintaining optimum blood stream is the most important and difficult part of the process. Blood stream is affected by cannula dimension, body fluid volume, and resistance to reinfusing current. The revolution of the pump is defined by per minute RPM. If you increase RPM, the blood flow and also blood pressure increase, but it causes negative pressure at the venous tip. High levels of pressure cause erythrocyte trauma. Another important part of the ECMO is anticoagulation process. Heparin is used for this purpose. If the heparin is contraindicated, direct thrombin inhibitors can be used. Platelet counts tends to decrease, so we should follow them, and the circuit should be observed for thrombus. When we are taking weaning decision, we have to see improvement in radiographic appearance, pulmonary compliance, arterial oxyhemoglobin saturation, and ventricular output. Then we can go to weaning trial step. In weaning trial step, for VV ECMO, it performed by elimination gas transfer and while maintaining the blood flow. For VA ECMO, it performed by clamping both drainage and infusion lines. The patient must follow at least 6 hours, then we can consider to decannulate. Severe bleeding from arterial site is the main problem in the decannulation step. For VA ECMO, at least 30 minutes of compression is required. Also, vascular closure devices can be used. Bleeding occurs in 30 to 50% of the patients who receive ECMO, and it can be life-threatening. On the other hand, systemic thromboembolism can be occur as high as 16%. We should know about managing serial arterial bleedings. We must have experience bypassing the leg to ensure blood supply. We should know what is special conditions such as left ventricle decompression, such as coronary and cerebral hypoxia, and etc. Lots of things. The priority of ECMO is eCPR in emergency practice. ECMO can also be used in the ERDC and cardiogenic shock, particularly which caused intoxication, post-restorative syndrome, and acute coronary syndrome, and pulmonary embolism. Emergency medicine professionals should know which patients can benefit from ECMO. ECMO management requires a trained and experienced team. Okay, at the end of my presentation, there's a question here. This one or this one, which would you like to have? Yes, I know your answer. Last words, in many diseases, the patient should be kept in life until the treatment heals the patient or until the body overcomes it. Many patients die because they cannot exceed this critical threshold. We must help the patients to overcome this threshold, and ECMO can do it for us. Of course, it is not an elixir of immortality. We just had a new bunker to survive until attack ended. The first thing we need today is to reduce the costs of ECMO, because ECMO costs are not only our problem, but also the problem of developed countries. In the future, we need a device that's smaller, more practical, and easier to manage. Okay, thank you.
Thank you very much, Dr. Mujahid. Yes, ECMO plays in the future of emergency medicine. Any question or comment? Okay, thank you.
Thank you very much.
Sorry? Okay, thank you very much. After 10 minutes, we will start opening ceremony. Arkadaşlar 10 dakika sonra burada toplanalım. Açılış töreninde herkesin burada olmasını istiyoruz. Gerçekten çok özel bir tören hazırlamış durumdayız. Şimdiye kadar gördüğünüz törenlere benzemiyor. Bu törene katılan arkadaşların hepsinin zaten isimleri de burada belli. Onlara da kitap hediye edeceğiz. Onun için hepinizi burada bekliyoruz. 10 dakika sonra. 10 dakika sonra buradayız.
This year Congress is another scientific feast with more than 75 foreigner participants from more than 43 countries. On this meaningful day, now I would like to invite Professor Luis Garcia Castrillo Riesco, President of the European Society for Emergency Medicine, USEM.
Good evening to everybody. Yes, I come from this small country that looks like a square, and it's at the end of Europe, as far as Turkey is. So we are in the opposite side. I am really pleased to be here. It's not my first time. Fortunately, I have been with you during the last 4 congresses, and I hope that in the future we can share also our experience here in this wonderful venue. I am also pleased to be the USEN representative, very proud of, but I have to say that I am not the only member of USEN. Fortunately, to show the support that USEN is providing to your organization and to this Congress, we have an extended group of members of the USEN board. We have past presidents, board members, and I will say future presidents with us today, acting as speakers and taking part in this Congress. But there is a small problem. The organization offers me the opportunity to share some thoughts with you, and I don't want to resign this offering. So in the next minutes, I am going to share with you some personal thoughts. As president of USEM, during the last years, in my mind, it has been struggling the idea of what is the role of scientific societies. And I want to share now with you my ideas. We are all going to agree in the idea that the first objective of a scientific society is to look for the excellence in the care of the patients. And for doing so, we have 2 tools. One is the continuous medical education, and the other one is research. And this Congress is a good example of both things. Here we are going to be exposed to the state of the art of the situation of care. We are going to be exposed to new technologies. We are going to be exposed and trained on skills. And this is one of the objectives and the main objective of a scientific society. Research is the other one. And here we are going to see the last results of research. But mainly we are going to join other colleagues here, and we are going to think about research ideas. We are going to do exchanges of opinions in between us. Our learning is not going to come from the speakers only, it's going to come from the speakers and from the colleagues. Probably discussing a poster, we are going to learn as much as hearing a speaker here in this room. I want to say that after the Congress, the scientific society work is not finished. It has to continue provide updated information, and this is done through journals, letters, workshops, online systems, and all this is part of the activity of the scientific societies as EPAD and as EUSEM. But this is not the only role. I would like to stress the idea that scientific societies has to be opinion leaders. We have to create guidelines, we have to promote the established guidelines, and we have the ones to have the knowledge to define the type of care that we have to provide to our patients. We have to define the systems of care, and with system, I include the pre-hospital part of our activity and the in-hospital part of our activity. It's impossible to think on emergency medicine without these two elements. And the scientific societies have to lead and have to be the opinion leaders on this. But we don't have to forget that we are working for a specific society, and our society is continuously changing. When I started doing my work, the society was completely different as it is now. Changes occur continuously. New diseases are appearing. New problems are appearing. New procedures are offered to us, as we have seen with the previous speakers, and we have to adapt to these circumstances. We are commonly exposed to the idea that the society is aging, and with the aging of the society, more fragile patients are arriving to our departments. But that is not the only problem. Isolation is a huge problem. You know that in Europe, 30% of the houses are occupied by only one member, meaning that the society is losing the network of the social group. And this is going to offer a new situation to our departments, to our services, and we have to consider and take in consideration this aspect. To deal with all these problems, we cannot do it alone. The scientific societies cannot do these things alone. So we have to look to generate links and synergies with other organizations, with other scientific societies, with other groups, with other federations, not only dealing with emergency medicine, but also dealing with other aspects, social aspects, technological aspects, and we need their collaboration. But mainly we need the collaborations of individuals. And from here I encourage everybody who is not member of a society to become member of a society and be part of this big project that I have been showing you. For those who are members of societies, I encourage them to be more active. Probably my words are going to be taken also by IPAD. We have our hands open and looking for more members to collaborate with us. Now I would like to finish these brief commentaries expressing my gratitude to the organizers that allowed us to try to reach our goals, to improve the education, to improve the research, to improve the network in between the groups. This Congress is the right place for do all these things. So thank you for the organizers.
Thank you, Luis Garcia Castriel-Resco, for your opening remarks. Now, I would like to invite Professor Jill McEwen, past president of the Canadian Association of Emergency Physicians.
I used to believe we were all burning on the edge of something beautiful, something beautiful. Selling a dream, smoking in the mirrors, keep us waiting on a miracle, on a miracle. Darkest of days, having a heartbreak away. Never let you go, never let me down. Holy Spirit has our right, hiding the edge of a night. Never let you go, never let me down. Don't you give up, nah, nah, nah. I won't give up, nah, nah, nah.
Good afternoon, ladies and gentlemen. President Professor Dr. Bajar Kandar, Emergency Physicians Association of Turkey, Organizing Committee. As the past president of the Canadian Association of Emergency Physicians, I'm honored and delighted to attend your 6th Intercontinental and International Emergency Medicine and Critical Care Congress and your 15th Acil TIP Congressi here in Antalya, Turkey. I'd like to thank the organizers for their kind hospitality. You know, it's the 5th time that I've been here in Antalya, and each time I come, it gets more, the quality of the conference gets better, and I'm very impressed with everything that you guys are doing here. It's fantastic. I'm also an emergency physician like you and have worked for 32 years at Vancouver General Hospital in Vancouver, BC in Canada, where we see over 100,000 patients a year. I've had a few other positions as assistant dean in UBC, University of British Columbia, and continued to be the undergraduate education program director at UBC. So I'm going to begin by telling you just a little bit about the Canadian Association of Emergency Physicians. We have about 2,500 members who represent the EPs of Canada. And we are organized around 4 pillars, very similar to what we are doing here. So education and research are 2 of our top priorities. We do an annual conference, and our conference is coming up in May in Halifax, Nova Scotia, and all of you are invited. If any of you are able to attend, we would be delighted to have you there. We also have road shows throughout the year, and we do some other continuing professional development activities across our country. Research, we offer modest seed grants to researchers in Canada that have led to some pretty impressive careers. And we do, the Canadian Journal of Emergency Medicine is our association's journal. The other 2 pillars are advocacy, and we advocate for the specialty of emergency medicine, mostly for our patients and also for emergency physicians in Canada. And our 4th pillar is advocating for emergency physicians. So we have a number of committees and special interest groups that our members can join, and whatever their interest is, and to connect and promote various subspecialties of emergency medicine. But no matter what country we come from, we emergency physicians have a lot in common. So the pride and enthusiasm that I see amongst my colleagues at home, I also see in all of you and in this room and in all the countries that have emergency medicine conferences. So no matter where we come from in the world, I think that we share the common attributes for the fast-paced emergency treatment of our patients, the unique opportunity to be a part of our patients' lives 24 hours a day, 7 days a week, from all socioeconomic statuses, and the ability to quickly diagnose and treat conditions from all walks of medicine. So I don't think global boundaries separate us, and you know, we are truly blessed to have such an amazing career and be part of our patients' lives in the world today with all of the division and the tumult that is happening all around us. There's no better time for us to get together at international conferences like this to share our knowledge and to become friends with each other. So I'm really happy to be here. On behalf of CAPE, I wish you all an excellent conference, and I hope you all learn a lot from both the academic sessions and the research that has been done and from connecting with each other. And thank you for your attention, and once again, thanks for your hospitality.
Thank you, Jill McEwan, for your opening remarks. Now I would like to invite Professor Carlos Garcia Rosas, first president and founder of the Mexican Society of Emergency Medicine and Mexican Academy of Emergency Medicine.
This is Latin flavor. We have on the brain, we have on the veins, on the heart, the feeling of the. Let me, first of all, I want to thank you for the organization to invite me to be here. Really, it's nice to be here to share a couple of words that we want to do. Let me tell you briefly about my life. I born in this town 33 years ago. No, just kidding. It looks like, but no. I born in this town. They are really a small town. The town, the particular thing is that they have founded by British. We have Bull Ring, the church, and the symbol of the city is the railroad because this is part of the connection between the Gulf, Mexican Gulf, and the Mexico City. And then I moved for the university because it's a small town, they don't have medical school at that time. I moved in 1986. Mexico City, the name is Distrito Federal. Everything is changing. Now the name of the Mexico is Mexico City, that's it. So I live in Coyoacán, in Mexico City. It's a small county in the big city, very nice neighbor. And when I started 33 years ago, probably many of you, they don't have that date. 33 years ago, we started emergency medicine in Mexico. So we don't have men control the emergency room. The land is like desert. We don't have rules. We don't have program. We don't have regulation, anything. At that time, we start to build everything in Mexico City. But it's not easy because we arrive like monkeys. The king of the jungle was the surgeon, and if something happened very strange, they call for the internal medicine because they have a very strange diagnosis. I don't know what, but they think that they know. Over the years, when we started in Mexico City. This is the pioneer of the Mexico City and the Latin America. 15 people started the emergency medicine program in Mexico in '86. And this, believe me or not, I am one of these. These 4 people, we organize the society, we continue to organize the board, we organize the Mexican Academy, and we organize the World Organization in Emergency Medicine for the rest of the world. And then spring in 1994, we spent for more than 60 places teaching emergency medicine now in Mexico. But we not promoted. The best promoting for you and for me, because we are relatives, only different is the language, but we saw similar patient, we are similar life. The best promoting was the ER talk show. They have 10 years on the top in the television and spread the rest of the world. Now the people know a little bit more about what the emergency physician doing. And they have different top shows in different countries, in different language. This is why one of the things I am worried about to know the artists and say, well, who is these Hollywood people doing? And I met, do you remember this nurse? The nurse was for the TV show. And then I came in 1990 to come to Euro. What Euro doing something, and they don't have program in 1990. Few countries, they have a program in emergency medicine. And I met one of the leaders is Dr. Germán de Luz and David Williams. And then met Dr. Pateron in France. And then we went to different conferences with the other part of the Europe. And also I met Roberta Petino. I don't saw her, but she was involved in many organizations of the conference, and she was the past president of SEM. And also, what is the reference if you want to study emergency medicine, because you don't have books. You have internal medicine or surgery. So we're looking for the guys, they have the New Testament and the Old Testament. Peter Rosen, the 3 tomes for the books in emergency medicine, and Judith Tintinelli for the books to read. And also I write my own book. Now we have 3 of the people that write books for emergency medicine in the rest of the world. So in 1990, I invited the first time Judy come to Mexico because we need to get reference how emergency medicine doing outside of Mexico. And this is why I invite her to come and participate. But this is the evolution in the rest of the country, in the rest of the world. We are the same. You speak Turkish, I speak Spanish, this guy speaks English, but the evolution was the same. We start like monkeys, and now you look tired, you look handsome man and pretty woman. But at that time, nobody believed in us, and this is the normal evolution and then we have. Until here, I saw many leaders that I know for the last 30 years doing these things and very interesting points. But remember, those who cannot remember last, they are condemned to repeat the same mistakes. So be careful. The younger guys, if you want to do something, pay attention in the people was before of you, because you don't need to make the mistake, and you advance quicker than us. And remember, the doctors and emergency physicians is like the wines. The more older, the better. Emergency medicine is this style of life. I lived 33 years like emergency physician, and I feel fine. I feel very well, like many of you. And I met a lot of friends. The life is not only emergency room. We need to socialize. This is why many people organize now conference. We need to outside to the emergency room, share, dancing, praying. And I met many people over the years. And remember, welcome, everybody is welcome for the National Congress in Emergency Medicine in Mérida this next November. Thank you.
Thank you, Carlos Garcia Rosas, for your opening remarks. Now I would like to invite Professor Roger Dickerson, President of the Emergency Medicine Society of South Africa.
To the goal, cause everyone's depending on me. See, we ain't got nowhere to go, but it's our destiny. Choosing to win, do what it takes to get to the top.
That really rouses my blood pressure. Merhaba. Güney Afrika'dan selamlar. What I should also be saying is I'm learning some Turkish, so I'm going to teach you some isikoza. What we refer to as a conference in isikoza is umbuzo. Now everyone, let's try together. Buzo. Now put it together. Umbuzo. And what an umbuzo is a time for the wise to learn from the young, and a time for the young to learn from the wise. And note there's no mention of old, it's only wise. And that's what this is all about. Now, you know that I come from the southern tip of the African continent. We have strange creatures like the Big Five. Now, the undoubted king of the Big Five is the giant cat called the lion. And I think Professor Kande is your version of the lion, certainly the king of the jungle in these parts. And it's a pleasure to be part of a conference that you've once again organized so incredibly well. But it's something that we can, as emergency physicians, and it's been interesting hearing all of the previous speakers standing up and saying, almost like an Alcoholics Anonymous meeting, going, I'm an emergency physician. But I think it's something that we can learn from the Big Five, because in order to survive in emergency medicine, you need to have the courage of a lion. You need to have the cunning of a leopard. You need to have the stubbornness of an elephant. You need to have the patience of a hippopotamus.
And then, when our patients' lives depend on it, you need to have the temper and aggression of a wounded rhinoceros. Because that, and it's something that Jill mentioned earlier, we need to be advocates for our patients. And I think that's what we're all here to do. We're here to learn, we're here to develop. We're here to take the specialty that is being carved out so delicately and enhanced. I was standing chatting to what have become really good friends, and it was really the past, the present, and the future of USIM. And in fact, they're starting to talk about not just the past, the present, and the future, but the past, the present, the future, and the future. And that's really where we should all be looking towards. And so I would like to express my sincerest appreciation to the organizers, not only for tremendous hospitality, but the amazing opportunity for me to learn from the wise, and the wise to learn from me. So thank you very much to the organizers, and congratulations.
Thank you, Roger Dickerson, for your opening remarks. Now I would like to invite Dr. Hikmet Anvarov, Deputy Director of Emergency Health Services of Ministry of Health of Uzbekistan.
Günaydın. Sayın Profesör Candır, sayın kardeşler, ata yurtunuz Özbekistan'a sıcak selamlar. Ben için bu kongrede konuşmak büyük onurdur. Ladies and gentlemen, it's a great honor for me to stand here on this fabulous place and greet you from my personal and from all entire system of emergency medicine from my country, which I will be happy to introduce you in this part of the world. Tomorrow I'll have an opportunity to talk about more detailed about my country, about the system of emergency medicine in Uzbekistan. But today, as per our tradition, with your kind permission, I would like to present a small gift to our common host, Professor Bashar Jander. This is not just a part of protocol. This is not just a part of our culture, which is, but is pure and sincere symbol of our appreciation and gratitude.
Thank you very much.
Thank you very much, and I wish all of us successful and fruitful Congress. Thank you.
Thank you, Hikmet Anvarov, for your opening remarks. Now I would like to invite Sivaminata Mahadevan, Professor of Emergency Medicine at Stanford University.
the confusion. Everybody who meets me in my life, they go, he's Indian, but when he opens his mouth, he sounds like an American. And that is because I am both. I am both. First off, I want to extend my sincere gratitude to Dr. Bashar Chander and the organizing committee for inviting us to this fantastic conference. As you can see from all the luminaries who are here speaking at the conference and just the agenda, it's going to be a fantastic Congress. It's my 5th time to Turkey and 2nd time to Antalya, and I'm very excited to spend the next 3 days with you. Just reflecting on what some of the other speakers have said, when we get together as emergency physicians, our histories, our challenges, our successes are mirrored in each of the countries that we work in. And I've had the privilege of not only being an emergency physician and a teacher in the United States, but traveling to other countries like India to help with the development of emergency medicine and emergency medical services. And I would hope that you take the time, since we're all here, have come so far, to spend these next few days with you. Go reach out to these folks. They are very kind and accommodating and want to talk with you. I would encourage all of you, the participants, the delegates, to speak to all the faculty who have come from around the world and share your stories, and so we can do the same. And I want to wish the organizers a fantastic conference. I want to thank you again for being invited to speak. Thank you.
Thank you, Swaminathan Mahadevan, for your opening remarks. Now, I would like to invite Professor Wang Zhang, President of the Chinese International Exchange Association of Emergency Medicine.
Good afternoon, everyone. Dear Professor Basa Kanda, ladies and gentlemen. I am Dr. Wang from China, and I'm chairman of the emergency branch of the International Exchange and Promotion Association of Medical and Healthcare. First of all, I would like to say that we are very happy to be invited by President Basa Kanda to come to the beautiful Turkey. This is the first time we are here, and last night we got into the hotel at 1 midnight, so we can see nothing. And this morning when we get up, we saw that everyone are beautiful. So we hope that we can come again. In 1983, China established the emergency medicine. After several decades of development, it has formed a relatively complete emergency medical service system, including the pre-hospital emergency, emergency department, and EICU. So we are very happy to share some experiences with our international counterpart and all of you here. And we also hope to learn from you and from everyone the experiences and improve together with the colleagues of emergency physicians. The 2019 annual meeting of our society will be held in Hefei, Anhui Province on October 13th. we seriously invite everyone of you to visit China and to join our meeting. And besides, we take a small gift and a formal invitation letter for Basa Canlı and the Association of Emergency Physicians of Turkey.
Thank you very much.
And we wish this conference behold completely success. Thank you very much.
Thank you, Wang Zhang, for your opening remarks. Now I would like to invite Professor Paul Kivilla, President of the American College of Emergency Physicians, ASAP.
Never quite sure what the music's going to be. Earlier I was told it was going to be 50 Cent. So I was going to try and figure out how I was going to rap my way up here to the stage. So thank you again. I'd like to thank the organizers of this conference for the wonderful hospitality. And on behalf of the 38,000 emergency physicians of ASAP, I would like again to say my thanks for being here. This past year, we were founded in 1968, so this was our 50th anniversary. And as we go forward, it was great to hear what a lot of the speakers prior to me had already said. And I want to say much of the same things. I think, this is just a wonderful conference here where there's an opportunity not just to learn, but also to collaborate and work together. It is my opinion and that of our organizations that emergency medicine has no borders, that we are a world community and we should learn and work together to advance our specialty. We are one of the youngest specialties, but we've matured very, very quickly. And in many parts of the world and the United States, we are now seen as one of the leading specialties that advocates not just for ourselves, but most importantly for our patients. I think that there has been a lot of collaboration that we have started on our side here in the past year, and I look forward to working together with many other organizations, including EPAT and USIM and many, many others, of how we can work together and move things forward that we can advance research, that we can advance learning and advance technology. In the United States, our residents are very unsure what the future holds. And I think this is a great opportunity because we are doing research to look at not where we're at right now, where we're going to be in a year, but where we're going to be in 30 years. Because that is about the lifetime of an emergency medicine trained physician, of how long they work. So we have to think forward that we're training them the right way, And if you look in the United States right now, and this is going to be a world issue, technology is going to change very quickly. And we believe that emergency medicine is no longer all going to be delivered in the emergency department. That we believe emergency medicine is a specialty and not a place. We're already seeing a lot of our graduates go into technology, deliver things via telemedicine. And we think that the future is only going to be brighter in all those regards. And our specialty is the one that usually adapts the most quickly. So I would like to thank everybody for here, and I hope to reach out to you here in the next several days as we talk about how we can work together, because I truly believe that we can learn from each other. And also, I'd like to thank Dr. Bashar Kanner. I'd like him to come up here, as we have a gift for him as well, is that, here's someone that is bringing the world together. And I think, here, this is their 15th anniversary of their conference. But the scope of the leaders that are here, the scope of the training that's going on here is really exemplary. And Dr. Cantor, will you please come up? And on behalf of the 38,000 members, this is a plaque that just honors the contribution that EPAD has made to emergency medicine. Also something you can put on your desk or your nightstand that will also remind you of our very much appreciation to what you've done for our specialty. Thank you.
Thank you, Paul Kivila, for your opening remarks. Now, I would like to invite the mentor and the constructor of the emergency medicine training in Turkey and the president of the Emergency Physicians Association of Turkey, İPAT, Professor Başar Candar.
Çok değerli arkadaşlar, sizinle burada bulunmaktan çok büyük bir mutluluk, onur ve gurur duyuyorum. Tabii yabancı konuşmacılar var, unuttuk. Onların da trans şeyleri var değil mi? Tercüme şeylerini verdiniz. Yani şu anda gerçekten bir yıllık büyük bir gayretin sonunda son derece büyük vakitler, efor, emek harcayarak böyle dev bir organizasyonu geliştirdik. Ama şurada gördünüz siz de. Burası artık diğer katılımcılar da kabul eder ki dünyanın acil tıbbının birleştiği yer olmaya aday bir yer görünüyor değil mi? Aday bir ülke olarak duruyoruz. Dünya acil tıbbını birleştiriyoruz. Dünya acil tıbbının birleştiği yer gibi bir görev üstlenmiş durumdayız. Burada zor konuşuyorum, biraz zor başladım. Niye zor başladım? Çünkü çok değerli, çok büyük bir hocamız aramızda. Onun önünde ilk defa konuşuyorum. Hocam bizi mazur görün. Sayın Profesör Doktor Bingür Sönmez hocamız bugün aramızda. Lütfen alkışlarımızı Size çok güzel bir ders anlatacak. Burada yani gerçekten çok güzel vakit geçireceksiniz. Bu yılki kongremizde de bazı yenilikler var. Onlardan size bahsedeceğim. Tabii acil tıpçıları bir araya görünce herkes konuşmak istiyor. Çok konuşmak istiyor. Çok güzel şeyler anlatmak istiyor. Sayın Carlos'un dediği gibi yaşlandıkça daha değerli oluyorsunuz. Daha değerli şeyler anlatmak istiyorsunuz. Ama ben artık acil tıpta hep acilden bahsetmekten yoruldum. Ben de size bugün olimpiyatlardan bahsedeceğim. Olimpiyatlar ilk olarak ne zaman başlamış arkadaşlar? Bilen var mı? İlk olimpiyat 800'lü yıllarda. Peki bu olimpiyatta bu 5 halka neyi temsil ediyor biliyor musunuz? Bu 5 halka neyi temsil ediyor? Bilen var mı? Şey sorusu değil mi? 5 kıtayı temsil ediyor. Biz ne yapıyoruz burada? Biz de 5 kıtayı, hatta 6 kıtayı temsil eden bir organizasyondayız. Yani buranın bundan sonraki ismi ne? Acil Tıp Olimpiyatları değil mi? Acil Tıp Olimpiyatlarında bundan sonra hep bir arada olacağız. Acil Tıp Olimpiyatları. Kıtalar bir arada, hepimiz bir aradayız. Peki bu olimpiyatlarda, olimpiyat deyince aklınıza hangi yarışlar geliyor arkadaşlar? Mesela hangi sporcular aklınıza geliyor? Sporla çok ilgileniyoruz değil mi? Mesela ilk akla gelen herhalde, kimler var burada? Yüzmede bakın 29 altın değil mi? Kaç? 23 altın. Larissa, Muhammed Ali Kılay, boksta, Usain Bolt. Bu isimleri aklınızda tutun. Bu isimleri aklınızda tutun. Burada ne görüyoruz arkadaşlar? Kim bu? Usain Bolt. 9.58 ile rekor kıracak değil mi? İlk aklımıza gelen atlet neredeyse bu. 100 metre yarışı. Olimpiyatların ruhu mu neredeyse bu? Bu rekor. Tek olimpiyatlar bunlarla ilgili değil. Güreş de olimpiyatlarda çok önemli. Gördüğünüz gibi.
Harika bir hareket. Bakalım süre yeterli olacak mı?
İşte bu an. Değil mi? Galibiyet anı. Ama başka sporlar da var. Mesela bizim de iddialı olduğumuz olabilir. Mesela diyelim ki ne aklınıza geliyor? Gülle atma.
Alman. Dostan. Şşt. Ne yapıyor? Kardeş Türk müsün? Almancı mısın? Vas. Ne vası? Ben hazırın dibi aynıdır.
Beyefendi müdahale etmeyin.
Hocam tamam bir şey yapalım moral motivasyon.
20-15. Son sırada Türkiye var.
Aha geldi. Aha bize sayacağız.
Abi hadi sana güveniyorum. Hadi abi yaparsın.
Hocam saygılar selamünaleyküm.
Hadi Recep abi. Beyefendi buyurun.
Şu arkadaşa söyleyeyim hocam çeksin oradan bu.
Beyefendi orası dünya rekorunun ötesinde nasıl atacaksınız?
Ya hocam ben yemişim dünya rekorunu ya. Şu anda sahamızda kainat rekoru kıracağım. Söyle çekin şu arkadaş. Çekin şuradan.
Beyefendi buyurun atın.
Bak hocam ben uyardım. Masadakiler. Bu çekit tutmuyor.
Bizim için sorun yok tabii atabilirsiniz.
Ya Allah bismillah. Pip çak. Efsane kadar.
Okta da iyiyiz. Okçulukta da biliyorsunuz yine olimpiyatlarda okçuluk.
Dört halka.
Evet. Şimdi bunlar tabii çok değerli sporlar ama sizce, şimdi asıl soruyu soracağım. Olimpiyatın en değerli sporu hangisi? Efendim? Maraton. Olabilir. Ama şimdi şunu izleyin. Hiç duydunuz mu? Duymadık belki de. Burada birçok rekor göreceksiniz. Dekatlon, hemen her branşta rekor. 9.000 puana ulaşmış. Dünya rekorları ama gören, duyan var mı? Yok. Neden? Çünkü isimsiz. Bu size neyi andırıyor? İşte biz acil tıpçılar, olimpiyatların dekatloncularıyız. Aslında her branşta yarışıyoruz. Herkes bir branşta yarışırken biz 10 branşta yarışıyoruz. 10 branşta rekor kırıyoruz. Ama problem ne? Kimse bilmiyor değil mi? İsimsiz kahramanlarız. Bu kadar isimsiz kahramanlara bir alkış alacağım. Böyle yazılarımız var tabii. Acil tıp benzersiz bir branş. Gerçekten çok zor, çok ağır. Ama işte bunu benzersiz kılan şeyler var. Mesela çok zor şartlarda yarışıyoruz. Çok zor şartlarda hasta bakıyoruz. Kalabalıklar var. Ekonomik koşulların iyi olmaması var. Şiddet var. Bunu yıl boyunca görmüşsünüzdür. Tekrar göstermekte fayda var. Acil servislerin halini görmek açısından.
Jeg får trilla den inn på kirurgi, da. Det er ikke så ille som det ser ut. Her er halve hodet ut, ja. Det går så fint, så. Hva skjer?
Jeg føler meg litt sånn pjusk.
Å, herregud, slipp alt dere har i hendene! Vi har en mann som er pjusk her! Få den i rullestolen! Få ut. Få den ut. Hvilke rom er det der som er ledig? Og så få ut han der jævla hvitpersongen. Sånn, få han her. Så få tak i noen store puter ned fra barneavdelingen! Herregud, han har nesten 38 i feber! Sånn, ja. Sånn, ja.
Bunu istiyorlar. Bir de her şeyi muayene etmemizi istiyorlar acilde. Birkaç doktorun birden. Yani medyanın, şiddetin, ondan sonra ekonomik durumların, hasta zor yakınlarıyla uğraşmanın, yani burada bize bir şey değil mi? Bunu kimse yapmaz. Ancak ne yapar? İşte isimsiz kahraman dedik ya da çılgın insanlar, çılgın iyi insanlar bunu yapabilir. Biz hepimiz o çılgınlarız. Bütün çılgınlar bir araya gelmişiz, öyle görünüyor. Burada da doktorun aslında şiddete nasıl maruz kaldığına dair güzel bir video var. İstiyorsanız onu da hemen
If you felt
geçirelim.
ill, what would you do?
Go to bed.
Before that,
Take the clothes off.
you would go to the doctors.
No, no doctor. Doctor killed my uncle in Madrid.
Really?
See, my uncle, he has pain in the chest. He goes see doctor. Doctor, he listen and say, it's all right. 10 minutes later in the street, my uncle, finito.
What, a heart attack?
Autocar.
Well, you can hardly blame the doctor for that.
See, the doctor, he was driving the motor.
Neydi? Tabii böyle şiddet olunca da böyle bunu tercüme edebiliyorum bilmiyorum. Şiddet sadece acillerde değil, her yerde bir şiddet var. Ama tek bizim medyamızda. Mesela biz hep diyorduk ki ya ülkemizde bu dizilerde neler neler gösteriyorlar, yeter artık biraz uslanın. Ki Hindistan'ı görünce, Hindistan bizim imdadımıza yetişti. Hindistan'da nasıl CPR yapıyorlar bir de ona bakalım.
ಹಾರ್ಟ್ ಗೆ ಮೈಂಡ್ ಎಲೆಕ್ಟ್ರಿಕ್ ಶಾಕ್ ಕೊಡ್ಬೇಕು ಆದ್ರೆ ಅದಕ್ಕೆಲ್ಲ ಸ್ಪೆಷಲ್ ಎಕ್ವಿಪ್ಮೆಂಟ್ಸ್ ಬೇಕು ಓ ಮೈ ಗಾಡ್ ಇಂಥ ಸಿಚುವೇಶನ್ ಅಲ್ಲಿ ನೋಬಡಿ ಕ್ಯಾನ್ ಹೆಲ್ಪ್ ಯು
Hasta arrest da biliyorsunuz, defibrilasyon yapacaklar. olmasına gerek yok. Dünyanın her tarafında medya aynı yani gördüğünüz gibi. Bakın bizde de medyada neler var. Elektrik akımına kapılan genç matematik aşığı olmuş. Nasıl oluyorsa. Burada da Çin'den bir haber var. Çinliler var. Çin'de 200 gündür komada olan hasta kendisine para koklatılması üzerine komadan uyanmış. Bu da çok ilginç geldi yani Çin'de. Velhasıl medya her yerde aynı. Ama bizim gerçekten sorunlarımız hasta yoğunluğu, en önemli sorunlarımızdan biri. Bakın Türkiye'de şikayet ediyoruz ama bu Amerika'dan bir şey. Avustralya'dan, pardon Amerika'dan da vereceğim de. Avustralya'dan. Orada da koridorda hastalar var. Yani bütün dünyada aynı sorunları yaşıyoruz. Az çok. Bakın burada hemen benzer sorun. Washington Post'ta olan bir haber bu. Bizi çok tanıdık geldi değil mi? Biz bloklama yapıyoruz bunun için. Önce acilden hasta. Acil hastalarını yatırmak, onlara hizmet etmek, hep bu zorlukları aşmakla, onlarla mücadele etmekle uğraşan bir grubuz. Bunlar bütün dünyanın sorunu, sadece bizim değil. O yüzden biz diyoruz ki bu dünya bir araya gelecek, acil tıpçılar bir araya gelecek ve bu sorunlar üzerine gideceğiz. Bakın ne kadar benzer sorunlar. Burada bir doktoru görmesi için 5 saat gerekiyor. Bizim Kanuni'de 3000 hasta geliyor. Ortalama bekleme süresi ne kadar biliyor musunuz? Kanuni'de arkadaşlar vardı burada, asistanlarımız 10 dakika. 10 dakika. 3000 hastanın geldiği yerde beklediği dakika doktoru görmek için beklediği süre 10 dakika. Tabii yani bu hizmeti nasıl üreteceğiz? Tabii bir sürü bu gereksiz hastalar var. Bu kalabalığı oluşturan. Böyle cevap veren bir sisteme ihtiyacımız var yani. Doktorların böyle koruyucu olduğunu, acil tıpçıların böyle olduğunu herkesin anlaması lazım. Rektörlerin biz geçince selam çakması lazım. Bu söz tanıdık geldi mi? Belki bir gün yani acil tıpçı bu kadar şey yapıyor yani bu kadar hizmetle uğraşıyor. Biz bunları yaparken diğer doktorlar ne yapıyor? Yani şimdi biz onlarla nasıl bir olalım? Ama yine de bizim mesela düşünün biz en azından şöyle yani kötünün kötüsü var. Bunlar yine iyi de. Bir de filozof olsaydık ne olacak? Dolayısıyla yine de herkesin bir şekilde CPR'ı bilmesi lazım. Böyle geçelim. Acil tıpçılar böyle dev güçlü, dekatloncu olacak derecede büyük şeylerdir. Şimdi arkadaşlar bir dakika anlatacağım. Şöyle, bu sene kongreye çok iyi hazırlandık. Çünkü biliyorsunuz Türkiye'nin çok büyük 2 tane şeyi var, STK'sı var. Dünyanın belki Türkiye'nin en büyük şeyleri bunlar. Biri Fenerbahçe, diğeri Atüder. Şimdi geçen yıl başımın etini yediniz, seçim yapalım. Ben dedim seçim yok dedim. Aha şu fotoğrafa bakın, ne görüyorsunuz? Şimdi bak, o otomatik gelmeyecek ama bak fotoğrafları incelersek, bak Aziz Yıldırım ayakta, ben koltukta oturuyorum. Kaç defa dedim ona ayakta durma, bak koltuktan kalkma. Koltuktan kalkarsan gider. Bak Ankara'da bu metot var yani. Ankara'da bakanlıkta herkes koltukta oturuyor. Kalktı mı gidecek yani o şekilde. Ben ona diyorum bak koltukta otur, kalkma ayağa. Hem kalktı hem el salladı. Sonuç Aziz Yıldırım gitti. Peki Aziz Yıldırım gitti, Fenerbahçe kurtuldu mu? Ya işte bu. Yani ben nasıl seçim yapsaydım o geçen yıl? Ben de ya tamam biz de yıllardır Aziz Yıldırım'la beraber yönettik memleketi ama olsun yani bir başarı geliyorsa başarısızlığa şey yapmayacaksın. Onun için sormayın bunu. Tabii Fenerbahçe eskiden iyiydi, bu kadar değildi. Yani o da burada görmek lazım. Yani şimdi yani böyle bir efsane Fenerbahçe. Şarkısın sen. Sonraki söz anahtar kelime. Ömür boyu sürecek. Neyse canım espri yapıyoruz yani çok almayın. Bazıları öyle söylüyor da ömür boyu sürecek falan. Evet yine de o hale geldi işte. 20 yıl önce de böyleydi, sonra da böyle. Ne yapalım? Onun için bakın başkanlar değişmesi gerekmiyorsa değiştirmemek lazım. İşimize bakalım, çalışalım. Beraberce çalışıyoruz, iyi işler üretiyoruz. Bu resimleri niye koydum? Ya başarısızlıklar olabilir ama başarısızlıklardan sonra başarı gelecektir. Onun için ümidi yitirmemek lazım. Bu da Erik'in paylaştığı bir şey. Bakın acil tıbbın geleceği bizden farkı bak. Bu şekilde dahi kongreye gelen insanlardan, böyle çılgın insanlardan olan bir camia bir şekilde başarıya ulaşacaktır. Şimdi arkadaşlar tabii ben süre çok uzadı. Ben 2 saat kadar konuşmak istiyorum. Ama maalesef bu kadar şansım yok. Bir de benden sonra bekleyen büyük bir hocamız var. O yüzden hızlı bir şekilde ne kadar hızlı gidebilirsek 365 slide hazırladık dün gece ama bunu hızlı bir şekilde yok. Çok hızlı geçeceğim. Bakın biz kongrelerde çok ciddi aktivasyonlar yaptık. Bunu biliyorsunuz. Kongremize gelinceye kadar neler yaptığımızı hemen kısaca gösteriyorum. Bunları hızlı geçtik. 13.'üydü. 14'te bir çığır açtık. Bu Atatürk'ün kongrelerden kimler geldi, kimler geçti bir bilseniz. Yani buradaki listeler yetmez yani. Herkese burada bir şeyimiz oldu. Çok güzel teşekkürler aldık. Hızlıca devam ediyorum bunları. Umarım takılmadan gideriz. Ve 14. geçen yılki kongre bir çığır açmıştık. Yüzlerce afiş oluşturduk. Bakın gördünüz. Her türlü afişi kullandık. Her türlü çalışma yaptık. Abdü çok teşekkürler bu video için. Garcia, Sayın Başkan'ın teşekkür.
I need to remind you to come to IEMC 2018. Don't forget.
Bunlarla yetinmedik arkadaşlar.
Ayer el ministro Bayern dijo que era imposible clasificar por el final for Bayern si no marcaban aquí. ¿Estás de acuerdo con él?
Antalya Spor tamamen lise öğrenti. Ben aslında Atatürk'ün acil kongresine gitmeyi düşünüyorum.
Yani ne kadar denesek zevk veren bir şey gördüğünüz gibi. Açılışımız çok fantastikti ama hepsini gösteremem. Ama şöyle bir iki şarkısını gösterelim. Yani bu yıl üstüne koymaya çalıştık. Koyabildiğimiz kadar onu göreceğiz. Bir yıl boyunca gerçekten o yılda işte gelen arkadaşlara kendi halk müzikleriyle hitap etmeye çalıştık. Kendi milli müzikleriyle diyelim. Ama bu İspanyol müziğiymiş. Yanlış çalmışız Meksika'ya. Onu sonra fark ettik. Bazen böyle farklı şeyler oluyor tabii. Bunu ileri alma şansı var mı ekibin? Biraz ortaya alalım. Zaten çok kısa da. Biraz daha ileri al. Şöyle bir iki müzik dinletelim evet. Roger Dickerson vardı. Geçelim bir daha. Bu sene de dinledik. Başka Srinat. Evet biraz dinleyelim. Abdu. Biraz dinleyelim. Burada duralım bir. Bir şarkı dinleyelim ya. Evet.
Lasciatemi cantare, sono un italiano.
Yani böyle değişik bir müzikle açılışları yapmaya çalıştık. Çok değerli hocalarımız hep buradaydılar. Çok güzel teşekkürler aldık. 14. kongreyi böyle büyük başarılarla bitirdik ve 15'e geldik. 15'te çok ciddi bir ekip. Yani 100'ün üstünde herhalde çalışma ekibi gece gündüz. Bakın buradaki afişleri görüyorsunuz. Her biri bir şey ifade ediyor. Yüzlerce afiş yaptık. Messi'yi yine kullanmışız görüyorsunuz. Videolar, afişler bunlar hep kongre için. Sosyal medyayı salladık. Bu kadar afiş. Breaking News görüyorsunuz. Her şeyi kullanmaya çalıştık. Şunu görmemişsinizdir dur. Şurayı mesela. Bakın şu yeni yaşam zinciri. Orada görüyorsunuz. Amerika Kongresi'nde birisi Amerika Kongresi hakkında bir şey söylemişti. Will Rogers. Biz de onu hemen kendi kongremize uyarladık. Bizim kongremiz de Amerikan Kongresi'nden sonra diyelim. Ve biliyorsunuz yıllarca birini beklemiştik.
Biliyorum sanatçıların bu tarz etkinliklere katılması çok sık görülen bir olay değil. Ancak Acil Tıp Uzmanları Derneği'nin bu muhteşem kongresine kayıtsız kalamadım. Harika bir otel, muhteşem bir ekip ve onlarca katılımcıyla kapsamlı bir organizasyon. Atatürk'ün etkinliklerini daha önce duymuştum ama katılma fırsatı bulamamıştım. Bu hepimiz için güzel bir fırsat olacak diye düşünüyorum. Kongreye katılacak olmamın bir diğer sebebi de
Burada da güzel bir şey var. Tercüme edebilirsek de güzel olur. Bakın. Kongrenin önemini gösteren bir şey hazırlamış arkadaşlar.
I just said that you might want to think about your children.
I wish I could make you go away.
Well, good luck with that, Francis. Yeah, good fucking luck with that.
Her yönüyle kullanmaya çalıştık. maçlarda kongre hakkında tezahüratlar aldık. Bu Ankara Gücü Galatasaray maçı. Togay teşekkürler. Togay'a bir alkışlar alalım arkadaşlar bu çalışmaları için. Evet, gidebildiğimiz her yere girdik gördüğünüz gibi. Yüzlerce video hazırladık. Tabii bunları gösterme şansım yok. Bunları siz izleyin. Bak, çok güzel videolar var. Ekip çok harika çalıştı. Özellikle bu çalışmaları yapan bu mükemmel ekibi. Şimdi kimler var? Önce onu gelelim. Evet, Şükrü o ekibi bir söyleyebilir miyiz? Kimler var bu sosyal medya ekibimizde? Ayağa kalkabilir mi ekipler? Ayça Hanım, ondan sonra M-Date ekibi, ondan sonra kimler var arkadaşlar? Hepimiz ayağa kalkabilir misiniz? Okay. Evet, bu arkadaşlarımıza İlker, Enes, hepinize güçlü bir alkış istiyoruz arkadaşlar. Çok çalıştılar. Ve bu kongreyi farklı hale getirdiler. Her konuyu işledik neredeyse kongrede. Bakın konuşmacılarımızı tanıttık. Şu kitapları da alalım. Evet, yani burada gördüğünüz gibi bunlar aslında izlemek de bir zevk gerçekten bunları. Boş kaldığınız zamanlarda yine izleyebilirsiniz. Burada ne vardı onu da göstereyim. Evet, bu geçen yıldan kalma bir hatıra. Gala gecesinde bunu da sizi bekliyoruz aramızda gerçekten. Bello'yla, Paul'la, bu da gala gecemizden, onu da gösterelim. Gala gecemizde de iddialıyız bu sene. Daha iddialıyız. Gece yarılarına kadar ekiple çalıştık. Fotoğrafları sinemeye geldik. 12, 11 falan. Şimdi ne oldu? Şu kitabı alabilir miyim? Yani siz çantalarınızda göreceksiniz. Bazı kitapları çantaya koyamadık. Bakın arkadaşlar, yani bunu bir kitap evinde bastırmaya çalışırsanız, bir ansiklopedi var yine elinizde. Ve bunu her yere yapıyoruz. 1500 bildiri. Bu insanlar 3000 hasta bakarken 1500 bildiri de yaptılar. Asıl alkışları bu çılgın kitleye yapıyoruz arkadaşlar. Bunların 200'ünü, 300'ünü reddettik buna rağmen. O kadar aktivasyonumuz var ya, bunları anlatamam. Ama bazı örnekler vereyim. 3 kıtada, 4 ülkede aynı gün bir orada açılışa gittik. Bir orada düşünün. Yani ne kadar organize. Bakın refresh kursu. Diğer ülkede ultrason kursu. Aynı gün acil tıpta bak geleneksel tedaviler. Bu nasıl, hani ozon tedavisi, hacamat vesaire bildiğiniz, onları da acil tıbba soktuk. Ultrason ve uluslararası aktivasyonlarımız, sonosukul vesaire, bunlar aynı gün yaptığımız şeyler. Tarihler çok önemlidir arkadaşlar. Mesela size bir ay desem, mesela tarih seçseniz, mesela bir tarih seçelim. Kim var önümde? Abdullah, bir tarih, o ayın bir gününü seçsen hangisini seçersin? 2. Yanlış. 6 Kasım, bak önemli tarihler vardır hayatta. 6 Kasım'ı hatırlayan var mı? Şimdi hatırlatalım. Çünkü Fenerbahçe'nin üstüne çok gittik. Yani Fenerbahçe'nin alınacağı bir tek bu kaldı. 6 Kasım. Onu da hiç olmasa gösterelim, bu kadar üzerlerine gittik. Ama onu göstermeyeceğim hepsini tabii. Golleri gördükten sonra nereye geleceğim? Tarih 6 Nisan. 6 Nisan da bizim için böyle bir Fenerbahçe Galatasaray maçı gibi bir şey oldu. Çünkü 6 Nisan'da 6 aktivasyon. Bir ülkede 2, 6 yerde. Düşünsenize bir ülke, yani Kıbrıs'ta 2 aktivasyon, bir yerde 2 sempozyum. Bir ona koşuyoruz, bir ona koşuyoruz. Ve ülkelerin her yerinde bir aktivasyonumuz vardı. İşte burada gördükleriniz. Şimdi bizim 365 günümüz o kadar dolu ki biz hangi birini anlatalım, anlatamayacağız. Yurt dışında yaptığımız aktivasyonlar, Ukrayna, Özbekistan, Makedonya, bu yıl Macaristan, bunları anlatamam çünkü böyle bir vakit sürem yok. Bu yüzden slaytları ileri gitmek zorundayım. Ben bitirmem gerekiyor. Çünkü bunları anlatmaya kalksam herhalde akşama kadar beraberiz. O yüzden kesiyorum. Ama yani burada 300 tane aktivasyonumuz var ve artık yılın hafta sonları yetmediği gibi şey de yetmiyor ama MD'de özel bir şey verelim. MD çok güzel gelişti. MD ekibi burada. Onları da alkışlayalım. MD ekibini gerçekten çok başarılı çalışmalar yaptılar. Onu burada vurgulamam lazım. Hepsine teşekkür ediyorum. Sarper başta olmak üzere ekibe, Enes'e, diğerlerine. Bakın geleneksel tamamlayıcı acil tıbba da el attık. Onu da unutmayın. Reboa'ya el attık. Daha önce görüldü. Rize'de, Munzur'da bile sempozyum yapıyoruz. Yani düşünün her yerde. Yani Munzur bile derken yani şimdiye kadar sempozyum yapılmadığı için söylüyorum. Gidilebilecek her yere gidiyoruz. Sonoschool'un biliyorsunuz çok uluslararası projesi oldu. Ve bunlardan en sonuçta şuraya geldik. Bakın 6 ülkeye geçtik. Sonoschool 6 ülkede yapılıyor. Çok başarılı bir organizasyon halinde. Her konuda kurs veriyoruz. Her konuda eğitim yapıyoruz. Boş saatimiz yok. Bütün ekibi çalıştırmak, yani tabana yayılmamız gerekiyor. Her ekibi. Bütün bunları yaparken yine de bazı şeyleri atlıyor olabiliriz. Sayı doğru en azından.
Não é para parar a massagem. O médico falou, não é para parar. Alguém aprende com ele para revezar.
Segura a mão dele aqui, gente.
Não para.
Bak elini tutarak. Elini tutarak.
Alguém ajuda ele aí.
Bütün bunlara da yani İK'de kursları vermeye devam ediyoruz. Bir şeyleri değiştirmemiz gerekiyor gördüğünüz gibi. Neler var hayatta. EKG kurslarımız, bakın İK'de kursları için aynı zamanda başkan vekilim, her zaman yanımda duran ve çok zor zamanları hep beraber yürüyerek açtığımız Sayın Profesör Doktor Zeynep Hanım'a alkışlarınızı rica ediyorum. Yine birlikte yürümekten çok gurur duydum. Bu büyük holdingi yönetirken CEO'suz olmaz dediğimiz CEO'muz Profesör Doktor Mehmet Gül hocamız. Mehmet hocam. Şimdi ATOK'lara geçtik. ATOK'larda emeğinden dolayı EKG kurslarını da çok güzel yürüttü Mehmet okumuş hocamıza. Sonoschool'daki başarılarıyla uluslararası şeylere imza atan Erol Ünlüer hocamıza. Toksikolojideki büyük çalışmaları dolayısıyla Yunsur Çevik hocamıza. Genç Atüder'in büyük aktivasyonlarını yöneten Burak Katipoğlu'na, onun akışlarını. Her zaman yanımda durup bir şeyler üreten yönetim kurulundaki arkadaşlarımız. Şimdi unuttuklarımız var. Nuri Bey var. Mehmet Koşar Gelir var. Hatırlatın hepsini. Onların hepsine yönetim kuruluna alkış. Behçet Hoca'yı sona sakladık canım. Genel sekreterimiz Behçet Bey. Hepiniz biliyorsunuz. Bakın kurslar bitmez, goller bitmez. Neyse geçelim bunu. Şimdi biz federasyona ders veriyoruz. Galatasaray'a, Futbol Federasyonu'na, Basketbol Federasyonu'na. Maalesef bunları hızlı geçeceğim. Bu yıl şunu göstermem lazım. Bakın her dernek bir dergi çıkarır. Biz ne yaptık? Çantada göreceksiniz. 4 dergiye ulaştık. 4 dergi. Görün işte bak. 4 dergi. Burada görüyorsunuz. Bu dergi çalışmalarından dolayı arkadaşlarıma çok teşekkür ediyorum. Yani gerçekten gazetemiz bu yıl basılıyor, yarın elinizde olacak. 10 sayfa, 12 sayfa gazetemiz var. Gazetemiz, kendi televizyonumuz şu anda canlı yayında bütün ülkelere ulaşıyoruz biliyorsunuz. Çok yerden bizi seyrediyorlar. Böyle bir kuruluşuz. Ankara'yı hiç rahat bırakmıyoruz, medyayı bırakmıyoruz. Acil'in öyküsü 2019. Elinizde en güzel hikayeler. Acil'de sözün demi, Acil'in şarkısı dinleyeceksiniz. Ve kitaplarımız. Üst üste bir sürü kitap. Üst üste bir sürü kitap. Gel çabuk. Üst üste bir sürü kitap yayınladık. Hızlı çalışmamız lazım. Bak hiç şey yok, nezaket yok. Gel git falan. Çünkü hızlı çalışıyoruz. Sağ olsunlar. Bu yıl yine kitap çıkarttık. Onları biliyorsunuz. Şimdi arkadaşlar tabii ki bu kadar çalışma yaptık. Bu çalışmaların çok ödülünü aldık. Çok seviyoruz. Defalarca çıkardık. 2015'te ilk ödülümüzü Sirenat Kumar ve ekibi vermişti. Çok teşekkür ediyorum kendilerine. Geçen yılda çok güzel bir ödül aldık. Özbekistan'dan Sayın Bakan Vekilimizin huzurunda Emeritus Profesörlük ödülü tevdi ettiler. Yine Özbekistan ekibine çok teşekkür ediyorum. Katar'da çok güzel işler yaptık. Bu çalışmalarından dolayı Sayın Sagar Galvankar burada mı? Sagar. Thank you very much Sagar. Sagar'ı da alkışlayalım arkadaşlar. Vasem'in başkanı. Katar'da güzel bir aktivasyonu, Katar Sağlık Bakanı ile görüştük. Burada Ürdün'de en üst düzeyde ödüller aldık. Bulamadılar mı? Neyse, tamam. Olursa çal. Evet. Bu da Hindistan'da yaptığımız konuşmalar. Yine Srinath ve arkadaşlarına çok teşekkür ediyorum. Hindistan ayrı bir yer. Bakın orada yine onur konuğu olarak bulunmaktan çok büyük mutluluk duymuştum. Onur konuğu olmuştuk orada da. Ekiple birlikte oradaydık. Bunların hepsini ekip adına yapıyoruz. Dolayısıyla yani ne kadar anlatsak beni dinlemeniz gerekiyor. Her yerde bir şeyimiz var. Suudi Arabistan. Cemil burada mı? Cemil ve arkadaşlarına çok teşekkürler. Çok iyi işbirliğimiz var. Sayın Cemil Bey burada mı? Alkışlayalım Cemil Bey'i de. Şimdi arkadaşlar 1500'e yakın bildiri. Burada bakın sizi özellikle haklarınızı korumak adına şu girişte şeyler var. 12 saat. Sadece 12 saat derslere girmeniz yeterli olacak. Yani daha fazlasına girmeseniz de olur. Biz 12 saate sertifika vereceğiz. O kadar. Yani o kadar size kolaylaştırdık bu işi. O yüzden buralarda girişlere dikkat edelim. Mutlaka kimlik kartlarımız olsun. 12 saati doldurmamız gerekiyor. Bu yıl yeni bir uygulamamız vardı. Bir dediğimizi iki etmediler. Ve her çalışmamızda yani artık birbirimizin dilinden çok iyi anlıyoruz. Orkun Bey'e alkışlarınızı rica ediyorum. Emre'ye alkışlarınızı rica ediyorum. Sektör olmasa biz çok başarılı olamayız. Sektör bizim ana şeylerimiz diyelim, ana dayandığımız konulardan biri. Sektör yanımızda. Acili kimler anlar? Acilin kıymetini anlayanlar kıymetlilerdir diyoruz. Ve 3 firma yine bizim için bu konuda yani hani nasıl diyelim en üst düzeyde desteğini verdi ve acil için destek oldu, bilim için destek oldu. Üçüncüden başlıyoruz, adettir. Sandoz firması Nurşen Mekik. Burada mı kendisi? Buraya alalım lütfen hızlıca. Hızlıca buraya alalım. Koşarak, acilciler koşuyor çünkü biliyorsunuz. Koşturuyoruz. İkincilik merak ediyoruz. Daha önce listemizde yoktu. İbrahim Ethem firması Erinç Hanım, Erinç Çınar. Yanımızda mı Erinç Hanım? Buyurun. Alkışlarınızla Erinç Hanım. Birinci. Bilim ilaç. Kim ama? He? Bahar Hanım. Birinci. Bahar Hanım buraya, evet. kadar yavaş yürüyeyim diyorum, yapamıyorum, hızlı yürümem lazım. Şimdi arkadaşlar bakın 9 salonda dersimiz var. Birinden çıkacağız. Bugün saat 6'da başlayacak, 9'a kadar bildiriler var. Bunun yanında simülasyon yarışması, bilgi yarışması, sunum yarışması. Bu yıl bir de buna satranç turnuvası ekledik. Satranç hepimizin bildiği ve Satranç Federasyonu Başkanı gelecek. Bu konudaki çabalarından dolayı da Serra Hanım, milli satranççımız, ona da teşekkür ediyorum. Kanlı ekibi olarak. Ve gerçekten şu anda kaç slide oldu saydınız mı bilmiyorum. 365 slaytım oldu. Tabii ben hazırlamadım. Gece 3'e kadar asistanım sağ olsun Bensu Hanım onları hazırlamış. Ona da alkışlarınızı rica ederim. Bütün ekibe alkışlıyorum. Şimdi arkadaşlar biz her yıl çok önemli bir ödül veriyoruz. Gazi Yaşargil'e verdik biliyorsunuz ilk ödülümüzü. Daha sonra Aziz Sancar Nobel'den sonra bizim ödülü aldı. Sonra Goldfrank'a verdik Amerika'dan. Geçen yılda Paul Kivela'ya verdik. Şimdi Zeynep Hanım bu ödülü kime vermeyeceğimizi açıklamak üzere yanıma geliyor. Buyurun Zeynep Hanım.
Herkese merhabalar. 1952 yılında Sarıkamış'ta doğdu. Pendik Lisesi'ni 1969 yılında bitirerek İstanbul Tıp Fakültesi'ne girdi. 1976 yılında tıp doktoru olarak mezun olduktan sonra burslu olarak İngiltere'de bir sene yabancı dil eğitimi aldı. 1977-1984 yılları arasında uzmanlık eğitiminin içerisinde Londra St. Thomas Hastanesi'nde kalp cerrahisi asistanlığı ve Rhein Enstitüsü'nde araştırma görevliliği yaptı. İngiltere'de aynı hastanede tekrar 3 yıl çalışarak koroner cerrahisi eğitimi aldı. 1988 yılında doçent, 1997 yılında profesör oldu. 1990 yılı sonunda kesin dönüş yaptığı İstanbul Üniversitesi Kardiyoloji Enstitüsü'nde göreve başladı ve 1995 yılına kadar aynı zamanda Florence Nightingale Hastanesi'nde çalıştı. Daha sonra Florence Nightingale Hastanesi'nde kalp cerrahisi bölüm başkanı, aynı zamanda Kadir Has Üniversitesi'nin Tıp Fakültesi'nde cerrahi bölüm başkanı olarak çalıştı. 2001 yılından beri de Memorial Hastanesi'ne kalp cerrahisi bölüm başkanı olarak görev yapmaktadır. Evli, 2 çocuğu ve bir kız torunu var. Yurt içi ve yurt dışında 100'den fazla yayını, 5 kitapta yazdığı 8 bölümü mevcut. Radyal arter greft hazırlanması, kalp yogası ve ateşe dönen dünya Sarıkamış isimli kitapları var. Birçok tıbbi derginin editör listesinde görevli olup Sarıkamış ile ilgili sinema, belgesel, kitap gibi tüm çalışmalara katkıda bulunuyor ve bilimsel danışmanlığını yapıyor. Ülkem ateş çemberi içindeyken Sarıkamış, Nargin, Kafkas cephesi, Aşıkların dilinden Sarıkamış, Sarıkamış'tan Çanakkale'ye, Güneybatı Kafkasya Kars Rumları, Esaret Yıllarım, Asteğmen Vehbi Bey'in Sibirya'dan Kaçışı isimli kitapları da yayına hazırlamıştır. Amatör bir illüzyonisttir, bilgisayar merakı var, iyi kayak yapar, aletli dalış favori sporudur. Bahçesinde organik tarım yapar, çoban kavalı yani dilsiz kaval ve balaban çalar. Boş vakitlerinde ameliyat yapar. 17 binin üzerinde açık kalp ameliyatı yapmıştır. Hasta kaybetmeyi hiç sevmez. Sonu ölümle biten operasyonları sevmediği için savaşlara hayır diyor. Yurt içi ve yurt dışında bulunan 24 derneğin üyesidir. Evet, bu sene 15.sini düzenlediğimiz Ulusal Acil Tıp Kongremizde şimdi 5. kez Altın Acil Ödülünü vereceğiz. Ve Altın Madalya Ödülü Sayın Profesör Doktor Bingür Sönmez'e gidiyor. Kendisini sahneye davet ediyorum.
Arkadaşlar, törenin bundan sonraki kısmında Sayın Bingür Sönmez hocamızın çok değerli bir dersi olacak. Çok uzun değil ama çok şiddetle ilgili, bizi çok seven ama ondan önce teşekkür etmeyi unuttuğum insanlar olabilir. Lütfen ondan sonra beni hemen inince başlıyorlar. Bana teşekkür etmedin. Özlem'i görüyorum burada. Özlem Hanım'ı alkışlayalım. Hakan Öztürk burada. Onu alkışlayalım. Başka ve herkesi, Şahin Hoca orada. Hepsi orada. İlker, özellikle İlker'i ve Abdullah. Hepsini alkışlatıyorum. Çok değerli katkılarınız için sizinle birlikte varız. Evet, söz büyük üstadımızın, Sayın Hocamızın, Bingür Hocamız Sarıkamış destanını Türkiye'ye tanıtan kişi olarak tarihe de geçmiştir. Buyurun Sayın Hocam.
Sesimiz de vardı. Zoom açınca.
Sayın Başkan, değerli meslektaşlarım, madalyalarım için çok teşekkür ediyorum. Ama Sayın Başar Cander, beni bu güzel insanlarla buluşturduğunuz için, yakınlaştırdığınız için ayrıca teşekkür ediyorum. Benim için en büyük ödül bu derneğe onursal üye olmaktır. Bunu sizden özellikle rica ediyorum. Sağlıkta şiddet hepimizin sorunu. Özellikle ön planda olan sizlerin sorunu. Hekime düşmanlık bir toplumun ayıbıdır. İfadedeki güzelliğe bakar mısınız? Doktor beyim bir çare. Biz Mektebi Tıbbiye Şahane ruhuna göre hareket eden, düşünen, vatansever, aydın, saygılı bir geleneğin devamıyız. Doktor kim, ne demiş, ne yapmış, neye inanır diye düşünmez. İdare amir değildir, savcı değildir, din görevlisi değildir, kolluk kuvveti değildir. Doktor işi yaşatmaktır. Doktor yaşatır. Bu bilinci yitirmemek dileğiyle tüm Mektebi Tıbbiyelilere selam olsun. Ben tüm genç meslektaşlarımıza hep bunu söylüyorum. Stetoskop en değerli mücevherinizdir. Bedeli gençliğinizdir.
Anne! Tıbbı kazanmışım. Anne, son sınavımı verdim, bitti okul.
Oğlum, çok şükür kurtuldun sınavlardan. Onca yıl mahvoldun.
Anne! Sınavlarım bitmedi anne. TUS var, en zoru o. Vallahi hiçbir şeyiniz yok. Maşallah Türk gibisiniz. Ne demek yok? Ama ben kendimi hiç iyi hissetmiyorum doktor. Ama inanın ki hiçbir şey yok. Önüne gelen elifton veriyorlar ya. Hastayım hasta, çok hastayım. Acıyor, yanıyorum. Fatih abi verdiğin ilaçları kullandın mı?
Yok, kullanmadım. Bizim bacanakta da aynı hastalık varmış. O kendine lahana suyu yapıp içmiş. Ben de kendim ondan yaptım.
Abi ilaçları kullanmayacaksan niye buraya gidip geliyorsun? Bak bütün değerlerini mahvetmişsin. Niye kafana göre şeyler kullanıyorsun?
Ama ona iyi gelmiş.
Ona iyi gelmiş, sana iyi gelmemiş.
Peki yaz madem.
Kullanacak mısın?
Kullanacağım. Belki ben lahanayı yanlış yaptım. Ya o kara lahana kullandıysa?
Şimdi Saniye Hanım, öncelikle egzersizinizi yapacaksınız. Yağlı, tuzlu, baharatlı yemek yok. Bir ay sonra gelip tekrar kontrolünüze bakalım.
Başka bir şey vermeyecek misin ilaç mı?
Şimdi ilaca gerek yok. Doğal yollarla gidelim.
Sen ne biçim doktorsun? İlaç yazmıyorsun, sen beni iyi edemezsin.
Sinan Bey, maalesef sinüzit olmuşsunuz. Islak saçlara dışarı çıkıyorsun sanırım.
Vallahi ben sinüzit falan olmadım.
Ne demek sinüzit olmadı?
Ha bak Google'da yazıyor işte. Kanser olmuşum ben. Bütün belirtiler var. Tümör var benim beynimde ya.
Sinan Bey, bütün tahlillerinize baktık, kanser falan değilsiniz.
Ya burada yazıyor işte. Sen beni kesin üzmemek için söylemiyorsun ha kanser olduğumu. Doğru değil mi?
Şu Google'a bakmayı bırakır mısınız Sinan Bey?
Ya ben kesin kanserim, kesin ya.
Şimdi sonuçlarınıza baktım. Bazı tetkikler yapmamız gerekiyor. Yani kötü olma ihtimaline karşı bazı tetkikler yapacağız.
Kardeşim sen ne söylüyorsun ya? Kötü ne diyorsun sen?
İhtimal diyorum. Onun için bazı tetkikler yapacağız.
Kardeşim ne ihtimali? Gayet sağlıklı kadını düşürdüğün duruma bak ya. Ya bu nasıl doktorluk ya? Kadını bak bir anda ne hale geldi ya. Ya bırak. Gayet sağlıklı kadın kötü bilmem ne tutturdunuz. Uyduruyorsunuz bunları.
Para koparmak için ben.
Beyefendi önce tetkikleri yaptırın, ondan sonra şikayet edersiniz.
Sen görürsün, ben nereye şikayet edeceğim. Bekle sen.
Doktor bey, acil hastanız geldi, hemen gelmeniz lazım. Doktor bey, aynı anda 5 hasta geldi, trafik kazası olmuş. Doktor bey, 100.000 hastanız geldi.
Merhabalar hocam.
Benim biraz akut laranjitim var galiba. Televizyonda izlemiştim aynı belirtiler. Eşim de daha önce aynı teşhisle şu ilaçları yazmışlardı. Bunları bana yazabilir misiniz acaba?
Alo. Efendim Koray. Doktorun yanındayım ben şimdi. Öyle mi? Kimler geliyor? Tamam ben yetişirim. Tamam yetişirim. Şunları yazar mısınız? Yetişeceğim canım ben dedim sana. Araba var ayarlarım. Bir saniye. Ayağım da kaşınıyor. Tamam oldu.
Öksürecek gibi hissediyorum kendimi. Hasta olmaktan korkuyorum. Hasta olmam değil mi?
Doktorcuğum, ilaçlarım bitti. Birçok ilaç kullanıyorum. Hangisi bitti bilmiyorum. Yazıver.
Günlük hayatımızdan küçük kesitler sundum sizlere.
Hastanın yakını kim?
Ben.
Çok mu uzaktan geldiniz?
Valla daha yoludur. 1 saatlik yoldan geliyoruz, köyden geliyoruz.
Hasta bize gelene kadar çok kan kaybetmiş. Biz ekip arkadaşlarla elimizden geleni yaptık ama...
Katiller! Onları pastalar getirmiş. Burada sen bunu krampini istenler yok mu burada ya? Getirirsin senden öldürürsün sonra kimse bakmıyor ya.
Ya ne yapıyorsun bunu? Sakin ol.
Ben yine bayrama yakın. Sadıya bölme saatler yakın.
Ölmediler, yaşıyorlar.
Keferatın yüzüne bakın. Sadıya gidiyorum. Ya.
Muhles. Ya doktor diyor ki ölmemişler diyor.
Günlük yaşantımızda sıklıkla rastladığımız abartılmış yaz. Şiddet, tüm ulusların yaşamında var olan, bireyleri, bütün sosyal meslekleri, etnik grupları etkileyen, çağımızın en kontrol dışı antisosyal davranışlarından birisidir. Sağlık kurumlarına görülen şiddet, hasta yakınları ve diğer bireylerden gelen ve sağlık çalışanları için potansiyel risk oluşturan tehdit edici söz, ekonomik istismar veya davranış, fiziksel, psikolojik veya cinsel saldırıdan oluşan olaylar olarak ele alınmaktadır. Günümüzde sağlık çalışanlarının karşılaştıkları şiddet olayları gün geçtikçe artmakta ve yasalarla önlenmesi gereken ayrı bir önem kazanmaktadır. Hekime karşı işlenen bir suçun muhatabının sırasıyla başhekim, sağlık müdürü, müsteşar ve hatta bakan olduğu bilincine varılmadıkça bu soruna çözüm getirmek mümkün olmayacaktır. Hekime sadece kurumu değil, hizmet verdiği hastaların, onların ailelerinin desteği olmadıkça bu hizmetin yürütülmesinde çok zorlanırız. Bakın bir ilkokul öğretmenine yapılan bir şiddet karşısında bütün öğrenciler, bütün veliler bir araya geldiler, olayı protesto ettiler. Ama biz öldürülen bir meslektaşımızda ne yapıyoruz? Sadece doktorlar, sadece hastane personeli bir araya geliyoruz ve olayı protesto ediyoruz. Peki o doktordan iyilik bulan yüzlerce, binlerce insan, yakınları, hastaların sahipleri, bu meslekten geçimini sağlayan insanlar, onlar nerede? Ortada yoklar. Bir çocuğa anne ve babasından sonra en yakın kişi o çocuğun doktorudur. Bir kadının kocasından sonra en mahremi doktorudur. Çocuğa soruyorlar, büyüyünce ne olacaksın? Doktor olacağım. Olamazsan doktor düşman olacağım. Doktor döveceğim diyor. En gözde damat adayıdır doktor. Her anne kızını doktora vermek ister. Hatta bu yüzden benim kızımı ne doktorlar istediği özü vardır annelerin. Doktor afrodiziyaktır. Meslek seçerken, kız verirken, kocaya varırken, otomobil alırken, ev kiralarken doktor iyi. Ama para isterse şerefsiz. Yılmaz Özdil, Sözcü 1 Şubat 2018. Savaşta bile dokunulmazlığı olan sağlık çalışanları ne yazık ki günlük hayatta sadece darp edilmiyor, artık öldürülüyorlar. Anılarına saygıyla. Doçent Doktor Edip Kürklü 58 yaşındaydı. 1988 yılında 3 kurşunla öldürüldü. Buran cezalandırdım dedi. İngiltere'de benim elimde vefat etti maalesef. Göksel Kalaycı çağımızın Türkiye'nin yetiştirdiği en büyük göğüs cerrahıydı. En değerli hocamızdı. Benim de hocamdı. 65 yaşındaydı. 10 kurşunla öldürüldü. Hastası kanser rezidi olduğu için öldürüldü. Ölümünden önce dedi ki ikimizin de ölüm ilanı aynı sayfada çıkacak ve öyle oldu. İkisinin de ölümü aynı sayfada çıktı. Doktor Ersin Ergin her sene 17 Nisan'da artık sembol haline geldi. 2012 yılında bir 83 yaşında hastanın vefatından sonra torunu tarafından maaşını artık alamayacağı için bıçaklandı. 30 yaşındaydı.
Gaziantep'te acil serviste görevli göğüs cerrahi uzmanı Ersin Aslan hasta yakını tarafından bıçaklandı. Ağır yaralanan doktor hemen ameliyata alındı ancak kurtarılamadı. Cinayet sağlık çalışanlarını ayağa kaldırdı.
Doktor Ali Menteşe 50 yaşındaydı, göğüs hastalığı uzmanıydı. 2008 yılında Giresun'da tartıştığı bir hasta yakın tarafından koridorda kurşunlandı. Doktor Necati Yence 58 yaşında Ok Meydanı Hastanesi'nde çalışıyordu. 2006 yılında kronik bağırsak hastalığı nedeniyle eşini kaybeden bir hasta yakın tarafından kurşunlandı. Hasta yakını çocukluk arkadaşıydı, sonra intihar etti. Doktor 4 ay komada kaldı, tedavisi 3 yıl sürdü. Şu anda böyle felçli olarak görevine devam ediyor. Kamil Fortun 56 yaşındaydı. 2015 yılında göğüs cerrahı işe alınmayan bir şahıs tarafından 3 kurşunla katledildi. Niye yaptığın sorusuna canım sıkıldı. Hoşuma gidiyor, böyle zevkler var abi dedi. Doktor Abdullah Biroğlu 28 yaşındaydı. Mezun olduğu gün memleketi olan Diyarbakır'a tayin istedi. PKK tarafından öldürüldü. 3 yıllık doktordu. Sait Belirgen 50 yaşındaydı. Elazığ'da başhekimdi. 2017 yılında bir medikal firma sahibi tarafından odasına kurşunlandı. Saldırgan intihara kalkıştı. Başarılı olamadı. Bebek gibi yüzü var. Hüseyin Ar 28 yaşında. Bir emekli polis tarafından sağlık ocağında katledildi. Katil intihar etti. Doktor Aynur Dağdemir 49 yaşındaydı. Sekreterinin eski kocası tarafından 2015 yılında katledildi. Kadın doğumcuydu. Katil intihar etti. Doktor Metin Güneş 45 yaşındaydı. Radyoloji uzmanıydı. Karabük'te çalışıyordu. Yanına çalışan bir personel kocası tarafından arabasının önü kesilerek kurşun yağmuruna tutuldu. En son şehidimiz Doktor Fikret Hacı Osman. Psikiyatri uzmanıydı. 2018 yılında kafasına sıkılan tek kurşunla katledildi. Sana yazdığım ilaçlar tam ve zamanla kullanırsan kurtulursun dediğine sinirlenen bir hasta tarafından katledildi. Katil babasının tabancası kullanmıştı. Bir çocuğu anne babasından sonra en yakın kişi o çocuğun doktorudur. Doktor Hüsrev Çetin Hacı Osman Asaf şu şiiri yazmıştı. Çocukluğumda kasabanın tek doktor ölünce annem yas tutup sormuştu. Doktorlar ölür mü? Büyüyünce anladım herkes ölürmüş. Şimdi ben soruyorum. Doktorlar hiç öldürülür mü? Fakültesine girebilmek için sen en başarılı öğrencisi olmak zorundasınız. Üniversite giriş sınavından en yüksek puan alıp eğitiminize başladığınız zaman karşınıza tüm üniversitelerin yaklaşık 1,5 misli 6-7 yıl süren bir eğitim çıkar. Hiçbir fakültede olmadığı kadar ağırlıktaki dersler, vazgeçilmez gece ve hafta sonu nöbetleri beklediğini görürsünüz. Mezun olduğunuz gün hiçbir üniversite görülmeyen bir uygulamaya maruz kalırsınız. Diplomanızı vermezler. İstediğiniz derecede mezun olsanız bile diplomanızı alamazsınız. Alınmayan tek meslektir. Bu durumda ne ulusal ne uluslararası mesleği icra edemezsiniz. 18 yaşta girdik fakülteden 25-26 yaşta çıkarsınız. 2 yıl zorunlu hizmete gitmek zorundasınız. Zorunlu hizmeti bitirdiğiniz zaman 28-29 yaşta gelmiş olursunuz. İhtisas yapmaya karar verirseniz istifa ederek 1 veya 2 yıl özel bir kursa gidersiniz. TUS sınavına hazırlanırsınız. ÖSYM'den daha zor bir sınav olan TUS sınavını geçerek hasbelkader arzu ettiğiniz veya zorunlu olarak şansınıza düşen herhangi bir uzmanlık eğitimi süresince insani koşullardan çok uzak, çok çalışmalı, bol nöbetli, en az 4 bazen 5-6 senelik az maaşlı çok çile bir dönemi yaşarsınız. İşte bunlar yatarak para kazanan genç meslektaşlarımız. Bir başarılı beyin ameliyatından sonra doktor ve hemşirenin zafer işareti. Bu inanılmaz bir fotoğraf. Tıp tarihinin en çabuk fotoğraflarından birisi belki de. 1987'de Polonya'da 23 saat süren bir kalp naklinden sonrası cerrah hastasını son bir kez kontrol ediyor. Asistanı köşede sızmış kalmış. İnanmayacaksınız ama kalp naklinden sonra hasta 30 yıl yaşadı. Doktor ondan 7 yıl önce yaşamını yitirdi. Uzman olduğunuzda yaklaşık olarak 35 yaşta gelmişsinizdir. Sizi tekrar 2 yıllık bir zorunlu hizmet bekler. Bu arada muhtemelen evlenmişsinizdir. 1 veya 2 çocuğunuz vardır. Eşiniz de herhangi bir şey çalışmaktadır ve ailenin bölünmesi kaçınılmazdır. 40 yaş sınırına yaklaşmışsınızdır. Erkekseniz evli, askerlik sizi bekliyor. Şanslıysanız kısa dönem askerlik denk gelir. Bana denk gelmedi. Kadınsanız evlenme şans geçmek üzeredir. Evliyseniz gecikmiş bir gebelik, evli değilseniz çok gecikmiş bir evlilik ile karşı karşıyasınız. Eğer bir de yan dal uzmanlığı yapmak isterseniz 2-4 yıl süren yan dal uzmanlık eğitimi sonrası tekrar 2 yıl zorunlu hizmete gitmek zorundasınız. Bir kez daha eş durumundan ayrılmak zorundasınız. Merak ediyorsanız maaşınız ancak sizinle aynı yaşta olan bir subay veya polisi maaşına yakın olabilir. Liseden birlikte mezun olduğunuz arkadaşınız 4 yıllık bir iş idaresi veya yönetim fakültesi bitirmişse o günlerde artık genel müdür veya genel müdür yardımcısı olmuştur. Büyük bir odası, 2 sekreteri, masada 3-4 telefonu vardır. Siz hala hastanede 5-6 kişi asistan odasında ancak çay içebilirsiniz. Bu arada arkadaşınızın aldığı maaşı ve çalışma şartlarını hayal bile edemezsiniz. Niye doktor oldum? Çünkü babamın parası çoktu. Uyumaktan nefret ederim. En uzun eğitim burasıydı. Hayatta yeterince zevk aldım. Aksiyonsuz yaşayamam. El yazım okunmasın isterim. Arada bir darp edilmek hoşuma gider. Kütüphanede yaşamayı seviyorum. Bu saçlar kafama fazla. Gözlük hastasıyım. Hep bir göbeğim olsun istedim. Canım tuz çekti. 40 yaşından önce ölemeyi düşünmüyorum. Özellikle son 10 yılda bu saldırının artmasının altına yatan bir kültür var. Ve kültürün oluşmasında televizyonlarda halka bol bol seslenen siyasilerin rolü elbette ki çok büyük. Yaratılan çatışmacı bir kültür, öteleştiren bir dil, haliyle halkı çok etkiliyor ve aslında şiddetin toplumun tüm kesimlerinde tırmandığını görüyoruz. Sağlıkta şiddet de bu toplumsal şiddetin bir parçası aslında.
İsteyene sebep çok. Kartı yetersiz bakiye uyarısı veren Maganda otobüste terör estirdi. Şoförü hastanelik etti.
Birbirini yaralayan öğrenciler, hayatını kaybeden öğretim görevlileri. Şiddetin nedeni ne? Ekranlar, bilgisayar oyunları, sosyal medya. Devir teknoloji devri ama özellikle çocuk ve gençlere dikkat. Çünkü şiddet fark etmeden bir anda hayatın içine girebiliyor.
Ekrandan şiddet algısını alıyoruz, yazılı basından alıyoruz, oyunlardan alıyoruz, sinemadan, sanattan, aslında edebiyattan pek çok yerden alıyoruz. Ama teknolojinin bir getirisi gene hızlanma ve teknolojiyle birlikte daha çok bizim ulaştığımız şey ekranlar. Yani internet, bilgisayar, televizyon.
Ekran.
İlk defa bir açık oturumda bir gazeteci şöyle söyledi.
Sağlık personeline de aynı şekilde çok yüksek bir şiddet var ve hatta doktorlar yani neredeyse yılda 2-3 meslektaşlarını yitiriyorlar ve protestolar ediyorlar. Bu konuyu gündeme getirmeye çalışıyorlar. Ama doktorlara da aynı şekilde sağlık personeli diyelim, doktor demeyelim sadece. Çok yükselen bir şiddet var. Bir kural tanımaz bir öfke var. Bu işte şu anda kendisini eğitim alanında gösterdi. İşte yarın bir hastanede gösterebiliyor. Öbürsü gün sokakta gösterebiliyor. Topluma hakim olan bir öfke ve şiddet var. Biz başta medya mensupları olmak üzere herkesin biraz daha sorumlu davranması gerekiyor diye düşünüyorum. Bir noktada dizilere de bu konuda biraz bakılması lazım.
Kendisine gerçekten teşekkür ederim.
Başkent Ankara'da doktorun ihmali pahalıya mal oldu.
Televizyonların tırmandırıcı
karnında
mesajları.
bant unutulan bir anne şimdi doğmamış çocuğundan vazgeçmek zorunda.
Devlet hastanesinde sezeryan olduydum. Karnımda bant unut.
Fakat meslek odalarının yaptığı baskıyla bakın ne hale geldiler.
tekrar geçtiğimiz günlerde doğum sırasında karnında bant unutulduğunu iddia eden bir kadın hasta ve avukatının açıklamaları kamuoyunda geniş yankı bulmuştu. Hasta ve avukatının iddialarına
İlgili derneklerin kesinlikle mücadele etmesi lazım.
Vermiştik.
Şimdi sıra dışı
Bu artık
mücadelesini ekranlarınıza
aklın
getireceğiz.
durduğu bir yer.
Tartışma sırasında bir kadın eşini bıçakladı. Adam ertesi gün hayatını kaybetti ama kadının iddiasına göre ölüm gerekçesi olay sonrasında gittikleri acil servisteki 2 doktorun eşiyle ilgilenmemesiydi.
Samsun Canikli'de yaşayan Bedriye Altun, eşi Erdoğan Altun'un ölümünün ardından 1,5 yıl hapis yattı.
Ben sadece korkutmak bıçaklamıştım ama doktor kocamı öldürdü. Meslek o kadar dersleştirildi ki bana iyisinden bir MR yaz bakalım. Buranın başhekimi nerede? O başhekim buraya gelecek. Randevum yok ama muayene olmak istiyorum. Ayrıca işim acele. Ben şimdi sana baktırmasını bilirim. Telefon açarsam görürsün. Bana eşek gibi bakacaksın. Ama bakın genç arkadaşımız mahkemeye veriyor.
Mahkemede adam şey dedi. Ben eşek gibi bakacaksın demedim. Eşek gibi bakılacağım.
Avukatının tavsiyesi de muhtemelen diyor ki estağfurullah ben doktor nasıl öyle söylerim? Ben demektim ki ben eşeğim. Bana eşek niyetine bakacaksınız. Mutlaka mücadele ediniz.
Mahkemede adam şey dedi. Ben eşek gibi bakacaksın.
9.000 lira para cezası aldı. Daha hastaneye gelmeden terör başlıyor. Bakın ATV'de bir dizi. Teröre niyetli
Doktorlar
kesin.
seni iyileştirmesi.
Eğer doktor seni yetmezse hastaneye geldikten sonra
Kardeşime bir şey olursa.
bu bir başka dizi.
Beni iyi dinleyin. Bugüne kadar yaptığınız en büyük ameliyat bu. Masada yatanın sadece benim babam olduğunu sanmayın. Şu an itibariyle hepinizin hayatı masada yatıyor. Ya babamı yaşatıp ameliyattan sağ çıkarsınız.
Antalya'da tedavi gördüğü hastanede hayatını kaybeden bir hastanın yakınları sağlık çalışanlarına saldırdı. Doktor ve hemşireleri tam 5 dakika boyunca darp ettiler. 3 şüphelinin hatırlamadığını iddia ettiği o saldırının güvenlik kamerası görüntüleri ortaya çıktı.
Üzerine yürüdü, tokat attı. Saçını çekip betona vurdu. Yoğun bakımdaki o şiddetin...
Dizi filmler gerçek hayatın biraz ötesine giderek acil veya polikliniklerde çıkan kavgalara rahmet okutan, yoğun bakım ve ameliyathaneye basma,
Sayın seyirciler, bundan böyle
tehdit
dayak
etme gibi
yiyen
olaylar
doktordan
sanki normal
halkın
olay gibi
haberi
sunulmakta.
olmayacak. Çünkü
Şiddet
bir genel
normalize
yayın
edilmekte.
Sağlık Bakanlığı şiddetin gizlenmesini istedi.
Bakanlık karar aldı. Doktora şiddet haberleri yayınlanmayacak.
Manası.
Adana'da Seyhan Devlet Hastanesi'nde 4 güvenlik görevlisiyle bir hastane çalışanının darp edilmesiyle ilgili güvenlik kamera görüntüleri ortaya çıktı. Hastane çalışanlarını darp eden 5 kişi hakkında dava açıldı.
Tekmeler, yumruklar havada uçuştu. Hastane koridoru...
Geçmişte siyasilerin, devlet büyüklerinin sağlık personel arkadaşlarına bir göz atalım. Kenan Evren, askeri cuntanın başıydı. Mecbur hizmete gelen doktorları ağaca bağlayın, kaçmasınlar dedi. Paşamızın bağlayın dediği o sağlık ocaklarında it bağlasanız durmazdı. Evren, askerden fazla alıyorlar diye sağlık personel esasını iptal ettirdi ve tüm sağlık çalışanlarını 657'ye tabi kıldı. Fırat Hekim 18 bin lira maaş almaya başladı. Bir teğmenin maaşı 35 bin liraydı. O sırada eşi hanımefendi Gülhane'de yatıyordu. Beyin tümörüydü. İyileşmesi mümkün değildi. Tüm doktor düşmanı oradan kaynaklanıyordu. İmran Aykut hanımefendi Çalışma Bakanıydı. Doktorların maaşlarının 400 dolar civarına inmesi karşısında ne verirseniz verin bu doktorla göz doymaz dedi. Yıldırım Akdoğan'a kendisi bir nöropsikiyatristti. Sağlık Bakanı iken habersiz gitti hastanede. Hafta sonu bakamında bulamadı. Başhekimin kapısını kırdı. Osman Durmuş bir biyoloji doçentiydi. Antalya Devlet Hastanesi'ni denetlerken Mayıs ayında kaloriferin yandığını gördü. Doktor elleri 10 dakika kaloriferin üzerine bastırarak yanmasını sağladı. Bir Sağlık Bakanımız doktorların eli hastanın cebinde dedi. Yetmedi. Üstüne bir de Paris doktorlar gürültü yapıyor diye ilave etti. Sağlıkta dönüşüm adı altında sağlık çalışanlarının ve doktorların sağlık kölesi haline getirdi. Hiçbir Adalet Bakanı duydunuz mu benim Hakimim, savcım rüşvet alır. Hiçbir İçişleri Bakanı duydunuz mu? Benim polisim rüşvet almıştır, alabilir. Tapu Kadastro Genel Müdürü bu alınanlar hediyedir dedi, biliyorsunuz. Devlet hastaneleri duvarlarına telefonumuz kadar yakınız. Şikayetiniz varsa hemen arayın dediler. Bir devlet büyüğümüz, ben doktora iğne yaptırmam. Doktorlar adam felç eder Allah dedi. Doktor efendi dönemi bitti diye ilave etti. İşte felakete başlayan gibi bu cümleler oldu ve doktora saygısızlık etmeyi, hakareti kendine hak gören bir vatandaş türü ortaya çıktı. Çok kolay erişim, değersizleştirme ve sıradanlaşma sağlık personelinin önde gelen sorunu haline geldi. İster istemez hastaneler insanların sıkıntılarını deşarj edebilecekleri, istediği gibi bağırıp çağırıp benim haklarım var diyerek devlet estirebilecekleri yerler haline geldi.
Sizin çocuğunuz olsa siz aynı şey yapmaz mıydınız? O zaman bana karışmayın. Bana karışmayın.
Bir anda hasta ve yakını efendi doktor maraba oldu. İnanmayacaksınız ama hasta ve yakınların canı istediği gibi şikayet edebileceği Sabim ve Bimer gibi telefon hatları sağlanmışken doktorun uğradığı haksızlık karşısında müracaat edebileceği hiçbir merci yoktu. Sağlık çalışanlarının vatandaşla zorunlu diyaloğunda şiddet sarmalıyla karşı karşıya bırakılması asla kabul edilebilir değildir. Giderek hak, özgürlüklerden ve eğitimden kopan bir süreç, magazinleşen bakış açısı, özendirici yaklaşımlar, yaptırımı olmayan düzenlemeler, böylesi kadim bir mesleği ve mensuplarını hızla itibar kaybına sürükledi. Bir de meslektaşlarımızla sorunlarımız var. Bakın bir meslektaşımız neler söylüyor. Kendisi Akçası Doktor Profesörü.
Hasta olduğunuz zaman mutlaka hemen hiç gecikmeden doktora gidin. Muayene parasını ödeyin. Çünkü doktorunuzun yaşaması lazım. Reçetenizi alın. Eczaneye gidin. İlaçları alın. Parasını ödeyin. Çünkü eczacının da yaşaması lazım. Eve gelin. İlaçların hepsini çöpe atın. Çünkü sizin de yaşamanız lazım.
Kendisi muhtemelen hastalarına ilaç vermeden iyileştiriyor. Bir başka onkolog arkadaşımız bütün kanser vakaları saçmadır dedi. Patologa bir takım olguları mikroskopta kansere benzetiyorlar ve hastanelere reyting yapıyorlar. Bu tür yayınların hepsinin ensest türü ilişkiler olduğunu farkındasınız. Bu iki arkadaşımız da İstanbul Tabip Odası tarafından disiplin kuruluna verildi. Bir de meslekte rakiplerimiz var.
Senin hayatını kurtarman için ben bir çaba sarf ediyorum burada. Bak, bir doktora gittiğin zaman doktor seni bir ameliyat ediyor. Kalpteki tıkanmış olan 2 tane damarını değiştiriyor. Bacaktan damarlar alıyor, takıyor ve doktora diyorsun ki doktor bey hayatımı kurtardın. Şu araba benim sana hediyemdir. Neden doktora bu arabayı hediye ettin? Çünkü doktor senin hayatını kurtardı. Tamam da hayatını kurtardı, daha 10 sene 20 sene daha yaşayacaksın. Sonra öleceksin. Doktor bir şey yapabilir mi? Yapamaz. Vaizler bir doktordan daha kıymetlidir, daha değerlidir. Neden? Dünyada hayatını kurtarmakla kalmaz. Bir de ebedi hayat.
Vatandaş kendisine hiçbir fayda sağlamayacak bir muska yazan önünde el pençe divan dururken doktor yapmadığını bırakmıyor. Onuru kırılmış bir sağlık personeli can kaygısı güderken acaba şiddete uğrayacak mıyım diye endişe ederken nasıl veriliyor sağlık hizmeti verebilir? Acaba ortada devletin görünmez bir mesleki kayrımcılığı mı var? Bir hakim, vali, kaymakam veya polise sözlü saldırı dahi olduğu zaman devlet ne yapıyorsa sağlık personeline de bu muamelelere maruz kaldığı zaman onu yapsın. Bunlar devletin adamı olabilir ama sağlık personeli devletin büyük masraflar yetiştirdiği çok değerli kamu görevlileridir. Cumhur'a göre 7 yıl ve üzeri hapis gerektiren durumlara tutuklama gerekmektedir. Fakat bugüne kadar hiçbir doktora şiddet yapan tutuklanmamıştır. İfadesi alıp evine gitmiştir. Doktoru dövdüm, evime gittim sloganı kullanılıyor. Ben çok merak ediyorum. Acaba aile bu şahsa aferin diyor mu? O aile bir daha ne yüzle hastaneye giderek hizmet talep ediyor? Bugüne kadar bir aile yakınını doktor döverek daha iyi sağlık hizmeti almış mıdır? Yerden 10 kilogramlık kaldırım taşını alıp doktorun kafasına 2 kez vuran, 3. darbeye yetiştirenler tarafından kurtarılan bir insanın ruh halinin normal olması mümkün müdür?
10 kiloluk parke taşıyla doktora saldıran Abdülkadir Keskinli gözaltına alındı. İfadesinde herhangi bir pişmanlık duymadığını...
Bu şahsın savcının sevki veya hakim kararıyla bir psikiyatrik kliniğe sevk edilmesi, tedavisi tamamlandıktan sonra tedavisi tamamlandı. Ancak kurul kararı verilerek yatması, ancak taburcu olduktan sonra mahkemeye çıkarılarak topluma kazandırılması gerekir. Çünkü bu sağlıklı bir davranış değildir gerçekten.
Ama bir niye doyuruyor? Doktorun hiç suçu yok mu? Ama bir niye doyuruyor?
Sorun bakayım. Niye dövdü doktoru? Buna ihkak-ı hak deniyormuş hukukta. Suçu kabul etmek.
Karaman'da bir hasta ameliyat sonrası pansuman yaptırmak için hastaneye gitti. Başta her şey normaldi ama pansuman sırasında canı yanınca sağlık çalışanını darp etti.
Önce
Önce tokat attı, sonra tekme. Pansumanda canının yandığını söyleyen hasta sağlık çalışanını darp etti. O anları güvenlik kamerası böyle kaydetti. Görüntüler Karaman'da bir özel hastaneden. Ameliyat olan bu hasta pansuman için geldi. İşte o sırada canının yandığını iddia etti, sağlık çalışanlarına saldırdı. Diğer görevliler araya girdi. Sağlık çalışanını tekme tokat darbelerinden kurtardı. Sağlık çalışanı darp raporu aldı. Saldırgan da polise teslim edildi. İfadesinin ardından serbest bırakıldı.
Farkındaysanız soldaki insan sağdaki hayvandı. Bu filmin bitiminde köpek veteriner yüzünü yalıyor.
Her name is Wunda, that it means close to die. Wunda. Wunda. And actually, her name is exactly with her, because she was in different situations and was very close to die. The last time she had a very serious illness. She was really bad. She lost weight and she was looked, or she became unbelievable. And now we are going to give her paradise on the island.
Hastalarımızdan bu kadar minnet beklemiyoruz ama saygı göstermelerini her zaman arzu ediyoruz. Bakın bu çok hasta olan bir maymun. Yemiyor, içmiyor, ölmek üzere. Yıllar önce kendisine bakan veteriner geliyor. Sevinçten çıldırıyor. Boynuna sarılıyor, saçlarına uçuyor. Karşılıklı seviştikten sonra yatağında kırılıyor ve ölümü bekliyor. Sağlıkta şiddet en çok sözel ve fiziksel şiddet 2015 yılında zirve yapmış durumda. 2017 yılına bakmayın, sonra 6 ay sadece. Yaklaşık her yıl 10.000 civarında sözel şiddet var. Yaklaşık 2500-3000 civarında fiziksel şiddet var. Sağlık Bakanlığı'nın istatistikleri. En çok eğitim hastanelerinde, devlet hastanelerinde oluyor. Eğitim hastanelerinde çok fazla. Üniversiteler ve özel hastaneye gittikçe şiddet azalıyor. İnanmayacaksınız ama %40 civarında şiddeti kadınlar yapıyor. Daha da ilginci %36 hastaların kendileri doktora şiddet uyguluyor. Bu çok ilginç bir grafik. Polikliniklerde bakın sabah şiddet başlıyor, öğlene doğru tırmanıyor, öğlen tatilinde bir dip yapıyor, öğleden sonra tekrar başlıyor, akşam saat 7'ye kadar şiddet devam ediyor. Acil servislerde sabah 7'de 0 şiddet varken başlıyor, öğlene doğru artıyor. Saat 20'den sonra çoğalıyor çünkü herkes evine gitmeden bir de doktora gideyim, bir acil muayene olayım telaş içerisinde oluyor. Gece 24'e kadar şiddet devam ediyor. Kliniklerdeki şiddet öğlen üzeri çok artıyor çünkü herkes hastasını görmek istiyor fakat çok yanında defalarca birkaç kişi kalmak istiyor. En çok şiddetin öğlen üzeri görüldüğünü görüyoruz. Sağlık kurumunda çalışanların şiddete uğrama oranı diğer iş yerlerine göre 16 kat olduğu saptanmıştır. Beyaz kod bir kurtarıcı gibi bakıyoruz. Kayıtlar incelendiğinde sağlık ortamındaki şiddetin yaygınlığı ve kanıksanmışlığı daha iyi anlaşılacaktır. Beyaz kod istatistiklerinden geçtiğimiz 5 yılda 46.000'i aşkın sağlık çalışanı beyaz kod başvurusunda bulunmuştur. Bu sayı yalnızca başvurulanlar. Çekinen, başvuru fırsatı bulamayan ya da bu düzenekten yarar gelemeyeceği varsayımıyla çağrı yapmayan meslektaşlarımız da var. Adliye ve polisiyenin ötesinde düşünmeyi gerektiren bir sorunla karşı karşıyayız. İnsanlara yaşam sunan bir sanatın icracıları olan hekimlerin ölümcül şiddetin bu hedefi olmaları değersizleştirme ve sıradanlaştırma ile açıklanabilir ancak. Bakınız bu bir hekim, kendisi bir sağlık komisyonu başkanı, cümle aynen şöyle. Bizim birkaç tane aklı haber başhekim hastanede ağır ameliyatlar yapmayın diye resmi yazı yazmışlar servislere. Öyle birkaç tane belge var. Tabii mazur görün, bunlar sopalık. İzmir Tabip Odası'ndan Ceyhun Balcı hocamızın yaptığı bir araştırma 2010-2012 yılında internet ortamında yapılan bir araştırma. 600 kişi telefonla aranmış. Ankete her iki hekimden biri meslek yaşamında fiziksel veya sözel şiddete uğradığını beyan etmiş. Şiddete uğrayan her iki hekimden birisi fiziksel şiddete uğramış. Bunların içinde tekmeli, tokatlı, yumruklu saldırıların yanı sıra ateşli silah, kesici delici alet olduğu ifade edilmiş. Sıra dışı bir oldu da bir samuray kılıcı var. Aynı ankette meslektaşlarımızın devlet büyüklerinin söylemlerinden şiddeti üreten ve özendiren nitelikte olduğunu ifade etmişler. Yine o ankete katılan meslektaşlarımız sağlık yöneticilerinin şiddet olaylarının yaşanmaması için çaba göstermediklerini ve şiddete uğrayan sağlık çalışanların yanında olmadıklarını ifade etmişlerdir. Aradan geçen zamanda beyaz kodun ne kadar faydalı olacağını göreceğiz. Sağlık çalışanlarının şiddete maruz kalmasının önlenmesindeki en önemli faktör yeterli güvenin sağlanmaması olmakla birlikte yetişmiş güvenlik eleman yetersizliği, bu elemandan sahip oldukları yetkiler ve sorumlulukların tanımlanmamış olmasından kaynaklanmaktadır. Örneğin, polise mukavemet suçu için uygulanan prosedür ve yasa maddeleri sağlık personeline yapılan şiddete karşı da uygulansa vatandaş cürmünün bedeli ne olduğunu bilecektir. Bizim insanımız polisi sevmez ama ona yaptırımlar nedeniyle saygı duymak zorundadır. İnsanlarımız doktor hiç zaman sevmemiştir. Doktor parası olsun diye bedduamız vardır. Ama doktor her zaman saygı duymuştur. İşte sorun bu saygının kaybolduğu yerde başladı. Bugün bir havayolu hatta otobüs şirketi sorun çıkaran bir yolcuya bir daha servis vermeme hakkına sahip. Ama hastane demin başına zarar veren, doktor ve personel darp eden bir hasta yakını aynı gün arsız bir şekilde hastaneden hizmet alabilmekte. Hastane ortamında alınan güvenlik önlemlerinin yetersizliği, yasal düzenlemedeki boşluklar ve görsel yazılı medyada yardımıyla ortaya çıkan şiddet olguları sağlık çalışanlarının kendilerini güvende hissetmemelerine neden oluyor. Sağlık personelinin önemli sorunlarından biri ani olarak şiddete uğradıkları sırada kendilerini koruyacak fizik kondisyonda olmadıkları gibi yardım alabilme imkanları da olmaması. Bu nedenle sağlık personeli oluşabilecek bir şiddet olan hissettiği zaman acilen yardım isteyemiyor.
Çok konuşma sen, ne olur.
Gelsene sen şöyle.
Böyle bir doktorun ancak dizilerde olabiliyor. Ne yapalım? Bu faktörleri bir de aykırı da dersini koyalım. Şiddet olaylarının nedenlerini sıralarsak, hasta ve hasta yakınlarının bir önce kendileriyle ilgilenmesi istemeleri, kendi hastalarının daha acil durumda olduğunu, kendilerinin herkesten daha önemli olduklarını düşünmeleri, yani yüksek ego, muayene veya tetkik için uzun süre beklemeleri, personel yetersizliği, iş motivasyonu, çalışma ortamı ve kontrolsüz öfkenin etkili olduğu görülmektedir. Bakın bu Ok Meydanı Hastanesi'nde saat 16.44 sırasında çekilen iki monitör görüntüsü. Birinci arkadaşımız 51 hasta muayene etmiş. Yani hastalığın başına öğlen tatiline düşerseniz 9 dakika. Biraz daha meraklı bir arkadaşımız. Öbür arkadaşımız 60 hasta muayene etmiş. Yani hasta başına 7.6 dakika düşmüştür. Böyle bir sağlık hizmetinden hangi hasta memnun olur? Hangi doktor bu hizmetten onur duyar? Size soruyorum. Başkaları adına ilaç yazdırma talepleri, nedensiz olarak rapor talep etmeleri ve sağlık personelinin bu talepleri haklı nedenlerle olumlu karşılamaması, hasta ve hasta yakınlarının işlerinin düzenli görülmediği veya doktora alınmada adil davranmadığı hakkındaki şüphelerinin olması, halkın hastane içinde sınırsız davranma, şiddet uygulama ve silah kullanmalarının bile hak olduğunu düşünmeleri, tüm bunların yanında görünürde güvenlik görevlilerinin yetersiz olması şiddete davet gibi algılanmaktadır. Sağlık personel şiddet uygulaması her ülkeye göre farklılık gösterse de özellikle gelişmekte olan ülkelerde ve eğitim seviyesi düşük olan yörelerde acil servisler şiddet olayının en sık rastlandığı yerlerdir. Bakın bu bir ambulans görevlisi.
Yediği dayağın nedeni ise basit bir uyarı.
Ambulans parkini oraya çekmeyin dedik. Vay efendim söz müsünüz deyip araçlara inip direkt üzerimize geldiler.
Kolu kırılan, yüzü şişen doktor şu anda çalışamıyor.
Ambulans hizmetleri de bunu takip etmektedir. Sağlıkta şiddetin en utanç verici yönünün en fazla cinsel istismara uğrayan sağlık personelinin hemşirelerimiz, kardeşlerimiz olduğundan da utanç duyuyorum. Tüm bu açıklamaların ötesinde asıl ve önemli olan konu sağlık personelinin uğradığı şiddete olan koruyucu yasal düzenlemelerin hazırlanması ve önemli uygulanmasıdır. Beyaz koddan bakalım ne çıkacak? Cezai müeyyideler uygulanacak güya. Kanunlar çıktı ama hiçbirinin sonuçları yok. Bugüne kadar bir hasta veya ailesinin şiddet uygulamaktan daha hizmet almış olduğu görülmüş değildir. Yeni çıkarılan yasalar bunu emrederken şiddet uygulayıcıların ifadeler alındıktan sonra serbest bırakılmaları, tutuksuz yargılanmaları, verilen cezalar tecil edilmesi veya paraya çevrilmesi, cezaların yaptırım gücünü ve caydırıcılığını ortadan kaldırmakta, toplumda yapılan kar kavgası zihniyetinin yerleşmesine neden olmakta, bazı toplumlarda bu tip kişilerin ailenin kahramanı muamelesi gördüğü bilinmektedir. Bakın bu bir doktorun kapısı. Tedavisi beğenmemiş olabilir ama bir hakimin, yargıcın kararını veya bir kaymakamın kararını beğenmediği için o görevlinin kapısını tekmeleyebilir mi bu insanlar? Kesinlikle hayır. Olaya çözümsüzlük getiren önemli nokta, bu mütecaviz arsız bir şekilde hastanede bulunan şikayet masasına gidiyor, şikayet ediyor, doktorun da savunması alınıyor. Bunlara rağmen doktorun hasta veya refakatçiler için Sağlık Bakanlığı'na giderek şikayet edebilecekleri bir makam veya telefon yok. Yani ister Sağlık Bakanlığı'na, ister hastane idaresi ilgili birimine herkes doktora şikayet edebilir ama doktor adeta aslanların önüne atılmıştır.
Doktor kendisine hakaret eden hasta yakınından şikayetçi oldu. Mahkemeden de emsal bir karar çıktı. Hakaret eden hasta yakını hapis cezası aldı.
Lütfen
Niğde'de
şikayette bulununuz. Eninde sonunda bu insanlar cezalandırılacak.
Çocuk acilinde görevli bir doktora hasta yakını hakaret etti.
Bu hasta 11 ay aldı ama iyi halden ceza indirimi aldı.
Ve dava açıldı. Niğde 5. Asliye Ceza Mahkemesi'nde
diğer bir husus, doktorlar da her insan gibi hata yapabilir. Ancak bilinmelidir ki doktor hatalarının en önemli bölümü sistemden kaynaklanmaktadır. Uzun çalışma saatleri, yardımcı personel yetersizliği, ağır iş yükü, modern teşhis ve tanı yöntemlerine kolayca ulaşılamaması, yetersiz ve kötü hastane koşullarının oluşturduğu zeminde istenmeden yapılan hatalar olmaktadır. Bu hataların dışında istenmeyerek yapılan hatalar olabileceği gibi bunlar malpraktis kuralları içerisinde tanımlanmıştır ve Hammurabi'den beri suçtur. Ancak ceza yargısı tarafından değerlendirecek bir konu olup, bu ülkede Hammurabi kanunları olmayıp ceza bireylerin kendi başına uygulayacakları bir hak değildir. Hatalı bulduğunuz zaman doktora şikayet edebilirsiniz, yargıya gidebilirsiniz. Tıpta yanlış uygulama sebebiyle hekimin hukuki sorumluluğu kapsamında yargı yolunu seçebilirsiniz ama elinizi sürmeye kalkamazsınız. Aslında doktor tüm eğitim boyunca 0 hata eğitimi almıştır ama buna rağmen hata yapabilir çünkü doktor da bir insandır. Bu son günlerde bir diziden alınan görüntü. Çok kısaca vereceğim.
Geçenlerde doktor.
Birincisi önemli. Evet.
Günden güne kötüleşiyor doktor. Beklenen tabloymuş. Ne konuşuyorsun sen bana? Bu çocuk bir haftadır 2 kelime etmedi be. Başlatma hastanenden. Ben sanki nereye
Konuşma
götüreceğini
boyunca
bilmiyorum
doktor
değil mi?
hakaret doluydu.
En iyisi
Ciddi
olduğu için sana
bir toplum
getirdik.
kuruluşu oluşturdu.
Delik
Türkiye müracaat ettik.
gönderiyorsunuz.
Türkiye müracaat ettiler.
Ya adam gibi bu çocuğu tedavi edersin.
Özür dilemek zorunda kaldı. Fakat bakın, özürü bile saçma.
Geçenlerde doktora ağır davrandım. Ne bileyim Nedim'i öyle görünce de...
Geçen doktora kötü davrandın. Bir akşam beni çağır da gönlünü alalım.
Değil, tabii.
Bakınız, Kayseri Memorial Hastanesi'nde bir genç arkadaşım sponsor çocuk malzeme satan firmadan biriyle direkt görüşme yaparak sponsorluk çekmesini sağladı. O kadar basit ki o dizideki sponsor firma arıyorsunuz, sponsorluk çekmeni istiyorsunuz ve bakın sizden kendi adımıza özür diler, göstermiş hassasiyetten ilgili alakalardan da teşekkür ederiz, sponsorluğumuzu çektik dediler. Ben böyle bir protesto hazırladım, Hürriyet Gazetesi'ne yayınlanması için yayınlamayı kabul etmediler. Sözcü Gazetesi ilan için 4.000 lira teklif etti, kabul ettim. Bir saat sonra da 9.000 lira istediler. Bakın bu da var. İlk defa böyle bir dizi oldu.
Arkadaşlar sizleri dışarı alalım.
Lütfen dışarı çıkar mısınız dedi doktor. İkinci seansta gene.
Arkadaşlar, her iki yaralımızın da durumu ciddi. Şu an ameliyata alındılar. Hepimiz için çok zor ve uzun bir gece olacak. Sizden ricamız, biz yakınlarınızı hayata döndürmeye çalışırken sakin kalmanız ve hastane personeline yardımcı olmanız. Şimdi sizi dışarı alabilir miyiz?
Doktor bey, hastalarımızın hayat riski olduğu kadar güvenlik riski de hala devam ediyor. Eğer müsaade ederseniz birkaçımız burada kalsın. Bizim içimiz rahat eder.
Muhtemelen dizi oyuncularının çoğu
kalabalık
tanıdığım
olması
olduğu
yeter.
için
Biz
olayı
her
çok
türlü
yumuşak bir
görüşmeyi
şekilde
sizinle paylaşacağız
cevaplandırdılar.
zaten.
İlk
Ama
defa
siz
bir
inşallah
mafya
bunu-
filminde
Teşekkür
doktora ve
ederiz.
hastane saygılı davranılmıştı. Bunun üzerine tabip odasına müracaat ettim. Örneklerini gönderdim. Bir teşekkür mektubu yazmalarını rica ettim. Hatta 14 Mart'ta bir plaket vermelerini, böyle onurlu bir davranış yaptıkları için, örnek bir davranış sergiledikleri için biz mafya filmine ödül vermeyiz dediler. Ama ben rahat durmadım gene. Gazetelerde kendilerine bizzat teşekkür ettim. Lütfen bunları teşvik edelim. Bakınız böyle bir korkunç olay yaşadık. Bir urolog arkadaşımız darp edildi. Sosyal medyadan birkaç tane yayını size utanarak anlatacağım. Vallahi kimse kalkıp da sağlıkta şiddet olmaz demesin. Bazıları o kadar hak ediyor ki sanki hayırlarına muayene ediyorlar. Azarlıyorlar. Kimse halkı dinlemiyor. Kesinlikle süper olmuş. Keşke sakat bıraksaydı. Az bile dövmüş. Sorun şimdi doktor haklı olur. O kardeşimizin ellerine sağlık. Bence iyi yapmış. Doktor önce hastasına bakar. Benim babama da yapsalar burun değil bütün kemiklerini kırarım. O çocuk acilen serbest bırakılmalı. Şov adı altına itibar etmeyin. Hasta yakını hakkı doktor ne yaptı ki? Dayağı yedi. Ellerine sağlık kardeşimin. Daha fazlasını okumaya gerçekten utanıyorum. Ne yapmalıyız? Bu doktor hanım gibi Aikido'da mı öğreneceğiz?
Bana bak. Çok konuşma sen ne
Mümkün değil. Taksi şoförleri gibi bunları mı bulunacağız arabamızda? Bize yakışmaz. Hele bu hiç mümkün değil. Bakın Marmara Üniversitesi Hastanesi'nde şiddete uğramış bir şiddet protesto posteri. Bakın bu tür posterler eminim çok ses getirecektir. Teşvik etmek lazım. Hiç veteriner ısıran köpek gördünüz mü? Bu biraz önce bahsettiğim sponsorluğun geri çekilme yazısı. Bu benim yayınlama kabul edilmeyen müracaatım.
Okudunuz. En parlak öğrencilerden biriydiniz lisede. Çok zor girilen tıp fakültesine girdiniz. 6 yıl okudunuz. Tıpta uzmanlık sınavına da girdiniz. Onu da kazandınız. İhtisas da yaptınız. Sonra da çalışacaksınız. Halk sağlığı için sizin huzurlu ve güven içinde çalışmanız, her türlü şiddetten sizin arındırılmış, güvenli bir çalışma ortamına ihtiyacınız var.
Bir yıl içerisinde 12.000 sağlıkta şiddet rapor edilmiş. 5 yıl içinde bu rakam 46.000. Bunun içerisinde ciddi darp var, bıçaklama var, yaralama var. Sağlıkta şiddet bir toplumun ayıbıdır.
14 Mart Tıp Bayramı kutlanıyor ancak sağlık çalışanları bayram coşkusundan
Medyayla
uzakta.
olan tüm bağlantılarımızı çok iyi kullanmamız gerekir. Ben elimden geldiği kadar tüm medya organlarına olan ilişkilerimi bu yönde en iyi şekilde kullanmaya çalışıyorum.
Önlem alınmazsa hastaların da sağlıklı sağlık hizmeti alamayacağına dikkat çekti.
Artık en tercih edilen ihtisas dalı cildiye, deri hastalıkları. Fizik tedavi, radyoloji gibi hasta temasının en az olduğu.
Bakın gazetelerde bu tür haberlerin çıkması her zaman iyi ses getiriyor. Ülkenin aydınlarından özel beyanatlar istememiz lazım.
Tarafından verilecek ceza bellidir. Kim olursa olsun zaten şiddete maruz kalmışsa onun cezası hukuken bellidir. Ama eğer şiddete uğrayan,
gerek sosyal medyada gerek televizyonlarda bu tür aydınlara vereceği mesajlar çok geçerli olacaktır. Bakın bu da televizyonda ilk defa yapılan bir program.
Doktor dövmek normal midir?
Değil, hayır. Bu yeni bir numaradır.
Çok
bunlar sizin hizmetçinizdir. Hizmet edecektir size. Fazla bunlara sıkıntı verme, sıkıntıya gelmeyin, hadlerini bildirin dersen o hadlerini bildirin dövmeye kadar gider.
Bunu
yani
eline bütün
bunlar siyasetlerden çekinmeyen, beyanat verebilen ülkenin aydınlarıdır.
Şimdi kardeşim,
yeni yıldan en büyük beklentim benim
kendisinden
şahsen
hayvanlar için verdiği emek kadar sağlıkta şiddet için emek vermesi bizzat rica
Cumhurbaşkanı
ettim.
Erdoğan
bütün doktorlarımızın, hemşirelerimizin, sağlık çalışanlarımızın da tıp bayramını kutlamış olalım. İzleyelim.
Geçen sene tıp bayramında bunu yaptık. Kanuni Sultan Süleyman'ın söylediği gibi halk içinde muteber bir nesne yok devlet gibi, olmaya devlet cihanda bir nefes sıhhat gibi.
Niye saldırıyorsun bana, niye?
Televizyonlarda gerçekten çok ilgi gördüm.
Sinirlenip
Köşe yazarlarından özel beyanatlar isteyebiliriz. Kendisi bir bypass'tır, benim hastamdır.
Sağlık Bakanı doktora şiddet uygulayan karşısında beni bulur dedi. Türkiye'nin dört bir yanından doktora şiddet haberleri gelmeye başladı.
Bakan öyle dedi ama ülkenin her yerinden sağlık şiddet haberleri geldi. Sağlıkta şiddete mahkumiyet dedi. Çıkan kanun sadece doktor karakola gitmesine gerek yok. Çalıştığı yerde ifadesini alabilir çünkü çalışmak zorunda şekline döndü. En acemi doktor bile onlarca insan hayatını kurtarabilir ama bugün şiddete maruz kalıyorlar, öldürülüyorlar. Bu ülkede yıllardır taşlar bağlı, köpekler serbest. Ne bekliyoruz? Aslında çözüm hukuk veya kanun değil, kamu vicdanıdır. Siyasilerimizden, bürokratlardan, sağlık çalışanlarını onore eden söylemler bekliyoruz. Dizilerde sağlık çalışanlarını rencide eden, acil servisi basma, ameliyathaneye girip ekibi tehdit etme gibi şiddeti normalize eden görüntülere rütük tarafından izin verilmemesini bekliyoruz. Sağlıkta şiddeti kınayan kamu spotla yapılmasını bekliyoruz. Şiddete uğrayan bir sağlık personeli protesto edenler arasında o doktor hizmet görmüş veya ya da hizmet bekleyen hasta yakınlarının da protestoya katılmalarını bekliyoruz. Fiziki yapı, donanım, iletişim ve eğitim konularında iyileştirmelerin yapılması tek başına yeterli olmayıp sağlık çalışanlarının yasalarla korunduğu güvenli ortamlarda motivasyonla çalışması ve huzur içinde kaliteli sağlık hizmeti sunabilmeleri için sağlık çalışanlarına yönelik şiddetin caydırılacağını amaçlayan yasal düzenlemeler bekliyoruz. 2018 gerçekten bir karayol oldu bizim için. Sayın Cumhurbaşkanımız bir konuşma yaptı 14 Mart'ta. İlk defa güzel sözler duyduk bir siyasetçiden. Dedi ki emekleri, fedakarlıkları ve önce insan, önce sağlık diyerek mesai kavramı gözetmeden özveriyle çalışan sağlık çalışanlarımızın 14 Mart Tıp Bayramı'nı tebrik ediyorum. Canımızı emanet ettiğimiz sağlık çalışanlarını yılın bir günü değil, her günü baş tacı etsek yeridir. Sağlık çalışanlarımıza yönelik sözlü ya da fiili hiçbir saldırıyı kabul etmiyor ve bu suçu işleyenlerin en ağır şekilde cezalandırmaları için gereken yasal düzenleri yapmaktan geri durmuyoruz. Sağlık çalışanlarımıza adeta mesleklerinin en yücesini, kıymetlisini icra eden, günün 24 saati kesintisiz verilen sağlık hizmetlerinde emeği katkısı olan çalışanlarımıza başarılar diliyor. 14 Mart Tıp Bayramı kutluyorum. Gerçekten büyük bir sürpriz oldu bizim için. Sayın Cumhurbaşkanımızın bu vaatlerinin gerçekleşeceği günleri özlemle beklerken tüm sağlık personeline içinde şiddet, taciz, darp olmayan çalışma ortamları diliyorum. Toplumun her kesiminde şiddeti kınayarak sunumuma son veriyorum. Teşekkür ediyorum. Çok yoruldunuz. Çok teşekkür ederim.
Hocam çok onur verdiniz. Çok güzel bir sunumdu. Sağlıkta şiddet hepimizin sorunu. Bu yaşta geldiniz, bu kadar uzun anlattınız.
Çok teşekkür ederim.
Hepiniz teşekkür ediyorum size. Arkadaşlar törenimizi burada bitiriyoruz. Ama birkaç salonda bildiriler var. Hepinize bu saate kadar durduğunuz için çok teşekkür ediyoruz. İşlerimiz bitmiyor. Beraberiz. Burada teşekkür etmediğim arkadaşlar kalmış. Onlara galada teşekkür edeceğim. Rahat olsunlar. Bölüyoruz yani. Teşekkür edecek çok var. Teşekkürler arkadaşlar.
Arrival on place. And this study also showed the disproportion in adults as well and in pediatric patients, because when we check this article and when we see the subgroup analysis, for example, in adult patients, in additional minutes of the time from EMS arrival to the administration of epinephrine was associated with the 4% decreasing in the odds ratio of survival to hospital discharge. In pediatric patients, it was not 4, it was 9. So we should even work faster when we have the pediatric patients. Besides, in this study, we see that I marked the time 10 minutes because authors show us that if we give the adrenaline in the time over 10 minutes, the first dose of adrenaline over 10 minutes when EMS arrival, the chances to survival rate decreasing 57% compared to those group in which we give adrenaline in the first 10 minutes on the place, on the scene of resuscitation. The second study, this study evaluate pediatric patients, and this study was conducted in the US and Canada, and this study confirmed the same in one thing. I mean that epinephrine administration was associated with the survival to hospital discharge among pediatric population. However, the timing in this study, the timing of adrenaline administration was not associated with the survival rate, but it's important that in the previous study they examined the non-shockable rhythm. In this study they examined all rhythms, so it was mixed shockable and not shockable. Maybe this parameter has place here, and we can this way transfer those data. Of course, we can also have other studies because, for example, in this study, in this meta-analysis, because I want to show you three most recent meta-analyses. In this cohort, studies show that adrenaline has an adverse effect on the long-term prognosis of out-of-hospital cardiac arrest. Why? I suppose we will discuss it because it's controversial. But in this one, I show you several forest plots. And on this forest plot, for example, which show the effects of adrenaline versus placebo on return of spontaneous circulation, we see that in randomized control trials, the odds ratio of the ROSC was at the level, as you see, near the 40% versus 11.7. In the cohort studies, it was 22.1 versus 6%. So, according to this, we know that adrenaline increasing, giving the adrenaline, we increase the ratio of return of spontaneous circulation. But what was happened when we divide those studies according to the shockable and not shockable rhythms? In shockable rhythm as well as in non-shockable rhythm, we see also this huge disproportion. But in shockable, the difference was not statistically significant because P was 0.27, but in non-shockable rhythm it was P at the level 0.001. So we should give adrenaline mostly at the non-shockable rhythms according to those studies. Of course, when we're talking about survival to hospital discharge, we can see also the results. The results are the effectiveness of survival to hospital discharge among the out-of-hospital cardiac arrest patients are smaller, and we know that, and we are preparing for that. But in RCTs, the difference was not statistically significant. But in cohort studies, it was 0.03, so it was 6 versus 5.4. However, the next slide is important because we see a positive relation. Because here, when we're talking about survival to hospital discharge, we see that the much more patients survive when the adrenaline was not given, because when was given, only 16% survived to hospital discharge versus 28.6 when the adrenaline was not given. In non-shockable rhythm, it was relatively similar and not statistically significant, but we will discuss it why it was happened. The same when we're talking about giving the adrenaline, the effect of adrenaline on the survival to hospital discharge with good neurological outcome. We see that this disproportions, especially in the RCT studies, was not statistically significantly because it was 0.25, it was 2.2 versus 1.9 respectively percent. In cohort study we see delicate or positive situation because it was 2.3 versus 2.7, but we talk about it that adrenaline can perform the occlusion of the blood vessels, especially in the brain. So maybe this is the situation. When we're talking about the shockable and not shockable, because this is last slide from this study, we see the same situation what was observed in the survival to hospital discharge. I mean that in shockable rhythms, when we not give adrenaline, we have better survival to hospital discharge with good neurological outcome. How we can translate those data? We know that the most important thing when we have some articles, when we have some trials, is the preparation of this article, is the methodology of those articles. And when we see, for example, here, we see only 2 randomized control trials and other are non-randomized. So in the future, when we want to see current, really good quality data, we should perform really nice multi-center international study focusing on the effectiveness and safety of the adrenaline. Other way, we will be as a child in the fog, because we see totally different situation in the RCTs, totally different situation in non-RCTs, because in RCTs we know that we should measure some points from time to time. We have the current protocol, but from the non-randomized we even don't know how long the resuscitation period taken, how many doses of adrenaline was placed, what was the delay of the adrenaline given from the EMS arrival, etc., etc. So we have many questions in the non-randomized trials. So we should focus on it, and in the future we should focus mostly on randomized trials. This is actually the results of our meta-analysis focusing on pediatric cardiac arrest, and in this, for example, we see that of course, when we're talking about out-of-hospital cardiac arrest, we should give the adrenaline, because the survival to hospital discharge was much more better when we give adrenaline, but in, for example, out-of-hospital cardiac arrest, the situation was totally opposite. But as you see, the number of publications are also small, so we cannot perform, for example, in this situation, some additional subgroup analysis, because we cannot do this. For do this, we need some extra publications, we need to create some really nice databases with those data of those patients. So I suppose this is the future, what we need to do. And of course, last meta-analysis, and the biggest one, because it's network meta-analysis conducting 18 trials and including over 21,000 of out-of-hospital cardiac arrest patients. And as you see on this table, the use of standard dose epinephrine, because they analyze different groups. High dose of epinephrine and epinephrine plus vasopressin increase the return of spontaneous circulation and survival to hospital admission, but may not improve survival to hospital discharge with good functional neurological outcome. However, standard dose epinephrine improved the survival to discharge among patients with non-shockable rhythm, but not those with shockable rhythms. And this is the same as we see in the previous studies, so we should give the adrenaline as fast as possible in the non-shockable rhythm, and then we have chances to increase the odds ratio of the outcomes of the patient. What will be the future? When we're talking about the future, we should focus, as I say, on or create together, really nice, prepared, randomized control trial, including a lot of patients, including all data which we want to do, which we want to examine. For example, the time of resuscitation, the comorbidities of those patients, the time of EMS arrival, the delays time, survival to hospital discharge, and longer outcomes, because we know that survival to hospital discharge or 1 month survival rate, it's not too enough for us. We need much more. We need to see what will be happened with those patients, for example, after 1 year, because it's totally depending. And for us as a clinicals, as a researchers, the most important thing right now is to create such a database, to publish it, to change the thinking about adrenaline and learn some much more knowledge about it, because of course, as I show you, we have some articles, we have some studies, but only a small amount of those are good studies with good data, with good knowledge. But even those knowledge we have much more questions than previously. So I suppose the next step for us of all will be conducting next nice study, and I hope in the next year we will be able to show you, I suppose, maybe preliminary data of those studies. Thank you so much.
Fantastic talk, Dr. Luspek. And I think the idea of epinephrine trial is very, very important. I think that will redefine the utility, because in resuscitation, whatever we have is a lot of anecdotal data, and RCT is very, very mandated. So I think what we'll do is we'll go through all the lectures, and then we'll open the forum for discussion and questions after the session is over, if that is okay with all the speakers.
Okay, thank you so much.
Yeah, thank you, Dr. Luspek. Thank you very much.
Thank you very much. And I want to invite my old friend from New Zealand, Dr. Bradley Pecker. His topic about simulation resuscitation.
Merhaba. Kia ora, tenakoto, kotoa. And that's just a traditional Maori, which is the indigenous people of New Zealand's greeting. I was asked to talk a little bit about simulation and resuscitation. And I think what I'd like to do is bring it to you from the angle of that, yeah, maybe we should do it, or should we do it? And do we need the investment to do it? So I'm going to go through that, and hopefully at the end of this talk, I've maybe planted some seeds in your head. So simulation really is an important part of medical education, but it's not without risk. What happens in the sim lab stays in the sim lab. That's fair. Because when people do simulation, they are putting themselves at risk. They're exposing themselves to make mistakes, errors, criticisms potentially, and it can get quite uncomfortable when you're debriefing very high acuity events. So what we ask is that you check your egos at the door and remember that there's always more than one way to do things. This is not the way I'd like you to do it, and this is really what this lecture is about, and trying to prevent you from doing this sort of thing. So I'm going to talk a little bit about what it is and why do we do it, why should you do it, why don't we do it, and how do we do it. So I'm going to start off with a definition about teamwork, and this is from Eduardo Salas, who's a industrial psychologist at the University of or Florida State University back in the early 90s, and I think this is probably the most worthwhile explanation. Is a teamwork is a collaborative effort, a group to achieve a common goal, to complete a task in an effective and efficient way, seen within the framework of a team, which is a group of interdependent individuals who work together towards a common goal. That sounds reasonable, I think, and I think that's really what we're trying to do. So we'll start with what is it that we actually do. So who do you actually train with? When you do resuscitation, who do you train with? Do you train with a bunch of doctors, or do you train with your nurses? Do you train with students? Do you train with the orderlies? Do you train with other ancillary staff? How often do you do it? What is actually your focus? What are you actually trying to learn? And I think at the end of the day, you have to ask yourself what you're doing, and does it actually make sense? So interprofessional training, some of you may be familiar with that term. Interprofessional is not intra-professional. Intra-professional is a bunch of doctors just practicing, or just a bunch of nurses. Interprofessional training means that everybody who actually will be in the resuscitation is actually taking part and doing it. So I've listed a couple of studies, one of them is mine, and what studies have shown is that when you do practice and you do interprofessional training, it increases performance of the team, increases morale, it increases satisfaction of the providers in their job, it increases communication and collaboration on many different outcome scales, and ultimately this is what actually helps increase outcomes. So we've just heard a talk about epinephrine, and that's really important, but I think if the team doesn't work, you're not going to get anywhere. And so it's great to get that technical knowledge, but I think this is the next step, and this is how you make it work, and that's what we continue to talk about. So the nature of what we do is very different from other operating teams within the hospital. All of our teams are what we call rolling teams, right? So you have a cardiac arrest or a trauma code or a medical or surgical code within the emergency department, and the teams are ad hoc. Who knows is going to show up? It's not always the same people, and you don't necessarily know who they are or what their skill levels is, and that's very difficult to assess when they show up and try to figure out in the heat of the battle, trying to figure out what's going on. And then of course, there's always the staggered presentations. When do people show up to the code? The anesthesiologist comes when they can, the surgeon may or may not be there, the ICU doctor may or may not be around. And so how do you then incorporate someone who doesn't really have all that knowledge into a team that's actually working at the moment? And so that is a skill that needs to be practiced and learned. So what I'm talking about are non-technical terms. The technical terms was the last lecture. This is more of the non-technical stuff. And this is communication. And when we talk about communication, we're thinking about things like leadership. How do you lead effectively? Active listening. The term active listening means that when someone speaks to you, you know that they know that you understood what they've said. So that can be circular communication, that can be facial gestures, body language, any different means of doing it. That is an important skill, and that's something that, again, needs to be practiced. There's also the concept of active followership. Active followership within a working team promotes people to actually speak up and give their opinions and do what they think should be done. And incorporating that into a functioning team is likewise a practicable skill and difficult to master. Who hasn't negotiated in a resuscitation? As I started to say, there are more than one ways to do things. How do you figure out what the best way to go is, and how do you do it so you can move the team forward and continue with the resuscitation without alienating any of your team members? De-escalation is also an important part of this. When a member of your team is escalated and not functioning very well, how do you get them back into the fold and get them to start practicing and working with you? One of the most difficult things you might find as a leader is task delegation. How do you give up authority? How do you give up that power? That's really important, and again, that is a skill that needs to be practiced. We'll talk a little bit in a second about crisis resource management or stress management. All these situations are very stressful. And the last term there is graded escalation. And graded escalation means when one member of the team sees that there's something wrong and they point it out and it's not listened to, how do you step that up and how do you increase your opposition to what they're doing, and how do you do that in a polite way? And this is something that can be practiced again. And I ask you to think about who has been in a resuscitation where there wasn't civility. Civility is probably one of the most important things that we can, and again, that should be practiced. So critical resource management, or some of you may have heard it as crisis resource management, composed really of four things, and this is from the aviation industry. And it's divided into tasks, the individual aspects of the person, the team characteristics, and then interruptions that you have in it. Now, I'm not going to read these, but you can take a look at these. And if you think about all these different aspects of what goes into a team performance, those are all different things that you could potentially work on or take in a simulation and figure out how to address that and make your team function better. So these are some crisis resource management principles that we use, and I'm going to show you a framework at the end of how we decide. And these are what we use as our learning outcomes. And though they seem like very small things, they're actually quite important and can add lots of value to your resuscitation. So I'm going to move on to why we team train. So this is the concept of practice how you play. Now I know everybody here is really excited about New Zealand and South Africa and the World Cup rugby tonight. Go All Blacks? Yeah? No? All right. It's Australian football. Really, what we're talking about is increasing your performance, developing habits that make a team function well. Talk about the processes and things that make a system or a resuscitation go well, and to create a culture that actually is beneficial for patient outcomes, and test your systems to make sure that those systems are actually working and will increase your outcomes. So let me ask you, when you think about team training, is this what your team looks like? Can you play the video, please?
Eric Maycroft, the front changer, Daniel Smith, Carrier, Mike Arno, Jackman, Stan Doolittle, and the fueler, Justin White. These 5 men were all together a year ago. Solid stuff so far. Harvick says he needs help on entry and a little bit more help on drive-off.
Here's the anatomy.
So 15 seconds to change your tires. How many people have gone to the mechanic shop and had their tires changed in 15 seconds? Not too many, right? But to do that, they would have had to practice that. That's not something that just happens. And that's a really good description, obviously not medical, but how a team functions well together, interacts, and plays upon each other's strengths and weaknesses. This is a out of cardiac arrest. It's a simulated event that we did in the car park. And so the question for this particular one is, should they resuscitate the patient in the car park, or should they take the patient inside and resuscitate him? And obviously they've chosen to go inside, but as you can see, they figured out and managed and worked with themselves to actually do CPR, and rather than riding on the rails, the smallest nurse available jumped on the bed and started doing CPR. So when you can think about training and what we do, and you compare it to things like sport or music, aviation, space flight, nuclear reactors, or military, people practice these things. This doesn't happen in isolation. These people practice them, and arguably what we do is as or more important, and do we practice? And just as a side note, after you got your driver's license, does anybody actually practice driving? But as we all know, it's probably one of the most deadly things we do. So this is this idea that experience is the best teacher. But as I finish and go through the rest of this presentation, I want you to think about that statement and ask yourself, is it really the best teacher? So this is a quote from a American College of Emergency Physicians about physician training. It's conventional training cannot provide the optimal number of clinical contacts to obtain adequate competency in all clinical areas. So it's estimated that you need to see somewhere between 5,000 and 10,000 patients to become an expert in emergency medicine after you've graduated from training. So that's another 3 or 4 years. Right? So does that really go ahead with experience is the best teacher? Maybe not. So I'm going to step back a second and ask you, well, why don't we necessarily do this? Why isn't this something that's part of our normal day? Some places maybe do. I know that we do, but not probably enough. So the reasons, what are the barriers to doing this? Well, it's time, money, equipment, space, expertise, who does the debriefing, is someone familiar with this? And as I mentioned at the beginning of this, simulation does have a risk to participants. There is a psychological toll that does happen if things go wrong. So that goes back to the expertise of the person running the simulation and the debrief to make sure that it's done right. And there's also a little bit of desire. Does anybody have a desire to actually practice driving? No, right? We do these resuscitations every day, but do we need to practice those resuscitations? So when you're thinking about why should you do this, there is some evidence, and some of you may have seen this sort of data before, but in the late 60s, early 70s, the rate of small aircraft and commercial aviation disasters was alarmingly high. And so the American Aviation Association reached out to a bunch of psychiatrists, and they developed a process called crew resource management. And what they did was they looked at things that pilots needed and aircraft crew needed. And this is leadership, team coordination, decision making, and what it actually does is it identifies threats, teach people how to communicate and mitigate different situations, and as a result of that, aviation catastrophes steeply declined to the current rate, which is incredibly small. So no one would even think about really getting on a commercial plane and having a crash, but that actually was a real thing back in the 70s and 60s. So how does this parallel medicine? Well, what they did was proficiency and task-oriented. It requires a team to function well and have a good performance. And you looked at the different influencing factors that cause potential team dysfunction and develop and validate different performance and measurement tools. And what is the optimum size for a team for different emergencies? I must have run thousands of simulations, and one of the questions that I frequently ask is, did you have too many people or too little people? Or is it the 3 little bears and it was just in the middle and just right? I don't know that we know the actual answer. I think it probably more depends on team dynamics. The last thing on this list is cognitive overload, and I'm going to talk a little bit about that at the end. So how do we do SIMs? This is probably the most important thing. Well, it takes a lot of planning, it takes a lot of work. It's like herding cats, trying to get lots of people to do different things, especially from different specialties. But in reality, I think it's about building professional relationships. So if you're planning to do things with different members, whether they be nurses, different kinds of doctors, different allied health or security or orderlies, I think that in itself has value. you have to pick the right scenario and create your learning objectives. And our learning objectives we take from that list from our crew resource management, or CRM, crisis resource management tools. And you figure out which communication skills you want to actually debrief and talk about. And so what we do is we pick those out, and then we use a framework for analyzing those. And so you think about the inputs, whether it's the doctors or the medicine or the situation, how we're going to train them, what are the different valuables that are the mediating circumstances, and then what are your outcomes? What are you hoping to achieve? And if you do that, it actually becomes a little bit easier, and you narrow it down, and this big body of work actually can be broken down into different steps. So this is an example of this. This is a study I did a couple years ago where we looked at, should doctors actually be running codes? These are cardiac arrests. And what we did was we had this idea of cognitive offload, where the nurses would run the code, the nurses would call out the drugs, the nurses would do the timing. That left the doctor free to do an ultrasound, to talk to the family, to look in the clinical notes to figure out if we should terminate resuscitation, to figure out if there's an actual cure, something that can reverse it, whether they need to go to cath lab, whatever it is. And so what we found is that it actually worked. And after doing cardiac arrest for 20 years and the past 5 years doing it like this, I can't imagine doing it any other way. So EDAM, Emergency Department Arrest Management, and this is on all of our code trolleys, as you can see here. And it has the list of what the doctor's responsibilities are and what the nurse's responsibilities are. And in the middle shows what the shared responsibilities. And what we found is that the objectives that we picked were looking at teamwork in general, looking at communication, promoted active questioning or active followership, adherence to our current ACLS algorithm, this idea of the cognitive offload, and also cognitive shared decision making, which I think is a really important aspect of any code. We used focused debriefing, and so we addressed any technical issues. If there was an elephant in the room, if someone gave the wrong dose of adrenaline or a cardiac drug, or if they didn't shock at the appropriate time. But the vast majority of it was spent on exploring learning objectives and making sure that those were met and understanding what those goals were. So I'm going to shift a little bit and finish up with a little bit about systems. Now, systems are how things work. Are things where they're supposed to be? Are the right people in the right roles? These sort of things. And what we looked at, this is really good for things that involve lots of different working parts. So whether you're giving a mass transfusion, looking at mass casualty incidents, or specific or obscure injuries and exposures, these are really good ways to do this. Other ways are when you have other things that are systems-based simulations, or when you have multiple specialties or specialties that are not used to being in the emergency department. So what you're looking at here is a simulation of a perimortem C-section. So the guy who's wearing a tie there is a consultant obstetrician with the emergency physician at the head of the airway and the neonatologist with the black sleeve reaching in there. And so this is an uncommon event in the emergency department, but how do you plan for it? And you don't necessarily have to plan for it as much as you have to have the team actually working together to make sense. So what we're talking about is an integrated healthcare system, and there are 6 basic things that make this work. And so is it safe? So safe for the staff, but also the patient. And is it providing the care that it's designed to do? Is it effective? Does it work? So is it right care, right time? Does it really do what we want it to do? Is it patient-centered? Is it timely? Is it efficient, right? Avoiding waste, and that is really important in what we do. And is it equitable? Does it make sense? So I'm going to leave you with this idea of the simulation center and what actually this can do for you. And this is sort of the grand hypothesis of simulation in resuscitation, is that you're putting the patient and the process together, and does it actually improve outcome? So this was I'm going to end with a quick story, and this is about processes. I was walking to get a cup of coffee, and one of the medical consultants saw me and said, "Hey, look, we've got a little problem in our medical ward." And this was a young, healthy psychiatric patient that was admitted for pneumonia, who decided he wanted to kill himself by cutting his wrist in a locked bathroom. So by the time we were able to get the door off to the bathroom, and the patient was very combative, and we had to do a delayed sequence intubation, which I'm sure everybody is familiar with, where we would knock him down with ketamine so we could actually pre-oxygenate him and then go ahead and fully intubate him and resuscitate him. That's not something, you wouldn't plan a simulation like this. This isn't something that happens every day. This isn't something that's going to be part of your regular curriculum. But the way this would work was that you'd have a team that could function and people that could communicate and actually understand what the needs and what wants of different members of the team. So experience is a great teacher, but it comes at a very high price. Thank you.
Thank you very much, Dr. Brett. We will take question later in this open discussion. Please.
Thank you, Dr. Peckler. So I must remind the audience, I want to tell a story. Dr. Peckler was one of the earliest leaders in simulation way back in 2002, when simulation just started picking up in the world. And he was one of the earliest leaders. In fact, I was trained by Dr. Peckler. I was my faculty, and I was his resident about 20 years ago when simulation just started. And today we see the world of simulation developing. So this session is uniquely designed, and you see clinical research in terms of epinephrine. You see resuscitation teamwork in terms of simulation. And we have a fantastic talk from Dr. Gajewski, who is one of the world leaders and research opinion experts in in resuscitation, and he's going to speak on ECMO. Dr. Gajewski, please. Thank you very much.
Great. Thank you so much, and I really appreciate the invitation and the hospitality here in Turkey. And I've been involved in WASM for quite a while, and it's been wonderful to see how things have developed and become more of a pan-world conference instead of just India and the United States, and really love to see that. I was asked to talk about ECMO, too big a topic, so I thought I'd keep it just for ECMO for cardiac arrest, which fits in with the epinephrine topic and with simulation. So really, this is a question of what's the status of research on using ECMO as part of CPR, and this concept of people in refractory ventricular fibrillation who are really too healthy to die, but how do we salvage these people? Several disclosures for consulting and speaking and membership and NIH grants. So this is a room where you might put someone on ECMO in an emergency department. This is actually in Osaka, Japan, where they have a out-of-hospital cardiac arrest protocol that specifically says if the person's in refractory ventricular fibrillation and they haven't had return of spontaneous circulation after 3 doses of epinephrine, that you transport them to an ECMO-capable hospital. So in this room at this hospital, you could intubate the person, do an echo, put them on ECMO, and then you'd move the patient down the hallway to the cath lab. some of the recent studies have been done where the people are taken directly to the cardiac catheterization lab. And then I'll show you a video in Japan where the cardiac catheterization lab's in the emergency department. So there's lots of different ways to approach this, but the goal is the same. It's to set up early perfusion that replaces the native perfusion and then fix the problem that led to the cardiac arrest. So we'll just run through a case and then eCPR as a rescue strategy, some early experience, and then the recent randomized trials and what's the future. And I think that's integrating CPR protocols for early transport and early ECMO. So here's a typical patient that you'd see in refractory ventricular fibrillation. She's 47 years old. She has a past medical history of hypertension and smokes cigarettes. And then she gets short of breath and calls EMS. So she's the one activating the EMS system. And then they arrive. This is a typical house in West Philadelphia, and they arrive and they see her behind a locked door, glass on the top of the door signaling that she can't breathe. Then she collapses as they come up to the door, which is locked, so they have to break the glass. And it takes them 2 minutes to break the window and then open the door and check for a pulse. And they start chest compressions, they put an AED on her, she's in ventricular fibrillation, she gets defibrillated, and then she has ongoing VF and gets continued ACLS. They make the decision to intubate her quickly and to transport her to the emergency department. So she gets a total of 3 shocks and 3 doses of epinephrine and a bolus of amiodarone en route. And it's only 15 minutes from collapse to arrival in the emergency department. So that's good. That's a short transport time. And then she gets to us in the emergency department, and we keep doing what we do, giving epinephrine, doing chest compressions, giving other medications, and trying to sort this out. And what you can see is that 44 minutes after ED arrival, so 59 minutes of cardiac arrest, she's been shocked 12 times. She's gotten 10 doses of epi, vasopressin, amiodarone. And if you look at the monitor, this is what you see. She's in ongoing ventricular fibrillation. So what do we do at this point with this patient? Do we call the code? Do we continue to do what we're doing? Do we have any other solutions? And do we have any physiologic parameters that we can look at that suggest that this person should be salvageable? Well, one quick parameter we can look at is her end-tidal CO2. Hers is 32. That's probably very similar to what mine is right now. That suggests that she should be salvageable, and it makes you wonder why we haven't been able to get this person back into a perfusing rhythm. So CPR works, but as time passes, survival and neurologic function decrease with sort of each passing minute. And once you get deep into a code, return of spontaneous circulation is very difficult to achieve because you get progression of what's called the metabolic phase of resuscitation. So at the very start of when someone collapses with a shockable rhythm, they're in what we call the electrical phase. You shock them. Within the first couple minutes, there should be a good chance that they come back, and that's sort of the whole physiologic principle behind defibrillators that are implanted into patients. And then as that progresses, you also have to increase circulation, but after a period of time, you start to get changes to the cell membranes, you start to get lactic acidosis, and then you start to get low cardiac output, further ischemia, refractory VF, and a worsening metabolic phase, and it's very hard to get the person out of that. So you need to come up with other solutions. This is a paper that we published in Circulation in 2016. I'm a member of the Japanese Circulation Society's Resuscitation Science Division, so this is using the Utstein database for Japan, so the basic data entry format for cardiac arrests. And in Japan, every cardiac arrest gets entered into this database within 24 hours of transport. So it's a massive database that you can study things in. And if you look here, you're looking at the length of time for the pre-hospital resuscitation efforts, and then the percentage of patients or the number of patients that get return of spontaneous circulation and then have a favorable neurologic outcome at 1 month. And you can see that depending upon the rhythm that these patients have, it's 40 to 50 minutes of CPR to get 99% of your neurologically intact survivors. And you can see a big drop off in the curve right about here. So you're at about 20 minutes and you get up toward most of your survivors, and then you just get a few more, and you get some that get return of spontaneous circulation in the emergency department. So the real question here is, how can we move to a point where we use other strategies, and instead of having this curve level off, it can continue up and we can salvage people instead of just with epinephrine, chest compressions, intubation, other medications. We can continue to fix the problem that caused the cardiac arrest and get more survivors. That's the fundamental question we're asking. So what can we do for this patient who's had 59 minutes of CPR, 10 shocks, 10 doses of epi, and is still in ventricular fibrillation? Continue conventional CPR, is that futile? So people always say that Einstein said that doing the same thing over and over again is his definition of insanity. Einstein didn't actually say that, someone else did, but it's attributed to him, and I always think of him when I think of, are we doing the same thing over and over, and how's that going to help our patient? We could maybe use mechanical CPR, so put the person on a Lucas device, take them to the cath lab. So you're getting your perfusion from your mechanical device and then use that as a bridge to PCI. And the rationale for that is that most refractory ventricular fibrillation is from coronary artery occlusion. And most of those coronary artery occlusions are either left main trunk or left anterior descending. So by taking that person to the cath lab, you should have something you can fix. So there's case reports of that, and there's some interesting ones. I'll show you one of those. Here's me on a mechanical chest compression device. I was stupid enough to turn it on. It hurts. Don't do that when you're conscious and sober. Or we could use eCPR. And this has evolved over time. The first times I talked about this, there were case series, and then I helped our Japanese colleagues with the development of the SAVE-J trial. Then that came out, and now there's been small randomized trials that have been published. So the data is accruing on this. And the other thing we could do, which is what most people do in these cases, is they terminate the resuscitation attempts, or they call the code. And that's just realistic. In a busy emergency department, you've been doing CPR for an hour and you have other patients that are sick and you need to get to them. So what are your options for that person? And that's really the standard of care in most American emergency departments, is after a period of time you would call the code. The thing that makes you really hesitant in this case is the ongoing gas exchange. So you'd say the time of death was, and that's what happened in this real case. The real patient I'm telling you about, we got a haste that we were getting 2 gunshots, 2 patients with gunshots, and you just don't have the resources, so you have to peel away from this person. And we pronounced her dead at 63 minutes post-arrest. Her end-tidal CO2 was still 28. So is she really dead? And what is dead? Are her mitochondria dead? Are her cells dead? Or is she dead? And it's very difficult to call those, but that's what we did. So what about putting her on a Lucas or an auto pulse, mechanical CPR as a bridge? This is a cool case that was in the Journal of Emergency Medicine back in 2014, and as I just read through this, you'll see very similar situation or parallels to the patient I was telling you about. This person's 53, he's a male, and he has known coronary artery disease. He's walking through a village in Italy, and he collapses and has a witnessed arrest, witnessed by the person he's walking with. Dispatcher provided CPR instructions to the person walking with him because the person who was with him didn't know how to do CPR. So he gets dispatcher instructed CPR. And then the first responders get there 10 minutes after collapse with CPR in progress. Ventricular fibrillation, defibrillated, intubated, they put in an IV, give him some saline, 2 more shocks, epi times 3, amiodarone 300 milligrams. Sounds just like our patient. But what's different here is a helicopter now lands. They put the patient on a Lucas, and they start to transport the patient at 40 minutes after, this is interesting because they make the decision to transport when the VF actually degenerates into PEA, which is a bad sign in cardiac arrest, right? You'd rather have ongoing VF. But they decide to transport this patient to a hospital with a cath lab. They put some ice bags on him, use the Lucas, and then get to the cath lab, and they do a PCI, and they stent the LAD, and they stent the circumflex. So this person has complex left coronary disease. And you can see they're really sick at that point. Blood gas with a pH of 7.05, a base deficit of negative 10.6, and a lactate of 11.1. And then this person does what people do if you stent them and you open up the coronary myocardium that's causing the refractory VF. They go into a perfusing rhythm on their own. So they get return of spontaneous circulation after the PCI. So you have ischemic tissue, and then you reperfuse that ischemic tissue, and you stop the driver of refractory VF. So 115 minutes of cardiac arrest, 90 minutes on the Lucas. This person got, what was at that time standard of care for post-cardiac arrest syndrome, hypothermia, was extubated on day 5 and then had full recovery after rehab. So here's someone who 99% of the time in emergency departments around the world would be pronounced dead and die. And it shows you a potential alternative strategy. So going back to the patient I was telling you about, why would we think that ECMO is good for this patient? Why is she a good candidate for extracorporeal CPR? So she's healthy. She's 47. She shouldn't smoke, but she does. And she has hypertension. She's, good protoplasm to use an aggressive strategy on. She is a witnessed arrest. She's actually going like this when they come up the walk, and then she collapses. So they know exactly when this happened. She gets pretty immediate CPR with the delay of having to break into the house. And then she's a shockable rhythm. So all of this is what you want for an advanced resuscitation strategy. She got high quality CPR, and she had a short transport time to a facility where potentially she could get an advanced resuscitation strategy. And then what does the end tidal CO2 of 32 and the ongoing VF tell you? It tells you that she has ongoing gas exchange and that she's actually delivering oxygen to her tissues and then offloading CO2. So someone that is not just in that state of sort of metabolic entropy. So what is ECPR? We're going to put someone on ECMO in an emergency situation and use that as a bridge to treating the underlying cause of the arrest. A lot of this came out of Japan. The first people getting put on ECPR around the world were really in Japan, and it grew out of their experience. I mean, everyone thinks of Japan as, Tokyo and the big cities with Yokohama and stuff, but 90% of Japan's mountainous and lots of snow and a lot of environmental hypothermia. So the Japanese started using ECMO to warm people up who were in cardiac arrest with environmental hypothermia, and then they said, well, why don't we translate this to patients with cardiac arrest from a coronary cause? So the first big study was the SAVE-J trial, which came out in Resuscitation in 2014. And it's a really important study with also really important limitations. So if you look at this trial, it was not a randomized trial. It was a prospective observational study. And they had 26 programs that routinely used ECPR to treat refractory arrest and 20 programs that in general didn't. And right there you start to get into some of the problems with this study because there was crossover in the standard group. But the inclusion criteria were what we're talking about. Refractory VF, no return of spontaneous circulation after 15 minutes of ED-based CPR, so pre-hospital and then 15 more minutes in the ED. It didn't have to be witnessed if it was VF. The idea there is VF, and so whether someone sees it or not, if it's VF when someone gets there, it was VF when it started. And then an age range in less than 60 minutes of time prior to attempting putting the person on bypass. And this is what they found in the SAVE-J trial. Very little survival if you're in refractory VF, neurologically intact survival. This is 1 month good outcomes. If you just continue to do conventional CPR. If you put the person on bypass and then you explore their coronary arteries, 13.7% good survival. This is 50% of the survivors, so it was 25% survival, and then CPC 1 or 2 was half of that group. So it's promising, but there's a lot of difficulties with this study because of crossover and of some of the more potentially salvageable patients in the standard group. So it's not a randomized trial. Let's see if this will play. This is a quick look at what they do. So this is an emergency department in Japan. This is an out-of-hospital cardiac arrest that gets worked in the field with CPR, defibrillation, and then brought into the hospital. And this is the emergency department in the hospital there. You see it's 9 a.m. in the morning. This is downtown Tokyo. And the person had bystander CPR. He's 65 years old, and VF's his initial rhythm. And so you can see a very old chest compression device here. And then after defibrillation, the third time, he goes into asystole, which is actually a bad prognostic indicator. So they're preparing the ECMO machine, and they're preparing the patient for cannulation. And they start some chilled saline, and they continue conventional ACLS. But different from what we heard about in the first talk, they're going to actually back off the epinephrine as they cannulate, based on the idea that they're going to be putting the person on to the pump, and they don't want to just keep on giving the person a vasoconstrictor during this time. So these physicians are emergency physicians and interventional cardiologists, so they're cross-trained. They also, most of them are critical care trained as well. And so they're the ones doing the cannulation. And so they're cannulating on both sides, and whoever, accesses the artery the vein first is going to be the one putting them on ECMO, and then if the other side they're going to use for a balloon pump and a catheter. And so you'll see the sequential dilators going in. And you can see how calm it is. Compare this to, you know, the stimulation overload that you see in a lot of codes. This is very quiet, very systematic. There's people assisting the cannulators and feeding the dilators on so that everything's happening in a very systematic fashion. And this video is edited down to, you know, the 5 minutes I'm showing you, but it's 15 minutes total that you'd be seeing for the cannulation, and then the next step is, so basically they have the two catheters in, and now they're going to hook up to the ECMO. And then they're just making sure that there's no bubbles in the system as they hitch the catheter to the ECMO tubing. And so now they're releasing the clamps, and so now you 15 minutes after arrival in the emergency department, the person has mechanical circulation. You can hear that the chest compression device is still going. So even though the ECMO is starting to run, they're keeping that going, and then they'll shut that off once the balloon pump is actually functional. And what you often see in this scenario, so you see good flow here, 4.6 liters of flow on the ECMO, and then once you get that good flow and you're giving blood flow to the coronary arteries again, the person will often start to fibrillate. And so here they're putting in the intra-aortic balloon pump, and so 22 minutes after ED arrival, the patient has ECMO and a balloon pump. And now what they're going to actually do here, you'll see this in one sec. So there he goes from asystole back into VF. And they're not going to shock that. They're just going to let it go, and it usually will convert to a normal sinus. So now they're going into the arterial side of the ECMO circuit, and they're going to use that access to the arterial side to do a coronary angiography. And then when they're done, they'll take that access and they'll hitch it down distally into the artery so they perfuse the leg. So they're going to use that as well. And we're almost done here. But here in the emergency department, they do the cath, and they find a blockage in the LAD, and they're putting a stent in it. So this is about 40 minutes of total emergency department time, where the patient gets put on ECMO, balloon pump, cath, stent, and so you've compressed down all this time, and you've restored perfusion, and you've fixed the problem with the coronary artery. Now you have to fix the patient after that. So let's just end by going through the most recent iterations of this approach that we've seen published in the literature. Dr. Yiannopoulos at the University of Minnesota has really been driving a lot of this in the U.S. With both basic science research and sequential studies of this. And he's an interventional cardiologist there. So this was their first study they published in JAHA in 2016. So they started this out-of-hospital protocol for refractory VF and then used a Lucas device and took these patients to the cath lab where they did some ultrasound to assess the whether the artery and veins, femoral artery and veins were amenable to being cannulated for ECMO. And if they were, they'd put them on ECMO, do angiography, and then PCI as needed, and then they got return to spontaneous circulation with that strategy, treat them with targeted temperature management and post-cardiac arrest care. So 27 patients transported, 18 met inclusion criteria. 83% of them were put on ECMO, 67% needed PCI, and 55% survived to discharge, with 50% of the total, 9 out of 18, with good neurologic outcome. So this suggested that a very organized approach to this could improve outcomes significantly. Then they followed up with a larger database of the same patients plus more compared to historic controls. So here is the group we were just talking about, ECMO, PCI, post-arrest care, and then they compared them to similar patients who either did or did not get ROSC using standard therapy. And you can see 45% survival to hospital discharge in the aggressive strategy and 15% in the standard therapy group. So this data led them to do the ARREST trial, which was published in Lancet back in 2020. And this was funded by the NHLBI, the National Heart, Lung, and Blood Institute at the NIH in the US, and was basically the same strategy: identify patients pre-hospital, transport them through the ED to the cath lab, put them on ECMO, or continue conventional CPR. And this is a complicated study to read into because you'll see there's only 15 patients in each group. And you say, why did they do the study that way? And what you can see is there's 6 survivors in the ECMO group and 1 survivor in the other group. And this is the Kaplan-Meier curve of that survival. So what happened with this study is that the NHLBI's Data Safety Monitoring Board stopped this study early for efficacy. And to me, that's crazy because you've at that point randomized 30 patients. The trial was supposed to have this adaptive randomization, so you'd end up with 2 people in the ECPR group for every 1 in the standard therapy group, but it started out with a 1-to-1 approach. And so there's this massive fragility index in this study where there's 6 survivors versus 1 survivor. And that's not a study that you can base a whole international change in how we do cardiac arrest care on. So very important trial, but really limited by the way the Data Safety Monitoring Board thought this study should be analyzed at the first interim analysis. The other study we have is the Prague study. Very similar, single-center adult witnessed out-of-hospital cardiac arrest, no return to spontaneous circulation, essentially the same interventional invasive strategy, mechanical CPR, intra-arrest transport, ECPR, and immediate coronary angiography and treatment, and then a standard therapy group. This trial was stopped early at the recommendation of the Data Safety Monitoring Board for futility, so the opposite reason. 256 patients were randomized, and the main analysis was based on survival to 180 days with good neurologic outcome. And you can see huge trend toward improved outcomes. 39 patients 31.5% in the invasive strategy, 29 patients, 22% in the standard therapy group. So higher than Yiannopoulos' historic controls. And the odds ratio is 0.09. So big trend toward better outcomes, but probably an underpowered study that was stopped early because it's underpowered, so it can't reach significance by the end of the number of patients it was powered for. So to wrap that all up, I think the physiologic rationale for putting someone on ECMO during cardiac arrest and doing extracorporeal CPR is very sound. You need high quality CPR for salvage. Early cannulation may be another key. I showed you in the SAVE-J trial how it had to be under 60 minutes, and there's a lot of data that things really decline after that 60-minute period. There's case series and now single center reports that suggest a benefit, and as I just pointed out, the randomized trial data is mixed and affected by small sample size, interesting statistical approaches, but both show a suggestion of improvement. So the best data at present, and if you actually read the arrest trial in the Lancet article, it will say what's known until the trial's done, and then what do they suggest. Basically, Yiannopoulos and his colleagues said that right now we're at a point where specialized programs with clear protocols have the best success, that what we need is a multi-center trial, but that multi-center trial would require programs that got up to a certain baseline of therapy before you started the trial, because otherwise they're just learning how to do it while you do it. And if, like many huge international trials, you enroll 3 or 4 patients at each center while they're on the learning curve, you're not going to get any insight into what happens if you actually have expertise in this and then you start the trial. Time is of the essence, and we need more data from well-developed programs. This can be brought into the pre-hospital setting. This is from Regensburg, and this is an Audi sport wagon. That is their ECMO car that they take to out-of-hospital cardiac arrests in Regensburg, and they've published on their results from that as well. So thank you. I'll stop there.
Thank you very much. This is very interesting, and I think in the future of emergency is very important topic. And we have time for take question or comment. Yes.
So we have all the 3 speakers.
Thank you very much. Please.
Ready to answer. Need there be any questions? So to summarize all the sessions, the first session spoke about epinephrine and its expanded role in resuscitation and the upcoming research which has to open up the era to bettering resuscitation for the future. The second talk focused on simulation and the team building exercises around resuscitation. And the third lecture spoke about ECMO and its role in resuscitation. 3 different and important aspects of resuscitation were covered in this session. So if there are any questions you could ask, please introduce yourself, where are you from, and address the question to the speaker. Can we have a traveling mic, please?
I didn't see.
Tell them in Turkish for the mic. Any questions? Yes. The mic coming, please.
Yes.
Please introduce yourself and address the speaker.
Okay, I want to ask the question to Dr. Lucas. Can we separate the patients for using epinephrine in traumatic and non-traumatic patients? Not traumatic arrests, sorry.
Can you?
Did you repeat, please?
Can you repeat the question?
Yes.
Keep
my
the
question is
mic a little far.
Yes. Okay. Using epinephrine patients.
Epinephrine?
Yes, for traumatic and non-traumatic arrests.
Between differences?
Differences that separated in the researches.
Traumatic or non-traumatic?
Yes.
Okay. Dr. Lucas.
Thank you for this question. I suppose It's a good question, but unfortunately, currently we don't have such as data, and there is no such as even good clinical trials and meta-analysis in these subgroups. So this is also a nice idea for the future study, because when we together develop the protocol of the study, we should collect as much data as we can, and then we can perform some subgroups, some sub-analysis, and in future maybe we will be able to answer on your question. I have maybe not question, but also according to the lecture about the ECMO, because of course we use the ECPR to treat the patients, to increase the survival rate of these patients. But for example, in Poland, and probably you, Professor, also know this situation, we also use ECPR as a bridge to transplantation donors. So this is also some kind of important topic of this situation, because we don't leave the patients after cardiac arrest on the scene, but perform the chest compression using mechanical chest compression device, then transfer to the emergency department, implementate the ECMO, call for transplantation team, and then decide what will be the next.
One quick question to the team. We are still rambling with controversies between cardiac arrest resuscitation in trauma versus non-trauma. Till now, both the think tanks, the trauma resuscitation think tank and the opinion tank of cardiac resuscitation, there has been no consensus. So if you look at different countries, they are handling what you can say trauma code or traumatic cardiac arrest very differently. Many countries feel that giving blood first, looking for the 5 causes of trauma is very, very important. Then they do internal CPR versus external CPR, things like that. Do they do open thoracotomy, not open thoracotomy? So in such a complex situation where trauma code after so many years is still unsolved, where do both the opinion leaders stand in terms of dealing with that complexity where two different specialties have not been able to reach a consensus?
Yeah, I fully agree, but as I say, if we create some study and obtain really huge amount of different outcomes and different comorbidities, then we can globally decide what will be the best for those patients, because we will know each comorbidity, we will know what was the cause of trauma, how many blood was lost, and etc., etc.
So basically a traumatic cardiac arrest registry would be a better option.
Yeah, I suppose not maybe only traumatic or no traumatic. I think the best option will be create some out of hospital registry, cardiac arrest registry, including traumatic and non-traumatic, because then we can decide much more.
Yeah. All right.
Sagar, I mean, I think the issue with epinephrine and penetrating traumatic arrest, certainly, and you know, in blunt, that has led to intra-abdominal hemorrhage and stuff, is like, how could the epinephrine help, right? How, if I just watched a arrest in our trauma bay, you know, 8 gunshots, one that turned out to be through the left ventricle, but the first few minutes of it were chest compressions and epinephrine, and you say to yourself, what is that doing for this person? The only thing that's going to salvage that patient possibly is thoracotomy and fixing the cause of no blood being in the vessel. So you have to think this through and figure out what you're doing, I think. And then I think you raised a very important issue about ECMO in CPR, and it's certainly a bioethical
dilemma that a lot of people have, and there's countries like Spain that have set up programs, and if you do the cost-benefit analysis of putting a patient on ECMO, and then you're either, step one is obviously trying to salvage that patient, but step two is saying that if we can't salvage this patient, then there's lots of organs that can be harvested for the greater good. And most people who have refractory VF arrests are actually fairly healthy and have healthy organs. In the US, there's a lot of resistance to that argument, but the cost-benefit argument is definitely there if you figure in the organ transplantation. The cost-benefit analysis is probably in favor of ECMO anyway without the organ transplantation, but it's, you know, it's a different math at that point.
Yeah, I fully agree that it depends on countries, yeah? But for example, in Poland we have some nice experiences basing on Spain, on Japan, and together with the transplantation team from Poznań, I suppose we started the program several years ago. Right now we have some positive effects, kidney transplantation, lung transplantation, etc. So I suppose it's going forward, but we need, of course, time to change the thinking of the society.
Lovely. One question for Dr. Peckler. Dr. Peckler, when you look at the challenges of doing team training, trauma code, which is a very important resuscitation confusion episode where you have the CPR algorithms clashing with the trauma team and the trauma surgeons in the same room when a trauma patient codes. So they have one mindset of running ATLS, and then there's the ACLS mindset which is running in the nurses and the residents and everybody else. So I personally, I don't know what the audience feels, that this is a huge communication gap situation where there is a lot of confusion, there can be anger, there can be many things. So where do you see simulation in situations where we are trying to put ECMO, we are trying to look at trauma code, and we are trying to do these new things in the world of resuscitation?
So, I mean, I guess the answer to the medical question is sort of similar to the last one, is that you want to try to figure out what the problem is and what exactly are you trying to fix. The simulation question, I suppose, or how would you look at that, that was what I mentioned about negotiation. What are we trying to do? Where are we trying to get? And how do you do that calmly with civility? And how do you actually express your opinions in a graduated sort of fashion to make things happen for the benefit of the patient? And again, that's practice, right? That is, how do you work on those skills? How do you make a statement to say, oh, I think we should do A because of this particular reason? And I think the ability to do that, or to speak up, especially if you are a junior physician to the senior one and you have a difference of opinion, how do you do that and maintain civility and actually do that in the benefit of moving the care of the patient forward? And I think you practice it, and it doesn't have to be a specific incident or a specific scenario. I think it's something that is a culture that you'd have to create within your institution to make that work.
Hey, Brad, quick question just about your thoughts on simulation for complex things like airway or ECMO. And I've done a lot of ECMO simulation in the US and in Japan, and I guess, you know, obviously it's better than not doing it by a long shot. And I'm not denigrating simulation, but it seems to me that it takes you to here, and then the real world starts about here. And how do you fill that gap? Like, we've filled it sometimes in things like ECMO by doing sheep, you know, putting sheep on bypass, pigs on bypass, or
having people go to the CT surgery ORs and systematically learn. But I guess it's just sort of this question, like it definitely gets you someplace, but then everything hits the fan when you're in the real world.
No, we actually do some ECMO sims. In New Zealand, there's only one ECMO center, and that's in Auckland, but they come down to us to do their simulation training. And, you know, I mean, ECMO is a very technical thing. There are lots of technical aspects, lots of different tasks. And watching that video, I was really impressed, you know, and you mentioned how they were quiet and calm. Like, that would be a really hard thing to do. That didn't happen overnight. Those people work together, they've practiced, and they all know and competent at their physical tasks. But, I mean, I don't speak Japanese, but clearly they were calmly speaking to each other and communicating, and I think that's probably where that comes in, I think that's probably it. And you're right, there's no way you're going to take that to that next level. But I think to get it up to that point, to make it work, and as you said about, you know, having 3 or 4 centers in a multinational, like, that doesn't work, right? Everybody's got to actually be good at it and know how to do it. But how do you get to that point?
Thank you.
Yes, please, Dr. Muzaffer.
Sorry.
Okay.
I'm Ashish Bala.
Okay.
I have a question for you. ECMO is kind of a bridge till the time you have a definitive plan for a patient. You know, you can't keep a patient unlimited on an ECMO. So if you're doing an eCPR upfront, how do you know, or how do you decide that what is going to be the final outcome? And in a country like India, or in a developing country where the cost is a major constraint, so would it be wiser to go ahead with an eCPR kind of a process for every person walking in, or how would you make a choice?
Yeah, I mean, I think a lot of what we do in medicine is sort of Bayesian statistics and pretest probability, right? So I think, like in the US, in my emergency department, if you're in cardiac arrest, it's most likely from a fentanyl overdose, right? So there's probably no role of ECMO in that patient. We can get those patients back. Even 90 minutes after arrest, we can get a heartbeat again in those people, but their brains are already just gone, and we don't have a salvage strategy for their brain. So I think what you have to say to yourself is, do I have a reversible cause of arrest that was acute in onset? I mean, from my perspective, a 35-year-old woman who's either pregnant or postpartum who has an arrest, that person should go on ECMO, because you know why they arrested, right? They're a massive pulmonary embolism 90% of the time. So someone who's digging a ditch and grabs their chest and is in VF afterwards, we know what's going on. They have a coronary occlusion and that needs to be fixed. So that's sort of, I think, the approach to it versus putting everyone on ECMO, because I think there's so many patients that won't benefit from it.
Yeah, and from our point in New Zealand, it's a very small country, and we just would never have that kind of resource. And we've started to do it mostly ECMO for other things rather than cardiac arrest. As I said, it's only in Auckland and nowhere else in the country. And as I was thinking, you were talking, David, about you know, the cost-benefit ratio, and in New Zealand, we sort of, as you know, as you would in India, it's the most for the greatest good. And unfortunately, we don't have sort of the volume that would actually make this worthwhile for us. And I think that's probably going to be something that you'd find quite frequently outside of really big places.
Yeah, I mean, I would agree. And you just have to sift through these people. And that's why if you look at the ECPR protocols, they're trying to get to the patients with LAD occlusion or left main stem, main trunk occlusion or something like that. And then there's select other populations, overdoses that aren't opioids, beta blocker overdose, calcium channel blocker overdose, nortriptyline overdose, things like that, that respond to this kind of therapy. And then obviously refractory hypothermic arrests are perfect for this.
Okay, thank you very much.
Thank you very much.
Any other question or comment? Okay, the last.
We'll take the last question.
Last question.
Thanks all of you for presentations. I am Ozan, an emergency medicine resident here. I want to ask Dr. David, and when deciding ECPR, do we have to choose a small group like healthy, witnessed collapse, and immediate CPR? Because I think there could be a selection bias, because this group already we expect good outcomes. What do you think about that?
Small MCPR, ACPR, yes.
If I'm understanding the question correctly, it's about, is it a small group of patients that would get this strategy? Is that what you're asking?
Yes, and I think that group already we have expecting good outcomes, traditional CPR or ECPR. I think could be there a selection bias for to say ECPR is good.
Sorry.
Yeah. Yes. Certainly, all the studies to date are small groups of patients, and that was what I was trying to get at when I disagree with the stopping of those trials at the point they did. The problem with any pre-stopping strategies is it's dependent upon what you say the survival benefit of the intervention will be, and that's always just extracted from low-level evidence. So it's something to keep in mind when you think about how you power studies. Oftentimes a study will be powered for a 20% absolute difference or 20% relative difference, and the therapies change so much by the time you get to doing the trial that there's no way you're going to have that 20%. So as you're pointing out, you need much larger groups of patients to see the difference. Like you look at the epinephrine data that was shown, and what's statistically significant there? 3.2% versus 2.4%. That's 0.8% absolute difference. But they're huge studies. And so you get this shuffling out of that. ECMO for ECPR needs much larger studies done at expert centers. It's just like when we do studies of stents, right, for coronary artery disease. We don't say, hey, you're a family practice doctor, you put the stent in, right? It's interventional cardiologists with expertise who do it. You need people with expertise in cannulating people in cardiac arrest and putting them on ECMO, and then you do the trial.
Yes, thank you very much. I think it's okay. We will finish. Thank you very much for your participation. And after 20 minutes, we will start to opening ceremony. We prepared for this ceremony 1 year. We have a lot of surprise in this ceremony. Waiting all. Thank you very much.
Thank you.
This year, we are commemorating the centenary of the Republic of Turkey. This is an honor for us to host this event in Turkey in this year. The biggest truth in the universe is a life, and the most important service is to serve a life. In the spirit of this Congress, we believe that the next chapter of emergency medicine will be written here. Thank you for all that. Firstly, I would like to express my deepest gratitude to our rectors, to President of EPAT, to President of VAJEM, and Director of VAJEM, and also to EPAT team, to VAJEM team, to faculties, to all who contribution for this event possible, and of course to you, all participants interested in VAJEM 2023. Our guests, let me remind you first, during your stay, if you faced any issues, please do not hesitate to contact our staff. They are here to assist you. Before we start the Congress, we express our deepest gratitude to Gazi Mustafa Kemal and his friends who made the ultimate sacrifice for the unity of our homelands and the future of our republic. I would like to invite everyone to observe a moment of silence in their honors and Turkey national anthem. Thank you. You may sit down. Now, our Congress are supported financially by the Neotech Pharmacy Company. We have a video about to explain much more information about the companies.
Neotech Grup çatısı altındaki Seltis ilaç, insan sağlığını korumayı ve yaşam kalitesini arttırmayı hedefleyerek 1992 yılında Türk ilaç sektörüne adım atmıştır. Yüksek kalitedeki jenerik ve yenilikçi ilaçları başta Türkiye olmak üzere tüm dünyaya sunan %100 Türk sermayeli bir şirketler grubudur. Birçok terapötik alanda yer alarak hastaların ihtiyacını karşılayan Seltis ilaç, bilime, teknolojiye ve insan kaynağına sürekli yatırım yapmaktadır. Her hastaya aynı kalitede ilaç sunan Celtis ilaç, yapmış olduğu yatırımlar ve Ar-Ge sürecinde göstermiş olduğu başarılarla FDA ve EMA onaylı tesislerinde inovatif ürünler üretmektedir. Celtis ilaç, ürettiği inovatif ürünlerle yenilikçi tedavilere öncülük ederken, yerli ürünleri 36 ülkeye ihraç ederek dünya sağlığına katkıda bulunmaktadır. Eğitimin gücüne inanan kurucularımız, sağlık ve teknolojiyi birleştirmek için Bilgiç Vakfı çatısı altında 2020 yılında İstanbul Sağlık ve Teknoloji Üniversitesi'nin temellerini atmıştır. Yenilikçi bakış açısıyla ürettiğimiz inovatif ürünleri tüm dünyayla paylaşarak insan hayatına değer katmak için çalışıyoruz. Celtis ilaç.
Now I'm pleased to invite Hulusi Sarıcaoğlu, CEO of Neotech Companies. Please come in.
Teşekkür ederim. Merhabalar. Öncelikle bize bu imkanı veren değerli derneğimize çok teşekkür ediyoruz. Böyle güzide bir toplulukta, güzide bir organizasyonda, uluslararası bir organizasyonda, uluslararası bir firmayı tanıtmak bizim için büyük bir mutluluk olacak. Biz Neotech Grup olarak çatımızda birçok ilaç firmasını barındırıyoruz. Bugün Celtis ve Basel kimliğimizle beraber burada olacağız. Ben kısaca Neotech'i sizlere anlatmak istiyorum. Yaptıklarımızı ve yapmak istediklerimizi, nereye varmak istediğimizi siz hekimlerimize paylaşmak istiyorum. Hedeflerimiz büyük. Hedeflerimizi güzel kılan belki de yarın kutlayacağımız 100. yılın arifesinde burada olabilmek. Bu 100. yılımıza layık bir firma olabilmek için neler yaptığımızı, neler yapabileceğimizi siz değerli hekimlerimize dilim döndüğü kadar anlatmaya çalışacağım. Çok da vaktinizi almadan tabii ki. 3000'in üzerinde sadece ilaç sanayisinde istihdam sağladığımız bir yapımız var. Bu yapımızın 35 bin metrekaresini şu an üretim tesisi olarak kullanmaktayız. Ve çok önemli bir unsur, bunun altını çizmekte de fayda var. 10 bin metrekarelik de Ar-Ge alanımız bulunmakta. Bu üretim tesislerimizde 325 milyon kutu ve üzeri üretimi yıllık kapasitemizde yapabilmekteyiz. Ama bugün belki de en fazla değineceğim konulardan bir tanesi yeni yatırım alanlarımız. Uluslararası bir firma olabilmek için, ulusumuza layık bir firma olabilmek için, belki de dünyaya küçük düşünmeden, daha büyük düşünerek dünyaya çare olabilmek için Neotech olarak biz ne yatırımlarda bulunacağız, neler yapacağız, siz değerli hekimlerimize anlatmaya çalışacağım. Evet, uluslararası akreditasyonu olan bir tesisiz biz. Sadece Sağlık Bakanlığı akreditasyonu değil, Avrupa noktasında, Amerika noktasında uluslararası akreditasyonu olan bir yapımız bulunmakta. Bu yapı içerisinde görmüş olduğunuz 35 metrekare alan içerisinde bir üretim tesisimiz var şu an. Bunun içerisinde bağımsız 7-8 binamızla beraber biz üretimimizi gerçekleştirmekteyiz. Ama burada vurgulamak istediğim sizlere daha çok bizim yeni yatırım alanlarımız 145 bin metrekare ile beraber tüm ulusumuza, uluslararası paydaşlarımıza, dünyaya açılabilmek için yapacağımız unsurları sizlere anlatmak istiyorum değerli hekimlerimiz. Evet, aslında görmekte de fayda var. Şu an bulunduğumuz alan ve bu alanla beraber biz birçok ülkeye yatırım gerçekleştiriyoruz. Ürünlerimizi götürüyoruz. Şu an mevcut alanımız bu görmüş olduğunuz sol taraftaki alan. Ama yeni alanlarımızla beraber, yeni yatırımlarımızla beraber 200 bin metrekarelik bir alanı sadece ilaç sanayisi için kullanan, geliştiren bir bünye olacağız. Değerli hekimlerim, bunun içerisinde ne yapacağız? 35 bin metrekare alan ile beraber API üretimi gerçekleştireceğiz. Günümüzde ilacın önemi çok fazla. Günümüzde ilaca erişim noktasında büyük sıkıntılar var. Sadece ilacın bitmiş ürün olması çok önemli değil. Aslında bitmiş ürüne, yani hastaya ulaştırdığımız o ilacın apisini, etken maddesini yapabilmek, gerçekleştirebilmek muazzam bir iş. Bizim en büyük hedeflerimizden bir tanesi dışa bağımlılığı ortadan kaldırdığımız, api ürettiğimiz, etken madde ürettiğimiz, ulusumuzu güçlü kıldığımız bir yapıya yürüyebilmek. İnfüzyon tesisimiz hedeflerimizden bir tanesi ve bu projeler başlamış bulunmakta. Sekonder ambalaj tesislerimiz, enteral beslenme, Türkiye'de çok içine girilen bir yapı değil bu. Biz bu yapının içerisine girmek istiyoruz. Global şirketlerin bünyesinde olan bir sistem bu. Enteral beslenmeye de girmek istiyoruz. Medical device'ımız çok önemli. Onunla alakalı yine Türkiye'de ilk olabilecek bir fabrika oluşturuyoruz. Neokulot projemiz var. High potent, yüksek teknoloji gerektiren ilaçları üreteceğimiz tesislerimiz ve bunların daha ötesinde hedefimizi daha yukarı çıkartacağımız biyoteknolojik ürünleri yaptığımız tesislerimizi ulusumuza, uluslararası alanlara kavuşturmak istiyoruz. Biz bunları yaparken, evet bunları yapıyoruz ama bizi güçlü kılan, bizi akredite eden unsurlar da oldu. Günümüzde şunu çokça duymuşuzdur. Türkiye'den herhangi bir firmanın lisans almasını, herhangi bir global bir firmanın ürününü belki Türkiye için satış haklarını, tanıtım haklarını almasını çokça duymuşuzdur. Biz ama tam tersini yaptık 2015-16 yılları içerisinde. Uluslararası bir firmaya, çok uluslu, global bir firmaya ve full jenerik değil, orijinatör olan bir firmaya tamamen bize bağlı ürünlerin lisans haklarını verdik. Aslında Neotek'in akredite olduğu, Neotek'in yaptığı ürünlerinin kalitesinin hem ulusumuz adına hem uluslararası mecrada kaliteli olduğunun en büyük kanıtlarından bir tanesi çok uluslu firma olan Takeda Japon firmasına biz bu ürünlerimizin lisanslarını satmış bulunmaktayız. Bunu anlatmamızdaki sebep de şu, bu yapının teknolojik anlamda ne kadar kabul gördüğünün bir imajı olması adına sizlerle paylaşmak istedim. Bununla beraber etken madde sentezi, etken madde çok önemli. Bitmiş ürün evet önemli fakat o bitmiş ürünü elde edebilmek için de etken madde sentezi yapabilmek lazım. Biz API'yi, etken madde sentezini daha yüksek volümlü elde edebilmek için çalışmalar yapıyoruz. Ama hala hazırda astım ve koa alanında formoterol ve tiyotropiyumu endüstriyel boyutta sentezleyebiliyoruz. Bunun yanında Ar-Ge çalışmalarını yaptığımız ve sentezleyebildiğimiz diğer alanlarımızda bulunmakta. Bunu da siz değerli hekimlerimize paylaşmak istedim. Evet, biyoeşdeğerlik onayı dünya çapında aldığımız, uluslararası akredite edildiğimiz biyoeşdeğerlik çalışmamız var. Konunun başında da aslında sunumun başında da sizlere söylemeye çalışmıştım değerli hekimlerimiz. 10.000 metrekarelik bir Ar-Ge, dünya çapında biyoeşdeğerlik, birebir benzerlik yapabilmek çok önemli. Biz bunu becerdik, yaptık ama bizim için dur dediğimiz, bitti dediğimiz yerler değil bunlar. Daha başlangıcında olduğumuz, hedeflerimize bir bir gittiğimiz domine taşları bunlar. Bunlar domine etkisi edeceğini biz düşünüyoruz ve onun için mücadele veriyoruz. Bunlar Avrupa ülkeleri, Avrupa bloğundaki ülkeler. Bütün bu saymış olduğumuz ülkelerde biz %25'inde, Avrupa'nın %25'inde salmeterol flutikazon etken maddeli ürünümüzü Avrupa'daki insanlara ulaştırıyoruz. Buradaki mesele sadece Avrupa'daki insanlara bunu ulaştırabilmek değil. Aslında mesele şu, insanlara soluk olabilmek, insanlara nefes olabilmek. Sadece ülkemiz adına değil, uluslararası mecrada da, uluslararası dünyada da bu gibi ürünlere ulaşamayacak birçok insan var. Bizim için mesele o nefes olduğu dünyada, nefesine giren, hayatına tutunabildiği noktada, bu ürünün arkasını çevirdiğinde, orada Made in Turkey'yi görebilmek, bunun için mücadele vermek, bunu yapabilmek bizim en büyük idealimizdi ve bunu gerçekleştirdik. Bu ve buna benzer şeyleri yapmak için de mücadele veriyoruz. Bu ve buna benzer işleri yapmak için yatırım alanları gerçekleştiriyoruz. Bizim için önemli bir paylaşım. Bunları da sizlerle paylaşmak istedim. Sanayi Akademi İşbirliği, bizim buradaki hedefimiz şu, videomuzda da anlatmıştık. Yönetim kurulumuz, kurucularımız üniversite kurdular. Bu üniversite bizim için hani sadece üniversite işte öğrencileri eğittiğimiz, geliştirdiğimiz bir alan değil. Sanayi ile akademiyi işbirliğinde tuttuğumuz, birleştirdiğimiz ve en önemlisi bizim için yarınlar için, daha güzel günler için, uluslararası bir aktör olabilmek için faz 1 ve faz 2 çalışmaları yaptığımız, ülkemizin molekülünü bulabildiğimiz, geliştirilebildiğimiz, insanlığa sunabildiğimiz bir ortam oluşturmaya çalışıyoruz ve bunun için mücadele gösteriyoruz. Bizim üniversitemizin mihenk taşında eczacılık var, tıp var, kimya var, bu ve benzer unsurlar var. Çünkü biz ilaç sanayisiyiz. Bu ilaç sanayisini geliştirmek istediğimiz en önemli unsur da akademik yapıyla beraber yeni moleküller, bağımsız moleküller, bizim olabilecek molekülleri yapabilmek. Bugün ulusumuz birçok başarıya imza atıyor. Birçok güzellikler yapıyor. Sporda yapıyor bunu, sanayide yapıyor, savunmasında yapıyor, her tarafında yapıyor. Bugün dışa bağlılığı ortadan kaldırmamız lazım. Biraz çılgın olmamız lazım. Üretmemiz lazım. Biz de bunun için mücadele veriyoruz ve üretmeye çalışıyoruz. Evet, yeniliklerin öncüsü olmaya devam edeceğiz. Biz uluslararası bir firma olduğumuzu düşünüyoruz. Bu anlamda Türkiye'nin en büyük inovatif firmasıyız. Bunun altını çizmek istiyorum. Evet, belki Türkiye'de en büyük cürolu firma olmayabiliriz. Ama Türkiye'deki en büyük inovatif firmayız. Endüstriyel anlamda Türkiye'nin gücü olduğunu düşünüyoruz. Ve bunu uluslararası alanda da yapmaya çalışıyoruz. Sadece ulusumuz için değil. Bu anlamda %100 yerli ilaç firması olan bizler, 100'ü aşkın ürün portföyümüzle beraber, 100'ü aşkın ülkeye ihraç ederek Cumhuriyetimizin 100. yılına layık olmaya çalışıyoruz. Saygılarımı sunuyorum efendim. Teşekkür ediyorum.
In this congress, we have participants and lecturers from all over the world. I would like to invite them to ski, please. Dr. Pekler, New Zealand. Dr. Carl, Canada. Dr. Pekler, New Zealand, please. Dr. Carr from Canada. Dr. El Tahani from Qatar. Dr. Buhai from India.
Kardeş ya bahtımız ne kara hu,
Dr. Mizabata from Japan. Dr. Kaze from Lebanese. And Dr. Vincent from Belgium.
Okay, it's a big honor to see you all in Turkey, and we want to give for the 1 minute for speak and say hello to all participants. Okay, brilliant.
Merhaba, thank you. I would really like to thank the WASM organizers, and particularly Professor Kander, for having us here. And just a quick story. I met Professor Kander about 25 years ago in Konya when I was working here in Turkey at the beginning of EPAT, and have continued my relationship since then, and it's really a pleasure to be back here and see how many people are in this auditorium. Thank you.
So, what an incredible honor. Tomorrow I have a chance to speak on the 100th anniversary of your country, and I have the honor to speak at the same time. And at the same time, I know that for 25 of those years, the Emergency Physicians Association of Turkey has been thriving. I look forward to this conference. I look forward to learning together, to teaching together, and to seeing emergency medicine flourish with the natural bridge between Asia and Europe and the rest of the world. We're looking forward to an amazing conference together.
Good evening, everyone. Emergency medicine, in the beginning, evolved by having all of us be considered that we were stepping into other people's territory. Who was managing the supraventricular tachycardias, which cardiologists used to manage, who were reducing all the shoulder dislocations, where the orthopedic surgeon used to do them, and many more examples. We're doing all of that. And now emergency medicine has evolved to be at the center of the practice of medicine. Nobody can forget us, not any other discipline. So I really would like to congratulate all of you for standing and coming forwards today to attend this conference and to share with us for the next 4 days. And there's a lot more emergency medicine is going to offer, so hang on there and be a part of history. Thank you very much, and I also would like to congratulate EPAT on the 25th anniversary, and thank you to all the Turkish hosts that are hosting us for your hospitality. Thank you very much.
Hello. I bring greetings from WHO CSAT, and it has been really a great pleasure to be on the 25th anniversary of EPAT. This is the first time for me, but I feel that I've been there since last 25 years on the journey of emergency medicine of Turkey and India, which celebrated WASM, and it's really amazing. Every year it is growing bigger and bigger. So I congratulate the dynamic leadership of Professor Basar, who has been a friend as well as a dynamic leader who had taken Turkish emergency medicine to newer heights. Along with his team and along with the global team, I congratulate the people of Turkey for hosting this. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for the outstanding meeting, as usual, in Turkey. Last year for Qatar was exception year because we hosted the World Cup 2022. And with that, we had 10 years to prepare for the mass gathering. During this period of time, we had two events. One was not predictable, which was the blockade for Qatar. And the second one was the pandemic. But in the beginning of this year, Turkey faced one of the most devastating earthquakes. For that, I commend actually the emergency physicians, the physician and the medical staff in Turkey for outstanding work which was done. It was devastating, but the work was amazing, and actually I stand for what you guys done for the sufferer in the earthquake. So with all actually the physician and the emergency physician coming together, that make really a good impact for the best outcome for this disaster. So I'm here to learn from our colleagues from all over the world, and thank you again for the privilege of the podium.
"24 years ago, I met Sagar at the first Mediterranean meeting, which at the time was the first opportunity to meet Turkish colleagues and European colleagues and American colleagues and Middle Eastern colleagues coming together. There were some Koreans and Indians, but not many. The point is, I remember Joe Wood at my side looking ahead and telling me, look what we've done. It was a turning point. Today, I look here and I look at Besar and I look at Sagar, Huram together, and I say, look what you've done. So I will say you are making history. This is a turning point for the specialty of emergency medicine all over the world, and I wish to congratulate Turkey, emergency medicine, WASM, EPAT, and everybody who put Sagar and Besar for all of the effort they have put into making this a great success. I am currently the president of the Lebanese Society for Emergency Medicine. Prior to that, I was president for the American Academy of Emergency Medicine. And I am wearing the pin of the American Academy, which says, "When minutes count." When minutes count, because in emergency medicine, we count. As you all have learned from Corona, we are not only the front line, but we are also the last line. So to see us all together, coming together to speak the same language, to create exchange of information, of material, of relationships, progressing together to really establish the specialty is a great honor. I would like to end my 2 words by saying, considering that yesterday I was training 1,200 physicians in Lebanon for what could hit us, and I would like to just take maybe 10 seconds of silence among us all to think of all today, all the rescuers and emergency physicians that have lost, and nurses that have lost their lives in the lines of duty all over the world. And I'm not really singling out anybody here. So let's think about them for a moment and think of the great obligation and the responsibility we'll have together. Again, thank you, and a moment of silence.
Hocam başla, David Kerry'den başlayayım da. This is from Turkey. Zeynep hocam bana eşlik eder misiniz? Zeynep hocam. Bunları Amerika. This is for kalan yerden devam edelim.
Tamam.
Şimdi neyi çağırıyoruz? Kalan yerden devam edelim.
Thank you for your all contributions. Now I'm pleased to invite Vice President of EPAT, Professor Dr. Zeynep Çakır.
Sayın Rektörüm, Sayın Atuder ve VASEM Başkanı, Sayın VASEM Direktörü ve 100 yıllık Cumhuriyetimizin en genç, en dinamik grubu, tüm AC'ciler, hepiniz hoş geldiniz. İyi ki buradasınız, iyi ki bu salondasınız, iyi ki bizlerlesiniz. Çok uzun bir yola çıktık. Bu yolu sizlerle yürüdük, sizinle beraber yürüdük. Daha yakın, daha kol kola yürüdüğümüz arkadaşlarımız vardı. O yollarda ne taşlar olduğunu, nelere takıldığımızı, ne kadar zorlandığımızı onlar gördüler. Sizler de belki bu yolda ne kadar zahmet çektiğimizin bir kısmını gördünüz ama sonunda sizleri burada, bu salonda görmek, hepinizi bu güçle, bu dinamizmle burada görmek bizim en büyük ödülümüz. Cumhuriyetimizin 100. yılına birlikte girmek, Atuder'in 25. yılına birlikte girmek bizler için çok kıymetliydi. Ne iyi ettiniz geldiniz. Ayaklarınıza sağlık efendim. Çok teşekkür ediyoruz hepinize burada olduğunuz için. Burada bulunduğunuz süre boyunca elbette ki birbirimizle neyi biliyorsak onları paylaşacağız, bilgimizi paylaşacağız. Bilginin ışığından kendimize yollar yapacağız, meşaleler yapacağız, birlikte yürüyeceğiz. Birbirimizi göreceğiz, birbirimizi tanıyacağız ve çok mutlu olacağız. Hepsinden önemlisi bu asra, yeni Cumhuriyet asrına birlikte gireceğiz. Yolumuz açık olsun. Hep birlikte güzel günlerde çok çok güzel işler yapmak dileğiyle efendim. Herkesi tekrar selamlıyorum. Güzel bir kongre diliyorum hepimize.
Now, I would like to invite the Rector of Health Science University, Professor Dr. Kemalettin Aydın.
kıymetli misafirler, değerli başkan ve yönetim kurulu üyeleri, kıymetli meslektaşlarım, bu güzel zaman dilimini sizinle paylaşmaktan büyük bir mutluluk duyduğumu sizin bilmenizi isterim. Öncelikle uluslararası anlamda katılımı olan ve bir dünya kongresi olan bu kongrede aramızda olan yurt dışından gelen misafirlerimize de Cumhuriyetimizin 100. yılının tadı içerisinde hoş geldin demek isterim. Ayrıca yurt dışından gelen misafirlerimizin müsaadesiyle bir pandemi sürecini ve bir de 11 şehirde 13 milyonu etkileyen dünyanın en büyük felaketlerinden biri olan deprem felaketini, yani son 3 yılı Türkiye'nin en büyük kahramanları olarak acil servislerde gecesini gündüzüne katarak, çocuğunu, eşini, annesini görmeyerek bu millete hizmet eden siz acil uzmanları, arkadaşlarımı yürekten alkışlamak istiyorum. Hem burada hem de başka zaman dilimlerinde olan TAT ve Türkiye Acil Vakfı'nın üyeleri ve yönetimlerinin bu ülkeye acil hizmetlerinde nasıl katkı yaptığını, acil hizmetlerinin 1987'de 2,5 yıl o zaman acil uzmanlığın dahi olmadığı bir Türkiye'de mecbur hizmet kurası olarak Kastamonu Devlet Hastanesi acilini çeken birisi olarak, yeni nesil öyle kura çekildiğini bilmiyor. O zamanlar bundan 40 yıl önce devlet hastanesi acili çekiliyordu. 2,5 yılda biraz da sertifikalarımı tamamlarsam uzmanlık alabilecek gibi 2,5 yıl acil hekimliği yapmış birisi olarak huzurunuzda, aranızda olmak istedim. Kıymetli arkadaşlar, bir üniversitenin rektörüyüm. Bu üniversiteyi nereden baktığınıza bağlı olarak yorumlayabilirsiniz. Bir iki cümleyle bu üniversitenin varoluş hikayesini sizinle paylaşmak isterim. Bu üniversitenin varlık nedeni bir hikayedir. Bu hikayenin bir tarafı büyük şehir hastaneleri ve sağlık binaları yapmak, bir tarafı bunun içerisini yüksek maliyetli teknolojik cihazlarla doldurmak. Ama üçüncü ayağı yetişmiş insan kaynağı ile orada millete hizmet etme arzusu vardı bu hikayede. İşte bu hikayede Sağlık Bilimleri Üniversitesi 2015 yılında 2 kişi 2000 öğrenciyle başlayıp bugün 3500 öğretim üyesi ve 25.000 öğrencisiyle hizmet vermektedir. Ve Türkiye'de 60'ın üzerindeki eğitim araştırma hastanesinde kendi akademik gelişmişliğini tamamlamış ve onunla beraber hizmet ettiği kliniğe yüksek teknolojili ve yüksek sağlık hizmetini getiren kadronun millet ile buluştuğu bir hikayedir. Bu hikaye bir Cumhurbaşkanımızın hayal projesidir ve milletin daha fazla akademik yetişmişliği olan insanla buluşma hikayesidir. Öyle olunca da bugün geldiğimiz noktada 65 Eğitim Araştırma Hastanesi'nin yanında Somali'de, Sudan'da, Çobanbey'de, Buhara'da, Taşkent'te ve Filipinler'deki Bangsamoro'da dünyaya hizmet eden bir üniversite konumuna ulaşmıştır. Önümüzdeki günlerde de yeni dünya ülkelerinde hizmete gidecektir. Acil hizmetlerinin geldiği sürecin içerisinde bakanlıkta, Sağlık Bakanlığı'nda çok yakın çalışmış olduğum ve bu hizmetin oluşmasında büyük emekleri olan tüm genel müdürlerimize de bir huzurunuzda teşekkür ederken, beraber kongremize iştirak ettiğimiz Semih Korkut hocamızın da ne kadar acil sağlık hizmetlerinin gelişmesinde emeği olduğunu da paylaşarak kendisine de bir teşekkürü şahsen borç biliyorum. İlerlemeye arkadaşlar, çalışmadan gelince dersimize. Okey. Önce kısaca bir acil hizmetlerin Türkiye serüvenini konuşmak gerekirse 1900'lü yıllarda bir vatana muhabbetin yaralılara hizmet anlamında geldiğini, bunun bugün acil sağlık hizmetlerine evrildiğini, o günkü koşulları sizler biliyorsunuz. 100 yıllık bir hikayenin başlangıcı böyleyken, dünyada havadan hasta naklinin konuşulduğu 1917'lerden, daha sonra Türkiye'de de 1924'lerde başlayan bir sağlık hizmeti, onu 1924'te Besim Ömer'in Avrupa seyahatlerinde bu havadan sağlık hizmeti ve acil sağlık hizmetlerinin önemini içeren çalışmalarını yazdığı bir kitap Türkçe'ye çevrilmiş ve üniversitemizde bulunmaktadır. Türkiye'de bu sisteme kendini entegre etmeye çalışmış. 1941'lerde Türkiye acil sağlık hizmetlerinde kullanılmak üzere uçak yapmış. Hatta bu uçağı Danimarka'ya da ihraç etmiştir. Ama o günün koşullarında Türkiye'de bu fabrika ve bu uçak yapımının durdurulmasına karar verilmiş. Alınan siparişler de yaptırılmayarak bir sekteye uğramıştır. Elbette ki bu sekteye uğrayışın millet nezdinde de bir bedeli olmuştur ve kendim acilde çalışan birisi olarak bundan 35-40 yıl önce cebinizde paranız yok ise ambulansın sizi başka bir yere götürme şansı söz konusu değildi. Ben Kastamonu Devlet Hastanesi'nde çalışırken hastayı Ankara'ya sevk ettiğimiz zaman hasta sahibini odaya çağırıp, o günkü parayla söylüyorum, bilenler bilir, 254 TL Türkiye Cumhuriyeti'nin parasıyla maaş alırken 19 TL ambulansın mazot parasıydı. O parayı vermese devlet memuru da olsanız, Sosyal Güvenlik Kurumu'nun SSK'lı da olsanız o parayı vermeden hastanızı Türkiye Cumhuriyeti'nin mevcut imkanlarıyla götürülmez bir noktada acil hizmetleri, daha sonra 30 yılı aşkındır acil alanının gelişmesiyle beraber kırmızı taraf Türkiye'deki var olan kadro, mavi tarafta üniversitemizdeki var olan kadro, 129 profesör, 133 doçent, 149 doktor öğretim görevlisi Türkiye'de varken, üniversitemizde de 19 profesör, 36 doçent, doktor öğretim üyesi olmak üzere Sağlık Bilimleri Üniversitesi'nin de hızlı bir şekilde kadrosu artırılmaktadır ve özellikle acil sağlık hizmetlerinde hizmeti en üst düzeye taşıma arzusundayız. Peki Türkiye 20 yıllık bir geçmişle konuşacak olursak, 40'ını ben hatırlıyorum. Bundan 20 yıl önce acil yardım istasyonu 481 iken bugünlerde 3500'e ulaşmış. Toplam acil yardım ambulansı bundan 20 yıl önce 618 iken 6000 ambulansa ulaşmış. Yeni doğan ambulansı yokken bugün 50, bu yılın sonunda da 100'e tamamlamak üzere bir ambulans hizmetine ve diğer sağlık altyapısına yatırım yapılmıştır. Yine 20 yıl önce 383 bin vaka bir yılda taşınırken bugün 6 bin vaka, 5 milyon vaka taşınmaktadır. İstasyon başına düşen toplam ambulans sayısı 1,5 iken bugün 2'ye, istasyon başına düşen kişi sayısı bundan 20 yıl önce 138 binken bugün 25 bine inmiştir. Yani 3500'e yakın istasyon ile civarında 25 bin kişiye hizmet eder duruma gelmiştir. Ambulans başına düşen kişi sayısı da 100 binden 14 binlere inmiştir. Bu neyi sağlamıştır? Türkiye'de acil sağlık hizmetine ihtiyaç duyulduğunda ücretsiz ve dakikalar içerisinde ulaşılan bir altyapıya, bunun insan kaynağı olarak da siz meslektaşlarımın yetişmesiyle beraber güçlü bir Türkiye'nin acil sağlık hizmetine kavuşmuştur. Bugün pandemi sürecinde özellikle Batı toplumlarında, sokakta, evde ya da yaşlı bakım yurtlarında Covid'den ölen hastalar söz konusuyken Türkiye'de bir vaka dahi olmamıştır. Her kişi evinden veya istediği yerden hastaneye transfer edilmiş. Yoğun bakım, yatak açısından da Avrupa'nın en iyi rakamlarına sahip olan Türkiye'de herhangi bir Covid hastası mağdur olmamıştır. Batı toplumlarında ya da Avrupa'da gördüğümüz gibi. Biraz önce söylediğimiz gibi 1940'larda Türkiye'de bir hava ambulansı yapılmış olmasına rağmen ve durdurulmuş olmasına rağmen bugün Türkiye Cumhuriyeti'nin 13 istasyonunda 13 helikopter ve yine uçakla, yine deniz ulaşımıyla, yine bunların yanında kar paletli, snow truck, 4 seddeli, obez hastaların, yeni doğan hastaların transfer edildiği bir altyapıya sahip Türkiye Cumhuriyeti acil sağlık hizmetleri söz konusudur. Bütün bu aşamalarda hizmeti ve emeği geçen, ekonomik olarak katkısını sağlayan hem ülkeyi yöneten kadrolara hem de o gün Sağlık Bakanlığı'nda bu işleri yapan sağlık genel müdürlerine, acil sağlık genel müdürlerine ve tabii ki bu hizmeti en ciddi bir şekilde güçlü ve en başarılı şekilde yapan tüm acil uzmanlarına da yürekten teşekkürü bir borç biliyorum. Değerli arkadaşlar, bunun yanında bir de Sağlık Bakanlığımızda dünyanın en büyük kapasitesine sahip ulusal medikal kurtarma ekibinin var olduğunu, özellikle büyük depremde hem acil sağlık hizmetleri çalışanlarının hem de UMKE'cilerin büyük hizmet yaptığını sizlerle paylaşmayı bir sorumluluk bildim. Türkiye Cumhuriyeti bundan 100 yıl önce belirli bir şekilde bütün coğrafyası işgal altındaydı. İşte o işgal günü, o işgalde Türkiye'nin doğusundan batısının parçalanmış, bölünmüş ve batı toplumları tarafından her birinin belirli bölgelere bayrağını diktiği bir yerde bu Türk milletinin içinden bir yiğit Mustafa Kemal Atatürk çıkarak Türkiye'nin bağımsızlığını, Türkiye'nin kurtuluşunu ve bugünkü Türkiye'yi yaşamamıza ve bugünkü Türkiye'nin Cumhuriyet değerleriyle beraber var olan Türkiye Cumhuriyeti'nin değerleriyle beraber bizi buluşturan ve 100. yılına gelen ecdadımıza huzurunuzda bir şükran, rahmet ve minnet sunmak istiyorum. O gün Türkiye Cumhuriyeti'nin başına gelen ve içinden bir yiğidin çıktığı Türkiye'de, o günden sonraki 100 yıl içerisinde büyük bir gelişme kaydederek sadece acil sağlık hizmetlerindeki gelişmeyi Batı standartlarının üzerine taşındığını sizlere sundum. Bunun örnekleri savunma sanayinde, eğitimde, ulaştırmada birçok örneği söz konusudur ve Türkiye bugün dünyada bölgesinde lider ve üzerinde söz sahibi olan bir ülke konumuna gelmiştir. Dileğim şudur ki sözlerimin sonunda 100 yıl önce Türkiye'nin başına getirilmiş ve getirilmek istenen emperyalist güçlerin parçalanan Türkiye arzusunun içinden çıkardığı bir Mustafa Kemal ve arkadaşlarıyla bize bağımsızlığımızı ve özgürlüğümüzü ve bize 100. yılımızı yaşatan o kadrolardan Allah bugün Filistin'e de nasip etsin ve Filistin'in de annesinin memesinden kesilmemiş, daha gözlerini açmamış bebelerin üzerine bomba yağdıran ve ona tüm gücüyle destek veren Batı emperyalistlerine karşı da Filistin'e de Allah bir Mustafa Kemal ve arkadaşlarına nasip etsin. Özgür Filistin dünyanın özgür ülkelerinden birisi olsun. Saygı ve hürmetlerimi sunuyorum.
Now, I'm pleased to invite Professor Dr. Sagar Galkanvar, President of the Rajam.
Sevgili iş arkadaşlarım, muhteşem Türkiye hoş geldiniz. Yezoncu Cumhuriyet bayramınız kutlu olsun. Sevgili İpek, 25. yılın kutlu olsun. Tanım teri kurusum. Teşekkürler Hoca Başar Çandır. Atıdır, Ente ve Türkiye. Dear colleagues, from around the world of academics, welcome to the 9th annual edition of the World Academic Council of Emergency Medicine. Today, the World Council turns a new chapter as we enter our 10th year. But this is also a great occasion when I am very privileged to speak on the eve of the 100th Republic Day of Turkey. I was looking through the pages of history in Turkey, and it was at this time that the founder of the nation was discussing what the name should be for Turkey. He had dinner with his friends, and then he decided that it should be the Republic of Turkey. So at this very time, the Republic of Turkey got its name as I speak to you today, 100 years later, when we celebrate 100 years tomorrow. It is also a great occasion for EPAT because this is the 25th Etudar which is being hosted. It was founded in 1999. And this year starts the Silver Jubilee celebrations of the Emergency Physician Association of Turkey. So many things came together. The COVID pandemic put us back, but the COVID pandemic also taught us that disease never has any borders. Today, emergency medicine faces a major divide. It is the geographical divide, it is the economical divide, it is the educational divide, and the most important is the linguistic divide. Languages are a great hindrance for us to learn from each other all the time. This is the first time WASEM has tried to break that barrier, to bring a World Congress, to bridge that divide, to get colleagues from Korea, to get colleagues from Japan, to get colleagues from countries where other languages are prominent and spoken, and the science is discussed and developed those languages. Once we cross the barrier of the languages, we will be able to interact, share our science, and learn from each other. When I gave my TED talk last year, I spoke about collaborative creativity. It is very, very important to work together because COVID could not be defeated. There is COVID now, there will be something later. It is very, very important that we all join hands and connect via the language of science. There are many conferences held around the world, but academic has a specific meaning. Once you add the word academic, it carries certain amount of weight. Our specialty is totally existing because there are patients. If there are no emergency patients, we don't have to exist. The nurses don't have to exist, the hospitals don't have to exist. So our whole specialty is patient-centered. Academic means patient-centered research, patient-centered education, and patient-centered quality care. When these pillars come together, academics takes a different meaning. Nowadays, we have all knowledge available on the web. Videos are there, YouTube is there. But academic conferences talk about what's next in emergency medicine. What's going to be the future of emergency medicine? Today, simulation, sonography, migration medicine, disaster medicine are taking new frontiers. Toxicology, hyperbaric medicine, hospice care, ECMO, all resuscitation science are taking new leaps. COVID taught us that a small virus can throw us off the block, and we literally fought for air. We fought to breathe. in that pandemic. So a lot of things happened which brought us all together. One important fact is, if you fail to learn from each other, you will learn to fail with each other. So you should always learn from each and every one. When EPAT bid for WASEM to be hosted in Turkey 6 years ago, I met Professor Bashar in Orlando. So I called him, I said, I want to meet you. He said, well, I'm coming to Orlando for the American Academy meeting, and I want to meet you. So there was at 11 o'clock at night, a simple man sitting outside McDonald's, discussing what he wants to do for Turkey. What is his vision for Turkey? How he wants to bring the world to Turkey and present Turkey to the world. He talked to me about various things achieved by EPAT, the multiple journals, the TV channel, the conferences, the workshop ideology. It is a holistic system. When you develop a specialty needs a newsletter, it needs media, it needs a journal, it needs a conference, it needs a workshop. But after achieving that nationally, a country's specialty wants to present itself internationally. And that was the time when he said, I want to take Turkey to the global level. And it took us 7 years to bring WASEM to Turkey, but he waited patiently. I think such a vision is needed in every specialty. A leader, a champion is needed, because you need to have a direction. What we see is that we get too bogged down in diplomacy, we get too bogged down in day-to-day affairs that we forget that patients need better care every day. And it is conferences such as these which help us develop better care algorithms. The world will learn from what happens in Turkey, and Turkey will learn from what happens across the world in many, many situations. Each and every session has been designed to have a 360-degree approach. You will not find sessions on chest pain, shortness of breath, UTI, pneumonia, but the next frontier. So you will see simulation, ultrasound, education, research being integrated into each session. So each session is something different, something unique, something to remember. And that's very important. I want to give a round of applause for Behshat Al, Professor Behshat Al, who spent more than 200 hours with me across the continents designing the schedule, which took 79 revisions because we had to coordinate. A big round of applause, please. I also want to commend the leadership of Dr. Zainab, who worked very hard to bring the Women's Conclave together. This is the only academic platform in the world which brings women leaders in academic emergency medicine together to think about the next frontier. The best multitaskers, not to be against anybody, are women. They manage the home, they manage the relationships, they manage their patients and manage their job and still continue to provide care every day. So it is commendable to the leadership of women that we are holding the Women's Conclave at WASEM 2023. So these were the unique things we did. One of the other things which we have brought is gaming. So tomorrow, the World CPC competition will be held, where 19 teams from around the world will compete across 9 time zones to fight for the world championship of clinico-pathological case. So a case from one university is being solved by another university and vice versa. And in a round-robin format, the person who solves the case wins the competition. So it is a 9-hour competition which will start tomorrow. And gaming is an important part of learning today. The current generation is used to 2-minute reels on social media. We used to spend hours listening to our professor talk. This generation does not have that hours. They want instant education. And if they don't get it, they find it. They are used to reels on computer and social media. So their mind triggers to education given in that format. That means academics has to reinvent itself to the art of education, because this is not a generation gap, this is a generation leap. This is the next generation, fully tech savvy, understanding where they can get data, verifying whether you're teaching them the right thing or wrong thing. And that's where World Academic Congresses like these bring together these new ideas of bridging social media, technology, simulation, sonography, and education together to build this phenomenal platform. Tomorrow, we celebrate 100 years of the Republic. Republic means representing the public. For us in emergency medicine, means a lot. It means resuscitation. It means research. It means rescue. It means resilience. It means reboot. And it means managing the daily research. So, is very important to us. So as a republic means representing the people, for us, means representing our patients. We are the emergency medicine republic of the world. WASEM stands for the rights of patients worldwide. It stands for the right of good science and correct science. And that is where our conference and our organization goes ahead. In WASEM, there is no red tape, only red carpet. We do not have any parameters or any hurdles for a university to become a member, for a department to become a member, for an association to become a member. Anybody and everybody could be a member of WASEM, because for us, science is important for skills and survival of the patient. I would like to end by quoting a few points. It's been 10 years since WASEM. We have been able to establish a global dominance in terms of our simulation models, our ultrasound models, our big data models, as well as our focus on disaster management. We hope to expand our portfolio to include artificial intelligence, social media, medicine, that is taking medicine open access into the social media, expanding to migration medicine, which is very, very important to us, and newer corridors which can change the course of time. Wellness is a very important part of our fundamental. We saw a lot of physicians leaving medicine and going away. Hence, wellness and burnout will be a very big frontier to capture in the coming years. We want to work with everybody who wants to work with us. I have 4 words which I would end my speech. In WASEM, I have always believed we have to come together, we have to commit together, we have to work together, and finally, we have to win together. Thank you very much, and God bless you all.
Now, I'm pleased to invite Professor Dr. Bashar Jandar, President of EPAT.
Evet değerli arkadaşlar, çok güzel bir açılış töreninde bir aradayız ama tabii konuşulacak çok şey konuşuldu. Biraz da vakit geçti. Siz de sıkıldınız. Ben Türkçe çok daha kolay ifade edeceğim kendimi. O yüzden Sagar, you don't know Turkish. You should put headphone, okay? Ya böyle şeylerden sıkıldık. Şu şeyi açın. Neydi o Fransa? Bunu tamam. Bugün böyle tamam. Şimdi arkadaşlar şurada görüyorsunuz kaç kilometre olduğunu saydı mı buradaki konuşmacılar kaç kilometreden gelmiş. Bilene 3 yıl kongre sözü veriyoruz. Şu anda kaç kilometre yapılmıştı bilen var mı? Toplam burada aranızda hiç bilen var mı? Bileni 3 yıl boyunca uluslararası kongrelerde ağırlayacağız. Tamam 89.000. Onu not aldım. Eğer doğruysa 3 yıl kongredesin. Ben de bilmiyorum onun için. Şimdi evet. Ama arkadaşlar şu Antalya'dan bu kongreye gelmeyen var biliyor musunuz? Yeni Zelanda'dan Brett geliyor. Kanada'dan David Kerr geliyor. Bunlar dünyaca herkesin saygı duyduğu büyük bilim adamları. Ama şuradan buraya gelmek çabası göstermeyenler var. İşte VASEM'in özelliği bu. VASEM gerçek bilim adamlarıyla olmayanlar arasındaki farkı sadece Türkiye'de değil, Hindistan'da, dünyanın birçok yerinde ortaya koyan bir kuruluş. VASEM'i incelerseniz bunu anlarsınız. Tamam buradan geçelim, şu şeyi ver. Maçı ver ya, maçı ver. Biraz da maçtan bahsedelim. Çünkü hep acilden konuşuldu. Evet, bunu hatırlayan var mı? Bu hangi maç? Hasan El Tahani. You know. Bu Dünya Kupası. Ve final maçı. Hatırlıyorsunuz. Arjantin Fransa. Doğrusunu isterseniz Arjantin'in kazanması çok iyi oldu ama Mbappe için biraz Fransa'yı tuttuğumu söyleyebilirim. Hasan El Tahani şahsında, Almanya'nın şahsında Katar'ın bu muhteşem organizasyonu tekrar tebrik ediyorum, alkışlıyoruz. Şimdi arkadaşlar bunu niye anlattım biliyor musunuz? Çünkü ben Dünya Kupası aktivasyonunu gördükten sonra şunu hissettim. Ya Avrupa Kupası falan hikaye. Önemli olan Dünya Kupası. Çünkü bütün memleketler orada toplanıyor ve onu hissediyorsunuz. Dolayısıyla biz VASEM'i yaparken aslında dünyayı bir araya getiriyorduk. Futbol nasıl dünyayı birleştiriyorsa acil tıp dünyayı birleştirdi. Ve biz bu duyguları bir Dünya Kupası yapma duygularıyla birleştirdik. Yani adeta biz bir Dünya Kupası yapıyoruz. Maçın sonunu söyleyeceğim son slaytta. Son slaytta maçın sonunu göreceksiniz. Sıkıca takip edin. Şimdi arkadaşlar tabii Dünya Kupası gibi bir özelliği var kongremizin. Tamam. Yani dünyanın her tarafından insanın gelmesi farklı bir şey. Orada bir beyt var. Bu beytin kime ait olduğunu belki Turan hocam bilir. Ama soracağım. Turan hocam bilirseniz çok memnun olurum ama slayttan sonra tabii. Karanfiller tütsün dursun, çiçeklerin şahı güldür diye. Hocam duydunuz değil mi? Karanfiller tütsün dursun, çiçeklerin şahı güldür. Onun için de Dünya Kupası ve VASEM farklı bir yerde diyelim, geçelim. Şimdi arkadaşlar ilerleyelim hemen hızlıca. Tabii acil tıp. Hep bizi kandırıyorlar mı bilmiyorum ama 100 yılın branşı diyorlar. Ama şunu gördük. 100 yılın felaketi burada. Afet burada, deprem burada, savaş burada derken hep ön saftayız. Dolayısıyla acil tıp bu 100 yılın branşı olmak zorunda. Şimdi Filistin'e gidenler var. Çoğu acilci. Mısır'a gidenler. Hakan orada. gördüğüm. Eray orada. Hocam 3-4 kişi daha var acilden bildiğim kadarıyla. Acilciler orada. Yani sonuç olarak biz hep ön safta olmaya devam edeceğiz. Şimdi acilin sorunları var. Türkiye'den örnek bilemiyorum. Hindistan'ı da arkadaşlar söylesinler. Türkiye bakın normal bir gün bu. Normal bir gün. Afet değil. Normal bir gün acilin önü. Bu da Sultanbeyli acili. Acil burası. Çarşı değil. Kapalı pazar falan değil. Kapalı çarşı değil. Acil. Ve bir günde 500 hasta bakan insanlar. Tabii böyle şikayetler dünyanın her tarafında var. Kuru öksürükle 5 yıl süren kuru öksürükle acile gelmiş. Yani sadece Türkiye'de zannetmeyin bunu. Ya da vücuduma metal hissediyorum diyenler. Peki Amerika'daki durum nasıl M90? Yoğun bakım yatağı yok. Hastaları bekliyor. Acilin sorunu yoğunluk ve bu da hep artacak. Hepimizin sorunu bu. Devam edelim. Bir diğeri şiddet. Tabii yoğunluk ve şiddet iç içe. Şiddetle ilgili bizim çok çalışmamız oldu. Tabii onları gösteremem şimdi ama şöyle göreceksiniz. Ya bizim şeyimiz yok mu burada ilerletme şansımız olan bir şey? Hayır hayır o değil. Video ilerletme. Video ilerletme şansı var mı? Peki şimdi mesela burada kısa bir filmimiz var. Siz onu orada görüyorsunuz değil mi? Biz acille ilgili kısa bir film çekmiştik. Tabii rektörümüz bilmiyor, Sayın Kemalettin Hocam, görmediniz değil mi hocam? Biz kısa film çektik. Üstelik başrolde çok ünlü isimler vardı. Biri Gizem Karaca gördüğünüz. Biri Emre Kızılırmak. Bir de ben vardım hocam. Ben de sonda çıktım, filmde oynadım. Ama ben bu filmi hepsini böyle bitiremem. Benim ilerlemem lazım. Yok mu bunun bir mekanizması? Oradan ileri atamıyor musunuz? Neyse böyle gideceğiz. Vaktimiz yok o kadar hepsini seyretmeye. Ama bir de açılışlar var böyle. Neyse geçiyorum. Kamu spotu yaptık. Şiddetle ilgili elimizden gelen her şeyi yaptık. İşte gördüğünüz gibi. Tabii acilde çok çalışılıyor. Bu Amerika'dan bir örnek. Bunun sonu böyle. Gece şifti. Tabii bu önemli bir şey ama şimdi başka bir şey göreceksiniz. Bu da benim fotoğrafım. Vasem'den önce, Vasem'den sonra. Doktor Sagar. Before and after. Thank you. Bunları geçmek zorundayım. Zaten video yokmuş. Konsültasyonlar biliyorsunuz. Evet şimdi TUS'ta bakıyoruz en yüksek puanlar. Dermatoloji, radyoloji, oftalmoloji. Çünkü bunlar böyle tatil yapıyor. Biz nasıl tatil yapıyoruz? Bizim tatilimiz de bu. Gördüğünüz gibi. Dolayısıyla ama acili seçmek için sebepler vardır. Daha doğrusu seçilmek için sebepler diyelim. Siz acili seçmezsiniz. Acil sizi seçer özveci. Değişini burada kullanalım. Ya şimdi arkadaşlar ben video gösteremeyeceğim o zaman öyle mi? Peki. Ne önemli değil. Tabii biz sakin olmak zorundayız. Bu kadar kalabalıklarda, bu kadar şiddette bunu hep gösteriyorum. Eğer sakin olmazsanız sakin olmazsanız bu işi yönetemezsiniz. Evet. Tabii medyayla ilişkilerimiz biliyorsunuz. Medya bizim de iç içe gördüğünüz gibi. Laringoskopu böyle tutup entübe etmek. Buna retro entübasyon mu deniyor acaba bilemedim. Evet. Bunlar videolar işte. Neyse geçiyorum. Bunu hepiniz ezberlediniz ama görmeyenler için göstermekte fayda var. Belki görmeyenler olur. Acil servis böyle bir yer.
Acil, som du säger. Para hålla hodet ute. Det går så fint. Var så här. Jag føler meg litt sånn pjusk. Å herregud, slipp alt dere har i hendene! Vi har en mann som er pjusk her! Få den rullestolen! Få ut. Få den ut. Hvilke rom er det som er ledig? Og så få ut han der jævla vippersjongen. Sånn, få han med. Så få tak i noen store puter ned fra barneavdelingen. Herregud, han har nesten 38 i feber.
Hastalarımızın istediği bizden bu Covid'den sonra o kalabalık acil servisler böyle olmuştu.
Smash it through it, but it's going to be hard otherwise.
Bu golü hatırlayan var mı? Arada futbol. Ronaldo'yu tutuyorum doğru ama burada umarım çalışıyordur.
Ayer el ministro de Bayern dijo que era imposible clasificar por el final for Bayern si no marcaban aquí. ¿Estás de acuerdo con él?
Antalya Spor tamamen bir söylenti. Ben aslında Atader'in acil kongresine gitmeyi düşünüyorum yazın.
Anlaşılmıştı ya. Bunu da görelim. Dur geri alalım. Geri nasıl al? Kim elledi onu? Heh.
I just said you might want to think about your children.
I wish I could make you go away.
Well, good luck with that, Francis. Yeah.
Şimdi arkadaşlar tabii bizim çok renkli olur açılışlarımız ama dediğim gibi maalesef ben ilerlemek istiyorum ama böyle bir şansım yok. O yüzden sadece böyle bir şey göstereyim.
Invite Roger Dickerson, the
Mesela
president of the
ilk
Emergency
açılışımız
Medicine
Roger Dickerson'ı
Society
biraz
of
hatırlayalım.
South Africa and
Nasıl
member of the
yapmışız?
Presidential Committee of EPAD Intercontinental. The floor is yours.
Bilimsel konulardan önce en azından böyle şeyler yapmakta dediğim gibi bunları tek tek göstermek isterim. Çok önemli bulgular ama maalesef
I would like to invite
gösterme
Professor
şansım yok.
Luis Garcia Castro
Ama şunu da
Loviesco,
dinleyelim. Arada bir
President
dinlemiş
of the
olalım.
European Society for Emergency Medicine, USEM.
Kongrelerimizden nostalji. Evet devam edeceğim. Ülkeleri böyle dediğim gibi bir araya getirip ortak dil kullanmak bizim için çok önemli. Tabii bunlar giderek ilerleyen bakın Çince dahil, Rusça dahil, İngilizce dahil kongremizden örnekler verdim. Burada çok güzel videolar var ama sizin vaktinizi almamak adına isterseniz hocam ben sizin açılışınızı çok sevdim derseniz bir gün size ayrı bir yerde açılış dersi anlatırım. Ama şu anda vaktimiz yok. Şimdi Covid ile ilgili mücadelemiz en çok tabii Kemalettin Hoca ile en çok beraber orada bir tek ben onu kendisine de söyledim. Yani herkes televizyona çıkıyordu ama gerçekleri en iyi anlatan Kemalettin Hoca, bir de nacizane arada ben oluyorum diye söyleyelim. Gerçekten o konuda büyük mücadele verildi ve biz o sırada hemen her şey ilk kongreleri biz yaptık. Turan hocam dünyada ilk Covid kongresini yaptık. Dünyada ilk Covid kongresini biz yaptık Türkiye'de online. Geçiyorum. Ya ona haberlerde yer aldı. Bunlar çok güzel. Tabii çok güzel tebrik ediyorlar bizi her zaman. Bunlar güzel şeyler. Geçiyorum ama bu ya bir geri alır mısınız? Şimdi bazen soruyorlar. Ya sevgili babalar bu uzmanlık dernekleri ne işe yarar? Bakın hiç bizim müdahalemiz yok. Şu Onur Sakarya tanımıyorum orada. Atuder işlerinde en aktif çalışanları. Biz bazen bir günde 6 bazen yılda 400 aktivasyon yapan bir uzmanlık derneği pozisyonundayız. Şimdi uluslararası birçok sempozyum yapıyoruz. Kongreler tek değil. Bunları Katar'da, Amman'da, ondan sonra başka yerlerde birçok bakın Ürdün'de bunları yapıyoruz. Bu eski bir şeyden kalmış herhalde. Paradan 6-0 atamıyor. Bu 6 Kasım'ı hatırlatıyor. Bu niye burada? Çünkü 6 Nisan da bizim için önemli. 6 Nisan bizim bir günde 6 aktivasyon yaptığımız ve bunların 3'ü farklı ülkelerde olmak üzere. Tabii Suudi Arabistan'da kendileri burada değil. Sempozyum yapmayı beceren tek dernek olduk onu söyleyelim. Kolomba'da Vasem'le çalışmalarımız vesaire. Ukrayna'da, Makedonya'da, Kazakistan'da, Azerbaycan'da, Hindistan'da vesaire böyle devam ediyor. Bunları geçiyorum. Zaten bunları ara ara size anlatıyorum. Bir sürü kurs veriyoruz. Hemen hızlı geçelim ama bu sayfaya sığmayacak. Hemen her konuda arkadaşlar kurslarımız devam ediyor. Bunu da böyle geçmiş olalım. ATLS kursları bizim için çok değerli kurslar. Onlar da Behçet Hoca, Sono School devam ediyor. İleri kardiyak yaşam desteği kurslarımız devam ediyor. Burada bir örnek var gördüğünüz gibi. Kurslarımızda bunları öğretiyoruz. Kalp tekniği oldukça iyi görüyorsunuz. Masaj tekniği. Ama bir sürü sorun var. Hasta yaşıyor. Yaşayan hastaya kalp masajı bu. Gördüğünüz gibi adamın kolunu tutuyor, zorla masaj yapıyor. Yani korkmayın, çekinmeyin. Masaj yapmaktan bir şey olmuyormuş hastaya. Gördüğünüz gibi kolunu tutup masaj yapabiliyorsunuz. Tabii bu da değişik bir solut. Ya geri alalım. Bu çalışmayacak mı? Pekala, evet. Bu da hastanın en ileri teknik kendini solutma yöntemi. Ama arada bana ne yaptınız der gibi. Tabii bugünleri geçirdik. Tabii bunların hepsini Instagram'da Fatma falan paylaşıyor dakika başı. CPR'dan önce yapmıyoruz bunu ama yine de şundan iyidir diyoruz. Yani meslek hatırası. Şimdi bir sürü kitap yazdık ve bunları biliyorsunuz. Takip edin kitaplarımızı ama doruk noktası 4000 sayfalık 400 otelle textbook'umuz, yoğun bakım 4 dergimiz var. Geri al, 4 dergimiz olduğunu tekrar vurgulayalım. 4 dergi geçiyorum, tamam. Tamam ya, işte 4 dergimiz var. Biliyorsun her derneğin bir dergisi olur. Bizim 4 derneğin dergisi var. İşte o dönemlerde medyada çok fazla yer aldık. Ama burada dikkatinize kaçarsa başkan ulusal seslendi diye yakalamışlar. Yani öyle bir şeyimiz yok ama bir şekilde yakalamışlar bunu diyelim, geçelim. Bunları geçiyorum. Sırbistan'da ilk toplantıyı yaptık. Evet, bir sürü video var, gösteremeyeceğim. Ödüller, Özbekistan. Nadir burada mısınız? Özbekistan ekibi burada mı? Özbekistan, evet, çok teşekkürler. Özbekistan ekibi burada. Buhara'dan. Tabii bu Ürdün'de Genelkurmaylıkta aldığımız çalışmalar ve Katar Sağlık Bakanı'yla Tahani, çok teşekkürler Tahani, yine birlikte o VASEM'i yaptığımız zaman Sağlık Bakanı olmaya devam ediyor değil mi? Still Health Minister? Okay. Okay. Daha gitmemiş yani, orada işlemiyor bizimki. Evet. Suudi Arabistan'da yaptığımız çalışmalar. Tabii burada üniversiteden yüksek bu çalışmalar sonunda aldığımız yüksek puanlar ve ödüller. Murat Arafat Romanya İçişleri Bakanı. Önce Sağlık Bakanı'ydı, İçişleri Bakanı şimdi. Acil tıpta olduğumuzu söyledik. Yani gerçekten güzel şeyler yaptık. Birçok kongrede özel şeyler yaptık ve burada da biz özel ödüller veriyoruz arkadaşlar. 2015'te başladık. Altın Acil ödülü ve Gazi Yaşargil aldı. Aziz Sancar bizden ödül aldı Nobel'den sonra. Gold Frank ödül aldı. Paul Kivela aldı. Bingür Sönmez aldı. Sonra Louis Vincent, kendisi burada mı şu anda? Louis Vincent geldi mi? Yok ama herhalde akşam gelecektir. Bugün de burada bulabilirsiniz Vincent'i. Ve Brugada sendromunu tanımlayan Brugada da bize son altın acil ödülünü almıştı. Bu yine Özbekistan'dan bir örnek. Bizim de aldığımız ödüller var. Ukrayna'dan, Amerika'dan, Hindistan'dan. Evet, geçen yıl aldığımız thank you Sagar for that. Sagar'ı da alkışlarımızla beraber yürüdük Sagar'la bu işlerde. Gidelim. Tabii Türkiye 100 yılın felaketini yaşadı ve hemen VASEM olarak bu felakette Türkiye'nin yanında olduğumuzu zaten gösterdik. Depremde anlattık neler yapabiliriz, ne edilebilir. Ama yine burada Malezya, Doktor Alvi, burada mı Alvi? Doktor Alvi, evet, alkışlayalım. Malezya, Sırbistan, direkt bakın bunlar bize bakanlığa değil derneğe yazdılar ve yardım etmek istiyoruz dediler. Biz onları bakanlıkla buluşturmaya çalıştık. İspanya, Özbekistan yine ve Amerika'dan destek mesajları, destek şeyleri geldi. Şimdi arkadaşlar, sonuç olarak biz buralara kadar geldik. Ve bu gördüğünüz 3 güne biz 1 yıl hazırlandık. Yani gerçekten çok büyük emeklerle bu kongre burada ama bu bütün emeklerin hep hayalimiz şuydu. Hayalimiz şuydu. Bu kadar uğraştık, bu kadar çalıştık, bu kadar didindik. Şu açılış dolsun, dersler dolsun, sayılar artsın ve gerçekten rekor sayılara ulaştık. Bu sizin katkınızla oldu. Asıl alkışı siz hak ediyorsunuz. Buraya katılan herkese alkışlıyoruz. İyi adamlara ihtiyaç var. Gördüğünüz gibi VASEM'den son slayta geldim mi? Peki. VASEM'de bir sürü konuşmacımız var. Bu çalışır mı? Bunu da Hindistan, en çok katılımcı Hindistan'dan. Onlar için Türk model bir şarkı buraya koyduk. Turkish Hour. Buradaki senim arkadaşlar. Evet, çok güzel. Gerçekten Hindistan'a özel teşekkür ediyoruz. Tabii dünyanın geleceği de çok önemli bir yeri olacak Hindistan'ın. Onları söyleyeyim ve şimdi de gerçekten büyük bir güçle beraber yürüyoruz Hindistan'la. Birlikte yürüyoruz. Umarım ki dünya geleceğinde de güzel adımları beraber atacağız. Tabii bütün bu şeyler sonra maçın sonucu bu. Evet, maçı kazandık biz hepimiz bu şekilde. Ama kazanırken de bu haldeyiz. Bu haldeyiz. Ancak bu şekilde kazanabildik. Şimdi tabii ki konuşmam bitti ama bakayım saate. Bir dakika bekleyin. Şimdi arkadaşlar bu şeyin ödül kısmı var. Bir de ödül kısmı var. Ödül kısmı var şimdi toplantımızın. Ama çok kısa sürecek. Çok kısa sürecek. Ama öncelikle bazı teşekkürler etmek istiyorum. Burada bize gerçekten bu zor süreçte çok fazla emek sarf ederek yanımızda olan yönetim kurulundaki bütün arkadaşlarımız. Ayağa kalkabilirler mi? Evet, onları alkışlıyoruz. Tabii Kongre Sekreterimiz Ayhan Aküz, Uluslararası Kongre Sekreterimiz Behçet Hocamız ve tabii ki aslında beni öne sürüp hep arkadan işleri çeviren Zeynep Hocamız, Başkan Yardımcısı. Ve hep bir insan omuz omuza yürüyeceği bir arkadaşı olması lazım dediği arkadaşım Mehmet Gül. Ve diğer bütün ekip, buradaki arkadaşlar hepsi gece gündüz çalıştık. Şimdi de arkadaşlar buradaki bütün organlarda çalışan arkadaşlarımıza, yani bizim bütün organlarımıza özellikle teşekkür ediyorum. Ve şimdi de 3 tane önemli ödülümüz var. 3 tane ödülümüz var. Bunları takdim edeceğim. Zeynep Hoca'yı da yanıma çağırıyorum bununla ilgili. Plaketlerimiz burada mı? Burada. VASEM'le birlikte vereceğimiz ödüller var. Önce VASEM'in ödüllerini verelim. Sagar. Ödül törenimiz uzun sürmeyecek arkadaşlar. 10 dakikaya ihtiyacımız var, bitiyor. Çıkmayalım. Bir de çekiliş yapacağız, unutmayın. Çekilişimiz var. Çekiliş şeylerini de hazırlayın hemen. Evet. Okay. No, last. Okay.
So, as we come towards the end, one of the most important awards we give is the WASEM Leader of the Year. And because of COVID, we could not give these awards, which were instituted in 2019. We give it, the board votes to select one leader who should get this award every year. The 2019 recipient was Dr. Aruna Munasinghe from Sri Lanka. He could not travel because of the economic conditions in the country, but his whole team, the Ministry of Health, they worked very hard during the COVID pandemic. They worked very hard to bring emergency medicine to Sri Lanka. So the 2019 award winner was Dr. Munasinghe, who is not here. We'll make sure that he gets the award. The 2020 WASEM Leader of the Year was awarded to this leader for her path-breaking work in making sure that emergency medicine bridges all the gaps. She has worked very hard to make sure that emergency medicine across the world can join hands. We break all barriers. She was the first female president of the American Academy of Emergency Medicine in history of emergency medicine in the United States. American Academy of Emergency Medicine is the leader of the world of academics in terms of cutting-edge research about being fundamentally loyal to board-certified, residency-trained emergency physicians worldwide. So if you are residency trained and you are board certified in emergency medicine, then you are eligible to practice as an emergency medicine specialty, is what they stood for in America, and they have stood for it all along. So they are the torchbearers of academic emergency medicine, and as its first female president, and her work done in her 2 years as president-elect, 2 years as president, and 2 years as past president, we honor this leader from America who has traveled all the way, finished her shifts, will work, attend our conference and go back and do a shift. And she continues to build WASEM as she represents American Academy of Emergency Medicine in the World Academic Congress of Emergency Medicine. Dr. Lisa Moreno Walton, WASEM Leader of the Year 2020. Please, Dr. Lisa, please come on stage. The 2021 WASEM Leader of the Year was awarded to Dr. Kazi. As you know, international emergency medicine as a fundamental branch of emergency medicine was spearheaded by the vision of this man. The highest award in international emergency medicine, which is equivalent to the Nobel Prize in international EM, is named after Antoine Amin Kazi in the United States, and it is awarded to a world leader across the world who has changed the course of time. And about 25 years ago, the branch of international EM was started by the vision of this person who has really embalmed that story of being American board certified but going back to his home country and developing emergency medicine. So the 2021 award was given to Dr. Kazi. Please, if you can come on stage. ...2022 was a very defining year as we went back to in-person format for the World Council after the digital format. 2022 also brought to light the efficiency of emergency and trauma services when after the COVID pandemic, after all the challenges, the FIFA World Cup was held efficiently and very historically in Qatar. And the leadership of this leader was very crucial as he prepared for the FIFA World Cup with the 4th WASEM in 2018 and then annually holding a FIFA Congress, and the famous Qatar Health Congress, which happens every year, is the brainchild of this leader, His Excellency Honorable Dr. Hassan Al Thani, Chairman and Director of Trauma and Vascular Surgery at Hamad Medical Center, Qatar. And this year's award, the WASEM Leader of the Year Award 2023, goes to a person who WASEM has known for years. So whenever anybody wants to start a new journal, they don't get articles because the journal is not in PubMed. So this leader will say, I'll contribute, I'll give my research to you. If anybody wants to start the specialty, this leader will go there and help them. Apart from working full-time in the emergency department, she was also the member of parliament for 15 years. So when she spoke to me last time, I said, so next is Prime Minister or UN Ambassador? what do you want to do? And she said, no, I will retire from politics and go back to patient care. And she runs the biggest simulation center in the world. She does a full-time job, and now she has launched a mental health wellness alliance for doctors across many countries. And her diplomatic skills, her skills to think about our patients and also the physicians is what makes her legible to get the WASEM Leader of the Year 2023 award, Professor Dr. Fatima Latif of Singapore. And the last, to not keep you all waiting, the last and the best part is a tradition of honoring the president of WASEM who finishes his tenure with the end of this Congress. And Atudur hands over the charge to Italy as WASEM moves to Rome next year. And we all at WASEM, I worked very hard to make sure that it is done during the 25th EPAT Congress, during the 100th year of Turkish Republic. And this recognized the ceremonial plaque from WASEM to the president to keep in his room as a remembrance for Turkey that the World Congress, the first of its kind in emergency medicine, was hosted during the 100th year of the Republic, the 25th year of EPAT, and this glorious occasion will be my honor to give this to Professor Bashar and to EPAT, the gold plaque.
Teşekkürler. Thank you very much Sagar, Doktor Sagar. And son olarak şimdi Türkiye'deki ödüllere geliyoruz. En heyecanlı ödüller. Birincisi sektör adına ilk defa bakın bu kongrede biz rekorlar kırdık. İlk defa iki şehirde, ilk defa iki kıtada ilk defa bu rakamlara ulaştık. Ve bu şeyi yapmamızda en önemli şeyi sağlayanlardan biri Zeynep Hocam oturdu ya. Ne oturdun? 20 dakika uğradık. Baktık ki kongre zor durumda. Gittik sektörü ziyaret ediyoruz. Ya bu dünya kongresi, bunu yapmamız lazım diyoruz. Ama destek alamıyoruz. Kapıların kapanması kötü bir duygu falan. Derken ya bir şans dedik. Şu Hulusi Bey'le arada bir görüşüyoruz dedik. Bir uğrayalım Hulusi Bey'e. Hulusi Bey'e biraz konuyu anlattık. 20 dakikada bizim istediğimizin 3 katı bir şeyden bahsetti. Biz şöyle aşağı gittik, Zeynep Hoca ile Mehmet Hoca ile birbirimize bakıyoruz. Ya bu ne dedi falan diyoruz. Ne dedi bu acaba? Ne dediğinin farkında mı adam falan? Neyse bu kongreyi bu hale getiren ve bu yüzden de bizden yılın yöneticisi ödülünü alacak olan Hulusi Bey'i buraya davet ediyorum. Değerli arkadaşlar, ikinci ödülümüz şu anda. Ben bir gün Becm Alem'de ders anlatırken baktım hoca böyle eski yıllar önce gördüğümüz bir hoca gelebilir miyim dedi. Ondan sonra hocam dersteyim geçin hemen geliyorum dedim. Sonra kendisini ziyaret ettim. O gece de biraz dua etmiştim ya bu kongreyi ne yapacağız falan. Bir baktım Turan Hoca yanımıza gelmiş. Ondan sonra Turan Hoca yılların hocası, Hıfzı Sıha'nın kurucusu, dekanlıklar yapmış, bir sürü öğrenci yetiştirmiş ve gerçekten hocaların hocası olma unvanını kazanmış. Turan Hoca'ya yılın hayat boyu başarı ödülünü takdim edeceğim. Buyurun Sayın Hocam. mesela 60 hastaneden bahsetti. Kaç tane hocadan bütün işleri güçleri bıraktı. Bize destek verdi, yanımızda oldu. Covid'de büyük mücadeleler yaptı ve hak ederek liyakatla belli yerlere gelen çok değerli hocamız, bizim önümüzde yol açanlardan, bizden önde gidenlerden Sayın Profesör Doktor Kemalettin Aydın hocamıza tekrar sahneye davet ediyorum. Yine hayat boyu başarı ödülünü takdim edeceğim. Ve herkes unutacağım zannettiydi ama değil mi? Yani unutmuyoruz biz bakın. Ama zamanı geliyor. Şimdi son ödülü bu derneğin kurulmasından itibaren büyük çabalar veren, sonra dernek başkanlığını bana devreden ve benden önce dernek başkanı olan Profesör Doktor Figen Coşkun hocamıza vereceğiz. Arkadaşlar gelecek yıl için burs çekiliş sözü var. Değil mi Hüsnü Hocam? Öyle diyelim. Veya biz yaparız onu. Şimdi onun için rakamları aldık. Çekiliş yapacağız. Yusuf, o son slaytlar duruyor mu? Son slayt dediğim slaytı yaptın mı? Ha? Onu bir gösterebilir misin? Evet. Arkadaşlar törenimiz burada bitti aslında. Sadece çekiliş yapacağız. Ama tabii ki çekiliş yapmadan bir son slayt koymuştum. Yetiştirdilerse. Evet bu ama nerede okunacak ha? Burada gördüğünüz gibi Estağfirullah. Min ecli zâlike ketebne alâ beni İsrail'e ennehu men katele nefsen bi gayri nefsin ev fesadin fil ardi fekennema katelen nâse cemî'a ve men ahyâ fekennema ahyen nâse cemî'a ve lekad câetum rusulna bil beyinâti sümme inne kesiren minhum ba'de zâlike fil ardi le musrifûn. Biz yani İsrail'e dedik ki bir kişiyi öldüren bütün insanlığı öldürmüş gibidir. Bir kişinin hayatını kurtaran bütün insanlığı kurtarmış gibidir. Dolayısıyla biz acil tıpçılar, sağlıkçılar olarak hayat kurtarma görevini yapmaya devam edeceğiz. Biz hayat kurtaranların tarafında olmak zorundayız. Hayat kurtarmak bizim işimiz. Oradakileri de rahmetle anıyoruz ve çocukların ölmediği bir dünya istiyoruz. Hepinize teşekkür ediyorum. Buraya alabilirim. Tamam. Şimdi arkadaşlar çekiliş yapıyoruz. Burada şeyi alalım. Herkes numarası var mı? Numarası olan var değil mi? Gelecek yılın şey için 20 tane miydi?
30'a çıkardınız zaten.
Nasıl çıkarttım?
Siz çıkarttınız.
Ben 20 idi, ben 30 yapmışım. Tamam, 30'dayız. 30 tane.
Şerefine 25 dedi, sonra 30 dedik.
İlk numarayı ben çekiyorum, sonrasını devam ediyoruz. Numara değil, isimmiş. Erdal Demirtaş yabancıya gitmedi.
Erdal Demirtaş.
Erdal Demirtaş. Sen çek.
Sevgi Yumrutepe.
Asaf Bulak Vural. Büşra Kutlu.
Bağırana.
Evet hocam.
Alttan çekeyim.
Asaf Burak Vural. Duyuldu herhalde değil mi? Büşra Kutlu.
Ayşe Öktem. Ayşe Öktem.
Ayşe Ekler.
Ayşe Ökten.
Ökten. Ökten. Ayşe Ökten.
Kaç tane oldu bu arada, saymaya devam edin. Vay hocam maşallah.
Gözüm görmüyor. Seher. Bir tanedir herhalde. Örün.
Seher Örün.
Doğru mu?
Serhat Örün.
Serhat Örün.
Serhat Örün.
Gözlüğüm almayın.
Serhat Örün.
Serhat bak gördüm.
Sena Zeybek.
Kaç tane oldu bu arada, sayıyor musunuz?
Furkan Çavdar.
Furkan Chowdhury.
Furkan Çaytar.
Cesarettin Dikmetaş. Cesarettin. Nur Betül Coşkun.
Nur Betül Coşkun. 10 oldu. Muhammed Emin
Akçaöz.
Akzoz.
Muhammed Emin Akçaöz.
Bunu da tutun.
Muhammed Emin Akçaöz.
Ahmet Melih Savaş. Ahmet Melih Savaş. Bu da burada. Ahmet Melih Savaş.
Ahmet Melih Savaş.
Sertaç Gülen.
Sertaç Gülen.
Sertaç Gülen.
Sertaç Gülen. Kaç oldu?
Muhammed Burak Özbek.
Muhammed
Muhammed
Burak
Buğra Özbey. Daha 13 de miyiz? Bir de orada çektik 13.
Şeyleri yazabilir miyiz onları?
13.
Diyar
Mesela ne zaman 11'di ya? Nasıl saydın?
Diyar Badem olmuştu. Badem Kıran. Diyar Badem Kıran. Okey. Tamam. Yes. Kaç oldu?
Ebru Özkara.
Ebru Özkara.
Ben de alalım.
Faruk Aydemir.
Aydemir. Buradan alalım. Ben de çekeyim.
Ayşe Güldiken.
Sayılıyor abi, 15 oldu. 16.
Şuraya geçelim. Oraya da gidelim.
Hatice Güldal.
Hatice Güldal.
Bilgehan Demir.
Bilgehan Demir.
Bilgehan Demir.
Demet Acak.
Demet Acar.
Demet Acar.
Demet Acar.
Turan hocam 2 tane çeksin. Turan hocam 2 tane çeksin. Telefonu kilitli, evet.
Şöyle Can Hoca ver. Hocam
Kim?
ben
Semiha Güzel.
Semiha Güzel. Semiha Güzel.
Zana ikinci. Değil mi o?
Canan ikinci mi?
Zana ikinci.
Zana ikinci. Kaç? 23. Ben en alttan çektim zaten.
Melike Menendi.
Melike Menendi.
Vivek Chauhan.
Vivek. Doktor Vivek. Şoma.
Dr. Vivek Chauhan.
okey. Vivek şu an. We are together. Figen Özcan. Figen. Figen Özcan.
Figen Özcan.
Figen Özcan.
Figen Özcan.
Figen Özcan.
Kaç oldu kal?
Osman Ogas.
Osman.
Osman Ogas.
Osman Ogas.
Osman Oğuz Kıraç.
Osman Oğuz Kıraç.
Kıraç.
Son 3 mü? Son 3.
Yusuf.
Yusuf Horus.
Yusuf Oruz.
Fulya Köse. Fulya Köse.
Fulya Köse.
Rika Sener.
Berika Şener. Berika Şener. Berika Şener.
Berika Şener.
Berika Şener. Berika Şener.
Arkadaşlar 30 tane oldu. Bunlar bizden gelecek yıl burs kazandılar. Bu şeylerimiz devam edecek. Hepinize bu saate kadar burada olduğunuz için çok teşekkür ediyorum. Bundan sonra burs için şöyle bir şeyimiz var ama %70 ders katılımınızı istiyoruz. Ona göre dersleri takip edin arkadaşlar. Bu burslarımız devam edecek. Çok teşekkürler. Hocam.
For your invitation, Mrs. and moderators, and welcome to our great Congress in Emergency Medicine. And before I will talk about my presentation, I want to say some things about this Congress, and I am very excited and I am very happy to be in wonderful Congress, and thank you very much for giving me the opportunity of this presentation. Thank you. First of all, My submission's title is Prognostic Evaluation of CRP, Albumin Ratio, and Neutrophil Lymphocyte Ratio and Platelet Lymphocyte Ratio in Aortic Dissection Patients, a retrospective analysis. Acute aortic dissection is rare, but life-threatening condition characterized by separation of the layers within the aortic wall. But without prompt surgical intervention, patients may often confront severe complications such as aortic rupture. Unfortunately, even with surgical intervention, mortality rates can be made high. So, this study aims to assess the prognostic significance of the CRP, albumin ratio, and neutrophil lymphocyte ratio and platelet lymphocyte ratio, as I said, CAIR, NLR, and PLR, in predicting a length of hospital stay and mortality in emergency patients diagnosed with aortic dissection. In the materials and methods sections, the study was carried out retrospectively, observation and cross-sectional study, including 18 and over who present at our tertiary hospital for last 5 years. The set of patients diagnosed with aortic dissection were determined via ICD code, via hospital database system CARMET, and we confirmed the patient's diagnosis by thorac-abdominal CT angiography. Patients with incomplete data were excluded from the study. The mortality status of the patients referred to another hospital for surgical intervention was obtained from the patients themselves or their relatives. What are the variables analyzed in the study? We studied many factors, including patients' mortality rates, especially hospital stay durations and mortality, and the other variables such as laboratory parameters and demographic data. In the statistical analysis, we made comparison between survival and non-survival groups, and the descriptive characteristics of the study are given in numbers and percentages. Quantitative data expressed as mean and standard deviation for normal distributed data and median for non-normally distributed data. For normality test, we use Shapiro-Wilk test because of n lower 50. Independent t-test was used to compare the means between the two groups. And also correlation analysis was made. All analysis was performed in 90% confidence interval, and statistical significance was defined as a p-value less than 0.05. In our study results, the retrospective analysis include 32 individuals diagnosed with aortic dissection in our emergency medicine, with 24 of them being male. 81% of patients were diagnosed with type A dissection, and also surgical intervention was also performed in 81%. The mean age of patients was greater than 65. The median length of hospitalization was 4 days, and also in hospital mortality rate was 25%. Furthermore, the descriptive characteristics of all patients and between groups are summarized in Table 1. We look at the table. We compared the patients and diagnosed with aortic dissection in survival and died patients. We saw there was no statistical differences between the survival and non-survival groups in terms of age, gender, surgical status, and length of stay. Gender-based comparison of NLR, PLR, and CAR values revealed no statistical significant differences. And
sorry, Dr. Vural, please be fast.
Okay. However, when age considered, significant variations were observed in CAR values. The comparison of the effect of CAR, PLR, and NLR rates on hospital stay and mortality is shown in Table 2 and Figure 1. There was a positive correlation between length of hospital stay and CAR, while no statistical significant relation was found between. In the Figure 1, PLR demonstrated a statistically significant predictive value for in-hospital mortality. In conclusion, the results of this study demonstrate clear and significant associations between the PLR and mortality, as well as between the CAR and length of hospital stay in individuals diagnosed with aortic dissections. Thank you.
Thank you very much. Any question, any comment, please? Thank you, Dr. Vural. Second presentation. The value of rate of oxygenation shock and diastolic shock indices in COVID-19 patients. Dr. Sertaç Güler, please. Absent. Okay. Yok herhalde değil mi? Please, third presentation. Evet. Bu o değil. Post-myocardial infarction is a rare complication. Ventricular septal rupture. Dr. Miraç Özcan. Peki, yaz. Burada yaz. Yaz. Tamam, o zaman şöyle bir tamam de. İki şunlara eksin diyelim. Please, fourth presentation. Extracorporeal membrane oxygenation used to maintain tissue perfusion until harvesting in patient after brain death. Please. İsim? Efendim? Yok ama şey yok. Altı çizilmiş.
Hi everyone, my name is Mehmet Emre Akçay. Sorry for the interruption, but my professor, who is Mücahit Avcil, is COVID now. That's why I will present this presentation for him. How can I pass this slide in this one? So, I think you know what is ECMO therapy. ECMO therapy is a therapy if you had a lung infection or a heart malfunction. This device provides lungs, lung and the heart functions for you. That's why, and if you have a cardiopulmonary problem, we will put you on this device. So our case, who is a 48-year-old male who presents with syncope, no known disease or drugs, and the EMS services in our city recognize cardiac arrest and start CPR to the patient and take this patient to nearest hospital. And when we take these patients to our center, had and 40 minutes to CPR, and total 5 times defibrillation. In first physical examination, patient has a Glasgow Coma scale of 3 and force score of 0, 96 blood pressure and heart rate of 98. And the other, if this saturation is under intubation, of course. We make an CT angiography for intracranial arteries on the 3rd day, and the patient ruled for brain death. And we talk with other patient's family for organ donation, and the family accepted the organ donation. And we put this patient for critical care unit for follow-up. Of course, and patient is hypotensive despite 3 of inotropes and the vasopressors. So we decided to put this patient on ECMO. On later diagnosis of this patient, urine analysis comes with amphetamine positive, and patient takes heparin, sedation, inotropes and vasopressors. So you can see a picture of us here. We are putting ECMO to this patient, and in interaction we are placing cannulas here. On the left side you see Mücahit Avcil, and the donated organs on ECMO: liver, right kidney, heart, aorta and iliac arteries after 20 hours on cardiac arrest. So we are taking these patients to surgery room for extracting organs. So normally ECMO is a new therapy. The medical world is trying on it, so we think it is beneficial for using it. But I think it's the 3rd one that we use for organ donation patients, and its ECMO's usage areas will be widened in the future. And this is on the surgery room. So we think ECMO device can be utilized to buy time for harvesting in a brain dead patients, and it is proved ECMO device can be beneficial for organ perfusion. Thank you for listening.
Thank you. Any question? Any comment? Thank you. Please, 5th presentation. Post-myocardial infarction is a rare complication. Ventricular septal rupture. Dr. Miraç Özcan. Kaçıncıydı? Kendi bunlar. 3. mü? O zaman 3.
Thank you.
Değil mi? Sen? Var mı?
How do we use? Yeşil. So welcome again. Myocardial infarction is one of the leading causes of death in our country and in the world. As a result of the establishment of coronary care units and the development of the reperfusion methods, the mortality and complication rates due to MI have decreased considerably in recent years. Complications can be examined under the subheadings of ischemic, mechanical, arrhythmic, embolic, and inflammatory complications, such as pericarditis. The majority of MI-related deaths are the result of arrhythmic complications. However, although mechanical complications are much less common, they are more deadly. The most important ones are ventricular free wall rupture, ventricular septal rupture, and acute mitral insufficiency, and they often progress with cardiogenic shock and sudden death. Other mechanical complications include left ventricular aneurysm, ventricular pseudoaneurysm, cardiogenic shock due to severe left ventricular dysfunction, right ventricular failure, and dynamic left ventricular outflow tract obstruction. So in this case, an 85-year-old female patient was transferred to our emergency department after ST elevation was detected in the anterior and inferior leads in the EKG taking at this center where she applied, with complaints of typical chest and back pain. The patient's history was unremarkable except for hypertension and the medication she was using for this reason. In the physical examination of the patient, her general condition was fair, she was conscious, cooperative, oriented, her Glasgow Coma Scale was 15. Her vital signs were 90 to 60 millimeter, pulse was 95 beats per minute, respiratory rate was also 12 minutes per minute, temperature was normal, her saturation in room air was normal. No pathological findings were found in the system examinations except chest pain. In the EKG taking in our emergency department, there was ST elevation in the anterior and inferior leads, and bedside echo revealed her ejection fraction was 40%. Anterior and inferior were hypokinetic, or her also left atrium, so angiographic performed due to patient's current clinical picture revealed 100% LAD D2 level and 80% circumflex osteal obstruction, occlusion in the distal thin ends, and plaque in the RCA. Since there was no room in the coronary ICU, the patient was taken back to the emergency critical care unit in a stable condition and continued to be followed up. However, the patient who was hypotensive and unstable was consulted by the cardiovascular surgery clinic and was taken to ICU after ventricular septal was observed in the repeated echocardiography. This is a common situation in some of some ER departments around our country. These ICU beds are not enough for patients. Sometimes some post-op patients, post-coronary angiography patients will need it to take care in ER after their surgery. So they are not taking ICU treatment because ER is not like ICUs, but we are trying to do our best. But we are, for example, this patient was taken back to ER after her coronary angiography. So the patient was taken to intra-aortic balloon pump and inotropic aging was started. The patient arrested in the 3rd hour of the follow-up and was accepted as extus as she did not respond to the interventions. Discussion. Transthoracic echocardiography is used to determine mechanical complications caused by acute MI and has a sensitivity and specificity of nearly 100%. Especially with TTE, the location and the size of rupture, ventricular functions, and shunt degree can be determined. In this case, post-MI hypotension was detected and VSR was supported by bedside echo in terms of possible complications. Cardiac catheterization is also effective in confirming the diagnosis and measuring the shunt. Rupture localization can also be detected by left ventriculography. Aggressive medical methods and early surgical intervention are the basic approaches in providing hemodynamic stabilization in these patients. Intra-aortic balloon pump support, vasodilator agents, diuretics, and inotropic agents should be used to reduce left ventricular pressure and provide hemodynamic stabilization. However, since 24 of patients receiving medical treatment alone die within the first 3 days and 75 within first 3 weeks, early surgical interventions must be performed. However, despite surgical treatment, mortality increases up to 70%, especially in VSR that develops after inferior MI. Although coronary bypass performed with surgical repair does not affect in-hospital mortality, there is data that increases long-term survival. Although percutaneous closure is considered an alternative to surgery in patients with acute hemodynamic disorders, long-term data are needed. So these are the references. So I'd like to say a little few words about this again. These ICU bed insufficiencies are, as well as coronary ICU or normal ICU units, are a big pain for our performing our job. Any questions, any additions? Thanks.
Thank you, Dr. Özcan. Any question, any comment? Thank you. Next presentation.
This is my other presentation. I'd like to talk about a case with superior mesenteric artery dissection. Abdominal pain is one of the symptoms that constitute the majority of the reasons for admission to the emergency department, both acute and chronic. Abdominal pain, which occurs especially due to vascular pathologies of the intestines, is one of the rare conditions that come to the minds of clinicians less frequently and that significantly increases the mortality and morbidity if it's not diagnosed in the early period. Spontaneous isolated superior mesenteric artery dissection is a very rare condition without an underlying iatrogenic or traumatic cause. Since early diagnosis will change the treatment method, the time it takes for the patient to apply to the emergency department and the time of diagnosis in the emergency room are very important. Here we will examine a case with the spontaneous isolated superior mesenteric artery dissection and thrombosis. According to the anamnesis taken from a 47-year-old male patient who applied to the emergency department with sudden abdominal pain that started 4 hours ago. His current pain started suddenly and he applied to the emergency department due to its increasing severity. There was no feature in the patient's medical history other than hypertension and therefore 8 mg benidipine hydrochloride usage. In physical examination, his general condition was moderate. He was conscious, cooperative, oriented. Vital signs were blood pressure, arterial blood pressure was, they all in the normal scale. An abdominal examination revealed tenderness and rebound in all 4 quadrants. No pathological findings were found in other system examinations. The patient's history and physical examination findings were evaluated as acute abdomen and symptomatic treatment was started and tests were requested. Laboratory test shows leukocytes were determined as 9,000 millimeter cube. His CRP was 9.8 milligram per liter. Lactate was 1.6. In the repeated examination of the patient, as the abdominal findings increased, intravenous contrast enhanced abdominal computed tomography was performed as an advanced imaging method, and the thrombosed dissection line was detected along the long segment of the superior mesenteric artery, causing partial obstruction. Interventional radiology was consulted for endovascular stenting within the current findings. However, since the procedure was not considered, he was admitted to the general surgery clinic for follow-up and treatment. The patient was discharged with full recovery on the 4th day of hospitalization. Spontaneous dissection of isolated superior mesenteric artery is a rare condition. While connective tissue disorders may be the underlying cause of this disease, which is more common in young men in the 4th and 5th decades, definitive evidence for the disease is still lacking. In this case, no additional risk factor other than hypertension was found. Although treatment varies depending on the nature of the case, it may include medical treatment such as anticoagulation or antiplatelet therapy or invasive interventions such as endovascular stenting and also open surgery. Due to the emergency department crowd, the time allocated per patient is not sufficient. Appropriate imaging methods used together within the patient's history and physical examination are effective in reaching the correct diagnosis. Thank you. Any questions, any additions?
Thank you very much. Any question? Any comment? Thank you.
Thanks.
Next presentation, please. Pulmonary artery dissection in young patients with pulmonary hypertension. Dr. Elif Çamcı, please.
Okay. Good morning, everyone. I'm Dr. Elif Çamcı from Namık Kemal University Medical Faculty Hospital, Emergency Department, and I'll tell a case report to you. Pulmonary artery dissection in a young patient with pulmonary hypertension. Geçemiyorum. Nasıl geçeceğim? Tamam. Pulmonary artery dissection is an extremely rare but highly fatal condition. It is first described in 1842, and due to high fatality rates, most diagnoses are made from autopsies. Most patients die suddenly from major bleeding or tamponade caused by direct rupture into mediastinum or retrograde into the pericardial sac. We all know that aortic dissection may develop a reentricite, and this gives us more time to treat the patient and to diagnose patient than treat patient. But unlike aortic dissection, pulmonary artery dissection progresses rapidly and typically ruptures rather than developing a reentricite, and this causes cardiogenic shock or sudden death. It's usually paired with a pulmonary arterial aneurysm, mostly due to pulmonary hypertension. And by telling this case, I aim to raise awareness about this life-threatening condition, besides other emerging chest pain and back pain-related pathologies. When we see a patient with chest pain or back pain, we think of acute coronary syndromes, aortic dissection, pulmonary embolism, but not pulmonary artery dissection. Mostly. Our patient is a 37 years old woman. Her main complaint was cold and chest pain and back pain for 2 days. She and her husband, they stated that they were having similar symptoms due to common cold for several days, including a sore throat. Her chest pain was in a stubborn pattern and it was increasing while breathing. Her past history is remarkable, with pulmonary arterial hypertension for 8 years, which treated with bosentan and tadalafil. Physical examination showed a normal oropharynx, decreased lung sounds in left base, and in her back there were ecchymosis due to her cupping therapy. For her cold, she didn't go to hospital firstly, she didn't go to an ED firstly, but she preferred to do a cupping therapy first. And we thought that her back pain was about this cupping therapy firstly. Her blood pressure was 85/50, which responded well to a normal saline infusion. And her heart rate was in upper limit, and oxygen saturation was 92%, and our patient refused to give an arterial blood gas sample because she said it's painful and she didn't want. Her ECG, we see T-wave immersions in leads V1 to V4 and D3 and AVF, and we monitor cardiacally our patient and take her to observation ward. Her CRP level was 76, and cardiac troponins were within normal limits. We planned a chest X-ray. And after NR challenge, we persuaded the patient to give an arterial blood gas sample. We need that for diagnosis. And we had a problem there. Our ED was extremely crowded that day, and this patient waited more than an hour for a chest X-ray. Arterial blood gas was caused with respiratory alkalosis. Also, I thought that it was unlikely in a patient with pulmonary hypertension to see an pulmonary embolism, but this makes us think about pulmonary embolism in ED. So, not to lose any more time, I canceled the chest X-ray, and for further evaluation, we planned a pulmonary artery CT angiography. And this is our CT's first scan. We see an enlarged mediastinum here. And we see a giant enlarged pulmonary artery about 10 centimeters in diameter. And there is an 17 millimeters length dissection site. And we see an enlarged right pulmonary artery approximately 5 centimeters. And here our patient's sagittal view, our enlarged pulmonary trunk. Emergent cardiovascular surgery and cardiology consultations are made. Her echo was about normal, but although her echo was normal, unfortunately our patient suffered a sudden cardiac arrest while under observation in the ED. After 4 to 5 minutes CPR, our patient accepted died. When we see literature reviews, it's first described in 1842 and till 2018, a review of 150 patients shows that the survival rates are really increased till it's first described. And this review showed us that pulmonary artery dissection is not as rare nor as fatal as believed, and with a high index of suspicion and appropriate investigations and early diagnosis of PAD can be made and successful treatment instituted. First, we should suspect of this diagnosis and appropriate investigations should be made. I take this case to increase pulmonary artery dissection awareness among doctors. This was my first case in a pulmonary artery dissection, and maybe I will not see in my life again this. There wasn't even a sentence in Tintinelli emergency textbook. And symptom awareness among patients should be increased because our patient waited for 2 long days before coming to ED. And we lost time in this crowded ED. Also, when we diagnose these patients, our job isn't finished. We should refer these patients to centers which correct treatments can be made. Thank you for your considerations.
Thank you, Dr. Chamcı. Any question? Any comment? Thank you very much. Bullous skin disease is occurring due to bed bug bite case report. Dr. Abdurrahman Yılmaz, please.
Good morning, everybody. I will present a case report, bullous skin disease occurring due to bed bug bite. Bed bug bites are arthropod bites that are commonly seen especially in developing countries and in countries with low socioeconomic status. If an allergic reaction occurs due to these bites, urticarial skin rashes, macular and papular lesions can be observed. Its etiology is not clearly known. The aim of this case study to present skin reactions observed in a 40-year-old male patient who came to our emergency service due to a bed bug bite. Cymex lectularis, popularly known as the bed bug, belongs to the Simistae insect family. They feed with the blood of human and animals. A single symptom of bed bug bites for individuals who have not been bitten before can be ictioerythematous mucus. This case report presents the skin reactions in a patient who has been bitten by a bed bug previously and has present with the same complaint again. It also details the management of this reaction using corticosteroid treatment. A 40-year-old male patient presented to our emergency service complaining of bullous and papular skin lesions persisting for nearly a week. During the physical examination, it was observed that the patient had healed ulcerated lesions and fluid retention around his left eye. The patient reported that his symptoms arose after contact with semicirculars, commonly known as a bedbug. Upon arrival, the patient's vitals were stable. The patient's lesions are depicted below. We got permission from the patient, and this photograph is taken. These are skin lesions of the patient. And there is a ödem in his left eye. We learned that the patient doesn't have any chronic disease. Other system examinations of the patient were normal. We evaluated for prednisone, pantoprazole, and phenylmelath to this patient. This treatment continued for 3 days. Simultaneously, the patient was prescribed mepramylated, lidocaine hydrochloride, and gel consisting dexpantanol and antihistamine. The change the patient lesions were second day, as the picture. Bedbug bites can cause allergic reactions. In this case, we studied the diagnosis and treatment process of patients who present to emergency service with complaints of ictibulous papular lesions. The patient didn't have any previously known dermatological disease. Patient lesions occurred as a result of bedbug bite. Following our treatment, the patient fully treated and discharged from the hospital. Upon reviewing medical literature, they discovered that bullous reactions from these bites occurred to 6% of the patients. Antigens in the bedbug saliva are responsible for this hypersensitive reaction. Robin and colleagues emphasized in their study that bed bites should be considered during differential diagnosis. These bites, which can cause various skin lesions and physiological disorders, may even lead to anaphylaxis. They also suggest that corticosteroids and symptomatic drugs can be used to combat the effects of bedbug bites. However, the primary treatment is the eradication of these pests. Alexandra and her team report that their study that bedbug bites can resemble bullous disease such as pemphigoid or Dunning disease. They note that differential diagnosis of this autoimmune disease can be accurately made using immunofluorescence examinations. As a result, medical professionals should inquire about potential bedbug-related issues when patients present to the emergency department with erythematous, bullous, or papular lesions. This concern should not be overlooked. Conflicts of... Okay. It's the end of that. Any questions?
Thank you.
Thank you.
Any question? Comment? Thank you. Next. Attitudes and behaviors of emergency department physician towards prescribing oral anticoagulants and the discharge of patient with newly detected atrial fibrillation in the emergency department. Profesör Doktor Görkem Alper Solakoğlu.
Good morning, everyone. I am Murat Metin from Istanbul. Professor Dr. Süleyman Yalçın City Hospital. I'll talk about attitudes and behaviors of emergency department physicians towards prescribing oral anticoagulants at the discharge of patients with newly detected atrial fibrillation in the emergency department. As everybody knows, atrial fibrillation is the most common cardiac arrhythmia diagnosed in emergency departments. All clinical guidelines strongly recommend oral anticoagulant prophylaxis to prevent stroke in atrial fibrillation patients. However, only 20% to 60% of these patients at high risk of stroke are prescribed oral anticoagulant medication. More than one-third of emergency department patients diagnosed with newly detected atrial fibrillation do not see a doctor within 30 days, delaying potentially life-saving treatment, as like stroke. We wanted to learn to what extent emergency physicians use the guidelines in patients diagnosed with atrial fibrillation, their attitudes towards assessing the risk of stroke and preventing it, factors affecting patient approach, how often they use oral anticoagulant drugs, their hesitations and thoughts about prescribing oral anticoagulant drugs. Our study is a qualitative study using semi-structured interviews with the participation of emergency room physicians working at an urban tertiary care academic hospital with an average annual emergency department volume of 250,000 patients. The study group of the research consists of 6 emergency medicine specialists and 20 emergency medicine assistants working in the emergency department. Participating doctors were asked open-ended questions related to the subject of the study. Attitudes towards management of patients with atrial fibrillation in the emergency department, thrombophylactic approach at discharge of patients with atrial fibrillation, physicians' opinions and recommendations regarding the diagnosis, treatment and follow-up of patients with atrial fibrillation. When asked about the practices of emergency physicians regarding the evaluation of patients diagnosed with atrial fibrillation, one of the most frequent answers given by the participants was to seek the opinion of a cardiologist. The participants expressed a common opinion that the treatment and follow-up of chronic diseases should be carried out by the relevant branch physician. These are findings. When asked that what the known sources are for treatment decisions in atrial fibrillation patients, the majority of participants answered Chatwas score. However, when asked what is the reason for not calculating the scoring in practical practice, they cited the reason for receiving treatment recommendations through consultation for all patients diagnosed with atrial fibrillation. Although this situation suggests that the level of knowledge of doctors is sufficient, it also reveals the difference in behavior due to the defensive medical approach. Although emergency physicians can mostly manage hemodynamic evaluation and rate control alone in the first intervention of a patient diagnosed with atrial fibrillation, it was concluded that the reason for applying for cardiology consultation was the concern that newly diagnosed atrial fibrillation patients would not be able to undergo outpatient follow-up if oral anticoagulants were started. Emergency department physicians who participated in our study stated that they did not prescribe new oral anticoagulants. As a matter of fact, some participants responded to the questions examining the frequency of new drugs prescribing. He responded as follows: "My level of knowledge and experience about new drugs is lacking." Some emergency physicians have stated that they do not prefer new drugs which are not reimbursed by insurance if prescribed by emergency physicians in Turkey due to their cost to the patient. There are multiple variables that influence emergency physicians' decision to make prescribe oral anticoagulant medications at the discharge of newly detected atrial fibrillation patients. Guidelines specific to the branch of emergency medicine making recommendations for anticoagulants to be used in the discharge of atrial fibrillation patients will reduce the differences in approach between emergency medicine physicians. In summary, the role of emergency physicians in the approach to patients diagnosed with atrial fibrillation should be defined more clearly. There is a need for comprehensive development that includes improvements at the system level, establishing a diagnosis, intervention, prescription, follow-up chain, and increasing doctor training. Thank you for listening.
Thank you very much. Any question? Thank you, please. Comparison of demographic characteristics of unvaccinated patients admitted to give COVID PCR test. Dr. Mert Güven.
Good morning, everyone. I am Dr. Mert Güven from Süleyman Yalçın City Hospital from Istanbul. I'm going to talk about comparison of demographic characteristics of unvaccinated patients admitted to give COVID PCR test. Nasıl ilerliyoruz? In this study, we aim to determine the reasons for vaccine refusal, to compare the demographic characteristics, to learn the source of information about the vaccine in the people who refused the COVID vaccination. In the study, demographic data we looked for age, gender, education status, occupational status, chronic disease data were collected. In the questionnaire, reasons for vaccine refusal, source for information about vaccines, the number of the PCR tests performed in the last 1 year. In the findings, men are more likely to have COVID than women. The rate of undecided to vaccine among men is higher than among women. Women are more likely to learn about vaccination from medical publications than men. Men are more likely to learn from social media than women. High school graduates get information about vaccination from their environment and television. Primary school graduates show no interest in medical publications. Social media is effective among the more educated people. High school graduates tend to give more tests. Mid-aged and elder are more likely to learn vaccination information from TV and youngs than youngs. Youngs have a higher rate of learning from social media than mid-aged peoples. Mid-aged are more likely to have 2 or 5 tests than those aged youngs and elders. In the discussion, increased educational attainment suggests an increase in skepticism toward vaccines. They have to access more resources, exposed to more misinformation. We found that men and young people had a higher rate of COVID vaccine refusal. Individuals who accepted the COVID-19 vaccine were not included in the study, so no comparison could be made with this group. The reason for COVID vaccine refusal are concerns about vaccine side effects, doubts about the protection of the vaccine, lack of sufficient studies. It is thought that social media platforms, which are frequently used to obtain information about vaccines, may increase misinformation about vaccination and to lead to vaccine refusal. Thank you.
Thank you. Any question? Thank you. hematoma in the psoas region secondary to trauma and subsequent renal failure. Dr. Mustafa Yorgancıoğlu.
Good morning, everyone. I am talking about hematoma in the psoas region secondary to trauma and subsequent renal failure. Hematoma in the psoas muscle may occur spontaneously or secondary to trauma. Spontaneous causes include coagulopathies, anticoagulant use, and leakage from abdominal aortic aneurysm. While the incidence of spontaneous iliopsoas hematoma is 0.1% in general population, this value is 0.6% in the elderly population with the effect of anticoagulant use. Traumatic psoas hematoma may be an indicator of serious mechanism of injury, but may also be a marker of severe blood loss. Case report, a 49-year-old man with non-alcohol-related cirrhosis presented to emergency department with complaints of right lower quadrant abdominal pain and anorexia. 10 days ago, while sitting in a chair, he fell on his right side. Vital parameters, we can see hypotensive, the others are normal. Examination, neurological is normal, results are heard in both lungs, peritibial edema are positive in 2 legs, tenderness in the right lower quadrant of abdomen, the abdomen appears distended, there is 6 or 7 cm diameter ecchymotic area extending laterally on the right hip, which turn green in color. Tomography, abdominal tomography elevated 10x8 cm hypodense lesion in the right muscle, psoas muscle. Psoas hematoma due to trauma-caused renal failure and anemia. Erythrocyte suspension was given in the emergency room. Urine output was measured as approximately 100 cc in 6 hours. He was then admitted to in the intensive care unit, and it was decided to connect his to the dialysis unit. We can see laboratory result. Hemoglobin is 5.1 gram, and we can see creatine. Also, we use hypodense lesion. Result and conclusion, traumatic psoas hematoma is more common in adolescents. After trauma, pain in the lower abdomen, gait disturbances, motor and sensory deficits in the areas innervated by the femoral nerve may be encountered. A significant decrease was observed in our patient's hemoglobin value compared to normal. In a study by Amar et al., it was reported that hemoglobin decrease was detected in 56% of cases. The other in the study, Cavalier et al., these hemoglobin decreases were attributed to the fact that the psoas muscle can collect a volume of blood 10 times its own size. Although surgical methods are preferred in some patients, non-operative treatment methods were preferred in our patient, as in many cases. He was discharged after his clinical condition improved. Thank you.
Thank you. Any question, any comment? Thank you very much. Next, please. Factors affecting self-efficacy, self-competency and willingness of medical students in disasters. Dr. Görkem Alper Solakoğlu. Sorry, Dr. Nuray. Okay, please.
Merhaba. Hocam izninizle Türkçe sunsam olur mu?
Tamam, sıkıntı yok.
Teşekkürler. Merhaba arkadaşlar, ben Doktor Nuray. Süleyman Yalçın Şehir Hastanesi'nin Acil Tıp Departmanı'ndayım. Size bugün tıp öğrencilerinin afiyetlerde kendi yeterliliklerini ve istekliliklerini etkileyen faktörler üzerine bir çalışmadan bahsedeceğim. İçerik bu şekilde. Kısaca bir giriş yapıp materyal metotlardan bahsedip çözümle tamamlamayı düşünüyorum. Sağlık çalışanları afet yönetiminde çok önemli bir rol oynamaktadır ve acil durumlarda verdikleri kararlar önemli bir etkiye sahiptir. Ancak afet yönetimi eğitiminin yetersiz olduğu ülkelerde tıp eğitimi almış olanlar afetleri etkili bir şekilde yönetmek için gerekli uzmanlık, bilgi ve hazırlığa sahip olmayabilir ve bu durumda daha da kötüleşmesine neden olabilir durumun. Tıp fakültesi öğrencilerinin afet müdahalesine potansiyel katkısı literatürde özellikle COVID-19 zamanında tartışılmıştır. Türkiye gibi hastanelerin sıklıkla aşırı kalabalık olduğu ülkelerde özellikle tıp fakültelerinin genellikle hastanelere yakın olması sebebiyle tıp öğrencileri değerli destekleri sağlayabilirler bu durumlarda. Aslında yeterli bir eğitimle ekibin parçası olabilirler. Ancak tıp fakültelerinde afet konusunda çok asgari düzeyde bir eğitim verildiği için öğrenciler bu tür rolleri yetkin bir şekilde yönetmek için gereken bilgiye sahip olmayabiliyor. Avrupa Birliği İnsani Yardım ve Sivil Koruma tarafından finanse edilen TİM projesi, acil müdahale ekipleri için operasyonel ekip eğitimi, pilot uygulama ve değerlendirme odaklanan standart uygun maliyetli bir eğitim paketi geliştirmeyi amaçlıyor. 2-7 Ağustos 2022 tarihleri arasında da Türkiye'de gerçekleştirilen pilot çalışmada tıp öğrencileri afet simülasyonu yapan fonksiyonel ve masaüstü tatbikatlara rol oyuncusu, kolaylaştırıcı, tercüman ve gözlemci olarak katıldılar. Bu çalışmalarda tıp öğrencilerinin afetlere müdahale etme istekliliklerini, tıp öğrencilerinin atanmayı tercih ettiği rolleri ve Teams projesine katılımları da dahil olmak üzere karar vermelerini etkileyen faktörleri değerlendirmeyi amaçlıyorum. Üniversitede 5. ve 6. dönemdeki lisans öğrencilerinin afet müdahalesine ilişkin motivasyon ve tutumlarını değerlendirmek amacıyla kesitsel, niceliksel, gözlemsel ankete dayalı bir çalışma yaptık. Bu çalışmada öğrencilerin afet yardım çalışmalarına katılmaya hazır olup olmadıkları öz değerlendirmelerine yönelik 15 soru hazırlanırken farklı afet senaryolarında da gönüllülük kararlarını etkileyen faktörleri değerlendiren 25 soru hazırlandı. Ayrıca öğrencilerin afet anında gönüllü olarak görev yapmak istedikleri hastane bölümleri ve kendilerini yetkin olarak algıladıkları alanlara ilişkin tercihleri de araştırdık. Araştırmaya 71 erkek, 101 kadın olmak üzere toplam 172 kişi katıldı. Katılımcıların ortalama yaşı 23, 21-25 arasında. Toplam katılımcıların 55'i 5. dönemden, 117'si 6. dönemdendi. Bu tabloda tıp öğrencilerinin afet müdahalesinde öz yeterliliğini etkileyen faktörleri görüyoruz. Bu faktörler arasında bu projeye katılanlardan sonra felaketin yol açtığı göreceli hasarı tespit edebilirim artık, yaraları doğru hızlı bir şekilde değerlendirebilirim gibi sonuçların daha fazla olduğunu fark ettik. Bu tabloda da tıp öğrencisi afet müdahalesine istekliliğini etkileyen faktörler var. Bunun içinde de eğer ailem güvende olursa, ailemle iyi bir iletişim hattım olursa ya da ekip halinde çalışırsak, amirimle birlikte çalışırsam ya da bunun için bana para verirlerse afet yönetimine katılabilirim gibi sonuçlar elde ettik. Bu tabloda da afetlerde öğrencilerin çalışma alanını tercih etmelerini etkileyen faktörler var. Sonuç olarak bu tablodan çıkaracağımız Teams projesine eğitimine katılanlar travma bakımı ve ilaç enjeksiyon uygulamaları konusunda eğitim almayanlara göre kendilerini daha yetkin hissediyorlar. Afet eğitim alanlar triyaj, travma bakımı, ilaç enjeksiyon uygulaması, hasta takibi ve psikolojik destek konularında kendilerini daha yetkin hissediyor. Erkekler yoğun bakım konusunda daha yetkin hissederken 6. dönem öğrencileri ise travma bakımı, psikolojik destek, toplum sağlığı hizmetleri ve halka ilişkiler çalışmalarında kendilerini daha yetkin hissettiklerini gördük. Triyaj, hasta takibi ve toplum sağlığı konularında kendini yetkin hisseden öğrenciler triyajda çalışmayı tercih ediyor. Travma bakımı ve ilaç enjeksiyon yönetimi konusunda kendini yetkin hissedenler acil serviste, travma bakımı konusunda kendini yetkin hisseden kişiler ise ambulansta çalışmayı tercih ediyorlar daha çok. Çalışmamız öğrencilerin afet çalışmalarına katılmayı da istekli olduklarını, ancak motivasyonlar artırmak için kendilerini psikolojik ve tıbbi olarak hazır hissetmeleri gerektiğini gösterdi. Afet eğitim programlarına stajyer veya rol oyuncusu olarak aktif katılmanın, eğitim ortamında bulunmanın bile öğrencilere kendilerini yetkin hissettiklerini ve motivasyonlarının artırdığını fark ettik. Teşekkürler.
Teşekkür ederiz. Soru, katkı var mı? Teşekkür ederiz. Başka sunum var mı? Diagnosis of diffuse pulmonary hemorrhage by ultrasonography. Case report. Dr. İsmail Erkan Aydın, please.
Good morning, everyone. My name is İsmail Erkan Aydın, and I would like to present a case diagnosis of diffuse pulmonary hemorrhage by ultrasonography. Acute dyspnea is a common case of admission to the emergency department. For survival of these patients, the correct rapid diagnosis and management of the emergency physicians are necessary. Thoracic ultrasound is widely used in emergency departments in patients with respiratory symptoms and trauma patients. Especially in the last 10 years, the use of point-of-care ultrasound POCUS has become widespread with increase in POCUS trainings. In this case report, a patient with complaints of shortness of breath and rash on body and diagnosed with diffuse pulmonary hemorrhage by bedside POCUS in ED is presented. A 72-year-old male patient was admitted to emergency department with a complaint of rash all over his body and shortness of breath. The patient had petechial rashes all over the body, bleeding in the mouth and gums, dyspnea and tachypnea. Endotracheal intubation was applied to the patient with clinical findings and severe hypoxia in arterial blood gas. It was observed that there was bleeding towards the endotracheal tube. Continuous blood flow was observed when the endotracheal tube was aspirated. Positive pressure mechanical ventilation support was started. Bedside POCUS was performed by emergency physician. POCUS revealed multiple and confluent B lines, pleural line abnormality, disappearance of A lines, subpleural hypoechoic area, hepatization, shared sign, and pleural effusion, predominantly third, fourth, and fifth zones of the right lung and third and fourth zones of left lung. This image shows multiple and confluent B lines, pleural line abnormality, and disappearance of A line. This figure shows hepatization and shared sign. And this image shows subpleural hypoechoic area. And also stratosphere signs were detected in M-mode in zones with pleural line abnormality, subpleural hypoechoic area, hepatization, and shared sign. The patient was diagnosed with diffuse pulmonary hemorrhage with POCUS and clinical findings. This image shows hepatization, shared sign, and stratosphere sign, and also M-mode. This is our POCUS exam form, right lung and also left lung. Some pathological signs in this table. In conclusion, the most immediate life-threatening complication of diffuse pulmonary hemorrhage is acute hypoxemic respiratory failure, and its mortality rate is high. Chest X-ray and CT are limited value in differentiating diffuse alveolar hemorrhage from infection or other causes of diffuse alveolar opacification in diffuse pulmonary hemorrhage. POCUS contributes to the diagnosis and correct management of the patient in the emergency department in a short time. Thank you for listening.
Thank you. Thank you very much. Please, next. Comparison of pre-COVID-19, COVID-19 and post-COVID-19 urinalysis parameters and assessment of their relationship with renal function. Dr. Leyla Öztürk Sönmez, please.
Thank you. Good morning. I'll talk about comparison of pre-COVID, COVID and post-COVID urinalysis parameters and assessment of their relationships with renal functions. In this study, we aim to compare the before the disease, during the disease, and after recovery, post-disease periods of the patients in terms of urinalysis parameters and assess the relationship between the changes in these parameters and renal functions. In the study, we evaluated 482 moderate and severe COVID patients who had the data of urinalysis performed in the pre-COVID period at most 3 months before the onset of the disease, during COVID disease, and 15 days after they completely recovered from the disease were included. Parameters of bilirubin, erythrocyte, leukocyte, protein, glucose, STT, and density were analyzed in urine samples, and the results were recorded. In the study, underlying chronic diseases such as hypertension, diabetes, chronic heart failure, patients with urinary system oncological or stone disease, mild COVID patients who did not require hospitalization, or critically ill COVID patients who required intensive care unit follow-ups are excluded in the study. Due to our results, CRP, eGFR, fibrinogen, and D-dimer values were found to be significantly different between the 3 groups. A negative correlation was found between eGFR and both CRP and D-dimer values of the patients during the disease. Urine pH, acidity, presence of leukocyturia, presence of microscopic hematuria, and presence of proteinuria were found to be significantly different between the 3 groups. It was determined that these 4 parameters increased significantly during the disease period and decreased in the recovery period. A negative correlation between urine density and eGFR or positive correlation between urine density and CRP were detected during the disease. Here are the tables of results. The details of pre-disease, during the disease, and post-disease demographical and hematological parameters are shown. And urinalysis parameters tables are seen in the table. The figure of negative correlation between the eGFR and CRP and D-dimer values during the COVID disease, and the negative correlation figure between urine density and eGFR, and positive correlation between urine density and CRP figure during the disease. There are current studies conducted through the comparison of the SARS-CoV-2 positive and negative patients, but our study stands unique as it shows the changes in urine biochemistry in patients before the diagnosis of the disease, during the disease, and after recovery. In literature, Liu reported a higher urine protein pH values and erythrocyte counts, but lower urine density in the COVID period group compared to the control group. Margaret detected a higher rate of hematuria and proteinuria in COVID patients compared to the healthy controls. Demirelli categorized COVID patients based on the severity of the disease, and respective percentages of these patients had glucosuria, proteinuria, urobilinogen positivity, leukocyturia, and hematuria. In our study, patients were detected a significant increase in the rates of proteinuria, hematuria, and leukocyte counts during the disease compared to the pre-disease period, and a significant decrease in these parameters after the recovery from the disease. To conclude, the significant presence of hematuria and proteinuria during the disease in line with the literature supports the opinion that the disease causes renal involvement, and the tendency of the parameters on the post-COVID 15th day to return to normal ranges shows us that the effects of the inflammation are reversible after the recovery from the disease. Thank you.
Thank you very much. Next, the last presentation, I think. The DVT developing after a backache, a case report. Dr. Yasemin Pishkin, please.
Good morning, everyone. My name is Yasemin. I'm gonna present a case report. DVT developing after backache case report. Deep vein thrombosis occurs when one or more of the components of the virtual triad, status, hypercoagulability, and endothelial damage occur. The annual incidence varies between 5 or 20% per 100 people. Thrombosis in the deep venous system of the extremities causes symptoms such as pain, diameter difference, and redness in the extremities in the acute phase of the disease. The cases of venous thrombosis can be divided into two groups, hereditary and acute. Immobility is facilitating the development of deep vein thrombosis. Treatment includes anticoagulants, thrombolysis, and thrombectomy. In this article, we describe a case of our who remained immobile for 2 days after lower back pain, had swelling and redness in the leg, and was diagnosed with DVT. A 45-year-old male patient was admitted to the emergency room with a complaint of pain and swelling in his left leg. The patient has been complaining of back pain for 1 week. He has had little voluntary movement for the last 2 days. Pain and swelling in the left leg started for 2 days. He has a history of cervical disc herniation in his medical history. There is no disease in the family history that predisposes of thrombosis. There is no history of thrombosis. On physical examination, there was an increase in diameter in the left leg compared to the right leg. There was an increase in temperature, and hormones positivity was detected in the left lower extremity. Peripheral pulses are palpable. In the neurological examination, there is no motor sensory deficit. Glasgow Coma Scale 15 for limb motor power normal. There is no urinary or fecal incontinence, no drop feeds, there is no pathological reflex. Abdominal examination is comfortable, no defense, no rebound detected. Laboratory tests show no abnormalities in biochemistry and hemogram. D-dimer high, CRP little bit high was detected. Doppler ultrasound was performed on the patient with the preliminary diagnosis of deep vein thrombosis. Doppler ultrasound revealed widespread thrombosis compatible with acute deep vein thrombosis, which filled the lumen of the left femoral vein, popliteal vein, and vena saphana magna, and didn't allow flow of the compression. The patient was consulted to cardiovascular surgeon upon detected of deep vein thrombosis. The patient was admitted for the purpose of planning thrombectomy. Immobility can cause thrombosis and deep vein thrombosis in people, even in people who are not prone to clotting. In patients with lumbar hernia, starting a prophylactic dose, low molecular weight heparin may be considered to protect it against deep vein thrombosis due to immobilization. It should be kept in mind that patients are prone to deep vein thrombosis in cases that cause immobilization, such as lumbar hernia. Patients should be advised not to remain sedentary. Thank you for listening.
Thank you very much. We must close oral presentation session. Thank you, all contributing.
Good morning. I'm Professor Dr. Lisa Moreno, and I'm from the US, and this is Professor Dr. David Carr from Canada. We're going to be your moderators for this critical care session, and we're going to jump right in since everything is a little bit behind schedule today. Our first esteemed speaker is Dr. Ajay Ah, and he is an assistant professor at the All India Institute of Medical Sciences in Nagpur, India. Dr. Ajay is going to speak to us about trauma-induced coagulopathy.
Thank you, ma'am.
I'm Dr. Ajay. I'm a residency-trained MD emergency medicine physician from India. I have a fellowship in Academic College of Emergency Experts in India. I currently work as an assistant professor in emergency medicine at Indian Institute of Medical Sciences, Nagpur. My areas of expertise include inter-hospital transport, point of care ultrasound, and emergency medicine. Now, coming into the trauma-induced coagulopathy, we will be discussing on these headings, basically history, definition, pathophysiology, diagnosis, and some management pearls. Coming to the history, the first documented evidence of coagulopathy in trauma was found when they were experimenting stress in animals with giving up epinephrine. So it was provoked by the administration of epinephrine, provoked by hypercoagulability, and this was followed by hypocoagulability. This happened in 1916s. In the 1915s, a lot of civilian investigators like McFlaren, Stefani, Hardway, and Rapport found out that the culprit for coagulopathy could be either disseminated intravascular coagulation, platelet dysfunction, or loss of labile clotting factors. The investigation continued, and it continued and accelerated in the 1970s actually, when multiple cases of liver injury, even after attaining mechanical hemostasis, continued to bleed. So this is where the concept of preemptive treatment of plasma started. In 1980, as everyone knows, the lethal triad, now the lethal diamond, which consists of hypothermia, acidosis, and the coagulopathy, was introduced, and then came the concept of damage control resuscitation. In 2001, this was the breakthrough movement in the pathophysiology and also the management of trauma-induced coagulopathy, where the cell-based model of coagulation was introduced by Monroe et al. It had an initiation phase, amplification phase, and a propagation phase. And unlike the kinetic theory, here the cells had a lot of functions to play in maintaining the coagulation. In 2003, the first name was coined for this coagulopathy in trauma. It was coined as acute coagulopathy of trauma, based on the works of MacLeod and Broe et al. In 2007, they also came with a pathophysiology where there is an activation of protein C, which is an integral part of acute coagulopathy of trauma. And finally, in 2010, what we call trauma-induced coagulopathy, the name was coined by the Trans-Agency Consortium of Trauma-Induced Coagulopathy Workshop by the National Institute of Health. So that's in short about the history. Now, trauma-induced coagulopathy can be defined as an impairment of blood clotting that occurs after injury. This is from Firth in 2010, the same workshop. So there are two phenotypes for trauma-induced coagulopathy. We will be more concentrating on the early trauma-induced coagulopathy, and the second phenotype is the late trauma-induced coagulopathy. So the early trauma-induced coagulopathy is basically the inability to achieve hemostasis, which lead to uncontrolled hemorrhage and protracted shock. So what is the driver for an emergency or an early trauma-induced coagulopathy? It's again hypoperfusion and hypotension. So hypoperfusion and hypotension produces coagulopathy, which in turn increases hemorrhage and again produces coagulopathy. The late TAC, however, is the main driver is basically the level of the tissue injury, and it occurs more than 24 hours, and it is characterized by thrombosis. So the pathophysiology has two different settings. One is hypocoagulability and the other one is hypercoagulability. Hypocoagulability is explained by hyperfibrinolysis, platelet dysfunction, decreased thrombin generation, fibrinogen degradation, while hypercoagulability, increased thrombin generation, platelet activation, hyperfibrogenemia, and fibrinolysis. You can see that it's at the extremes of both. Coming to early trauma-induced coagulopathy in detail. First, we have endothelial dysfunction, which will produce tissue plasminogen activator, which will convert plasminogen to plasmin and result in clot degradation. Tissue injury also will produce end products like histones and polyphosphates, which contributes to platelet dysfunction, which again results in clot degradation. And any clot is actually maintained by the balance between the fibrinolytic agents and the thrombotic agents. If there is a reduced number of antifibrinolytic agents like PAI, TAFI, again this will result in clot degradation. Coming to what we do, when we restate, we produce hemodilation. there could be some amount of acidosis, there could be some amount of hypothermia. All these are non-risk factors for decreased thrombin generation. Even though hemodilution up to 50% does not affect the clotting mechanism, acidosis has a very profound effect. Acidosis can decrease the thrombin generation basically in the propagation phase by around 50%, but it does not affect the initiation phase of the coagulation. Hypothermia, any temperature less than 33 degrees Celsius, is known to produce coagulopathy. Now, there is always an ongoing debate whether ETIC is just another name for DIC. But if you look at the data, you can see that ETIC, thrombin levels are decreased, while in DIC it is normal. The factor 5, factor 7, factor 8 activity is decreased in ETIC but normal in DIC. The plasmin activator inhibitor is decreased in ETIC while it is normal in DIC. Now, if you go to the viscoelastic assays, then you can see that if it is hyperfibrinolytic phenotype, the TEG L/30 is increased in ETIC but normal in DIC. If it is a fibrinolytic shutdown phenotype, which is the late TIC, ETIC it is decreased and DIC it is normal. So there is definitely difference between in DIC and trauma-induced coagulopathy. Now, how can we predict early trauma-induced coagulopathy? So there have been multiple scoring systems. One is coagulopathy of severe trauma. Is coming from the Australian system, where there are 5 components, mainly entrapment, systolic blood pressure, temperature, chest decompression, abdominal or pelvic content injury, and the highest possible score was 7. So with a cutoff value of 3, the sensitivity was 60% and specificity was 90%. It's an external validated score. The second scoring system which is usually used is the prediction of acute coagulopathy of trauma. This had a validation and a derivation cohort, but the exclusion criteria and the inclusion criteria and the validation and the derivation cohort was not the same, so the external validity is still questionable. It had multiple variables: pre-hospital shock index, age, mechanism of injury, not motor vehicle, motorcycle or bicycle crash, number of GCS points below 15, pre-hospital CPR, pre-hospital intubation, etc. The total points were around 394 plus age, and if any score of more than 196 was considered to be a predictor for acute coagulopathy of trauma. Having said that, it has a specificity of 72% and a sensitivity of 73%. Then came the age of AI, artificial intelligence. So they used the data from a study called Acil, and they defined with different variables which could produce coagulopathy. So basically they did it in these sub variations. You can see that they did tissue injury, tissue hypoperfusion, acidosis, hypothermia, and hemodilution. These were the drivers which we have discussed in the pathophysiology of early trauma-induced coagulopathy, and they looked at other things which could contribute to this particular mechanism which could contribute to the trauma-induced coagulopathy. And they did a Bayesian network model, and this has a sensitivity, at a sensitivity of 90%, this has a specificity of more than 92%. So during your primary survey, if you want to look for coagulopathy, the basic testing which you're going to do are the hemoglobin value, PT-INR, your APTT values, platelet count, fibrinogen, and if you have access to a viscoelastic testing method, a ROTEM or an RTEC, platelet function test plus or minus based on the availability. The other thing which you could do was a blood gas analysis for base deficit lactate value and pH value. So what is the major difference between a conventional coagulation test with a viscoelastic test? So conventional coagulation tests usually will have PT, INR, APTT, platelet count and D-dimer, while the viscoelastic would be either TEG or ROTEM. The measurements in conventional coagulation test is basically to identify the rate of initial clot formation, absolute platelet number, and is there evidence of clot breakdown. But viscoelastic test will give you something else also. It will give you the clotting time, it will give the kinetics of the clot formation, it will also give information about the clot strength, and it also will tell you about the clot stability and breakdown. So in coagulopathy, conventional coagulation test indicates the factor of fibrinogen deficiency only. But while that in viscoelastic tests, it indicates factor deficiency, fibrinogen deficiency, indicates platelet and fibrinogen dysfunction, and indicates enhanced fibrinolysis. So this is basically TEG and ROTAM, where coagulation time and coagulation factors is set by the R or the CT time, clot kinetics by the alpha angle, CFT or kappa based on TEG or ROTAM, the clot strength basically by the maximum amplitude or the MCF, the clot stability by ML, LY30 or LI30. So when do you diagnose coagulopathy? So you diagnose coagulopathy when there is an extension of more than 3 seconds in the PT, more than 3 seconds in the thrombin time, or if it is more than 1.2 or 1.5 classically in INR, but most of the studies now quote 1.3. A APTT extension of more than 10 seconds, fibrinogen value of less than 2 gram per liter, D-dimer of more than 5 microgram per liter, platelet count of less than 125,000 per millimeter cube. Again, there are different waveforms which you can associate with clot, which says that the patient is having coagulopathy. Now coming to the management. The first thing which we have to consider is how to stop the bleeding, because when the bleeding is ongoing, it will again produce coagulopathy. So accurate identification of the patient, bleeding patient, and damage control resuscitation is very important. You have to use a lot of hemostatic methods. It could be tourniquets, it could be pelvic binders, it could be hemostatic dressing, or even Ribova. Thromboelastography, coagulation monitoring, tranexamic acid administration for those who with substantial hyperfibrinolysis should be employed. There should be a decreased time to the operating table or intervention radiology to curb the bleeding. There should be a goal-directed resuscitation with blood products. Now, what are the goals? We will come to that. Before that, we'll just look at the evidence basis for different treatment mechanisms. One is tranexamic acid. So first study which told us that tranexamic acid can be useful is the CRASH-2 trial. It was a multi-center international RCT. But if you look at it, most of the patients in the CRASH-2 trial did not require large amount of transfusion. But there was a subset of population in which tranexamic acid was very useful. That was the patient with shock. Again, it did not show any large complications in this data. It was a very huge data, but amount of complications in this study was very low. Then came the MATTER study, which was done in the military setting. It was a single center observational study. They also told that tranexamic acid is going to help in those patients who require massive blood transfusion. But there came with a rider. The rider was that thromboembolic disease was increased by 9 to 10 times to those patients who would not get tranexamic acid. This was followed by MATTERS-2 trial in 2013, where they tried to give cryoprecipitate along with tranexamic acid and found that those two given together has a better chance of controlling the bleeding. And the last and the final trial which came was pre-hospital use of tranexamic acid in the form of patch trial. It was a negative trial, saying that tranexamic acid did not influence the morbidity of the patient at 6 months. Now, evidence of using massive transfusion ratios. The first idea of massive transfusion ratio comes from the first prospective cohort study called the PROMET study in 2013, where they said that those patients who are receiving high ratio of RBCs to platelets and plasma had a high early death. Within 6 hours, the death was higher in that group. So they proposed a 1:1:1 or a low plasma FFP platelet ratio. This was further emphasized in the proper trial in 2015, which was a multi-center RCT, which compared 1:1:1 to 1:1:2 ratio and found that there is no actual difference, but 1:1:1 is again preferred now. Cryoprecipitate also came into the picture. They wanted to give early cryoprecipitate in cryostate trial and found out that there is no basic difference. In cryostatic trial 2, again they brought in cryoprecipitate to give 2 pints of cryoprecipitate early in the hemostatic resuscitation, but then it was also found to be not effective. Now coming to viscoelastic theory. Viscoelastic methods used management. The Cochrane review in 2015 told us that the diagnostic test accuracy was based on diagnostic test accuracy for the TEG and ROTAM. It is found that there is no evidence to use TEG and very minimal evidence to use ROTAM in TIC. This was followed by a goal-directed hemostatic resuscitation in trauma-induced coagulopathy by Monroe et al. It was a pragmatic RCT, which found things entirely different. They found that the ventilator days, the ICU days, the timing to attaining of hemostasis all were decreased when they used viscoelastic method as a measuring tool to guide blood products in trauma-induced coagulopathy. And the final trial which came was the ITATIC trial in 2021, again a multicentral trial, which compared viscoelastic method with the conventional clotting tests, and they found that there is no difference in mortality. So based on this, the ITATIC group gave an algorithm. Here, if you can see that there is fibrinogen, when to give fibrinogen, when to give platelet, when to give plasma, and when to give tranexamic acid. And first one is for the rotum, and the second one is for the TEG. So if FIPTUM CFI of less than 10 millimeter, you are going to give additional cryoprecipitate. If EXTUM CFI is less than 30, you are going to give an additional pool of platelets. If EXTUM CFI is 40 millimeters or EXTUM CT is more than 80 seconds, you are going to give an additional unit of plasma. And if your LY30 or LI30 is less than 85%, you are going to give 1 gram of tranexamic acid. Now coming to the conventional clotting test, which most of us have, and we don't have viscoelastic acids in places where. So if fibrinogen is less than 2, you give fibrinogen in the form of cryoprecipitate or fibrinogen concentrate. If platelet is less than 1 lakh, you give additional pool of platelets. And if the INR is more than 1.2 or 1.3, and fibrinogen is more than or equal to 2 gram, you give additional unit of plasma. We added one more thing into this algorithm. That is, if you look at the D-dimer, if it is more than 500 microgram per liter, you give tranexamic acid additional. This was in same as the one which Monroe et al. Had done, which is the gold director resuscitation for trauma-induced coagulopathy. So at the end of 6 hours, whatever said and done, these are the things which you have to attain. These are the goals at the 6 hours of resuscitation. That is, there should be no further hemorrhage. The systolic BP should be balanced, 80 to 90. The temperature should be more than 35 degrees Celsius. The pH should be more than 7.30. Hemoglobin should be more than 7. INR should be less than 1.5. APTT should be less than 40. Fibrinogen level should be more than 1. And if the patient is having low platelets, not having any traumatic brain injury, the platelet average value is 50,000. If he is having traumatic brain injury, it should be more than 1 lakh. And the ionized calcium level should be more than 1.1 millimole per liter. So these are the goals of resuscitation in trauma-induced coagulopathy. Thank you. Any questions?
I think we're going to save questions till the end of this. I think we're going to save questions until the end of all the sessions. So thank you, Ajay, for that excellent presentation.
Thank you, sir.
Thank you for coming. It's early in the morning. And for some of you, I know that it's challenging to hear speakers in another language, so I'm going to try to speak slowly. There is no topic that I like to speak more about than this. Syncope is about 1 to 3% of all emergency visits, and in our lifetime, it will happen about 48%, which means you or I, one of us is going to syncopize. So we kind of have to know a little bit about this, and this is everything you're going to see. What this talk is not about is it's not about a biomarker. It's not about troponin. And I'm going to even try to tell you that it's not about the EKG. For real. What I'm going to tell you is it's really about how you feel. Now, let me give you some housekeeping tips. Here are my conflicts of interest. I routinely lie about seeing fundoscopy or JVP. I'm just like you. During COVID, I barely examined people. But what I do is take a history. And what I want you to get from the end of this talk is the realization that history is queen, that history is everything. And that everything I want you to take from this talk is about your ability to talk to people, to go back to basics. Now, Amal Mattu, who's a very amazing American speaker, he talked about his rule of 15s. And he said that 15% of syncope is cardiac, and of these non-cardiac causes, they can occur up to 15% of the time. But I want you to look at this list. Yes, if someone comes in hypoxic or tachycardic, or severe abdo pain and hypotension, or the worst headache of the life, you're going to know their cause of non-cardiac syncope. I hope you will consider diagnosis, but I hope on the history it will be obvious. What I want to work on today is your diagnosis of cardiac syncope. And if there is one study, I'm not really a literature person, I'm really just a clinical knowledge translator. If there's one study that I think you need to know about, is there was a study in Annals in 2018 that showed 3,600 patients, 1,400 with near syncope and 2,200 with syncope. And these were all geriatric, they were older patients. And they looked at this cohort of old patients for 1 month. And what they found out is whether you have near syncope or syncope, the outcomes are identical. So what this means is if someone almost faints or someone faints, you need to treat them the exact same way. I think a lot of times we say, oh, you almost fainted, you're okay, you didn't actually faint. That is meaningless. You must treat these two groups the same. When I was younger, I used to think that cardiac syncope meant you had chest pain and you had palpitations and then you fainted. Cardiac syncope is this. Boom, you went down with no warning. If you break your teeth, if you break your glasses, you have to realize how important those are in terms of predicting cardiac syncope without warning where you didn't have time to catch yourself. I remember seeing a young woman, she was about 26, and she came into the emergency department, and the first thing she said to me was, "I'm so sorry for wasting your time." Do people apologize to you in Turkey? No. So this was the problem. They don't apologize in Canada either. And what I know is that the nicer people always have worse outcomes. So I was already very concerned about her. So she said, "I'm so sorry to waste your time. I should be at the dentist. I chipped my tooth." Okay. Well, what happened? Well, I was taking a shower, and the next thing I know is I'm on the ground and my tooth is gone. Well, okay. And what happened before I don't know. I just woke up on the ground. So I didn't like her story. She went down without a prodrome. She went down without pre-syncope. To me, this is cardiac syncope. So I told the specialist, I have this young woman, she just dropped to the ground with no warning. I'm very worried about her. So the first thing they said is, "What's her troponin?" I said, "Troponin? Who the hell cares about troponin?" Sorry, I know Lisa's giving a talk on troponin later. This is not a troponin talk. Do you have 2 troponins? Listen, I can do 1,000 troponins. This has nothing to do with troponin. Okay, so they come see the patient and they send her off. And I get a call from my colleague, Carolyn, about a month later, and she said, "Remember that patient you saw?" I don't know how to say that in Turkish, but it makes us all very nervous. I don't know. What are you talking about, Carolyn? Spit it out. She said, "You saw this woman, she was young, she fainted, she broke her tooth." Yeah. Well, they sent her home and I did a Holter and it showed nothing, but I didn't like her story. So I did an implantable loop recorder. and she had an episode of torsades. She had long QT and torsades, and the best part about it, David, is that she has an identical twin, and now they both have defibrillators. This is all taking a history. If someone doesn't have pre-syncope, if someone doesn't have a prodrome, you must think about cardiac syncope. Any history buffs in the room? Anyone know who this is? Good. You're not supposed to. So this is Pheidippides. Ring a bell? So Pheidippides is the fastest runner in Greece 2,500 years ago. And he's stationed in a city called Marathon. And the Greeks are being invaded by the Persians, and he goes to tell the people in Athens about the position of the Persians as they're coming to attack. And he runs 26.2 miles, just over 40 kilometers, to Athens. He arrives, he warns them of this attack, and then he's dead. And he's the first incident reported of sudden cardiac death in sports. If you die while you're exerting yourself, you have to be worried. And you will see people, whether you're Christian Eriksen on the soccer pitch, you will see people just drop. Cardiac syncope and exertional syncope need to be treated with respect. This guy has a marathon named after him. Often patients will have a hard time deciphering, or bystanders, was it a seizure or was it a syncope? 90% of people with syncope will have a few myoclonic jerks. When you drop the perfusion blood flow to your brain, you will have a few jerks. Now, people will look for the following. Yes, if you have epilepsy, you probably had a seizure. Being post-ictal, very helpful. People will always look for tongue biting. What is important to know is if you fell down, you will bite the front of your tongue. But if you have a seizure, you bite the sides of your tongue. Lateral tongue biting is much more specific for a seizure than central, 96%. So look for lateral tongue biting. Things like incontinence or prodrome aren't that helpful. What I like to use is the 10-20 rule. Has anyone heard of the 10-20 rule? This is a very helpful rule. If you have less than 10 jerks, it's syncope. If you have greater than 20, it's a seizure. This is very helpful when you speak to the people who witness this, the scared family members, to say, was it just like a few of these, or was it 20? That is an important rule, the 10-20 rule, to distinguish between syncope and seizure. I often will ask about family history of sudden cardiac death. You know, and I never hit it. I never kind of get anywhere with that question. I think what's more important to understand is there's another question you want to ask people who syncopize if they're young. Has anyone in your family had a motor vehicle collision and died for no reason? Or has anyone in your family drowned? If you drown, unless you're drunk, unless you break your neck, if you know how to swim, you have to look at this as an opportunity to do some testing. If you're 25 years old and you drown in a pool, that's not normal unless you don't know how to swim or there's strong waves or current. So instead of just asking about family history, ask about drowning or unprovoked motor vehicle collisions. Paramedics. Paramedics hold the Holy Grail. They hold all the information that when they leave your hospital, you must make sure that you've seen what they leave with. My grandmother had an episode when she fainted while brushing her teeth. I got a call from her caregiver who said, your grandmother has fainted. They're taking her to a hospital nearby. Her heart rate is really slow. And I get to the hospital, and she looks great. I see someone who is one of my residents looking after her. He says, your grandmother looks great. Her blood work's normal. Her troponin is normal. Like I care about troponin. Her ECG is normal. She looks great. She's ready to go home. I said, can I see her rhythm strip? What? You know, the paramedics must have a strip, and I heard my grandmother's heart rate was slow. Do you have that rhythm strip? No. Where are the paramedics? Oh, they're just over there. So when you looked at her strip, she was in complete heart block. She got a pacemaker, and we had her for 10 more years. You can't let EMS leave if they have something on the strip. You know, right before I was giving this talk, I don't know if it's the same for you, but whenever I'm giving a talk, always something cool comes my way. I saw this 80-year-old woman about a few months ago, and the paramedics brought her in, crushing chest pain, high-risk ECG features. They tell me the story. Yeah, we brought her in, she was having significant chest pain, and then we lost her for a little bit, and now she's here. Wait, you lost her for a little bit? What do you mean by that? Oh, well, we don't know. We couldn't really get her pulse, but she's back now. Do you have a strip? No. Was she on the monitor? Yeah. Can we look at the monitor? Huh. She had a run of VTAC. That's a little bit different. We just lost her. So that chest pain with we just lost her now went to the cath lab. It's all about the history, and it's all about getting that strip. If you have a pacemaker, you have it because your heart sucks. You have to realize that you can't blow off people with pacemakers and say, yeah, it's just vasovagal syncope. I know it's a pain in the ass, but if someone has a pacemaker and they syncopize, you need to have that pacemaker interrogated. That's not something that's easy to do at all hours of the night, but you have to assume that people with pacemakers have cardiac syncope and have something wrong with their device. Are there some young doctors in the room? This is a stethoscope. It's like an ultrasound for your ears. It's embarrassing that during COVID, people stopped examining people in Canada. If someone has syncope, you better put that stethoscope on their chest and listen for the murmur of aortic stenosis. Picking that up saves lives. This is the physical exam. Listen to people's hearts. There's not really a role for lab work. Syncope is not like a troponin thing. Yes, if a woman comes to me and says, I've been bleeding for a month and now I syncopized, of course a CBC is relevant. But you're not going to make brilliant diagnoses with labs. You're going to make brilliant diagnosis with your ability to take a history. And I also think it's important to realize that in the setting of you think someone has cardiac syncope, you really have to say, would you want this person driving your kids to school? And do you think this person is safe to be driving? In Canada, if I feel that someone has a seizure or cardiac syncope, we would report them and they would be not able to drive until they've been cleared. That is a safety issue. Okay. I have to talk a little bit about ECGs, but if you were the marketing manager of McDonald's and you were telling people to have Big Mac and fries, you would think that you wouldn't have a rhythm strip that shows some wonky P waves and then a run of non-sustained VTAC. But hey, that's okay. This is WASM, so we're not going to talk about blocks. But if someone comes in with a heart rate of 30, unless they're super fit, you could assume that's the cause of their syncope. Let's go through a handful of cases of ECGs that I think you need to know about. These were two of my idols growing up, Reggie Lewis and Hank Gathers. Both of them died on the basketball courts, and both of them had issues beforehand. Hank Gathers had had a slam dunk and fainted at a basketball game a week before his death. During his death, which was on national TV, he went up and he dunked, he came back on defense, and then you just see Gathers drop without any warning. There was no prodrome. Gathers proceeds to go on to have about 3 or 4 myoclonic jerks, and then he dies. If you saw Gathers in your emergency department a week prior when he fainted, you would have seen this. You would have seen an ECG, and the first thing you would have said to this 18-year-old or 21-year-old gentleman is, he's got, looks like an old inferior lateral MI. He's got some Q waves in 2, 3, AVF, in V5 and V6, and his voltages are up. He probably has LVH. What you have to realize about LVH is LVH doesn't happen overnight. Left ventricular hypertrophy is because of a process such as hypertension or aortic stenosis. If you have someone who has LVH who's not hypertensive, you have to think about why. And in this setting, this is classic for hypertrophic cardiomyopathy. When you see hypertrophic cardiomyopathy, you will see LVH without hypertension, and you will see Q waves, which are not pathological, because pathological Q waves are wide. These are dagger-like Q waves in the inferior lateral leads. This is the #1 cause of sudden cardiac death in sports, and the most inheritable cause of sudden cardiac death, with 1 in 500 worldwide. Don't miss this opportunity. A couple came to see me. They were paddling in our waterfront. Our waterfront doesn't look like yours, and it certainly doesn't look like this. And in the distance, they saw ice cream. So they biked really fast, really fast. The woman in the front, she got off to get ice cream, and then she drops. You don't even need to see her ECG. She has exertional syncope. In your mind, you're done. She's got a problem. She has cardiac syncope. But what she hands you is a great ECG. Now, we always tell our trainees, don't read the stuff up front. In Canada, the EKG comes with an interpretation. Does it come with an interpretation in Turkey? You know, it's often wrong, but what's not wrong is the PR interval, the rate, and the QRS, and the QT. So when you look at syncope patients, check the box. And when you check the box, the first thing you say is, crap, her PR is short. And then you go and you hunt for delta waves. And this is a very classic EKG for WPW. If you look at lead, it's best in lead AVL, you could see that delta wave is that blocking, that obtuse upstroke to get from the isoelectric baseline to the top of the R wave. It's sloped upwards. But even without the ECG, you know her story's bad because she had exertional syncope without a prodrome. You're done. I saw this gentleman, he was 34, kind of went to his family doctor. He was feeling dizzy with some palpitations. He got an EKG. He came to me with a fever, and he wasn't feeling well, and an ECG was done. And the top of our ECG said 2 things. It said, this person is having an acute MI, and it also had my name. So I knew I couldn't fuck up, okay? And I looked at this ECG, and he's a young man, and I said, he's not having a STEMI, he's not even having chest pain. But I looked at his ECG. What do people think about his ECG? Yes, Brugada. So this person has ST elevation in his precordial septal leads in V1 and V2, that's downsloping. I'm going to tell you 2 things about Brugada. 1, in the setting of fever, they are a lot more arrhythmogenic. So this is when people will show up, they'll have a fever, and you'll kind of think there's nothing wrong with them because they have a fever and they don't feel well. They might not even get an ECG, but that's when Brugada comes up. Number 2, If you see this guy tonight while you're on shift in the emergency department, there's a 10% chance, if you don't make this diagnosis, that he's dead before Turkey turns 101 next year on this date. The rate of death in missing Brugada is 10% per year. Don't miss Brugada. Anyone rock climb? Any rock climbers in the room? Not a big rock climbing room in Turkey. This young woman is rock climbing with her partner. She gets up to the top of it's an indoor rock climbing, gets up to the top of the gym, and then you don't even need to see her ECG. Exertional syncope without warning. But she hands you a gift. It's a gift that you will see once in your career. When I saw this, I was so happy for like a year. I looked at this ECG, and the first thing I said is, there's T-wave inversion in V1, V2, V3. I don't think it's a Wellens. She's not having chest pain. She's not having syncope. Does anyone want to hazard what this is? So I looked further, and when you look at her, you can see when you go back. In WPW, it's really hard to get to the top of the mountain from the baseline. She has something called ARVC, arrhythmogenic right ventricular cardiomyopathy, used to be called ARVD. She goes to the top, no problem. She goes down, no problem. But from the nadir of the S wave to the isoelectric baseline, it's blunted. It's kind of like a reverse delta. And in that area, there's a little blip called an epsilon wave. You can kind of see it in V2 here, where up, down, but then it's really hard to get to the baseline. This is ARVC. Again, her story was everything. One more ECG, and then I'm done. Do you guys see old people in the emergency department in Turkey? This woman has come to our emergency department 5 times. She's on an oral anticoagulant and a Pixaban, and every time she comes, she gets a CT head. It's normal, she goes home. CT head, normal, go home. CT head, normal, go home. CT head, normal, go home. I see her on the 5th visit. Every single time, her ECG looks like this. Nothing has changed. And if you read the printout, it says bifascicular block. Okay. You got 3 fascicles. If 2 of them are down and you're 80 years old and you keep fainting, you're screwed up. You have to assume that that has something to do with your fainting. In her case, she has a bifascicular block plus a 1st-degree hemiblock. She has a 1st-degree block. If you have syncope plus a bifascicular block, if you have syncope plus a bifascicular with a 1st-degree block, you and I might have called that a trifascicular back in the day, this person needs a pacemaker or someone to consider that. They don't keep needing CT heads, use your head. They need to see a cardiologist, not a neurosurgeon. If you like to take pictures, take a picture of this. When I see everyone with syncope, I look for 5 things. I look for WPW, I look for ARVC, I look for Brugada, I look for HCM, I look for long QT, and I document it. I go into every ECG looking for those 5 things, and then I move forward. But I know that that's my approach when I see an ECG, but I take value in the story. So what can I tell you to end this morning? History is queen. History is everything. Make sure that you ask people what they were doing before they fainted. The establishment of pre-syncope and the absence of pre-syncope should always make you nervous. These people don't need workups, they need you to take a great history and to take an ECG and look for 5 things. The EKGs are gravy. They're a gift. Just know how to look at them. Thank you very much for your time.
We'll take questions at the end.
As Dr. Carr said, we're going to hold the questions till the end because we're a little bit behind schedule. Our next speaker is going to be Dr. Lucas Sarspak. If I pronounced your name incorrectly, I apologize. I did good? Okay. All right. Professor Dr. Sarspak is going to speak to us about manual CPR versus automatic or automated chest compression device. Something very common to everybody's emergency department is this question. Thank you so much, Dr. Sarspak.
Thank you for introduction. It was nearly correct, Sharpak. I'm, as you see, director of the clinical research and development at the LuxMed Group in Poland, but I'm also president of Polish Society of Disaster Medicine. I will talk to you about the automated or mechanical chest compression devices. We know those devices from many years, but the same as during my previous speech for focusing on epinephrine. We have many studies, but with those studies we have much more questions, and this is problematic. So I will start. Of course, we know that according to American Heart Association, as well as the European Resuscitation Council guidelines, the most important thing during resuscitation is high-quality chest compression. High-quality chest compression composed of the correctly rate of chest compression, correctly deep, full recoil of the compression, but we know that in some cases it's difficult to obtain. And I will back to those situations in the next slides. Of course, currently we have many types of mechanical chest compression devices. We know that we use it in pre-hospital as well in hospital cardiac arrest situation, but the use of mechanical chest compression increased during the COVID-19 pandemic, mostly, for example, in Poland, from my experience, because the pandemic showed us that we have increasing number of the cardiac arrest situation, and different studies show us that, for example, when we know the outcomes of mortality of those patients, 85% of patients died compared to the only 62 in the pre-pandemic setting. So we know that this is most important thing. And when we're talking about those devices, we can talk about each device and we can show some advantages and disadvantages of each device, and I will show you some perspective of these devices. And of course, all of us know the Lucas. Lucas right now has third generation of this device. It's, I suppose, the best recognizable mechanical chest compression device worldwide. The most of studies are focusing to this fact on Lucas. So we have some research background of those devices. We know that this is a piston device. It's commonly used, for example, in the EMS in which I'm working. I'm in the EMS in Warsaw. This is the biggest EMS dispatcher in Poland. We have right now 88 ambulances in our region. About 60% of devices which we have in ambulances are Lucas device. So, as I say, Lucas device in Poland is mostly commonly used, and I suppose in other countries also. What is important, Lucas device we can use only on the adults. It's contraindicated in very obese patients as well as in the pregnant patient. The philosophy of this device is to create the active decompression suction on upstroke, and it's important for this device. The second device is, for example, Zoll. I saw this device also in this area, and this is nice device, but I personally don't use it because, as you know, Lucas is much more better, mostly for me. But of course, we have Zoll device, so Zoll Autopulse device is low distributing compression band to compress the chest, and it can be used only under patients under 130 kilograms. It can be used only on adult patients and can be used only on non-traumatic cardiac arrest, because when we have the problems with the chest, it will be problematic to use this device. When we're talking about other devices, one of the nearest and new device is Corpus CPR device, and this is nice device because we can change many things on it. We can use it even in adolescents, in adult patients. We can change the depth of compression, we can change the rate of compression, so it's nice for us to change the quality of compression of these patients. However, as you see on this slide, I know that maybe it's not good quality, but it shows us the most significantly research focusing on the chest compression devices. And when we talk about it, one of the important study was the CIRC trial published in 2014 in resuscitation. This was randomized control group sequential trial focusing on the adult out-of-hospital cardiac arrest, where the presumed cardiac origin of the cardiac arrest, and it was conducted in the US and in the European. In this study, authors compared the autopulse and manual chest compression. They create some outcomes such as survival to hospital discharge, and in this study they don't show significant difference between autopulse and manual chest compression. This is important for us because, firstly, the chest compression is important, as I talked previously, but when we perform such a study, we should focus also on some criticism of those studies, because majority of patients were excluded in this analysis, excluded post-random for various reasons. Bleeding was not, for example, possible due to the blinding of the study was not possible during this study due to the intervention type. But for example, 20 minutes CPR fraction was higher for the manual chest compression. And this is possible, we can explain this by the Hawthorne effect. Maybe you know this effect because the Hawthorne effect occurs when the participants' behavior, when they are observed, because when you are observed, your behaviors are changing. When someone observes you during resuscitation, you perform this resuscitation much more better, you perform higher quality chest compression. So when we compare on the one side the manual chest compression, on the other side mechanical chest compression, and this is observational study, we probably will perform much more better manual version of chest compression. Moreover, this study was not powered for a long-term period outcome, because such as, for example, 6 months survival rate or 6 months survival rate with the good neurological outcome. We only in this study, they only saw the short periods. However, in this short period, the difference between those techniques of chest compression, as I say, was not statistically significant. The second study is the LINK trial, published in the same year. I'm in the 214, this time in JAMA. This was also a randomized trial, this time involving 4 Swedish, 1 British and 1 Dutch ambulance service. In this study, they involve only out-of-hospital cardiac arrest. However, the previous study was focused on autopulse. This study was focused on Lucas, and I suppose it was a huge group because to the arm in which the patients were treated with the Lucas, they involved 103,000 patients. Near the same number was put it to the manual chest compression group. The problematic of this study is fact that they, as a primary outcome, focus on 4-hour survival rate, and this is not oriented of the patient outcome. However, the differences between those groups were similar because it was 23.6 for Lucas and 23.7 for manual chest compression. So the risk difference was over than 0.99. So it was really similar. Besides, no difference in the secondary outcomes. I mean, the good neurological recovery was also found between those groups. As I say, the primary outcome was 4-hour survival rate, and it was not patient-oriented outcome. Moreover, among patients with surviving at 6 months, 99% in the mechanical chest compression group, I mean in the Lucas group, and 94 in the manual chest compression group had the scores of CPC at the level 1 or 2. However, the 4-hour survival rate was not difference between those groups. The next study on which I want to talk about is paramedic trial, paramedic 1, the first one study, because as you know we have two studies, paramedic 1 and paramedic 2, and this study was conducted in UK in NHS ambulance service. Also focus on the out-of-hospital cardiac arrest. This time evaluate the chest compression techniques in 2 groups, in Lucas and manual chest compression. The randomized was 1:2. So in the Lucas group, they involve 1,652 patients, and in manual 2,819 patients. And this was randomized according to the first trial vehicle to arrive on the scene. However, when we're talking about, one more time, about the outcomes, the primary outcome in this study, which was the survival to 1 month, was 6% in the Lucas 2 and 7 in the manual chest compression. No serious adverse events was noted, and this is also important because one of point in which we in studies is the fact that mechanical chest compressions occur much more chest compression chest injuries. However, in this study, intervention to treat analysis was used, and this is problematic because, for example, when we see only in 60% patients in the Lucas group received formally mechanical chest compression. So if they will do, for example, not only intention to treat, but per protocol analysis, it will be much more better for this study. However, as I say, there was not any serious adverse events during chest compression with Lucas. with manual chest compression the same, and the survival in those studies was similar in both cases. When we're talking about the guidelines, because when we have the guidelines, we have, as I say, American Heart Association guidelines, we have European resuscitation guidelines, we have ILCOR about that. The current research does not support to mention the mechanical chest compression devices, I mean the mechanical pistol devices or load band distribution devices. They don't offer any advantages to manual chest compression in patients experiencing cardiac arrest. The current standard of care for management of cardiac arrest is still high quality manual chest compression, so we should obtain some extra trainings. According to the guidelines, every 3 months we should perform simulation trials on the chest compression. However, mechanical piston devices can be considered in some kind of situation, and for example, such scenarios can be limited to include the limited space for rescuers, incidences of prolonged cardiopulmonary resuscitation, hypothermic cardiac arrest, CPR in the moving ambulances, CPR when we prepare the patient to the angiography or preparation to the ECPR. So in those situations, we should use high quality chest compression performed by mechanical chest compression. However, in the crucial for rescuer is to minimizing the interruptions in the CPR, so it's not depend if we use mechanical chest compression or manual chest compression. We should previously train it to minimize this interruption and perform as high quality chest compression as we can. I want to talk to you about also some meta-analyses, because as you know, meta-analyses are one of the most important type of studies which we focusing. And for example, in this meta-analysis performed by ZOO, they include 15 trials, 9 randomized controlled trials and 6 cohort studies. The results of this meta-analysis showed there was no significant difference in the resuscitation effect of the mechanical and manual chest compression. In terms of the return of spontaneous circulation, survival to hospital admission, survival to hospital discharge, and survival to hospital discharge with good neurological outcome. This study focusing, of course, on the out-of-hospital cardiac arrest patients. The next one study in this study, for survival to hospital admission, the pool estimate of the randomized control trials did not indicate a difference between mechanical and manual chest compression. However, when we see the subgroup of non-randomized control trials, the difference was statistically different, and manual chest compression performed much more better survival rate. So, possible we can also talked in this space about Hofstrom effect. Survival to hospital discharge outcome did not differ between those strategies when we summarize all RCTs and non-RCTs trials. And this is also important for us. What the next? When we talking about the consideration of safety context,
allow me to act very quickly and shorten the amount of time that the patient is in the ED, and also make my decision about whether I'm going to be able to fix them and get them out of the ED, or whether they may need to be admitted. And again, hyperkalemia, I'm looking at that abnormal EKG. I'm thinking about that in patients who have who take ACE inhibitors, who I think have a heat-related illness or on dialysis, and certainly it could be a new diagnosis of Addison's disease. The ED troponin, again, you had a lot of discussion about that. I'm not going to belabor it, but patients with an MI, of course, can have a normal EKG. And what does a positive test mean? Again, you as a physician understand better than a nurse practitioner or a PA that it's not only an acute MI, but they could have recently had an MI, recently been cardioverted. Some troponins are not reliable in renal failure, but an elevated troponin can allow you to make a quick decision for admission, to call the admitting team even before all your other tests are back, to give them a heads up this patient's going to need to come in. The blood gas, that assists in choosing an oxygen delivery system. Are you going to give oxygen? And if so, how are you going to deliver it based on the results of your ABG and whether your oxygen delivery system is working or not by following a repeat ABG. It makes the decision for intubation or hospitalization. Hypoxia can explain altered mental status, and you quickly are able to assess your acid-base status, aiding your diagnosis in cases like hyperglycemia. And we absolutely cannot ignore the POGIS. Point of care ultrasound is just amazing. In the years since I graduated from my residency in 2004, in the past 20 years, it is shocking how much we can do with ultrasound. That long list of things that we can do immediately, a point of care ultrasound to tell whether a patient needs to be admitted or not, right? I mean, you can tell if a patient has hydronephrosis and renal stone that's impacted and that's too large to pass, that they're not going to be able to go home. You know that a patient with ascending cholangitis is not going to be able to go home. You know that the patient on DVT needs anticoagulation. So we can make so many diagnoses. Who needs to go to the OR? Who needs to be admitted? Who can be treated and go home just by using point of care ultrasound? There are other tests that I haven't discussed. The most common that are used are the fecal occult blood, COVID-19, influenza, which I referred to in my patient, my 16-year-old, the rapid strep. We can do rapid HIVs in the emergency department and rapid CDCs. There are new things on the horizon, and most of them do have to do with viruses. So keep your eyes open and think about the point of care tests that may be coming to the emergency department near you. Most of them will be for other SARS and COVID type viral assays using a lot of different recently discovered methods such as isothermal amplification or the CRISPR-Cas9 genome amplification. So this stands for clustered regularly interspaced short palindromic repeats. And as a female physician, I am proud to say that Doctors Jennifer Duda and Dr. Emmanuel Charpentier won the Nobel Prize, I believe it was 2020 or 2021, for the development of CRISPR. And using CRISPR technology, our colleagues in the lab, our PhD colleagues, are actually able to snip a lot of the fragments out of DNA to modify them so that a very quick PCR can be developed. A PCR can literally be developed within 24 hours to test a new variant of SARS-CoV-2 or many other genomic variants and mutations that occur in commonly seen viruses. CRISPR also has some gene amplification implications that can be used for genetic testing and genetic modification. But for us in the emergency department, what CRISPR-Cas9 does for us is it allows rapid PCR assays to be developed in it as quickly as 24 hours to test for new variants like your Delta COVID and other variants. So keep an eye out for that. You're going to be seeing a lot of that. It's exciting and amazing that this is happening in our lifetime. So your take-home points. Many of the problems that are plaguing emergency departments today result from improper patient management. The clinical assessment of a skilled emergency emergency physician will lead to the appropriate ordering of point-of-care tests. And sometimes a few point-of-care tests can actually combine results to make your diagnosis. The point-of-care results will guide the cost-effective ordering of further and appropriate tests, guide us through the diagnostic decision tree, and ultimately lead to an appropriate and timely disposition for your patient. So the protocol is your clinical assessment cues you to what point-of-care testing you need to do. The results of the point-of-care testing lead you to a focused treatment and further testing, and all of this amounts to the efficient, cost-effective, and time-saving care of every patient who comes to the emergency department. So thank you for your time. I'm sorry that our session ran over. We took some time away from your coffee break, but I hope that you learned from our session. Feel free to get in touch with me at drmoreno@gmail.com, or to just grab me when you see me at the conference for any questions about my talks or about the American Academy of Emergency Medicine. And thank you again for inviting me here to Turkey. I love your country. I'm thrilled to be here on the 100th anniversary of your independence. Thank you.
I know we've gone a little over. I think what might make sense is if you have questions to come up and maybe ask the speakers, because I know there's a break that is almost on the way out. So maybe get your coffee and get ready for a great afternoon, and I'm sure Ajay or Lucas or Lisa or I would be happy to take your questions up at the podium. Thank you so much.
Score at triage. And most of our staff would prefer to have some sort of electronic flag in the system. Most staff would prefer that triage be the site that we identify when a patient's going to become agitated. But we do think that when we're sort of identifying who's going to be agitated, it's not just about their agitation at that moment and doing a score in that moment, but really looking at historical factors and looking at their baseline issues. And so we're really looking at the scope of who exactly do we want to flag as potentially going to become agitated during their care. Most of our staff would like to use some validated agitation score, not only to identify, but then to sort of track them and monitor them throughout the stay. The same way that your pain scale can change over the course of your care, so your agitation level can change over time. Right now we have a lot of informal practices of how we're flagging patients. So a lot of it is just word of mouth on rounds. I'll kind of point to the patient and just let my colleague know, oh, by the way, this patient has been getting agitated, or in the past I treated him a week ago and they threatened me. So it's just been a lot of kind of word of mouth. Sometimes we'll write little progress notes, but that's very difficult because then we have to kind of comb through our electronic charts to find previous event notes. And so most of our staff would like some sort of a flag on our electronic medical record. Can I just see a show of hands, just because you guys I think are a little bit more ahead of us in starting this. Do you guys have electronic flags that exist so when you open a patient's chart it's very clear? And then do you guys have things like when you go to a patient room the same way you would have for a fall risk, where they'd have a wristband or a note on the outside the door so that anybody entering or interacting with that patient is aware? I see a couple of nods. And then a question of, you know, once they're flagged, does that flag carry on? How long does it carry on for? And how are we managing all these patients? So for us, if somebody comes in and states they have suicidality, you know, there's a very, very set process we do. If somebody says they're thinking about hurting themselves, no matter what the patient is, no matter anything else, there's a set of standards that we follow. And so we're discussing for people who have been screened or flagged as potentially violent, do we want to manage them all the same, or do we want to manage it case by case, and how are we kind of deciding that? And then we asked them sort of which types of management options would you guys like, as far as doing environmental precautions like, undressing them, removing all personal belongings, looking, having specific rooms that don't have things that can be thrown around, that type of thing. So what sort of environmental things can we do to make caring for that patient and the environment more safe? How often should we be assessing their agitation? And then based on their score, what actions should we be taking? So this was brief, and again, part of my reason for wanting to present this is that I understand that you guys are actually much further ahead of us, and so I can't stress enough that I would love to get feedback from you guys just as you see me in the conference, because I am in the process of creating this policy with my team for both our outpatient and inpatient departments, and I'd love to hear kind of what you've seen work, what doesn't work, and again, each area within the healthcare sector is so different, and so I primarily work in the ER, so it's harder for me to help develop policies in areas that I don't normally work in, such as the inpatient care or the clinics or pharmacy or other outpatient services. But that's kind of where the US is. We're a little bit more behind just developing active shooter trainings and really finally putting the burden on healthcare administration to start factoring in workplace violence into the policies so that our staff doesn't have to feel that it's normal to be threatened at work. Our staff shouldn't feel that it's normal to feel unsafe ever. And just to understand that our administration is sort of taking protective measures. And then the other part is just that our other patients often feel unsafe when they're seeing our staff get yelled at, even if they're not part of it. Just being in that, you're in a place of care, and to see that type of workplace violence happening on a daily basis is really going to be the opposite of providing good care. So thank you so much. I really appreciate you guys listening. And again, I know we have no time for questions, but more than questions, I would love to hear you guys' comments after this.
Thank you. Thank you, Dr. Pia. It was a lovely presentation. And due to keep our time, I think if there's any available time later, we will take the question. By the way, I need to talk now because my presentation is the return of landslide, Die Another Day, and my name is Muhammad Alwi Abdul Rahman from Malaysia. I'm the emergency physician. So I'm here. Okay, ladies and gentlemen, my presentation is going to be about landslide. Malaysia is part of Southeast Asia, and we have lots of natural disaster. 50% of all disaster that happens in Malaysia, Indonesia, Philippines, and other of our ASEAN counterparts. According to WHO, between 1998 to 2017, they estimated about 18,000 deaths related to landslide. Well, we have cyclones, typhoons, and everything, and we have to blame it all to the change of climate, rising temperatures and waters, and of course, migration, populations, industry, urbanization, and etc. In Malaysia, there has been landslide, more than about 29 incidents dated back 1961. So landslide, beside flood, which is very common in Malaysia, we go through a lot of incidents, and that includes also the aftershock from the earthquake from Indonesia. This is the location in the capital of Malaysia, and it is about 1 kilometer, it's about 2 kilometers from my hospitals, and it is a well-established area, but there's a lot of landscape there for picnics and camping. So what happened is during this incident, on the 16th of December 2002, my hospital was the responding hospitals, and we received information from the residents that there's a landslide and at 2 o'clock morning, so we have to send the first responder team to the site to do what is best in a remote area which is full of forests, as well as the routes and the communication at that area is very poor, and it's heavy rain later after the incidents. It involved a lot of mass volume of debris, sands, etc., the trees, which covers almost about 500 meters. And the whole cascade of events is very unfortunate, as people and children and teachers were doing picnic and they were sleeping. And most of them submerged to the debris of the soil, and they never had an early warning system to evacuate. Now, the moral of the story is this is an illegal landslide camping because it is free of charge, and is the scenarios there, the landscape there is fantastic. So this is what exactly happened. The first primary incident and the secondary incident. And it happened between the first and second incidents about gaps of 20 to 30 minutes. That is the first landslide where the camping was submerged by the debris, by the trees and sand, and subsequently the next one which sweep. You can see far right there is a car park and etc., and every of these things are involved. So I just want to share what exactly happened at that particular time. So I want to go in deep about the video you've seen before and after of the landslide and the impact towards the population or the tourists that having camping in that area. So this is the outcome of the incident itself. 37 dead bodies. Of course, there were almost about 92 people at the site camping overnight for the next few days. Beautiful landscape and good views. And when it happens, they were sleeping and they didn't have the early warning system, and they have to, in the remote night, they have to run for their life. And 31 dead, out of which children about 12, and including a baby. So what was the lesson learned from here is in a resource poor environment at that time, in a remote area, we need to do the best to save life. So we need to deploy a lot of technical teams, tracker dogs, search and rescue team, excavators, as well as ground penetrating radar to do the search and rescue. Malaysia have the INSARAG team, search and rescue team, and they were deployed within the first 2 hours after the call, after the incident, and it was scaled up accordingly. Thank God it happened in the urban area where everything was next to the services were in place, and of course we responded in a typical pitch dark night. The incident command was difficult because it's a remote area. Accessibility is very poor. Climate was not good. Heavy rain, and we are working in an area that we are not trained as part of the medical team. That is the hospital that is responding at the emergency department. So it is the issues of triage. How do you want to triage 96 people, say, at the pitch of the night time, where there is a remote area? You have to go deep into the forest and with improper lighting at the initial stage, because the first responders at all organizations in Malaysia, even though they are equipped, but it is not prepared for such a extraordinary moment. So triage was very difficult, very situational. It has to be facilitated, and those who can run the green cases, we remove them and send it to the nearest police stations, where that was the only place, shelter, that we have to do the assessment and do the triage and retriage part of the casualties. We have polytrauma cases, and we treated at the incident site. We established the incident command post. We established the zoning of the system with the help of the police as well as the fire service, and all the hospitals at that moment were activated to receive cases according to the specialties of that hospitals. The chronology of event, of course, it went from day, night, and 2 days to more than 10 days. So we developed the critical incident stress among the rescuers. It disrupted the routines. We have to bring in more team. There are almost about 650 staffs on the ground zero, and first responders beginning to show sign of fatigue, sign of tiredness, and most of them never took their medicine. So an establishment, observation base, zoning was done, triage was continuous, and then we had a lot of communication between the hospitals, and we have to address the surge capacity, particularly to staff, space, systems, as well as supply. And then in a remote area with the weather disturbing you all the time, you need to do something. And of course, the SAR search and rescue team accommodated. And we also, as more teams come, burnout, etc., we have to replace not only staff, also the animals, the dogs and everything, because they were doing 24-hour search and rescue capabilities and capacity at that time. And we have to do the public health preventions, and we managed to screen them and then give them prophylaxis for malaria as well as leptospirosis. And then we have to handle the fatalities, the dead bodies, and how do you want to store them, evacuate them, body identification, recovery and disposal in a remote area was difficult, and the final fatality of that moment was about 92 total casualties, and a lot of survivors among them, family and friends, and we need to handle the dead. In most of the mortuaries were occupied, and then we had a lot of media interest, a lot of challenges, and related to capacity, capability, terrains. We had multi-agency coordination meeting. We have to work in a remote, confined area, in a wilderness medicine, and we have to go through the experience with the flood, and there is a lot of challenges at that time, communications within inter-agencies and as a partnership. And we had few pitfalls, we had difficult challenges in communication, both inter and intra-communication, accessibilities of big, large trucks, both military and non-military, ambulance. We're working in unpredictable nature of the site with wild animals, dogs and etc., that we have to be very careful, insects too, and of course with storage, logistic, supply chain management disturbed, and poor network. Ladies and gentlemen, that is the Malaysian experience on natural disaster, and now currently we are preparing for massive flood. With that, thank you very much.
Thank you very much, Doctor, for this very interesting talk, and we give the microphone to the next speaker, Karen Koenig.
Thank you, Lucas. Thank you, Dr. Mohammed. Today is our National Day, and I would like to commemorate and congratulate the 100th anniversary of our Republic of Turkey. I commemorate the founding father of this Republic, Mustafa Kemal, and his companions. And I hope this sovereign nation serves as an inspiration for next generations and other nations, oppressed nations like Palestine and other nations, exploited nations in different parts of the world. And I would like to give my condolences to whom lost their lives in Kahramanmaraş earthquakes, and the recent hostilities in Gaza Strip, and it is really sad to witness human rights violations, international humanitarian law violations, and war rules violations in Gaza Strip, to see bombed hospitals, killed medics and civilians, and the hostilities, disproportionality of the hostilities. I would like to present a case study regarding our last big disaster catastrophe we faced in Kahramanmaraş, damage and disaster response to earthquakes in Kahramanmaraş. Before starting my presentation, I would like to emphasize our discipline is disaster medicine, bridging disciplines. Disaster medicine is a scientific discipline resulting from the joint venture of emergency medicine and disaster management. So we have many nexuses with other disciplines like emergency medical services, hospital services, public health especially, and disaster management. You can see all these topics, and disaster medicine is interesting all those topics during the disaster or before disaster for preparation or after disaster for recovery. In Turkey, we have a well-established disaster management framework. We have a disaster management strategy framework at the strategic level. AFAD, Civil Defense Authority, Disaster Authority, also in charge of this strategy making processes. At the tactical level, we have three different plans: disaster risk reduction plan and country disaster response plan, and the recovery plan, who are covering all phases of the disaster life cycle. And we have many action plans between the operational layer and the tactical layer, and provincial base, we have disaster risk reduction plans and response plans, not the recovery plans yet, but we will have. What about the health cluster? We have harmony in chaos. In our health cluster coordination, we have SACOM, Healthcare Coordination Command and Coordination Center in Ministry of Health in the Ankara headquarters. So under the SACOM, we have provincial level SACOMs, command and control centers, and we have rural mobile health teams, emergency service at the scan. We have teams, we have EMT 1, 2, 3 types of mobile hospitals, field health screenings, mobile healthcare services, emergency response units, ERUs, disaster camp family medicine units, many services during the disaster our system is providing. At the field level, we have a call center who are recording all calls and orchestrating operations among other institutions like security forces, like army, like other ministries and civil societies and national societies like Kızılay, Turkish Red Crescent Society. As my colleague Feridun mentioned, that we are living on a very active earthquake fault. So this is our earthquake hazard map of the Turkey is updated, and you can see the danger map, the hazard map of Turkey. So we need to change our mindset for urbanization and the settlement. So because of many neglection, we faced this big size catastrophe. So it was not usual earthquakes. On the same day, we faced 3 great earthquakes with magnitudes of 7.7, 7.6, and 6.5. So after those big size earthquakes, 50,000 aftershocks have been occurred, and if we compare with other earthquakes or the man-made disasters like Hiroshima, this was 2,000 times bigger than the Hiroshima in Kahramanmaraş. So after adding numbers, death toll reached 60,000, including the casualties inside Syria. So we have been shaken by same tremor. You can see on the map from Lebanon, from Egypt to Syria, from Iraq to some Caucasian part of the world. So almost 60,000 people lost their lives, and 122,000 people injured, and almost in Turkey, almost 1 million independent units demolished or heavily damaged after this earthquake, and estimation of the damage almost more than 100 billion US dollars in Turkey and 15 billion US dollars in Syria. As for the magnitude, yes, we can compare with others, but because of the fault lengths and the depths and the habits of the earthquake, the damage bigger than other same earthquakes. So the total fault length was 500 kilometers, and it was just 7 kilometers close to surface. So it created a huge damage and destruction. So we can compare the total affected areas, 11 provinces, with other countries. This area bigger than many countries. If you compare the population, this population is higher than many countries. So it was really difficult to manage all this catastrophe and the chaos during the disaster. So many personnel and staff from different institutions deployed to the affected areas, and almost 650,000 staff have been worked so far in affected area. And we have unsung heroes, volunteers, and civil society organizations, and our colleagues coming from abroad to solidarity with our nation, and almost 10,000 international search and rescue staff, and from 90 different countries. And we have our volunteers, AFAD volunteers, Turkish Red Crescent volunteers, and other national non-governmental organizations volunteers worked in the first phase for the response and the recovery phase for the disasters. You can see the map, our international solidarity map. Thanks all of the colleagues who came to Turkey and bestowed their hands to affected population. If we look facts and figures for navigating disasters, you can see huge heavy machinery fellows and the teams. Just for the sample, medical evacuations, personnel transport, material transport, and firefighting activities have been conducted by aircraft, and almost 17,000 sorties did the aircrafts. It was really tough issue and a tough duty for the Turkish Red Crescent Society that I was leading as a president, and it was the mass feeding duty. So almost 14 million people have been affected, and by the time being, for at least 4 months, Turkish Red Crescent Society and its nutrition platform members provided 500 million hot meal so far, and at the peak time, daily 2.5 million affected people received hot meal and 3 meals a day from Kızılay and the feeding platform. As for shelter, so far almost 900,000 tents set up at the field, many of them dispatched to the villages and the rural areas, but we set up 350 disaster camps, and 2.5 million people also took shelter in those camps. Immediately they moved on to the from the tents to the container style housing facilities. Almost 200,000 container house have been installed so far, and now many of them living in the good, better conditions if you compare with the tents. What about the health infrastructure? Actually, in this area, we have 11 provinces in 100,000 square kilometer area, 124 hospitals, 13 of them damaged severely, and 14 moderately, and 75 minor, and 84 private hospitals and primary health care facilities, more than 2,000. Yes, we could manage, but in collaboration with the other provinces, neighboring provinces, healthcare staff, because all our colleagues who were living in the affected areas became the victim of the disaster. So they lost their loved ones, they lost their siblings or houses, so they need to get support abroad and neighboring provinces, and the total population in those areas, as I mentioned, 14 million. As an operational overview, so I selected 4 provinces, mostly affected provinces in the disaster. Arrival time of the first UMKE, our medical rescue team, from outside the province, 7:15. So arrival time of the first ambulance from outside the province, 7:15 as well. This day was the coldest day of the year, minus 20 degrees. So heavy snow blocked many roads. The frozen roads and broken roads and bridges closed many highways. It was really difficult to reach affected population, affected areas from neighboring provinces, and it took time to receive search and rescue services abroad or neighboring provinces, so hours and days. So because of this period, we lost many lives, unfortunately. Many UMKE vehicles, air ambulances and land ambulances, and UMKE teams, 15,000 UMKE and emergency health personnel also worked in the area, and the transportation of the patients, almost 2,500 of them transport by the plane, and 50,000 of them by the ambulances, and more than 300 by the maritime. After 2 months, you can see the occupancy rate of the active ward beds and the ICU beds. So 200,000 surgical operations have been done by the colleagues, and more than 4,000 intensive care cases, 600,000 discharged, and after 2 months, still 400,000 inpatients were exist in the wards. According to the experts of the mental health, almost 1 million people, victims, need emergency psychosocial support during the disaster. So you can see the activities of the Minister of Health, psychiatrists, psychologists, and Minister of Family in charge of psychosocial support, and Turkish Red Crescent Society and other NGOs as a member of this platform provided 2.5 million PSS sessions to the affected community. As for the water, sanitation and hygiene, all infrastructure, all utility infrastructure have been affected. Water pipes, water reservoirs, water and wastewater treatment plants, pumping stations, and all infrastructure have been damaged, and it was really difficult to provide drinkable water to 14 million people daily, and we did it, thanks God, alhamdulillah, in collaboration with the private sector and other water directorates of the municipalities and the civil society organizations and the individuals. They carried the bottles of the waters to the affected people, and we didn't see any outbreaks and infection diseases, waterborne diseases during the disaster. So almost 19,000 mobile toilets have been established, and 10,000 mobile shower and the washing machines have been established in affected areas. Another issue, another challenge for the system is managing the logistics. And supply chain have been broken, then it is really difficult to create a new value chain for a healthcare supply chain and nutrition supply chain and other basic humanitarian needs, non-food items and food items supply chain system during these bad conditions. But as having an agile system is important during these disaster times, and health logistics continue to serve the hospitals and small clinics everywhere. Thanks for civil society organizations and our disaster partners all over the world, like Brother Mohammed from the Malaysia Red Crescent Society. He is in charge of disaster department, our colleague, and they bestow their hands to Turkey and Syria as well. And you can see on the screen, and the many NGOs, International Red Cross and Red Crescent Movement, and UN agencies who implement their projects and activities in the affected areas. I thank you very much.
Thank you for the speech. I think you and your country faced the disaster, but I suppose the next step will be face the PTSD among survivors and all rescue staff. So it will be also problematic for the medical staff. Do you have any questions to our lecturers? Anyone? I know that you are tired and you want to go to lunch, but maybe I have a question, and maybe this question will go to the Dr. Mustafa, because you talked about that preparing to disaster, and I have a question from the education field, because we know that we can train disaster medicine, emergency medicine, but when we're talking about disaster medicine, I'm curious when we should perform such as trainings in the undergraduate or postgraduate level, and with what frequency we should do it. Do you have microphone?
Sure. Could you get closer to the microphone? I need to repeat again, please, your question. I can't hear you.
Okay, so I have a question. Should we train disaster medicine in the undergraduate or postgraduate education level? I mean that during them, for example, medical studies, or when someone finalizes her medical studies and it's physician. So at which level we should train disaster medicine according to your knowledge and your experience?
Thank you. It's a very important point. I heard that maybe Pierre knows better than me. In the U.S., is disaster medicine is again a subspecialty in the emergency medicine. It must be, because the future, there's lots of disaster waiting for us. And the overwhelming of the emergency medicine is only handle these type of problems. Briefly, disaster medicine should be subspecialty for the emergency medicine. I believe that.
Mm-hmm. And with what frequency we should return the courses, for example? Because according to, for example, resuscitation, we know that every, for example, 3 months we should go to the simulation center and train the chest compression. But I know that disaster medicine is totally different, and in which frequency, 1 per year or 2 per year, you should think those courses, those trainings should be continue?
I think that only the course is not enough for the handling this issue. As you see, that's on the picture, is wars and lots of problems waiting for us. At least 2 years subspecialty training, because in the scene, in the collapsed building, for example, when we're talking about the earthquakes, we should get close. And nobody can do the emergency physician's capacity, pseudoanaesthesia, for example, and also nerve blocks. As I mentioned during my presentation, you are talking with the victims of the earthquake, still alive but trapped. Maybe needs 1 week to take it out to all the collapsed building. You need to pull out this patient as much as you can, and you need to give IV infusion, pseudoanaesthetic medications, nerve blocks, and amputation. I saw that even in the orthopedic surgeon. I have respect for the other specialties, but they hesitate to do this. You know, these are not looks like an operating theater conditions. Everywhere, dust everywhere. Full of the dirty waters, green waters, dark waters, totally collapsed building. It's a very interesting issue. And there's a lot of challenging also waiting for us, and we should need at least 2 years subspecial training. It's not only handling with the courses, I believe that.
Okay, thank you so much.
You're welcome.
Yeah, Dr. Karim, you want to say something, yeah? I have a question for you also at the same time. I want to ask you, Dr. Karim, what was your challenges for coordination with the foreign medical team or foreign search and rescue team that was deployed during the Turkey earthquake? Thank you.
Thank you, Mohammed. As for echo to Feridun, I would like to answer Lucas' question. I'm head of disaster medicine department in Health Science University, and I'm head of emergency aid and disaster management program. So we have a disaster medicine course at the last class of our undergraduate. Frequency once in a year, but we have the PhD program in the same time for the post-graduation. And there is still debate, disaster medicine belonging to whom. So disaster medicine as a multidisciplinary area, we have connection, very strong connection with emergency medicine, public health and military medicine, and the disaster management as well. So we have to keep this multidimensional focus. Otherwise, we can lose some skills. So, as for my knowledge and experience, we have to give an introduction to the emergency medicine residents and the students in the Faculty of Medicine, not only medicine, but all health-related also programs in the faculties, but well-established curriculum for the disaster medicine must be at the last classes, and we have to identify certain skill sets for the curriculum, especially for the medical leadership or leadership during the disasters, and team collaboration, and ethics, and prioritization of the cases. Many issues we have to deal with. So we need a certain experience and the skills. So the late classes and for the no doubt for the post graduation as well. As for your question, Mohammed, it was really difficult. So 10,000 search and rescue staff in the same days, within 3 days, from land, Iran or Iraq or Caucasia or the Western Europe part, or by plane, by ship. So we received then all of our colleagues in our accommodation areas. We recorded them, and according to our national disaster response plan, AFAD identified the gaps in terms of the search and rescue teams. So they dispatched all our colleagues. Turkish Red Crescent Society deal with the Red Cross and Red Crescent partners, and AFAD, Turkish Disaster Authority, deal with the states and the official departments, and we, as well as we try to manage the NGOs, and UN immediately set up the OCHA office in Turkey. Then OCHA set up their clusters. Then each leading agency of the clusters lead their own clusters from the UN agencies. So well organized, and it was difficult, but I believe we did it. Thank you.
Excellent. I think part of the Malaysian search and rescue team were there, and we were also coordinating well, and as well as the Malaysian Red Crescent Society. Now, thank you, sir. I'd like to ask Dr. Pia. I know active shooting incident, it is not as easy as we think, because you need to act and react on care under fire. So in the context of your presentation just now, what is the preparedness level of tertiary hospitals that you have, and how was your tactical medical team responded to such an event? Thank you.
So we have been going and we've created a system where we approach each department, and we bring our university police, our hospital security with us. And our goal is that all of our staff are trained and practice on responding to an active shooter event. So we actually do real life simulations about once a month in different units. We train our staff in their area, and that's really the key part, is to go to their unit, show them which is the area that they would need to hide, which area, if they hide, they'll actually protect from bullets, versus just being concealed where they can't see you. And then we actually do disarming training. So we will have somebody come in with a fake gun, and we will train sort of people without any sort of military or fighting skills, the simple way that anybody can disarm anybody. And there's a couple of simple steps, and we'll usually take somebody kind of, on the smaller side like me, and we'll have the person who is going to be carrying the weapon be somebody physically larger, just to show that it's not about how strong you are, but certain techniques develop. So about once a month, we do different units, and we actually make sure our staff practice hiding and actually disarming an active shooter, so that they at least have the tools in their muscle memory of how to do it. And the idea is that we hit each unit, each staff once a year. That's the training program we developed. We started it last year, and so far it's been really well received. And it's also a skill, it's a life skill that our staff then takes into their daily lives, because these skills, they could be applied anywhere, even outside a hospital.
Thank you so much. If there is no any question, oh, I'm sorry, there is one.
I have two questions, one for Dr. Mustafa Çelikmen. We know you're very active internationally, and thank you for your effort in earthquakes. I wonder if you think it would be beneficial, or it would be efficient to add disaster medicine knowledge to the curriculums, to medical curriculums actually. Thank you. Here I.
Thank you very much. This is a very important point. Definitely, disaster medicine, especially the developing countries, that they are living under, like us, disaster every landslides, earthquakes, floods. 2023 years, we saw all of them. We should get prepared, especially the healthcare workers, medical doctors, paramedics, nurses, they should get prepared. They get ready for this type of problems. Otherwise, after that, I mean, we should get ready for the risk management instead of crisis management. After the crisis happened, we are losing the game. But if you get prepared with the knowledge of the disaster medicine, thank you for this question. This is the definitely should insert the medical education to the curriculum of the medical faculties. Thank you for the question.
I have one more for Dr. Pia Daniel. Thank you for a presentation in advance. Sometimes when it comes to the violations, sometimes it's not the patient that causes the problem, but it's the come-alongs and their relatives. Do you think it would be ethically or legal or any kind of beneficial to flag these patients as violent, or do you think it would be beneficial to eliminate these patients from the healthcare systems for good? Do you have any studies that based on these cases? Thank you.
Yeah, that's a great question, and it was brought up at our planning meetings. The issue is that it's not just patients that are the issue. Often family members, I've been meeting with a lot of the pediatric department leadership, it's the parents. And so really, looking at the scope of who are we flagging, who are we identifying, and that we want it to go beyond just an agitation scale at triage, but just, maybe you have a comorbidity or psychiatric issue, or maybe you're having an acute delirium issue that we know it's going to be a problem, but maybe your family member or your parent has a history of violent acts or workplace violence. And so the first thing is really us broadening the scope of who are we flagging, right? And I think that that's a really, really good question, that it's not just the patients. And then what are we doing with those flags? So yes, I've identified that patient A or child patient A's mother is often an issue. And then how are we handling it? And we actually just had a meeting before I came with our legal department to really just figure out what is sort of our ethical obligation. And our end goal is that we want to sort of safely treat everybody. And we don't want to not give care because somebody is violent or potentially going to be violent or has a history of violence, but we want to give that care in a safe way. We want to have systems in place to protect both the patient, their family, our staff, and other patients. And so that is a really important consideration. And again, I know that in general hospitals here, you're probably a couple of steps ahead of us as far as flagging patients, but I really recommend that everybody look at your hospital policy of what are you doing once you flag patients? What is the scope of the people that you're flagging, and what is a way that you can manage them? And so that's sort of why I listed in one of those surveys, we gave our staff a lot of different options of what would you like us to see? Once we have flagged them, then what should we do, right? And so maybe it looks like always having a psychiatry consult initially. Maybe it looks like having patient relations, especially if it's not necessarily the patient itself, but a family member, come and get involved early on. Maybe it looks like security more frequently rounding in that area. So the idea is that we don't want to, and even when we are wording the flag in the chart, we don't want it to look like it is that we're biasing people against giving good care. We don't want that perception. And so we want it to be in a very sort of objective, we are putting this in place for your protection and for our protection. So it's never about you're not allowed here. It's more that we understand that this is an issue. You need care, whether it's just in the outpatient setting or maybe you need to be admitted, and you need to be able to visit your child, right? You're the child's mother, but we know in the past there have been issues, so what are the steps that we can start implementing to make it a much more sort of a pleasant visit for everybody? So I think that's a great question. It's a very gray area, and we're sort of getting everybody involved, but the overall idea is that we want to provide care. We don't want anybody not allowed. We want people's families to be able to come. So instead of just barring people, instead of just getting security to throw somebody out, let's take some steps ahead. We know this mother has been aggressive, so let's get patient relations, let's get University Police, let's get all this on board early on so that she understands sort of the behaviors accepted. And the other thing we've just established is a patient code of conduct that they need to sign, and family members and visitors. And so in that code of conduct, it states acceptable and unacceptable behavior by patients and family, and that also kind of gives us the reason saying, well, you signed this, you agreed to it, and now you're breaking that code. And so that also is one way that we're kind of approaching that. But it's tricky, but the idea is we don't want people to feel unwelcome. We don't want providers to give suboptimal care, but we want everybody to have a safe environment. So I answer and don't answer your question.
So thank you so much. If you have another questions, please talk directly to the speakers. As I suppose we can agree that we can finalize this session, and we will meet here in 2:30, because right now you have the lunch break. So bon appetit, and see you later. Thank you.
Yeah, can we have the speakers on stage for a photograph, if you don't mind? Thank you.
A significant burden, getting financial and other penalties for missing deadlines, and essentially diverting staff from patient care. I was an emergency room physician who was taken out of the ER during the peak of our COVID response for 2 weeks so that I could be in an office helping input this data, because our reporting team wasn't able to catch up with it, and our hospital administration was so afraid of getting penalties. And then when you look at the resources of a facility like ours, where we're sort of independent, don't have a lot of shared resources in the city, and then you compare it with a large network hospital where there's 11 different hospitals across New York City, just looking at the difference in the resources, right? The large network hospital, they had a specific non-clinical 50-person team that could do this reporting. They had a centralized process. It was all automated, automatic updates. Everybody had universal access to it. So the burden for that group was very small on the clinical staff. And then you compare it to the resources that our hospital has, right? We have no dedicated analytic team. The process of getting reporting essentially was decentralized across 17 different clinical departments. There was no centralized place that we could even share information. And a lot of the information was not able to get automatic from our electronic medical record. We had to get it manually. And so it ended up looking like using clinical staff. So the mandate reporting, it really leads to reporting, there's significant reporting barriers, and there's also diversion of resources away from the front line. And when you look at the questions they were asking, when you look at the different agencies, there was so much redundancy. But it was just done in such a way that was really, really difficult to create nice processes, right? So the frequencies of when you report constantly changed, and then the definitions of the variables was either very obscure or constantly changing. And so the idea is that the public health needs of a disaster, it requires a more coordinated, efficient system to share information and minimize straining healthcare systems, and really understanding that different healthcare systems have different capacity to do this. And when you ramp up a mandated reporting from 5 to 30 daily reports, you need to understand how that's affecting the acute care facility. And then again, it all translates to the community, right? So the community that we were serving, it had less clinical resources to treat patients because those clinical resources were being diverted to reporting, versus those larger networks, they had the capacity to deal with it. So just understanding that creating these universal mandated reporting is very, very difficult on certain institutions. And really, this is all about the public health sector really needs to have a better communication with the acute care facilities during a disaster, and really kind of prioritize what are the variables that we need from every facility, and maybe what are some variables that maybe we just ask from the facilities that have the capacity to give this without sacrificing care to their community. Thank you.
Bravo, Doctora. I can't believe you did that in 10 minutes. Any questions for Dr. Appiah? She deserves that. Thank you, Dr. Appiah. Our next speaker is Dr. Muzaffar Ahmed. Let me see. Dr. Ahmed, are you here? No, Dr. Ahmed? Okay, so I guess now you introduce me.
All right. Amin Antoine Kazi, who is an emergency medicine specialist. Definition, challenges, opportunities.
First of all, thank you for having me at WASAM and in Turkey. It's always a pleasure to come and see my colleagues, and to be so proud of Turkey who has been able to develop emergency medicine faster and more in a more advanced way than many nations in the world. Bravo. Today, I was supposed originally to talk about some type of challenges and something. But I decided to change the topic to something that's more relevant, because I just came from training more than 1,000 physicians and nurses in Lebanon. On Thursday, the Ministry of Health, the Lebanese Order of Physicians, our National Association of Doctors, as well as the MSF, ISF, ICRC, come together to start preparing our physicians in Lebanon for, God forbid, but maybe full-scale war. And of course, not only a full-scale war, but possibly whatever other type of internal strife and civil wars we may have in our own country.